caffeinated and ready for another power-packed day of learning. Thank you all to join us bright and early. Before we begin, just a quick friendly reminder. As announced yesterday, we request all speakers, moderators and panelists to take their places on the stage for their respected sessions, and the session director and session coordinators along with the chairperson to kindly take seats in the front row opposite the stage for a seamless interaction. One more gentle nudge, our program today is tightly packed, as you all know, and we'd love to run a well-tuned infusion pump, smooth and steady. To make sure every session gets the space it truly deserves, may I kindly request all our faculty to help us stay on schedule. You'll hear a soft bell 5 minutes before and a final bell a minute before your talk, when we would request you to share key takeaway messages and bring the talk to a close. In the interest of time, we invite our chairpersons to conclude each session together with one concise closing note. We'll try to accommodate questions when the schedule permits, and if not, we hope you'll carry those discussions forward during our shared meals. We would request everyone to kindly put your cell phones on the silent mode. With that, once again, a warm welcome to all of you. Let's begin day 2 with our first academic session. We start the day with academic session 6, GI Cancer Colorectal. I invite our session director, Dr. Anant Ramaswamy, Consultant Medical Oncology, Mumbai, and session coordinator, Dr. Ravi Kumar Vatigaonkar, Medical Oncologist, Pune. I would request our chairpersons, Dr. Sudeep Sarkar, Senior Consultant Surgical Oncology, Mumbai, Dr. Kaustav Talpatra, Senior Director Radiation Oncology, Mumbai, Dr. Mrunmaya Kumar Panda, Consultant Hepatology and Gastroenterology, Pune, and Dr. Deepak Dangwal, Breast Surgical Oncologist, Mumbai, to join us. To open this session, I invite Dr. Avinash C.V., Senior Consultant Medical Oncologist, Mysore, for his talk on ctDNA-guided adjuvant chemotherapy de-escalation in stage 3 colon cancer.
Good morning, everyone. So I will be discussing about ctDNA-guided adjuvant chemotherapy de-escalation in stage 3 colon cancer, which was presented in this ESMO 2025 and later published in Nature Medicine as Dynamic 3 study. So we all know that ctDNA has demonstrated considerable potential in the management of colorectal cancer, and it's being used in various settings, starting from screening to MRD assessment to metastatic colorectal cancer, because it provides a non-invasive, real-time, dynamic and comprehensive method for tumor burden assessment. So there are basically two approaches, tumor-informed approach and tumor-agnostic setting. Tumor-informed, what we do is we take a tumor tissue sample from surgical specimen or biopsy, and we do a sequencing to make a customized assay, and that customized assay will be tracked on liquid biopsy. Basically, it is very highly sensitive, and it is usually used in early stage cancers. Tumor agnostic, where we don't use the original tumor tissue sample, we have a fixed panel, and that will be assayed and then tracked through liquid biopsy. It is not very sensitive, it's usually used in metastatic colorectal cancer. The paradox of adjuvant therapy is, out of 100 patients we treat with adjuvant chemotherapy in stage 3, only 20% will have benefit, 30% will relapse, probably 50% doesn't need any treatment apart from surgery. So we all know that from the IDEA study, substaging on stage 3, they have a different DFS, 5-year DFS value. So definitely there comes a question whether we can improve by omitting or whether we can de-escalate the treatment, whether we can avoid oxaliplatin, whether we can avoid chemotherapy altogether. So these are the questions which arises, and there lies the potential application of ctDNA with MRD assessment. So ideally, what should be the role of MRD assessment? Do surgery, do MRD assessment. If MRD is positive, give chemotherapy. If MRD is negative, don't give chemotherapy. But that's not the actual real world scenario. So what we knew before the pre-ESMO 2025, definitely ctDNA predicted the recurrence post-surgery with specificity and positive predictive value of almost more than 95% when we do a tumor-informed tissue-free ctDNA MRD test based on various trials, Galaxy, Bespoke, Track and Pegasus. Also, it's not just about the presence or absence, the amount of ctDNA matter. Higher the ctDNA molecular burden, definitely worse are the ctDNA negative, usually they do not relapse irrespective of adjuvant chemotherapy. In ctDNA positive, definitely DFS improves with adjuvant chemotherapy, but there is little scope for improvement. So we knew this dynamic 2 study, which was published somewhere in 2022, in stage 2 colon cancer, post-surgery, they have randomized to ctDNA guided management versus standard management based on the standard clinical pathological criteria. ctDNA positive, chemo, ctDNA negative, no treatment. It was a non-inferiority trial. Clearly it showed that ctDNA guided management was non-inferior to standard management. But the matter was almost the patients who received adjuvant chemotherapy reduced by 50% by using ctDNA guided. So that's how the dynamic 3 study started. So dynamic 3 study is almost similar to dynamic 2, where stage 3 colon cancer patients were taken. Post-surgery 5 to 6 weeks, ctDNA, tumor-informed ctDNA was done, randomized to ctDNA guided management versus standard management. In ctDNA-informed management, there were 2 cohorts of patients, ctDNA positive, ctDNA negative. So ctDNA positive patients, the treatment was escalated. For example, no chemotherapy to single-agent capecitabine, or single-agent capecitabine to 6 months doublet to triplet. So the initial the ctDNA positive cohort, the result was published or presented in ASCO 2025 with a primary endpoint of 2-year RFS. The cutoff for non-inferiority was put up somewhere around hazard ratio of 0.75, but it didn't meet the non-inferiority cutoff. The 2-year recurrence-free survival was 61% with the standard management, and only ctDNA informed it was 52% with a hazard of 1.11. So, in spite of escalation of treatment, ctDNA positive patients fared bad. So, probably there needs some novel strategies to refine or improve this outcome. In ctDNA negative patient cohort, the results were published in this ESMO. Here the treatment was de-escalated from 6 months single agent to no treatment, or 3 months single agent, 3 months doublet to only single agent chemo, or 6 months doublet to 3 months of doublet. The primary analysis was 3-year recurrence-free survival. Here the cutoff value was 750 patients, somewhere around would provide 80% power to show non-inferiority with a rate margin of around 7.5%. So this is a patient disposition of around 1,000 patients were randomized, 500 in each arm, and the ctDNA negative patients were 73% in each arm. So this is the baseline characteristics. Somewhat higher percentage in standard management with clinical high risk, and MSI high or little high in ctDNA informed. Treatment, this is what the single agent treatment was only 10% in standard management, 58% nearly in ctDNA informed. The oxaliplatin was significantly reduced from 88.6% to 35%. So obviously, the lesser usage, the treatment-related hospitalization and side effects were low, and the recurrence-free survival is the primary endpoint 88.1 versus 85.3. It narrowly missed the cutoff value of 7.5%. Here, the absolute difference in the lower part was 8%. So, but when you look in detail, the low risk patient, the T1, 2, 3 and N1, the absolute difference was only 2.2%, high risk the absolute difference was 5.8%. So we all knew that, it's not about the positivity, the amount of tumor burden was also matter. So limitations, why the trial didn't show positive results? Probably sample size constraints, probably unadjusted confounding factors. There was significant strategies, various strategies of de-escalation in dynamic 3. Somewhat baseline imbalances were there.
Whether recurrence-free survival at the end of 2 or 3 years was really a surrogate marker for overall survival. Also, we have to look into, with this prognostic insight, really the cost-value equation for MRD assessment. So where we are now, probably we are sure about using ctDNA in stage 3, not very sure. Probably it is called as predictive uncertainty. So take-home message is probably ctDNA testing in stage 2 and 3 colon cancer is definitely we know that it is prognostic. The current evidence doesn't support the de-escalation of adjuvant therapy in stage 3, even if ctDNA negative. Probably we can consider in low-risk patient after information. ctDNA positive treatment intensification or substitution for thus has proven ineffective. Probably more refinements or use of molecular targeted therapies and immunotherapies in the earlier stage may definitely improve outcome. We don't know, probably various trials which are taking place might answer this. Thank you.
Thank you, Dr. Avinash, for that crisp and insightful start to the morning. We now move on to the abstract presentation by Dr. Karan Sood. He's a consultant medical oncologist, Navi.
So thank you so much for the invitation, and good morning to everyone. So I think we'll quickly go through and brush through a lot of updates. I've been replacing a speaker, so please forgive me if I've made mistakes at the last moment. So the outline would be, we'll be discussing a bit about hepatocellular, some NET, some pancreatic, gastric, and then the major colorectal. So in the hepatocellular space, you see the triplet HCC trial where they added EP to the atezo-bev arm. And the primary endpoint for this trial was ORR and secondary endpoint was PFS. And if you can see the primary endpoint, you see there was no difference in the PFS and the initial OS curves. So basically telling that triplet HCC approach of adding EP did not change practice, but definitely OS data is still awaited, and that would be presented later. Then comes the IM-BRAVE, where they tried to add tiragolumab to the atezo-bev arm. That's a TIGIT antibody, and you can see they compared it with the placebo, where the primary endpoint was investigator-initiated PFS and OS. And if you see the primary endpoint of PFS, there is no difference between the two, 8.3 versus 8.2, and the HR being 0.97. So the conclusion was that the primary endpoint was not met, but again, immature OS data and expected to reach statistical significance may or may not be there. Moving on to the neuroendocrine space, the Alpha Medics 02 study. Here they had patients of JEP-NETs where they had two cohorts, one which were radioligand treatment naive, the other one was exposed. And the intervention was lead-dotamate PRRT. So the primary endpoint was ORR and incidence of adverse effects, and secondary endpoint was progression-free survival and time to tumor progression, including OS and health-related quality of life. So as you can see, the primary endpoint of ORR and duration of response, in especially the exposed patients and the second or third later lines, the PR was to the tune of about 35% and stable disease to the tune of 61%. The overall response rate you see is about 35%, and the disease control rate is about 96%. And also you can see the duration of response is more than 1.5 years. So secondary endpoints of PFS and OS in RLT exposed patients. The PFS at 18 months was more than 80%, and overall survival also crossing the 85% mark. So it said that in this space, where a lot of inadequate responses post the PRRT is there. So this intervention has given us an unprecedented almost 60% ORR and DCR of about 95%. And adverse effects in this domain, in this strategy were dysphagia and chronic renal function. And this is a good strategy for patients with advanced JEP-NETs. Coming on to the pancreatic carcinoma, the PANOVA trial, where they added tumor treating fields to the GEM nab-pacli backbone, and they compared it with the conventional standard of care arm. So the primary endpoint was overall survival, and you can see there is the median OS is 16.2 versus 14.2, and the HR is 0.82. If you see some mixed responses online saying that it might not be the go-to therapy. But yes, if you see Dr. Namrata writing that the side effects were predominantly grade 1 dermatitis, and this is a good therapy. Even their paper says that this is a very good strategy for patients with pancreatic, where even a 1% increase in survival is very much appreciated. Coming on to this ADC on CMET, that is Timab-A. So this is an ADC which has been used in in a basket trial where cohort 2 was pancreatic cancer. They received 2.4 to 3 mg per kg 3 weekly, and the endpoint was confirmed CR or PR assessed by the investigator as per RECIST. So you can see the overall ORR was about 10% and clinical benefit rate was about 34%. So this is good in this space, and you can see the immunohistochemical analysis showed that all tumor tissues had CMET protein staining with 2+ and 3+ intensities, and CMET expression prevalence was consistent between diagnosis and recently obtained samples from the patients. And the relationship between CMET expression and treatment response will be further evaluated in the next phase 2 trial. Switching on from NETs to gastric cancers. So firstly, the gastric 04 Destiny, where they used in the HER2 population, they used TDXD 6.4 mg per kg, and the primary endpoint was OS. And as we know that the HR ratio in here was 0.7, and at 24 months the OS was 29% and 13.9% in the ramucirumab and paclitaxel arm. And again, so reactions from Dr. Amol, and it says that there's a lot of ILD, no cross trial, HER2 heterogeneity was not fully assessed, and the confidence interval was greater than 1 in many cohorts. So not a good uptake, but yes, definitely a good good drug in the latter lines. Coming on to the Matterhorn, where they added the durvalumab to the standard of care FLOT, and the primary endpoint in this trial was EFS and secondary endpoint was OS. So the final OS readings, the median OS was not reached in the Durva arm and also in the placebo arm, and the HR was 0.78, and the 36-month OS was 68.6 versus 61.9 with a delta of 6.7. So the conclusions from this trial were it demonstrated a significant and a clinical meaningful OS versus FLOT alone. HR was 0.78 and OS improved with Durva plus FLOT versus the standard of care. And the degree of pathological response was associated with improved EFS, and EFS was also improved regardless of pathological nodal status. Next, going on to the Fortitude 101 study. So here a newer drug, bemarituzumab, was added with the Folfox, and it was compared with the Folfox in FGFR 2B population, and the OS was the primary endpoint. And you can see in the overall survival analysis, the bemarituzumab had the median OS of 14.5 versus placebo at 13.2 with an HR of 0.8. So FGFR2 remains a promising target in this gastric cancer domain, and it demonstrated a biological activity. It was not practice changing due to omission of PD-1 blockade in the control arm and no meaningful difference at 2 years. But Fortitude 102 incorporates optimized AE managements and anti-PD-L1 chemotherapy arm, which will allow definitive better assessments in larger cohorts. Switching to colorectal cancers, so we want to see checkmate 8HW. So here there were 3 arms: Nivo 240 every 2 weekly followed by 480 every 4 weekly, Nivo AP for 4 doses, and then it was followed by Nivo, and investigator choice of chemotherapy. And you can see the dual primary endpoints in patients with centrally confirmed MSI DMMR status was PFS by BICR in versus the Nivo EP, and Nivo EP versus Nivo in all lines. And you can see the updated PFS in Nivo EP versus Nivo across all lines. There is the graphs are separating very well, and the median PFS was not reached in the doublet. Versus Nivo, it was 44.3, and the HR was 0.62. So Nivo plus EP demonstrated a clinical meaningful PFS versus Nivo in patients with centrally confirmed MSI high CMMR with almost 31% reduction in the risk of progression to death, and clinically meaningful improvement in ORR, higher CR rates, lower PD was observed with first-line Nivo plus EP versus Nivo in patients with the dMMR CRC. Although OS is still immature, we are still waiting for the results. Going on to zenzalitimab plus atezo versus regorafenib in previously treated metastatic CRC patients. So previously, no phase 3 trial of ICI has shown improvement in OS in that is not MSI, that is pMMR. So zenzalitinib is a novel small molecular inhibitor which inhibits MET, VEGFR, and TAM kinases. So it has been seen that inhibition of these kinases leads to better responsiveness of ICI. So the Stellar 001 demonstrated that anti-tumor activity and manageable toxic side effects of zanlitinib versus plus atezo compared with zanzalitinib alone. So in this study, they compared zanzalintinib plus atezo and they compared it with regorafenib, and the dual primary endpoint was OS in ITT and OS without active liver mets. And if you see OS in the ITT population, the zanzalintinib plus atezo, the median OS was 10.9 versus regorafenib 9.4, and the HR is very close, 0.80. So the conclusions from Stellar 303 is that the first randomized phase 3 trial to improve OS and PFS in ICI combinations in metastatic, that is basically an pMMR. Another BOT-BAL trial which we've been waiting, this was the dose study, and I mean, just to make things a little more better, so they wanted to check the dosing of boseltimab versus balseltimab. So increasing the doses definitely made the ORR more, but it had added toxicity. So we are still waiting for phase 3 trial. Then the atomic trial where they added atezo to FOLFOX in the adjuvant setting, and again Dr. Amol's tweets telling us that the 3-year DFS was 86.4 versus 76.6 and HR of 0.3, but then number of cycles, toxicity, and then he also said that comparing it with niche in the neoadjuvant ICI with only just 2 doses of nivi-epo and a good PAT CR, is it justified? I think this is another fascinating trial where they used a phase 1 drug called Presitabart tocotecan, which is an anti-CEA CAM antibody with the top 1 inhibitor, and they saw that there was a good efficacy, and you can see good ORRs in the setting of 2.8 and both 2.4 mg per kg. And the last is the breakwater study where in corafenib, EC was added to modified FOLFOX and was compared with standard of care. So the dual endpoint was PFS and ORR, and secondary was OS. And as you can see, the PFS by BICR in the EC was 6.7, but when it was combined with modified FOLFOX, this was 12.8. versus standard of care, which was 7.1. So the conclusions was breakwater has not met both its primary endpoints and the secondary endpoints. So PFS by BICR data demonstrated that it was a statistically significant, clinically meaningful improvement in the addition of EC with the modified FOLFOX. And this second interim analysis of OS demonstrated a statistically significant, clinically meaningful improvement in the experimental arm. Also, EC plus modified FOLFOX6 is practice changing as a new standard of care for patients with BRAF V600E mutation, including the first line setting. And EC also showed a numerically higher ORR, comparable PFS and longer OS, and early separation of OS curves versus standard of care. And EC is more tolerable safety profile than standard of care. So, thank you so much.
Thank you, Dr. Karan. Next, we move on to our panel discussion. Moderating this session is Dr. Udip Maheshwari, Consultant Medical Oncologist and Hemato-Oncologist, Mumbai. Our distinguished panelists are Dr. Sameer Gupta, Senior Consultant Surgical Oncologist, Pune, Dr. Shrikant Ankolikar, Oncosurgeon and Laparoscopic Surgeon, Pune, Dr. Rahul Krishnatri, Consultant Radiation Oncology, Mumbai, Dr. Anisha Madineni, Consultant Medical Oncologist, Pune, Dr. Venkateshwar Rao, Consultant Medical Oncologist, Vishakhapatnam, Dr. Vishwas Pai, Consultant Surgical Oncologist, Hubli, Dr. Ajay Kumar Singh, Senior Consultant Medical Oncology, Lucknow, Dr. Joy Ghosh, Consultant Surgical Oncology, Pune, Dr. Chaitanya Datar, Consultant Medical Genetics, Pune, Dr. Debanshu Bhaduri, Consultant Surgical Oncologist, Pune, Dr. Abhishek Shankar, Consultant Radiation Oncology, Delhi, Dr. Karan Sood, Consultant Medical Oncologist, Navi Mumbai, and Dr. Jagdish Shinde, Senior Consultant Radiation Oncology, Pune.
Good morning, everyone. It'll be a tough task to remember everyone's name. I'm extremely sorry. I've met most of you all for the first time. I'm Dr. Udip Maheshwari. So we'll be discussing about colon cancer. How much time do we have? 25 minutes. Okay. So we'll be discussing about colon cancer adjuvant. I think 1 or 2 abstracts have been presented, and 1 ctDNA abstract has also been presented. Just to keep the surgeons also interested, I've included oligomet case initially, and the second case would be adjuvant. So we'll be discussing 2 cases. I welcome all my panelists and chairpersons. Oligometastatic disease, how much is oligo? That's the question right now. So this much is oligo or this much is oligo? So how do we feel from our panel? How do we define oligometastasis? Anyone from the panel can take it? Surgeon, preferably an oncosurgeon? Yes, please.
Maybe, sir, 1 to 5 metastatic disease which is amenable for treatment and having controlled local disease, maybe maximum up to 5 metastatic.
Correct. Okay, agree. Anyone else who has a different opinion? Are we defining it to 1 to 5 resectable metastasis which is amenable without any comorbidities, giving patients a comorbidity? Is that the definition that everyone agrees to? I think, yeah, that's what even the research says. And what is the incidence of oligometastatic colon cancer, sir? Abhishek, sir, if you know, we talk about incidence.
So I think if you see the total metastatic cancer, it is around 15 to 30%. And out of those metastatic cancer, I think 10 to 15% is lump sum around oligometastatic colon cancer. So.
And you have any, so we don't, do we have any data on how much oligometastatic disease are we seeing, and are they getting operated, or are we giving them a curative intent? Is there any data of that sort?
I'm not the right person to tell about this, but anybody who wants to come.
Anybody who wants to take? Yeah, please. Any oncosurgeons who can?
Yeah. I think I agree with the data that is coming in, but as to how many actually get treatment as per international guidelines is a questionable thing.
Correct.
Most of the times we find that as a cancer center, we find that we get referrals of patients suboptimally treated once they have oligometastasis.
Correct.
And that's basically a technical challenge that surgeons face once they see the liver involved. They say, okay, I'll just treat the colon and send it to a referral center.
Correct.
And that leads to a little bit of compromise, but that's the reality that we face all the time.
So completely point taken. Most of the patients who've gone here and there, they've done primary surgery, and then, you know, when they were out of reach, then probably they've been referred to the referral centers, is what we see. So I don't think there is any exact data as to how many patients of these oligometastatic disease are getting treated in a curative intent, but the data says that, you know, almost 34% of these patients who are treated with a curative intent do very well, and a 5-year survival is very good for these patients. Right, so even the ASTRO consensus says that there is 1 to 5 metastasis. That is what is said by the consensus here. There have been also studies which have included molecular subtyping as risk stratification in these particular patients. Now coming to the case 1, so a 39-year-old female, this is an actual case we did in Mumbai. So 39-year-old female presented with constipation, abdominal pain, there was anemia also. USG showed hepatic lesions, PET scan suggestive of multiple large heterogeneous enhancing focal masses which are seen in both lobes of liver, largest one 7.2 into 6.9. FDG with irregular transmural circumferential thickening in the sigmoid, extending in the length of 4.5 into 1.1 centimeter. SUV was also 17. And FDG with sigmoid mesocolic lymph nodes are seen measuring up to 10 mm. So that was the case. How would you further evaluate? I think if a surgeon wants to take a call on this, what would you need for defining the liver metastasis or the abdomen? Do you need any other test for this?
You know, at this point, Dr. Maheshwari, because she is obstructed,
Yes.
I would look at alleviating her symptomatology first. You
So
know?
she is passing motions. She is taking liquid to semi-solid diet.
Yeah.
She is not completely obstructed as of now.
All right. And you just have a PET scan which shows these.
We
You
have
don't
a PET scan. No, we've done other tests, but we've done first the PET scan, and with this report, would you want to do anything else?
Yeah. Do you have some kind of contrast conventional imaging like a CCT or an MRI?
Correct. So we definitely. So what is the? I would just want to reiterate importance of MRI, sir. Anything? Why an MRI needs to be done to for liver defining images? Any?
I think it also helps us to define as to which of these lesions are highly suspicious. A, and B. As far as I'm concerned in my clinical practice, I'm comfortable with either a CCT or an MR for planning resections.
Okay. Perfect. Perfect. Any medical oncologist from the team for any molecular test that we would want to do? Would you want to do the whole NGS panel or an hotspot panel? Anyone? Yeah.
So,
Dr. Sood,
I think I would probably agree with sir, but I think a baseline MRI is really required to finalize the intent of therapy in the MDT as well. How many number of lesions are there, and how do we go about it? Eventually, do we how much therapy do we give? And surgeon needs to be comfortable for resection or any other local therapy that needs to be done. So that could be decided upfront. For the molecular testing, I think MSI testing is very central to this.
Perfect.
And all-RAS testing is also very important.
Perfect.
So minimal these two, and if
Okay.
the patient can afford, then maybe an NGS on tumor.
Okay. Any other medical oncologist who would want to take this? Is age and sidedness of tumor define your intent of treatment?
Yes, definitely. We all know that left-sided tumors do better than the right-sided ones, and
Correct.
also I would be more justified in treating a patient aggressively if the age is less when compared to a very old patient.
So, would you be interested in treating this patient with a curative intent or a palliative intent, looking at the metastases that are there? I'll give you. Prior to that question, I'll just want to clarify that why MRI is important. MRI changes the treatment in about 31% of patients, is what the data says. That just a CT scan versus if you get an MRI of the abdomen in liver metastasis, in colonic liver metastasis, it changes about 31% of the patients, and that is why an MRI becomes very important. So this patient biopsy suggestive of adenocarcinoma, MRI liver showing these many metastases in these many segments, no mets anywhere else, patient clinical stable. Now you can answer that question. So would you be wanting to treat this with?
So, definitely, though she is a young woman, but it's not an oligometastatic disease. There are mets in both the lobes, and there are multiple, and the largest one, as you were mentioning, it was more than 7 centimeters.
Correct.
So it doesn't look like a resectable one. I would offer her chemotherapy first and then decide based on the response.
Correct. Anyone
Looking at
else? So anyone else who would want to has difference of opinion? I've shared the molecular profile also. Would want to differ on this?
Irrespective of the molecular markers, looking at the bilobar liver mets and particularly single lesion up to 7 centimeters, she won't be for a curative resection, at least in the beginning.
Correct. So would you be wanting to give her an aggressive chemotherapy with target therapy versus a palliative chemotherapy?
Only reason being she is 39.
Yeah.
Other than that, this doesn't look operable at all.
So absolutely, I completely agree with. Yes, please, sir. No, absolutely, sir. Please. So, madam, you've not spoken. I think madam has not spoken as of now. What will be your take on this patient?
My intent of treatment would be probably like I will try with the triplet and then I'll go ahead.
Absolutely.
Whether if it is going to be resectable ahead or not.
Okay, so any choice that you would want to prefer from here? Anyone who can take this?
See, we should look at the performance status, the liver function
She's
as well.
fit, PS1, liver function normal, RFT, LFT normal, 2D echo normal.
I would discuss with them, and my choice would be Folfox with the first one.
So
that's
anyone
what
from,
I usually do.
So okay, point taken. So we'll be very fast with the answers. You can just.
So basically, sir, it will require discussion with family. What is their goal? What they want to achieve. If they are very keen for aggressive treatment, then maybe we'll go ahead with the Folfox.
The family says we want to do everything. She's very young. She has one son, one daughter.
We will try to go as aggressive as possible with Folfox.
Folfox plus?
Folfox IRI plus BEV, if the family is very keen.
Correct.
But otherwise, looking at the baseline profile, at baseline at least my goal will be palliative with double agent with a target agent bevacizumab. But if family is very keen to go ahead with very aggressive management, then I'll go with the triple agent with bevacizumab.
So similar was my approach. Is what we did. We give for 2 months of Folfoxiri plus Bev. CT scan said there is almost 30 to 40% reduction in liver lesions, but that liver, the portal veins were involved, still involved. They were persistently touched with the disease, and number of lesions had not reduced, but symptomatically patient was dramatically better, constipation relieved, eating everything, walking, talking, doing everything. PS 0 ho gayi thi patient. So now would you want to operate in this case, sir? Anyone who would want to do anything different?
Because the response has been very good, let's continue chemo for some more time and look at the response. In this CT, what's the size of the lesion, liver lesion?
So CT scan liver lesions were reduced to 3 centimeters. The 7 centimeter one was reduced to 3 centimeters. The maximum size of disease was about 3.5 centimeters.
So definitely let's continue chemo for some more time and then reassess.
Sir, surgeon, any
other?
Did
you say that the portal vein was involved in this?
Veins were involved, yes.
Yeah, I don't think this is ever going to be resectable.
Okay.
So,
any other surgeon on the board? Sir,
if the response is great, at the end of reasonable cycles of chemotherapy, her GC is well maintained. Nowadays, we are more thinking in terms of non-anatomical resection than anatomical.
Correct.
So, even though initially the portal vein was involved, if there is a good shrinkage, then maybe at a later date we may consider. But still, it's a more of optimistic thought than reality.
So, the point was bringing these cases, this is unusual. I don't think this can be standard practice for most patients. But this patient did get surgery. Most of the lesions were removed. It was about an 8 to 9 hour surgery. Patient was discharged fantastic on day 3. I saw her walking on day 3. Day 5 she was discharged with normal liver function. FLR was about 30%. So functional liver reserve for liver. And that was followed by 2 more cycles, 2 more months of chemo plus BEV and 1 month of chemo without BEV. And then there was a second stage surgery for the colon which was done. So, and now it's been 2 years, she's disease free and she's completely disease free and she's now 43, son has completed 10th. So they've achieved a major milestone in their lives. So they're doing very well. So we did get the hepatic surgery done and this was the report for hepatic surgery. If you see liver segment 8, 7, 5A were removed. Segment 5 wedge resection was done. Segment 3 wedge resection was done. Omentum and adrenal. This was the liver surgery. And most of the lesions had shown dramatic response with chemotherapy. And then the second surgery that we did was again colon. Prior to second surgery, the imaging again showed that there was some liver lesion which is again cropped up, which were in segment 4, 2 and 3. Again, those were resected. There were no lymph nodes, fortunately, and all the liver lesions were resected. And post that, patient's PET scan for last 2 years has been normal. MRI we've repeated yearly, that has been normal, and she's doing fantastically well. So, yes. Yes, sir, please. Correct. Correct. Absolutely. We could do the, absolutely. Absolutely. So point of bringing this case was that let's not limit ourselves to 1 to 5 metastases. There are, as sir said, there are many areas where we can aggressively treat such young patients. If possible, let's take consult of surgeons who, oncosurgeons who are doing only liver surgeries, whether this can be done, because vascular reconstruction can be done in such patients. And this patient has gotten extremely good survival. And there have been other patients who, as sir rightly mentioned, that 2 lesions were amenable to surgery and 1 lesion was, some local therapy was done, and that can be, done for these patients. How will you surgically assess these patients? How will you classify them? And any comment on FLR? Sir, any oncosurgeons on the board? Sir, if there is any patient that you would want to say, suppose not these many mets, say there are 2 or 3 mets in such patients, so how would you classify them as resectable, upfront resectable, not resectable, anything that, and is FLR, how much of FLR would you want to keep? And what is the assessment generally when you consider for surgery, sir?
Okay, so I think if we look at this patient specifically and then we generalize this answer, functional hepatic reserve becomes a big thing for us.
Correct.
And we try to see if in a younger patient, sometimes even a 10% hepatic reserve the liver undergoes compensatory hypertrophy. So previously in around 95, 96, we were actually doing a trial in Tata where we were embolizing the liver, transhepatic portal vein embolization we were doing on the metastatic side, and we would get compensatory hypertrophy on the other side, and then go in and resect about 14 days after embolization.
Correct.
But 30% is definitely acceptable. Again, it depends on the generalized condition of the liver. If it's a pristine liver, which I expect in this kind of lady, then you can be aggressive as this. God bless her that she got away with so many metastases. I would still not do it, although we do quite a few liver resections. But good for her. But I would require at least a minimum 30%.
30%, yeah, absolutely. So that's the guideline, 25 to 30% odd liver function if a liver is extremely healthy, and if it is cirrhotic liver, about 40 to 50% is what should be the reserve that should be there. So moving ahead, any radiation oncologist here? Yeah, sir. Sir, at the last, any role of SBRT in such patients? Suppose if there was one lesion which was pending, not amenable to resection, leading to a lot of decrease in FLR. So would you want to radiate that?
Yeah, definitely. In this particular case, the size of tumor was 3 centimeter after chemo.
Yes.
So that tumor is amenable for SBRT liver. So we can finish the treatment in 5 fractions of radiation.
So any specific case where you would not want to do an SBRT? Suppose if there is a lesion somewhere, any indications where we cannot do SBRT?
If the tumor size is very large and we cannot spare the surrounding liver, adequate liver, in that case we cannot do SBRT.
SBRT, correct. Yeah. Okay, so role of local therapies, any medical oncologist or someone who can take this? I don't think we have intervention radiologist here, no? We don't have an intervention. So any medical oncologist, local therapies, have you done? Anyone has done in their practice?
So we are doing HAIC in our patients, and also TACE is there.
Okay.
So we can do TACE. Also coming on to the point for SBRT, any lesion close to the vessel also probably might not be a SBRT candidate.
Can we do SBRT for, I think that is for RFA, right?
Vessels not. Yeah, portal vein is the good case for a SBRT. Yeah.
Correct. So RFA, I think RFA is something, yeah. So RFA is something which has, if it is below the vessel, then it is difficult.
So IR procedures, they may not like vessels, but we are okay with the vessels.
Okay. Great. So I think we have less than 6 minutes to do the second case, which is also important. A 55-year-old male, a straightforward case of PT3N0, young, fit male, no obstructive symptoms, no LVI, no PNI, MSS, it's a proficient MMR. We all know that what are the risk factors. I'm not going to go in detail of those risk factors because this case is shorter one. We'll move fast. So these are the guidelines which we have been practicing right now. Now, de-escalation therapy. So the first abstract that we presented today, which groups can we consider for de-escalation and any personal experience of de-escalating? Medical oncologist can take this, or anyone who would want to answer.
Until now, I do not have any, I did not practice about the self-DNA inclusion of it in the treatment. But again, with the dynamic 3 trial report results, we can say that post-surgery, as they have said, after 4 to 6 weeks, if it is negative, then to de-escalate is a
Okay. Okay. So we have a geneticist also, I think. No, not there. Okay. How many of us are, raise of hands, how many of us are doing CT DNA or CFDNA in adjuvant colon regularly, sir? So any experience that you would want to share, sir?
So firstly, going on to the previous case, so we have couple of patients of CRLM where we are doing ctDNA post-therapy,
we can do it
and
there
then
as well.
we've had some patients on maintenance KIP if they were positive. And in the adjuvant setting, we've done 2 patients and both of them were negative, so we've not given them adjuvant chemotherapy.
So you've de-escalated for them?
Yes.
Correct. So we'll know in another 2 years what happens to them. What is the, I think there's no genetic, molecular oncologist on board. So there are 2 trials, and I'll just go through it again because we have less than 5 minutes. There were 2 trials. One was the dynamic 3 that was presented, and the other was Pegasus trial. So dynamic used the Natera's, I think, Signetra for CTC, which was a tumor-informed CTC, and Pegasus used Onco360, Guardant's Onco360, and that was tumor uninformed. So anyone knows any difference on tumor informed and tumor uninformed biology? Anyone from the Dr. Anant? Anyone? You have any comments to make on the ctDNA, CTC?
So both of them are good tests. There is a meta-analysis which says that probably a tissue-informed assay is more informative than a tissue non-informed assay. The problem with the informed assay is that you need good quality tissue.
Correct.
Now, in resected colon, that's not a problem. You generally end up getting good tissue. But in biopsy specimens where you want to track, probably it's a problem. But they're coming now with their liquid
informed as well, yes.
So probably that, and once they take up the integrated platforms, that issue will vanish.
Correct.
But both of them are good. There's a meta-analysis which says that tumor-informed
is slightly better, yeah, correct. And are you using this de-escalation therapy? With the recent results, they have shown that it doesn't meet in.
This case that you showed, right?
Yes.
From a sensitivity, specificity point of view, it is going to be negative.
Correct.
Right? If it is positive, you go back and recheck the test. Because it had no high-risk factors.
Yeah, absolutely.
So, yeah, but we are using, it's just that the cost is so much that very few of my patients can afford. But we are with those who can.
So are you using any Indian test for it to?
That's the billion-dollar question, I guess. I am. But after explaining pros and cons,
Correct.
the data is
Not validated, absolutely.
That's a major problem.
Absolutely. Perfect. So point well, yes. Yes, sir, please, sir.
So this tumor-informed testing, molecular testing is not new. If you look at acute lymphatic leukemia, there were patient-specific PCR primers were made so that the test result would be positive only if the relapse for minimal residual disease was related to that patient.
Correct.
The limitation of that is that it's a genomic unstable disease. So you might have some additional genetic changes which will not be identified if you only focus on tumor informed.
Correct. So there are both debates where people are saying that tumor informed is also good. Each company can defend themselves with some points. But I think the crux of the matter is that dynamic 3 trial did not meet the non-inferiority trial, and the abstract did show that why there was many problems with the trial, and that is why. But there is definite indication that ctDNA negative patients will definitely do better. And again, if you see, the curve was down and did not meet the non-inferiority. Again, the Pegasus trial also did the same thing. The trial design was again very complicated. I personally did not understand a lot of their arms. And there were definite improvement in the DFS in ctDNA negative patients, but however, it was not powered enough to tell us it was very close. In fact, they wanted 134 patients, they got only 100 patients. It was very close to getting positive results, but again, the power of the study was not good enough to generalize and use this study. So last 2 slides, MSI-H histology. Anyone doing anything differently in colon cancer now? There was an atomic trial presented, I think abstract presented. Anyone in medical oncologist? Just to one-line answer. Anyone knows? So this is this one, high-risk stage 3 colon cancer, MSI high. Anyone who's using atezolizumab or in practice, in adjuvant. So that's the guidelines have changed now.
So yes, sir, we have these 2 data. So I used one nivolumab in neoadjuvant setting in one of the patients.
Correct.
Based on the niche data.
Okay, so we have this data now. The atomic trial did show some benefit. Folfox plus atezolizumab or Capox plus atezo can be used in MSI high. So I thank my panel for a wonderful discussion. I know there was a shortage of time. We could not go into a detail for MSI high, but I think that is immunotherapy is going to stay. So thank you so much, panel. Thank you so much, audience, for being fantastic.
Thank you, Dr. Udip.
And thank you, Chairperson. Sorry.
Thank you, our moderator and the entire panel for that engaging and comprehensive discussion. We now move into a series of focused, industry-led scientific updates that bring important real-world and emerging evidence to the forefront of clinical practice. Our first update in this segment brings us to an area of keen interest in hematology, exploring the potential of zanubrutinib in the management of B-cell lymphomas. I'd like to invite our speaker, Dr. Vijay Ramanan. He's a consultant clinical hematologist, Pune, to take us through this evolving space. This academic session is sponsored by Glenmark.
Thank you, everybody. Thank you, Dr. Tushar and MOC for giving me this opportunity, and Glenmark for sponsoring the same. So today's talk is on basically zanubrutinib, and we'll be talking about this BTK inhibitor, which has got the widest recommendation as such. So we'll be talking about unleashing the potential of zanubrutinib in B-cell lymphomas. Now, why is it a better BTKI? Why do we need a better BTK inhibitor? Is because ibrutinib seems to have a lot of off-target toxicity, and there is a high discontinuation rate because of atrial fibrillation, hypertension, bleeding rates. And so we needed a more safer BTK inhibitor, which would be more selective. So the profile of zanubrutinib is it's a highly selective covalent BTK inhibitor. All of these are acalabrutinib, ibrutinib, and zanubrutinib are all covalent binding BTK inhibitors, and zanubrutinib has a high BTK occupancy, means it binds to the site and remains there for longer period, and minimal off-target activity. There have been some animations which have been removed. Can I connect mine? Slides में थोड़े changes है. Yeah, I have my laptop. ये कहाँ निकाल? कनेक्टर भी है मेरे. बोल दीजिए उसको मैं कर दूँ.
Yeah, sure. सेटिंग मध्ये जायचं मल्टिपल स्लाइड तुमची स्लाइड घेऊ है ना सॉरी फाइल रिसीव 18 दिसते का 18 तर नाही दिसत आहे हां 18 एक बॅकग्राउंड on kara. Yeah, we are back in business. So now the kinase selectivity of BTK inhibitors, this is a heat map of what are the off-target activities. The zanubrutinib has less amount of red as compared to ibrutinib. The calibrutinib seems to have less, but its active metabolite, the M27, seems to have a lot of red spots. The red spots leads to a lot of cross-reactivity and side effects of BTK inhibitors. So what's important to remember is, because BTK is not one-time treatment, it's a continuous treatment, so you need to have a drug which has less amount of adverse effects. So because of lack of selectivity, there's a lot of interaction with TEC, EGFR and CSK, which leads to inhibition by ibrutinib. So zanubrutinib does not do it, so there are fewer cardiac and fewer bleeding events. So what is the mechanism of action of zanubrutinib? It basically gets attached to BTK, which is an important signaling pathway, which ultimately BTK activates NF-kappa B and ultimately leads to B cell proliferation, trafficking, chemotaxis and adhesion. The inhibition ultimately leads to suppression of these activities. Dosing is very simple. Either if your patient is able to take, is disciplined to take twice a day 160 BD, or otherwise 320 once a day. So it's a predictable pharmacokinetics, which is very, very important, and it has the broadest BTK label. So let's go through some of the data. So coming to CLL, that's our first disease in which zanubrutinib has been approved. Now CLL has a lot of unmet needs, the TP53, the unmutated IGH variable chain, complex karyotypes, the Richter's transformation, which have poor prognosis, and there could be resistance. Now with the first resistance, none of these ibrutinib and the other things would act, but these are the unmet needs today. The first 2 points would probably be taken care of by the zanubrutinib, and with lower long-term toxicities, we would be able to continue the treatment. So coming to CLL, the first study was Alpine, which was basically done in relapsed refractory CLL, comparing zanubrutinib with ibrutinib, which showed that there was an improved overall response rate. So there was a 32% reduction in the PFS risk reduction, and more so 49% in the high-risk group, which is deletion 17p and TP53 positive. So you look at the hazard ratio, which is there, 0.68, so there was around 32% reduction in the risk reduction in the PFS. The second study which was done in CLL was in upfront cohort, frontline cohort, which is called Sequoia, but the comparative arm was bendamustine and rituximab. So what did it show? It showed a very strong results in patients who were high risk, which was deletion 17p. And there are 3 cohorts. The third cohort was a Zanu with venetoclax, and that showed a brilliant response. So you look at the 24 months PFS, which was 92%, overall response rate of 97%,
and CR and CR incomplete, which was 49%, which is a very rare event to occur in CLL, double digit, in fact close to 50% people getting CR. So that was the result for zanubrutinib in CLL as such. So then there were few statistical analysis. Now statistics is a game which I do not understand much beyond clinical trials. So there was these two methods that were used. One is called the matching adjusted indirect comparison, or MAIC, and network meta-analysis, which was like a real world data. And all of these showed a consistent favorable reduction in progression-free survival, risk reduction in progression-free survival. So it was very competitive with acalabrutinib and venetoclax. So zanubrutinib single agent was good enough as compared to acalabrutinib with venetoclax. So you look at in first line CLL, you look at the hazard ratio was 0.41. So there was around 59% reduction, risk reduction in the PFS. Similarly, in the unmutated immunoglobulin heavy chain, which is a high-risk group, there was a reduction of nearly 70% improvement in the risk reduction of PFS and better progression-free survival as such. And similarly, in an arm which is better, which is mutated immunoglobulin heavy chain, in fact, they were 50% better than acalabrutinib and venetoclax. So, moral of the story is zanubrutinib is better than ibrutinib, bendamustine rituximab, and acalabrutinib with venetoclax. Most important thing is the safety profile is very good. There is lower rate of atrial fibrillation, hypertension, fewer discontinuation, lesser bleeding, and better tolerability. Coming to the second indication, which is Waldenstrom's. So one of the five, that's why it's the broadest, it's a BTK inhibitor with the broadest label. So in Waldenstrom's, there was a study called ASPEN, where it was single agent, single arm. So it was done with, it was compared, it was compared to ibrutinib, not single arm, and it showed a better safety versus ibrutinib. So even in treatment naive or relapsed refractory settings. So results, you can look over here, the CR, the VGPR, everything was close to 95% in treatment naive and 94% in relapsed refractory. So in comparison to ibrutinib, in Waldenstrom's macroglobulinemia, the results are comparable or even better. And you look by the CXCR status, because we know that CXCR4 NS or nonsense mutation has a very poor response or lesser response or slow response to ibrutinib and BTK inhibitors. Over here also, which is the worser group, the extreme right for you. So that was CXCR4 NS, where you can see the major response rate was nearly 86% as compared to ibrutinib, which is only 53.5. And for frame shift mutation, it was similar. Frame shift is better than NS as far as the response is concerned. And in the worser scenario where TP53 mutated, the response rate with zanubrutinib was much better than ibrutinib. So this is an important slide for all of us in patients with Waldenstrom's. Now coming to the third indication, which is follicular lymphoma. Now this is a study called Rosewood, where it was compared to obinutuzumab. So zanubrutinib with obinutuzumab, which ultimately led to higher overall response rate and CR rate with a durable response that was seen. So this is a summary of the whole study, where you can see at the CR rate, which is around 57% with the zanu with obinutuzumab versus 14% only for obinutuzumab. Even the PR rates are much better, 43 versus 19. And you look at time to new treatment, which is not achieved in the zanu with obinutuzumab, which is around 12.2 months in obinutuzumab. So looking at it, so it seems to work even in rituximab refractory patients or responsive patient. Even if your patient has not responded to the previous chemotherapy, it seems to respond. Even if your previous treatment had only a PFS of 6 to 12 months, zanu with obinutuzumab seems to be working. So this is a very good drug, even in follicular lymphoma, when it's not responding to rituximab-based or obinutuzumab-based treatment. Coming to the fourth one, which is mantle cell lymphoma, which we all know. When we passed out, we used to think mantle cell lymphoma is like a death sentence with a 3-year survival. But thanks to BTK inhibitors, we are looking at we are having better results with the cytosine-based chemotherapies, but we have now a better result with BTK inhibitors. With zanubrutinib, there is a higher overall response rate with durable PFS as such. So this was a single arm, and this was monotherapy which was seen. And 2-year PFS, you can see, is around 58% and 3-year at 48%. So around 50% of the patients get a PFS as such. So overall response rate of 84% with CR of around 78%. So look at the duration of treatment. I mean, the whole OS overall survival is around 80% at 2 years and 75%. So that's a very, very important thing for all our patients with mantle cell lymphoma if they've relapsed, or even upfront, we can think of zanubrutinib with a very gratifying result. Now coming to marginal zone lymphoma, which is the last of the treatment, on which this drug works. So there was a study named Magnolia, which was use of zanubrutinib, and it showed complete response across all the subtypes of marginal zone lymphoma with a favorable safety. So the best overall response, which was seen in extranodal, followed by nodal, and ultimately splenic. The splenic marginal zones do not seem to be responding as good, but there is a response, very good. If you look at the VGPR and the CR, that PR and the CR, it does exist. Around 60 to 70% of the patients have CR plus PR with a single oral drug. So that's a very important thing for all our patients with marginal zone lymphomas, except for splenic, probably where we could consider a more splenectomy-based treatment. So there were studies to see whether there is BTK inhibitor intolerance. So there were multiple studies which were done to compare whether a patient who was on ibrutinib or acalabrutinib, if he gets an intolerance, will he tolerate zanubrutinib? So what they found was there was a low recurrence rate of intolerance. For example, only 30% of people will have the intolerance again if you give zanubrutinib. So your patient who has not been able to tolerate other BTKs, ibrutinib or acalabrutinib, surely can be given zanubrutinib because 70% of them will surely tolerate. And none of them became worse than the baseline. So to finish, this is from the NCCN guideline as such. Remember, summary slide. So zanubrutinib can be used as a first line in CLL and Waldenstrom's. It can be used as a second line in marginal zone lymphoma and mantle cell lymphoma, and as a third line in follicular lymphoma. So that's the summary of the whole presentation as such. So in conclusion, zanubrutinib has best-in-class selectivity with superior efficacy and safety with a strong activity across B-cell lymphomas as I just described to you. So take-home message is basically it's a balanced BTK inhibitor for long-term management, obviously for a patient who can afford it for a long duration. So that's the only problem we have. Thank you.
Thank you, Dr. Vijay. We now have a talk on expanding horizons in metastatic EGFR mutated NSCLC with combination therapies. I invite Dr. Bowman Dabar, Senior Consultant Medical Oncologist, Mumbai, to present his talk. This academic session is sponsored by AstraZeneca.
At the onset, I am thankful to the organizer, Dr. Vijay Patil, MOC and AstraZeneca for giving me this opportunity. Today I'll be just briefly discussing how the combination therapy has made a big progress in treating EGFR mutation non-small cell lung cancer in the metastatic setup. So this is just an introductory slide, which we all know that Asian population has a higher incidence of EGFR mutation, 40% compared to non-Asian, and the mutation that we generally see are exon 19 and exon 21, which are the commonest EGFR mutations that we see. And this is just to show you how the development has occurred. First time Geftinib was used in 2003 in a metastatic setup, and at that time it was a third line treatment. From there, after 10 years roughly came the game changer. More than 10 years later came the game changer, osimertinib. In between, we all know there was erlotinib, afatinib. Then came the game changer, the osimertinib. This was clearly a game changer because we saw in the FLORA study how it has shown a better PFS and overall survival compared to the earlier generation, gefitinib and erlotinib. Then after this, in this 2023-24, we understood how combinations have to be used. Osimertinib first came in a metastatic setup, then came the ADURA trial where we learned how to use this drug in the adjuvant setup. And now in the metastatic setup, we are trying to learn how this combination works, how combination therapy works in a metastatic setup. Although at the beginning there was a lot of optimism for earlier EGFR mutation drugs, gefitinib, erlotinib, but unfortunately none of them showed an overall survival benefit. It was just a PFS benefit. Till the FLORA study came, where osimertinib was directly compared with the previous generation, the erlotinib and the gefitinib, and there was, as you can see, a clear-cut advantage in PFS, overall survival, and most importantly, the CNS. If you see the PFS benefit of CNS involvement was much more than any of these. So we clearly know that osimertinib works much better for patients who have CNS involvement. But then why is the need for a combination when we know osimertinib? Here you can see major trials from US, Japan, everywhere it shows that 5-year overall survival with single agent osimertinib still continues to be in the range of 15% or 20%. Japanese, like us, have more EGFR mutations, so there may be a little bit more improvement in the median overall survival. You can see up to 20%, whereas major studies in US have shown. And here you can see at 3 years also, the osimertinib could only control in 50% of the patients, single agent drug. And hence the concept of combination therapy, the earlier gefitinib with chemotherapy came from a very own TMH study here, from the Narora study, where they had used gefitinib with pemetrexed, and there was a clear-cut improvement in median PFS. And another study also, a large phase 3 randomized study, showed that there was a PFS advantage when gefitinib, the earlier generation TKI, was combined with pemetrexed carboplatinum. So there the concept came, but unfortunately, gefitinib could not hold its ground when better drugs started coming in. And hence now we have osimertinib, which we showed in FLORA trial, clearly superior to gefitinib or erlotinib. So this is what is the FLORA 2 study. This is a large phase 3 randomized study where osimertinib was given as a single agent or osimertinib with PEM-carbo or PEM-cisplat. The study was very clear-cut, and you can see the inclusion criteria here. This was those who had EGFR exon 19 or 21, no prior systemic therapies, CNS involvement patients were taken provided they were stable disease. And here the primary endpoint was PFS by investigator and blinded independent committee review. And secondary endpoints were plenty, PFS, overall survival, and so on. The baseline characteristics of patient who received combination therapy, that is osimertinib plus PEM-carbo versus osimertinib, was well balanced, and here you can see they had included 40% of the patient who had CNS involvement were included in the study. Most of the time CNS involvement becomes an exclusion criteria in many of our studies. And here you can clearly see a PFS advantage when the combination was used, that is osimertinib with PEM-carbo was much superior to single agent osimertinib, the hazard ratio of 0.6, 8.8 months as per the investigators committee, whereas blinded in fact showed much more. If you see, it was 9.5 months. So a significant improvement. The hazard ratios were also quite in favor of a combination, 0.6. Both of them were 0.6, 0.6 and 0.62. And this PFS advantage was seen in all subgroups that were predefined subgroups were there, and it was seen clearly. And what I want you to see is here also, let it be exon 19 or little bit tougher, exon 21, L85, 85, the PFS was similar, irrespective of the mutation. Now let us see its close competitor in another combination study, that is the Mariposa study, where amivantanib plus lazertinib, this was another combination therapy which was used in first-line metastatic EGFR positive patients with lung cancer. And here it was, the inclusion criteria were very similar. They had also included patients with brain metastasis. And here amivantanab plus lazertinib, that was the Mariposa study. It was again a very large study, here you can see. And amivantanab plus lazertinib was compared to single agent osimertinib or single agent lazertinib. Again, in this, if you see the baseline characteristics were all well balanced. And here also there was a PFS benefit. The hazard ratio was 0.7 and there was a benefit of 7.1 by the blinded independent committee review. Well, we always say in a meeting that cross-trial comparison is not good, but inadvertently we go on doing it if we have to know which is better. So here also, this is a comparative trial, a graph showing comparison between FLORA and the Mariposa. Then FLORA, we saw the blinded independent committee review, the PFS advantage was 9.5 months. And here you can see hazard ratio of 0.62, whereas in the Mariposa, where two drugs which we are not so much familiar in using, amivantanab plus lazertinib, I don't know whether lazertinib is available, the hazard ratio was 0.7 and it was 7.1 by the blinded independent committee review. So it was, so I think so FLORA 2 really scored over Mariposa, at least statistically. This is just to show you that the PFS advantage was similar. Let it be exon 19 or exon 21, both were very similar, hazard ratios were very similar. Intracranial, those who had intracranial metastasis also, they were stable intracranial metastasis. The FLORA 2 shows a hazard ratio of 0.47, means there was a significant improvement of 11.1 months in the PFS if that patient had CNS metastasis. In fact, the tougher the disease, I feel this combination works better. Those patients who had CNS involvement, here you can see the complete response rates with the combination going up to nearly 50% compared to single agent osimertinib in the FLORA 2 study. TP53 we all know is a poor prognostic factor. Here also, irrespective of TP53, osimertinib plus PEM-carbo was nearly equivalent to those who had TP53 altered also. The hazard ratios you can see here were very, very similar. So TP53 no longer continued to be a poor prognostic factor if we use this. Similarly, those with liver metastasis or without liver metastasis, with liver metastasis when we see, we are always worried how many months or how many years our patient is going to survive here, but you can see if this combination is used, it was irrespective of liver metastasis, hazard ratios were similar, 0.66 versus 0.63. Even in patients with bone metastasis, the PFS was similar, those with or without bone metastasis. In fact, if you see here patients with bone metastasis, the hazard ratio was 0.6 versus without bone metastasis, it was 0.7. FLORA 2 said that the high tumor burden is more than 3 metastatic sites, and here you can see even in those patients who had a high tumor burden, more than 3 metastatic sites, the combination did much better than single agent. The hazard ratio was nearly 0.57 and here 0.75. So as I told you, tougher the disease, better this combination works. And now we have the updated overall survival. Here you can see at 4 years also, it continued to show a benefit. The overall survival benefit was significant. If you see, approximately 50% of the patients are going to survive at 4 years if we use this combination, which is a very good figure. When we started, when I was a registrar in Tata Memorial, at that time, the only drug I had was mitomycin and cisplatinum. That is the only drug we used to use for, and any patient even above 60 or 65 would come, and not in a good performance status, we would say just best supportive care. So from there, now at 4 years, we see 50% of the patients surviving with a metastatic disease. Let it be CNS metastasis, let it be bone metastasis, let it be liver metastasis we saw. And here we can see the overall survival benefit in most of the subgroups. Here I just want you to pay the attention that overall survival benefit persisted. Let it be exon 19 or exon 21, there was a significant benefit, whichever mutation was there. The Mariposa also showed a clear-cut benefit in overall survival, but what I want to show you, of course, this is a subgroup analysis which is not very much taken seriously, but here in this, if you see, those with L8585R exon 21 did not do so well as compared to exon 19 in the Mariposa trial. And here you can see at 3 years, if I am not, yeah, at 3 years the survival was approximately 60%. Here we saw at 4 years nearly 50%. Here this is just to show you this chart here, in this flow chart here, that irrespective of all these tough things that we see, CNS metastasis, EGFR mutation, circulating tumor DNA positive, liver mets, bone mets, TP53, everywhere the combination was better. And this slide is just to show you that the median duration when we use a combination and we give pemetrexed after 4 cycles as a maintenance, pemetrexed with osimertinib when we give as a maintenance, the median use of pemetrexed was only 8.3. So if you see the other part of it, there was a very long gap where we can still use chemotherapy once the patient relapses. And this is just to show you that when this combination was used and the first subsequent treatment a platinum drug could be used in approximately 45% of the patient, even when the combination was used, because the platinum free interval was very large. This is the updated safety analysis of this study. We all know the safety analysis. We have been using osimertinib and we have been using PEM-carbo. So there were no new safety signals. Even at the end of 2 years, a little bit more of anemia that was seen, which was maybe chemotherapy related earlier. But at the same time, again, the adverse events that occurred, most of the time they occurred during the induction phase and gradually they tapered off. And those are some of the adverse events that we see, rash, anemia, etc. This is just to show you the safety analysis of our Mariposa trial, where amivantamab and lazertinib were used together. Here, approximately 40% of the patient developed thromboembolic phenomena. Here, thromboembolic phenomena includes pulmonary embolism also. And 5% of the patient required anticoagulant therapy when they used Mariposa, when Mariposa study, in the Mariposa study rather. There were a lot of skin rashes also, and hence now there are treatment algorithms how to take care of these adverse events that come when we use amivantamab plus lazertinib. There is a very funny name Cocoon study also, where they have shown that you have to apply topical clindamycin. The NCCN guideline says that you have to use even anticoagulants when you are using this combination. And this is the NCCN guidelines, where we know we have been using osimertinib single agent for so long. So single agent osimertinib continues to be one of the best treatment options. However, for the hard to treat disease, which I showed you, those with liver metastasis, bone metastasis, brain metastasis, it's the combination therapy that we have to consider, and this is osimertinib plus pemetrexed or amivantamab, because both of them had shown an overall survival improvement. This is to summarize. Here you can see the combination therapy is here now with us to stay, and we should be aware of the side effects that come on the way. And we saw there was the FLORA scored over Mariposa in the PFS, so was also marginally in the overall survival also it showed. So first line osimertinib plus pemetrexed carboplatinum demonstrated superior overall survival versus single agent. Overall survival hazard ratio of 0.77. Approximately 50% surviving at 4 years. The median overall survival with osimertinib plus chemotherapy was 47.5 months, which is the longest duration known in a phase 3 trial. So these overall survival results from FLORA-2 suggest that osimertinib plus chemotherapy can be the first line treatment in EGFR mutation advanced patients who can tolerate this treatment. Thank you very much.
Thank you, Dr. Bum. We now have a talk on redefining treatment outcomes with adjuvant immunotherapy in renal cell carcinoma. Our speaker for this session is Dr. Udip Maheshwari, Consultant Medical Oncologist and Hemato-Oncologist, Mumbai. This academic session is sponsored by MSD.
Good morning, everyone. So, I'll be talking about adjuvant immunotherapy in renal cell cancer. These are my disclosures. MSD has provided me the slides, and so we'll be going ahead with the topics would be overview of RCC stages of RCC, the keynote trial, adjuvant treatment early RCC, and the safety profile of the keynote trial, right? So overview of renal cell cancers, we all know that it arises from the proximal renal tubules, origins within the renal cortex, and it is responsible for about 80 to 85% of all renal cancers. The most common type of kidney cancer in adults and occurs most often in men of ages of 50 to 70. So moving on to the RCC, it can be divided or classified rather as it's a new structured classification now: cytoplasmic, architectural, anatomic, specific disease background, molecular alteration based, and familial predisposition based. So the common ones are clear cell RCCs, and then the papillary RCC, which constitutes to about 90%, and others would be collecting duct, renal medullary, and SDS deficient renal carcinomas. So risk factors, we all know that there are genetic risk factors: the von Hippel-Lindau disease, the the hereditary papillary syndrome, there is the Burt-Hugh-Dupe syndrome, and the Cordon syndrome. So others are men are more predisposed than women. Family history of RCC is a risk factor. High blood pressure, obesity, increased frequency of smoking are the risk factors associated with RCC. 5-year survival rates, as we know, that for localized disease are good, up to 90%. Regional and distant metastasis disease are less than 10%. So highest in those which in patients who have a regional and a non-metastatic disease. So kidney cancer, some key statistics: it is the 15th in mortality, ranks highest incidence and mortality of kidney cancer in Asia, in the Asia region. Incidence is about 4.6, males more than females is what we see. The Globocon 2020 data also shows deaths more in male than females. One of the tumors which is more in males, right? So global distribution, again, Asia forms a big chunk of the global tumor burden of RCC, and it is represented in the with respect to incidence, fire prevalence, as well as mortality. Now, prevalence of RCC in available approximately 2 times in males. Again, we are reiterating the same thing. More common in geriatric population, age about 50 to 60 years is common. Clear cell RCCs accounts for about 70% of almost RCCs. Stages of renal cell carcinoma, we all know stage 1, 2, 3, 4, and the stages 3 will be where a vein or a node is involved, renal vein nodal involvement, and stage 4 is of course nearby organ invasion and a distant metastasis. So prognosis depends on histology as well. Papillary RCC would do well with a 5-year prognosis of 90% and survival rate, and a clear cell RCC with a 5-year survival of 70%. So definitely some research needs to happen to increase in RCC for increasing the survival. So TNM staging, we know that, I'm going over the slide, stage-wise management. We know that stage 1, we need either a partial nephrectomy or in selected cases we'll need a radical nephrectomy, sometimes even active surveillances for these cases. Stage 2 is again a radical or a partial nephrectomy, followed by adjuvant immunotherapy in cases which are high risk. Stage 3, again a radical nephrectomy followed by adjuvant immunotherapy. And stage 4, we have lots of treatment options, including systemic therapy, metastectomy, palliative therapy, ablative techniques. So adjuvant treatment in early renal cell carcinomas. Risk increases with stage. We know that for patients with stage 3 RCC, larger tumors have substantially high risk. Although surgery represents potentially curative option for locoregional disease, within 44 months, regardless of stage of diagnosis, 8% recurrence rates, 3% metastatic rates. So this is the need gap where how do we identify these patients as high risk and give them something different or something else so that their recurrences can reduce. So again, treatment is SOCs, partial radical nephrectomy. Risk factors would be, we know that the disease stage is one of the risk factors, size is the risk factor, nuclear grade is the risk factor, and regional lymph nodal involvement is a risk factor. So increased likelihood of disease recurrence with respect to these risk factors, and that is where we are placing Keytruda as adjuvant therapy. So RCC recurrence worsens the prognosis is what we all know, a big beak-like Kaplan-Meier graph. Adjuvant therapy improves outcomes. We all know that it does. A relatively high risk recurrence following surgery suggests that localized RCC patients may have increased micrometastatic disease at baseline itself, and this adjuvant therapy helps to improve or reduce these micrometastases and in the process increase DFS, OS. Targeted therapies such as anti-VEGF TKIs have provided impetus, like sunitinib in the STRAC trial has provided us with high risk features and the patients who can get benefited. But then their toxicity levels and maintaining those doses for entire year is going to be difficult, and that is where you have another need gap. So current adjuvant therapies is VEGF therapy, which we've spoken, and so that is why, with respect to tolerance issues and the meager betterment of PFS, that is where immunotherapy comes into picture. Targeting PD-1, PD-L1, CTLA-4 pathways has demonstrated significant clinical benefit with monotherapies or combination therapies in patients with advanced RCCs, and that is what has generated enthusiasm, in the adjuvant setting with respect to their durable responses. Now coming to stage 1A, again we've gone over this. Partial nephrectomy is the way to go forward. Stage T1B, again partial nephrectomy, radical nephrectomy in certain cases, and adjuvant therapy, we can keep them on surveillance. Stage 2, adjuvant therapy can be used in patients who have higher grade disease or high risk factors, and where adjuvant immunotherapy can be discussed post definitive surgery. Stage 3, again, mostly will have, in certain cases, partial nephrectomy or radical nephrectomy. In case of clear cell histology, adjuvant pembrolizumab becomes a category 1 recommendation for 1 year. Adjuvant sunitinib, which was initially a category 1, has moved to category 3 recommendation. While in non-clear cell histology, it's still surveillance, right? So Keytruda, we know the mechanism of action. It closes the back door for cancer cells against our own immune system, binding to the ligands PD-L1, PD-L2, and that is blocked. So reactivates PD-1 pathway mediated inhibition of the immune system, and including the anti-tumor responses. So indications: adjuvant Keytruda as monotherapy is indicated as adjuvant treatment of adults with renal cell carcinoma with increased risk of recurrence. So the keynote trial which had done this was the keynote 564, and which was as monotherapy of adjuvant treatment for patients with RCC at intermediate or high risk of disease, or patients who had M1, no evidence of disease, means completely resected M1s. So this was the schema of the trial: Keytruda 200 mg IV Q3 weekly versus placebo, and most patients post nephrectomy more than 4 weeks prior to the time of screening, no active immune disease. Obviously, all the exclusion criteria of any immunotherapy trial were there. So intermediate risk was defined as, this is a key slide, so intermediate risk was defined as PT2 with grade 4 or sarcomatoid N0, M0, PT3 any grade N0, M0. So this is what will be useful in our practice when we categorize these patients. Any PT4 or N0, M0, any P, any grade with node positive is going to be a high risk disease. And M1 disease, where metastaectomy has been done and there is no evidence of disease now, are the patients where we can give adjuvant immunotherapy. Baseline characteristics were mostly patients were more than 65 years of age, males were 71%, and mostly N0 disease was 94%, no sarcomatoid features in 84%. ECOG was 0 for 85, 1 for 15%. So DFS was the primary endpoint of the study. I think the European societies do agree that DFS is the primary endpoint, and they can design a trial based on that. So, considering a superior DFS, Keytruda reduced the risk of disease recurrence or death by 32% as compared to placebo. The events observed were 109 out of 496 with Keytruda and 151 out of 498 with placebo. Median DFS had not been reached for the treatment group, and the median follow-up time was about 23.9 months. So it definitely shows a separation of curve, early separation of curve rather, and definitely in RCC we've been struggling to have anything in adjuvant, and a trial showing such separation of curves is important, really important. So this trial again stating the p-value of 0.001. The median follow-up duration was 23.9 months in this trial. So again, for DFS Keytruda versus placebo, HR for DFS was 0.63. Events observed were 114 out of 496 versus 169. Estimated 30 months DFS were 75.2 with Keytruda and 65.5 with placebo. And again, so graph with this again showed a significantly separating graph with a good number of good hazards ratio of 0.63. The trial was not designed to look at subgroups. They were not predefined subgroups, so all these subgroup analysis may be taken with a pinch of salt. But we see most of them are in favor of Keytruda. However, many of them do touch the central line of equality. So again, going to patient-reported outcomes were also good with Keytruda. They've done FKSI DRS at 52 weeks and the QC30, the quality of life analysis at 52 weeks, and which was good results. The safety trial, the safety profile was also dramatically not very bad. Discontinuation of therapies were in 20% for Keytruda versus 2% for placebo as expected, and their death due to the adverse reactions was 2, that is 0.4 versus 0.2. Serious ADRs were 20% versus 11%. Discontinuations due to serious ADRs were 10%. So again, if we see treatment-related ARs, discontinuation due to adverse reactions was 17% for Keytruda. Death was 0 in both the groups, and serious ADRs were 12.1%. So again, this graph reiterates that grade 3, grade 4 toxicities were far less and few. Mainly, most of the any grade toxicities were more grade 1, grade 2. So immune-mediated adverse events more common were thyroid, hypo and hyperthyroidism, and pneumonitis were the commonest 3 side effects with respect to MS. So to summarize, the Keytruda as monotherapy is indicated for adjuvant treatment of patients with RCC at intermediate, high or high risk of recurrence, post-nephrectomy or following nephrectomy and resection of metastatic lesions. Intermediate risk is PT3 any grade N0 M0, PT2 with grade 4 or sarcomatoid features N0 M0. High risk is any PT any grade with node positive M0, T4 any grade N0 M0 or M1 no evidence of disease where metastectomy has been done. Keytruda reduced the risk of recurrence or death by 32% versus placebo, HR of 0.68. The median follow-up was 23.9 months, p-value being very significant, 0.001. Most common adverse events were fatigue, diarrhea, pruritus, arthralgia, hypothyroidism, and rash, reported more than 20% of patients in either group. And the immune-mediated reactions of any grade was 34.6% with Keytruda, 5.8% placebo. Grade 3, grade 4 was 8.6% with Keytruda and 0.6% with placebo. So moving on to a case, a 68-year-old man represents with 2 months of history of fatigue, lower back pain, and severe unintentional weight loss, had several episodes of fever in past 3 weeks with episodes of rigors, hypertension, medically controlled for the last 10 years, and was on 2 drugs, right? So physical examination looked good, BMI was okay, BP vitals were okay, hemoglobin values 11, WBC 11,000, platelets 2.37 lakhs, all electrolytes were normal. Ultrasound showed that there was involvement of renal vein with tumor, left renal vein was engorged with thrombi internally. CT scan again showed a huge 10 into 8.9 to 13 centimeter mass, heterogeneous enhancements, calcific contents in abdomen, para-aortic lymph nodes involved, renal parenchyma cells were not involved. Percutaneous biopsy showed a clear cell RCC. Again, this patient underwent surgery, adjuvant Keytruda for 200 milligram Q3 weekly, and at 9 months the patient has had a thyroid function which dropped. Suddenly he was put on levothyroxine. Patient was stabilized, again continued at 12 months, continued with stable disease on CT scan, and was successfully managed for 1 year with Keytruda with minor hiccups with respect to thyroid function. So I thank you for your patient hearing, and I reiterate that Keytruda is here to stay with respect to adjuvant RCC, and it's a drug which is now in our armamentarium for this bad disease. Thank you so much. Thank you.
Thank you, Dr. Udit. Towards the end of this session, we have a talk on the role of comprehensive genomic profiling, CGP, in solid tumors. To present, may I invite Dr. Feroz Ahmed, Head Clinical Genomics, Ahmedabad. This academic session is sponsored by Unipath.
A very good morning to all of you. Today I'll be discussing an important genomic portfolio test, which is known as comprehensive genomic profiling in solid tumors. So basically, if we look the evolution of molecular profiling over the last 20-25 years, so in early 70s we used to have traditionally PCR or IC based markers for diagnosing a case or identifying a certain oncogenic mutations. Then in late 70s, we found that Sanger sequencing was coming into picture, and wherein we could identify both Sanger, targeted mutations as well as unknown mutations. Then in next early 2000, NGS came into picture, wherein it totally changed the dynamics, and now we are looking at multi-gene testing, and slowly we are moving towards whole exome, whole genome, and also we are talking about long-read sequencing. So this shows that there has been considerable increment in terms of identifying different types of molecular markers in solid tumors. And that's how CGP has come into picture, wherein we want to identify molecular targets which can help us in deciding the treatment. So why this comprehensive genomic portfolio is gaining attention in recent time? Mainly because with one single test, now it is possible that you can identify multiple genetic alterations, whether it is base substitutions, insertions, deletions, copy number alterations, as well as fusions. And we have already seen success stories in lung, colon, and other tumors. So if you know, the power of CGP comes into picture, wherein you identify different types of markers. So a good CGP is basically a 500 gene panel which should contain both DNA and RNA. It should also give you NCCN guideline genes. It should give AMP tier 1, tier 2, tier 3 variants. It should also give in and off labeled drug information, TMB status, MSI status as well. In addition to these, there are certain CGPs which also give therapeutic resistance marker as well as MET exon 14 skipping, NTRK fusions, and HR and HRD. So the whole gamut of these molecular markers are now being investigated with a single test, which we are now calling it as comprehensive genomic profiling. So these are some of the important gene lists. Now it can be as big as a hotspot mutation. It can be also copy number variations, and there could be certain genes which are covered in a full gene also. And with respect to fusions and TMB, at least TMB panel should have at least 90 to 100 genes so that it comprehensively identifies the TMB status. So what an ideal CGP is that it should have reduced lab work. It should have minimal amount of DNA, because at times, especially in lung, the tumor is an issue wherein you get very less amount of DNA and RNA. In such scenario, your assay should be robust enough to do even with the lowest amount of DNA and RNA. And obtain molecular profiling, and then increase testing rate, as well as reduce the risk of rebiopsy. This is the ideal scenario wherein these are the combination of different approach. Now, before doing any CGP, it is very important to validate, because many different kits will say, okay, this is the sensitivity, specificity, or sometimes they will say these are the targets. So actually, one should always test these targets in the lab before implementing into clinical practice. For that, we have also validated this CGP, and wherein we have tested known DNA and RNA samples. We have used external horizontal controls. We have also used TMB FFP score and known MSI high and low stable molecules. And as far as the lab work is concerned, it takes around 3 to 4 days time right from DNA extraction to library. And then once your library is sequenced, you can analyze. There are a lot of automated analysis system which is being used in the lab currently. So this is a representative figure wherein you can see T53 deletion. The gap one indicates there is a deletion of 2 nucleotides over here. And what is important to see at the right side is that these are our control samples which were run with our CGP. And if you see, the expected ratio for allelic burden was 5% to 6%, and our frequency was almost same. So indicating that all of these assays have worked excellent in terms of sensitivity and specificity. This is a representative figure of NTRK fusion which is being investigated, and also TMB expected score was 12 and what we obtained was 12.32, indicating that again the observed value was matching closely with the given sample. And in addition to this, we also participate in external quality control system from European Molecular Biology, wherein if you see, both our panels have been passed as per certification received from the EMQ1 lab. And one interesting thing what we are doing right now, it's a very small attempt from our side, is that we also want to compare our CGP with the best in the industry, and of course Foundation One is one of them. And right now we are evaluating around 10 cases. We have done a head-on comparison with Foundation One. And this is one example wherein a case of 52-year male, soft tissue sarcoma, and these are their findings with on the left side was from Foundation One. And when we did the same sample, the same tissue, same DNA and RNA in our CGP, this is the comparison. If you see, the TMB, the microsatellite stable which was given stable by Foundation was also stable in our report also. Similarly, the TMB was low in Foundation One. Even in our case, it was low. ATM was identified in the Foundation One. The same was also identified in our CGP. CDK amplification was also reported in our case, and also MDM2. So there was almost 95% concordant between Foundation 1 and CGP which we used. And in addition to this, our CGP also gives HRR and HRD status, which was not covered in your foundation. So what I mean to say here is that this is a very small attempt, and right now this is an ongoing study. And we are enrolling sample across India. Any clinicians who is interested, we are more than happy to do their test, and this is absolutely free of cost. We don't charge to the patient. So this is basically to understand what is the performance of CGP in terms of best in the industry. And this, I would like to share some demographic data. We have done around 386 cases of CGP till date. The male to female was predominantly seen in our case. Median age was 64 years. And across 25 different solid tumors have been tested with our CGP. And if you look at the distribution of various tumor, so sarcoma, lung, breast, and ovary and biliary tract cancers are the most common ones which are being referred for CGP, followed by other tumor types. But I would like to mention that there is a trend towards increased referral for biliary tract cancer and ovarian cancer and pancreas, and what we see in our lab. And we wanted to understand which all the genes were commonly mutated. And as you can see from here is that P53 was the most commonly mutated gene seen in 125 times. Some of the cases, they showed multiple P53 mutations, followed by KRAS, PIK3CA, and other genes. So technically, T53, KRAS, and PIK3 were the most recurrent mutations which we identified in our CGP. And we also wanted to understand what are the fusion genes which we can see in our stage. So if you see, ALK fusion was the most recurrent fusion which we have identified, followed by TMPRS fusion. FGFR fusion was mostly seen in colon cancer, NTRK fusions, then STAT fusion, EGFR. Some rare fusions were also seen. So interestingly, the idea is that this test is very well validated for detecting even the rarest to the rare fusions. And these are some key signatures of different tumors. Of the sarcoma, again, ERBB2 amplification and STAT rearrangement was the most recurrent one as per tier 1 information. And in addition to this, we also identified some rare fusions, though in lesser cases, but they were quite significant. With respect to TMB status, 8 cases shows TMB high. The TMB high status is being given as per score of 15 and more, and intermediate was 1 and low was 37. Similarly, for lung, EGFR, of course, was the most recurrent mutation which we identified, followed by ALK fusion, ROS, and RET. And in addition to this, we also identified some rare fusions as highlighted in the right side. With respect to TMB, out of the 46 cases, 9 cases were TMB high, and average mutation per MB was very high for lung cases. If you can see 74 mutations. Intermediate was 3 and low was 33. Similarly, for ovarian cancer, ATM, again, ATM and BRCA were the most recurrent fusions, and we also identified EML4, NTRK fusions, and ETV6. And the average mutation per load for TMB for ovarian cancer is relatively less as compared to other tumors. And in breast cancer, again, as I saw that PIK3CA was the most recurrent mutation, followed by BRCA1 and BRCA2. P53 was again one of the recurrent mutation, and followed by ERBB2 amplification. And in case of tumor mutation burden, high number of cases were 3 cases were TMB high. In case of biliary tract cancer, pancreatic and cholangiocarcinoma, KRAS and P53 was the most recurrent mutation in pancreatic tumor, and TMB status was high for 6 cases. In case of cholangiocarcinoma, as per the literature also, P53, IDH2 and FGFR were the most recurrent mutations, and which was seen in these many cases. And TMB high was seen in around 3 cases. So this is, I would like to conclude my talk with one case wherein there was a female, 59-year female with complaint of abdominal pain. CT scans showed nodular thickening of the gallbladder. ISC results were positive for CK7 2019, and diagnosis was metastatic adenocarcinoma from gallbladder, or other possibility could be cholangiocarcinoma. So we wanted to rule out between gallbladder and cholangiocarcinoma, is there any molecular signature which we can identify? And for that, we did our comprehensive genomic profiling assay. And what we found that there was 2 key important mutations, KMT2C gene, P53 mutation, and ERBB2 amplification. And when we did a literature, and again, since there was ERBB2 amplification, we also validated these findings with ISC, and ISC showed 3+ positive. And that means it was a completely correlating with the result what we got in the molecular. And when we did a literature review, we found that KMT2, P53, and ERBB2 has been very well documented with cholangiocarcinoma. And based on the molecular profiling, the diagnosis was finally confirmed to be cholangiocarcinoma. So with this, I would like to thank you for your attention, and I would be happy to take any question if allowed. Thank you so much for your time.
Thank you, Dr. Firoz. We now continue our momentum with academic session 7, genitourinary cancers. I invite our session director, Dr. Bhalchandra Kashyapi, urologic cancer surgeon, Pune, and our session coordinator, Dr. Ashwin Rajbhoj, consultant medical oncologist and hemato-oncologist, Pune. I also invite our chairpersons, Dr. Devendra Pal, senior consultant medical oncologist, Navi Mumbai, Dr. Avinash Pujari, consultant surgical oncologist, Kolhapur, and Dr. Ajay Punpale, senior oncosurgeon, Latur, to kindly take their seats. We open this session with a panel discussion on challenging cases in uro-oncology. May I request our moderator, Dr. Bhalchandra Kashyapi, along with our panelists, Dr. Ashish Shah, consultant histopathologist, Mumbai, Dr. Chirag Desai, consultant medical oncologist, Ahmedabad, Dr. Karan Chanchlani, consultant radiation oncologist, Pune, Dr. Ganesh Bakshi, consultant uro-oncologist, Mumbai, Dr. Vipul Doshi, consultant medical oncologist, Solapur, Dr. Puneet Aluwalia, urologic oncologist and robotic surgeon, Gurugram, Dr. Rahul Jaiswal, consultant medical oncologist, Ahmedabad, Dr. Bhagyashri Khaladkar, consultant surgical oncologist, Pune, Dr. Manoj Dongre, hepatobiliary and transplant surgeon, Pune, Dr. Pratik Patil, consultant medical oncologist, Pune, Dr. Ashwin Tamankar, consultant urological oncology and robotic surgery, Pune, Dr. Harshvardhan Pokharkar, consultant surgical oncologist, Kolhapur, and Dr. Pooja Nandwani Patel, consultant radiation oncologist, Ahmedabad, to please join us on stage.
Thank you very much. I would like to thank the organizers of this Onco360 conference and Dr. Tushar Patil and Ashwin Rajboj for giving me this opportunity. I'm going to discuss challenging cases in uro-oncology. We have about half an hour, and we have an esteemed panelist comprising of medical oncologists, radiation oncologists, urology oncologists, and we have an histopathologist, Ashish, also. So I'll go through the first case scenario. This was a 32-year-old female, 28 weeks pregnant, presented with a right flank pain and a frank hematuria of 3 days duration. Ultrasound done initially reported a right adrenal mass of 6 centimeter size. An MRI was done in view of she being pregnant, and which reported a right kidney upper pole well circumscribed mass about 7 centimeters, likely to be neoplastic. These are the images. If you could see, there is an upper polar mass here. What would you offer for this lady? She is 28 weeks pregnant, yet to complete in her third trimester. What would you offer? And she has a frank hematuria. Ashwin? Can you give the mics, please? Yeah, Ashwin.
Hello. Yeah. So basically, the tumor will go in precedence over the pregnancy at this point of time. Not that we will be committed to aborting her or doing anything for that, but tumor will always go in precedence because of two reasons. One is active immature and fairly large size mass, which is very difficult for even active surveillance. So had it been a smallish mass, I would have probably waited till the pregnancy is over. So surgical intervention, preferably yes. And it looks like kidney mass, so there is no confusion between adrenal versus kidney. So probably a role of biopsy will be lesser.
Anybody for an angioembolization? She's very keen on her pregnancy.
Yeah, so that also depends upon her previous pregnancy history and
first pregnancy.
So with pregnancy, she has to undergo a lot of radiation.
Yeah, we will have to convince her for surgery.
Discussion. So she being a medico herself, these all questions were discussed with us.
So probably the thing will be safe on the tumor side, and we can have another pregnancy if anything goes wrong here.
So these options were discussed. So she finally agreed for a surgery. We did a upper pole partial nephrectomy. We were able to get away with a partial nephrectomy, and these are the specimens. And the final histopathology is a conventional RCC, clear cell RCC grade 2, no sarcomatid or rhabdoid features. The tumor is invading the renal sinus fat. It's PT3A, PNX. So the question here is, any role of adjuvant therapy in this young lady? Dr. Desai. If you go by the guidelines currently,
yeah, so T3 and X, we have to give adjuvant pembrolizumab. But my question to all the surgeons in the panel, and including you as well, Dr. Kashyapi, is that uro-oncologists are fond of NX, and we want, as medical oncologists, we want N to be categorized. So this question I have been raising quite frequently, that is there any specific issue in getting out some nodes along with surgery, because that might change the outcome prognosis of the patient.
So during this surgery, one of the prime concerns was also maintaining her pregnancy. Right. So she was given all those drugs for suppressing the uterine contractions and all that. So upper partial nephrectomy was done. There was hardly any tissue at the hilum. We did look for it, but then we said, okay, we should, so we did not have, so therefore the pathology is reported as PNX. Now, she subsequently, post-operative, she developed UTI for 2-3 days, two episodes, went to term, she delivered a healthy boy. Now, the question again still remains, obviously she was in no frame to receive any adjuvant therapy till she completed her delivery and the pregnancy. Now, it's about now, around 3 months after the surgery, a follow-up PET showed some residual activity in the bed, query inflammatory, we are not sure, no mass seen, anything. Now the question again is, any role of adjuvant therapy for this young lady with the current guidelines?
Sure, yeah. Adjuvant pembrolizumab for 1 year.
For 1 year, okay. It's been discussed. Will that, so the question next asked was, will that affect her breastfeeding with a pembro 3 weekly? I said I don't have a data, I'll have to find out.
I'm not aware of, but ideally not. I mean, she should
not. Okay, okay. A similar scenario, but a different scenario. This was a 70-year-old male, right mid-pole partial nephrectomy, minimally invasive, was done in May 23. It was a clear cell RCC grade 2, margins were clear. 2 years ago, he was kept on a surveillance. May 25, ultrasound in a follow-up showed a mid-polar mass. A PET CT was done. It's a solid mid-polar mass, almost occupying the mid and the lower pole of the kidney. He underwent a right radical nephrectomy, and the final histopathology now is a grade 3. Its tumor is seen involving the perinephric fat, but not beyond the Gerota's fascia. Pelvic health system is also involved. Not pelvic system, so PT3A. But perhaps there is a very clear-cut role for an adjuvant in this gentleman.
I think we should consider adjuvant.
Yeah, he's started on an adjuvant pembro. So coming to few questions on adjuvant therapy in RCC, indications after partial nephrectomy, after radical nephrectomy. Now, my question to the medical oncologist here is, after partial nephrectomy, we sometimes get a single margin positive or a sinus fat involvement there. Again, for these young patients, should we be offering a pembro with the data of Keynote 564, or is observation still an option? I'm saying a histopathology report.
Sir, if margin is positive, that means we have to do a resurgery, or we cannot leave.
Ganesh, do you have a different opinion about a margin positivity?
So focal margin positive, we observe the patient or see the grade in the histopathology usually. Grade 1, 2, or mostly we will observe only. At 3 months we would repeat a good imaging, maybe an MRI or something, and then take a call about margin positivity.
Yeah. So focal margin positivity is generally observed. We look at the grade also. There has been a lot of data retrospective.
Margin positive
Multiple focal margins, gross violation, yes. So whether you consider a completion nephrectomy, because people have done completion nephrectomies for these focal margin, and many times they have not found any tumor there. So current guidelines say recommend is observation and then reevaluate in 3 months' time.
So one small thing which I want to say, if it comes PT1A, less than 4 centimeters, up to 4 centimeters, but grade 3, that is not an indication for adjuvant pembro in the trial.
Yeah.
So that we should remember.
So
after radical nephrectomy, I think all our, we use the study-based inclusion criteria to decide the...
Yeah, these were the criteria which were used for the Keynote 564, intermediate high risk or any high risk, the adjuvant pembro was recommended. Going on to the next scenario. This was a 40-year-old male, hematuria 3 months, large left lateral wall mass, CT pictures are shown, obvious extravascular extension. Biopsy was high-grade TCC, muscle not identified. Question to Bhagyashri. Now, classically for a muscle invasion, we want a muscle invasion in a biopsy. In this patient, there is no muscle invasion. Should we be doing a rebiopsy?
So looking at the images, I think there is definite muscle invasion.
Yeah.
And so ideally he is a candidate for neoadjuvant chemo followed by surgery.
Yes.
So unless the medical oncologist insists on it, depending on the images, I don't think it's required.
Yeah, okay. Would anyone be considering a bladder preservation in this young chap? Medical oncologist, radiation oncologist, there is a lot of data now, and there is a, I might say there is a fashion to offer a bladder preservation, but perhaps, what's your opinion, Dr. Desai? Anybody? Radiation therapy, would you be offering, considering this chap for a bladder preservation? You have all the drugs available, he's affording everything.
So it's a controversy whether to go for surgery or to go for bladder preservation. Particularly in this case, there is a dilatation of the ureter, and that will make a point towards surgery rather than towards chemoradiation. But otherwise, without ureteric dilatation with muscle invasion, my opinion will be 70% for surgery, 30% for chemoradiation.
Okay. So you may say, okay, give a neoadjuvant and assess the response and then take a call at that time.
Sir, but data sake or study sakes, we see a lot of presentations where we equate surgery with radiation therapy in bladder cancer, especially surgery, radical cystoprostatectomy with bladder preservation. So it should be very clear in the forum that
it is not equated.
Selective cases are much better only for bladder preservation. You should select well, as sir has just said. The things are problem, and the results are not the same. surgery, I would
So
still say
many
is
times the
immediate
patients
superior.
are given the impression bladder preservation is equal, but if you look at the long-term result, there is a 20 to 30% chance of recurrence by 5 years. Maximum recurrences occur in the first 2 to 3 years, so that should be made very clear to the patient. Sometimes they are not aware of it.
And then one small comment was, we always talk about evidence about NACT and surgery. With bladder preservation, we never talk about NACT and bladder preservation. What we talk is sensitizing chemotherapy.
Sensitizing
which is
chemotherapy.
totally different. So about 3-4 months back, we had a discussion in Mumbai in a larger forum. We said that with the AstraZeneca study, we should really have a NACT in all these patients of bladder preservation and then start bladder preservation.
Yeah.
So as a radiation oncologist, I would like to make a comment. You know, we have been always been the ones to be blamed for, but in agreeing with all the panelists here, whenever we go for any bladder preservation protocol, especially the TMT, we have to be very sure enough that the patient selection is a very important criteria. We have to make sure the patient we have taken is having at least maximal TURBT, doesn't have any hydronephrosis, has a good bladder function. Those are the patients who can really be helpful with the...
Not this.
Not this.
Yes, okay. Okay, this patient declined neoadjuvant chemotherapy, underwent a cystectomy and ileal conduit. Nodes positive, multiple nodes right, left and the right side. There was a transmural involvement. So final histopathology was PT3B N2 M0 high grade. The question now I am coming to is any adjuvant therapy here. And what kind of an adjuvant therapy would you? In general, now this is a question. So all patients, selected patients, chemo, currently IO, RT, both, combination, duration of therapy.
So I will want to give him both chemo as well as immuno-oncology therapy.
Okay.
Patient declined neoadjuvant chemotherapy.
He declined neoadjuvant chemotherapy.
Patient might decline the adjuvant chemotherapy as well. So in that case, if the patient declines adjuvant chemotherapy, I will go with only nivolumab. But otherwise, I will want to give the patient both adjuvant cisplatin-based chemotherapy as well as nivolumab.
How about a radiation therapy?
So I think in this we are very pretty clear there is no role of radiation, adjuvant radiation.
There is no role of adjuvant radiation?
No.
Even with your current trial?
No, we have a BART trial which is almost published and there
It's
is
almost
advantage of radiation therapy.
Okay. So various factors to consider: histopathology report, T and N staging, whether he received a neoadjuvant or not, how has he recovered after the surgery, comorbidities and everything. So this is a rough chart which says based on the prior neoadjuvant chemotherapy and the prior stage of the disease, clinical stage and node positivity. So I'll skip this and go to some about the radiation after cystectomy. Ma'am, could you elaborate us when would you give, when would you not give, and the duration?
So of course, there are papers which advocate for radiation, adjuvant radiation after cystectomy, but this is really very controversial. In bladder, I think as a radiation oncologist, my foot would be only for the cases, very selective cases for the TMT protocol. Otherwise, adjuvant radiation has been not that much helpful. As far as the dose of radiation is concerned, it's an adjuvant radiation dose we are considering where we give initially phase-wise, we first to the tumor bed volume 50 gray, then coning down, but not more than 60 gray. So that is what the adjuvant protocol we follow.
But this BART trial which has been published now, and there is a good data on that which is showing a definite response. Okay. Similar, on the same topic of adjuvant therapy, few short cases and quick responses from anybody of you. Muscle invasive bladder cancer, clinically T2N1, M0, cisplatinum eligible. Received 3 cycles of GemCis, cystectomy done. Now there is a no residual disease. Any adjuvant therapy?
No, sir.
Okay. Second scenario, same patient receives 3 cycles, but he has a residual disease, but margins are free. Any role of adjuvant therapy in this patient?
YPN1, right?
Yes. By P2N1, sir.
T2N1, yeah. But T2N1.
There is a residual disease, but margins are free.
Adjuvant nivolumab, yeah.
Adjuvant therapy, yes. Nivo you would consider. Okay. No role of radiation here. The current BART trial is recommending a radiation in this scenario. Okay. Next scenario. This chap is cisplatinum ineligible but platinum eligible. Received gem carbo 3 cycles, residual disease. Now what?
All the more reason for giving adjuvant nivolumab.
Nivolumab. Okay. Now this chap.
Before we, just a
Yes,
second.
yes.
Now we have data for neoadjuvant.
Durvalumab.
Niagara trial. In which both cisplatin as well as carboplatin are allowed. So patient would better have given neoadjuvant durvalumab.
I am not going into the details because of the lack of time. So scenario where this chap has received a Pembro neoadjuvant and no residual disease. Now again a question.
Anyway, I'm not sure about this particular trial of pembrolizumab. There is some data.
No,
but
some people, I have seen some patients who have been given a Pembro before this your durvalumab trial came, Niagara trial came.
This is an excellent result, and I think I will want to complete 1 year of pembrolizumab. I'm not so sure about the trial data, but I will complete 1 year of pembrolizumab.
Okay, let's move on to the next scenario. I think so. This was a medical practitioner diagnosed in 2015 with a metastatic CA prostate. 78 PSA, multiple pelvic nodes, few pelvic skeletal lesions, adenocarcinoma Gleason score 3+4. An orchidectomy was done. He was given 6 cycles of docetaxel and was started on abiraterone. This was about 11 years ago. He did well with low, almost nadir PSA values until 2020. So 5 years down the line, he showed a PSA rise with uptake only in the prostate on the PSMA scan. Was given a local radiation to the prostate in 2020, and the abiraterone was shifted to enzalutamide. Was this approach okay?
I think at this moment of time, having given radiation to the prostate, depending what the PSA value would have been, but if I would have been treated, I would have given radiation to the lymph nodes as well at that point.
Lymph node also. Okay. So, but he was given, based on the PSMA PET scan, he was given only radiation to the prostate because there was no other disease seen on the scan. Yeah, and the PSA was in the range of 2.2, 2.3. And abiraterone was shifted to enzalutamide. Is that okay, Dr. Desai? He took abiraterone for nearly 5 years and then was shifted to enza.
Yeah. So in this particular situation, we will not have any phase level 1 evidence, no randomized phase 3 trial. But with such a long remission, this is a good approach.
So docetaxel re-challenge can be also thought of at this point of time?
So we'll come to that. So he was shifted to enzalutamide. PSA remained for 5 years. Until 5 years, the PSA now has come back to 3.4. PET CT showed only pelvic lymph nodes now. This was in January 2025. I can show you the picture. The only pelvic, if you look at this picture, the first picture, these were the only pelvic lymph nodes seen. And he was given a radiation now, not in 2020. So nearly 5 years later, So again the PSA in August increased to 14 and was given a re-challenge with docetaxel because it was nearly 8 years since the first, nearly 9-10 years. He could receive 3 cycles, started getting GI toxicities. So in November this was stopped. Currently his PSA is 18 and there is a new PET CT which shows persistent pelvic and retroperitoneal nodes and one small bony lesion has come up new. Let me show you the picture. One small bony lesion. And so options now are 11 years since diagnosis. He has received most of the therapies in fairly good performance status, still practices. He has received orchiectomy, docetaxel, abiraterone, enzalutamide, prostate radiation, pelvic radiation, docetaxel re-challenge. Now what do we offer? And this is the current scenario. The last picture on the right side is what do we have to offer now?
Can we offer PRRT? We can offer, the age is also, I think.
Yes, 63, 64 now.
Yes, 69.
Anybody else? Any other thoughts? Any other thoughts on this?
Biopsy and rebiopsy.
Biopsy of the nodes and NGS. It was done, didn't give any clue. Now, so PRRT is one option. So cabazitaxel was another option discussed. Not very keen to receive a cabazit because with a docetaxel re-challenge he had a significant toxicity. He is not very keen on that. So PRRT has been discussed. So my question is actinium or lutetium? It's predominantly nodal disease.
Lutetium, because it's relatively less toxic and I can use actinium later as well in case he fails on lutetium. So that's the point.
I brought this case for discussion today with all you experts. So I said, let me get an opinion from the experts and get back to you.
So it's all about sequencing, right, sir? That's the whole reason that sometimes, just to clarify in the forum, sometimes people ask PRRT even before docetaxel, which may not be an optimal choice because that is going to get the bone marrow down.
Currently, there are people offering PRRT on day one.
Yeah, so probably
I'm not sure whether that is the right approach. That might compromise the receipt of chemo later also. Okay, fine.
But surely we will go for the genetic test first.
Genetic test.
That is positive. I will give a good trial of olaparib. That's first thing.
If anything we get in
if
that.
HRR is
yes, HRR positive.
Yeah. But otherwise, the vision trial is there comparing carboxylaxel versus lutetium. Lutetium is better than
lutetium is better than.
Plus the biopsy might be revisited for MSI testing and pembrolizumab.
Yeah, all testing will need to be done on that. Okay. A final case perhaps. This was a 36-year-old male, slow urinary stream since few months. Ultrasound showed a chronic urinary retention. Prostate was enlarged prostate, raised bladder neck. The urologist thought perhaps it's a bladder neck obstruction. He took him up for a surgery, but it showed a fluffy tumor from the prostatic urethra and bladder neck area. This was initially reported as a high-grade urothelial tumor. It was sent to Ashish and the group for a review. They reported as an embryonal rhabdomyosarcoma. He is 36 years old. Took 6 cycles of standard chemo. Current scenario, his retention has gone, his voiding, prostate has shrunk. I'll show you the images now. Now these are the images, if you look at it. On the left hand side of the screen are the pre-chemo images. There is a reduction in the size. Similar picture here. Now my question is, for this 36-year-old, what do we offer? Ashish, first question to you. Do this rhabdomyosarcoma in an adult, will it behave like a pediatric embryonal rhabdomyosarcoma?
This is a relatively uncommon situation
Uncommon.
because we see embryonal RMS in a relatively younger.
Correct. He is 36 years old.
20 years of age, we see such tumors, but in a 36-year-old male, it is relatively uncommon. I cannot tell the actual.
Verified by 2-3 people. So my question was the principle in pediatric RMS is organ preservation. So what do we do for this chap? He is 36 years old. Surgery or radiation?
So practically speaking, surgically only prostatectomy looks little difficult in terms of overall response. I would want to examine him under anesthesia and then take a call. If cystoprostatectomy can be still offered, I would probably discuss out with that and ask him whether the survival is a priority or bladder saving is a priority, as in the cystectomy.
Anybody for only radiation therapy? Ma'am.
It's a very tricky case, but I think I would agree with him. I would put the ball in the patient's court that what he would like to have, because this is very uncommon. I don't have enough literature also to support.
Yeah,
him.
there is not much literature on this.
Yes,
Ganesh,
so-
what would you offer?
So
Maybe initially at least and see the report. It's difficult because if you
Surgery
follow the
what?
pediatric data, it is
Cystoprostatectomy
radiation
or only a radical prostatectomy? Or radical prostatectomy followed by an adjuvant radiation, because perhaps the margins would come as positive.
We'll have to consider this out of the box case, because ERMS in pediatric age group is totally different management. So if he has completed family, married, everything, then
One child, he is 36 years old.
it's very young.
Obviously, functional preservation is also important for him.
Agreed.
Dr. Desai, you have any thoughts?
Extrapolate from the pediatric data, and we have to follow that protocol. Neoadjuvant chemotherapy has been given with good response. Now
The protocol is a radiation now, as per the pediatric, and followed by continued chemotherapy.
Exactly. Radiation followed by chemotherapy.
Okay. So I think perhaps that's my last slide. And we are going to personalized medicine, and I would like to thank all of you for an active participation. Any other questions you want? I think we are before we finished well in time. Anything else you want to discuss? So could you take the mic, please?
Regarding robotic surgery for radical prostatectomy.
Yes, sir.
I wanted to know because many patients ask
So currently that's the stand. So basically, prostatectomy we have to understand as an oncologist. Prostatectomy is something which is important. The tool is not something which is the desperate consideration. Anyone who does good open prostatectomy and someone who does good robotic prostatectomy, both the outcomes should be fairly in long term doing well. That should not be concerned.
Ganesh, you want to add anything to the robotic prostatectomy?
Data-wise, there is no published difference, but all over the place, like we have shifted ourselves to doing robotic radical prostatectomies. Somehow the vision, the magnification, the dexterity,
the recovery is
with
also
the robots
faster.
And the recovery, like you can
minimally invasive being recovery is also faster.
Patient even next day morning, the patients go on full diet on the same day, which was never happening in open surgeries.
Okay, then.
There are people like once in twice in a year they will ask you why robotic surgery, why don't you do open surgery? So today I tell them that before I left Tata in 21, we used to do 2-3 per year just to show the residents, even though we had a robot. After that, after I joined a private hospital, we have just stopped doing open RPs. Cystectomy is still fine.
Okay, I'd like to thank all my panelists. Thank you very much, everybody. And thank you all the delegates.
Thank you.
Yeah,
to
you
our
have a
moderator.
question? Yeah. Yeah, you can ask. Go ahead.
Mic, sir, mic.
So see, I'll tell you, the original surgery described radical nephrectomy was a lymph node dissection right from the crux of the diaphragm to the aortic bifurcation. With data flowing on, there is a randomized trial for RCCs till 5 centimeter of size. I think EORTC 30884. So that says till 5 centimeter lymph node dissection is technically not necessary. The study said no advantage. Beyond that, what we do probably is when we see abnormal nodes intra-op or on the imaging, we do a lymph node dissection which is limited. In radical nephrectomies, personally, I do a small lymph node dissection, not
At
from
the
the
hilar.
crux to the aortic bifurcation, but around the hilar lesion. I always
Majority
have
people
nodes
have
in
given
my
up dissecting from the
HPR.
crux up to the iliac bifurcation.
Yes.
It's a
And-
hilar dissection which is done and any obvious nodes.
And
seen
bigger
pre-op.
mass, lot of necrosis, nodes seen in the pre-op CT, I would still counsel the patient, I'll do a good lymph node dissection. But good lymph node dissection will not be then only hilar, it will be intra-aortocaval
Yes.
probably also. Because the drainage from both sides go here, there.
So there is an advantage of doing a good lymph node dissection with enlarged nodes. Otherwise, their local recurrence reduces. And sometimes they get adherent to the vessels or to the posterior abdominal wall. Resection, removing them is difficult then later on.
And what happens is many people don't do a lymph node dissection, as sir said, I know that. It takes a little good time, it takes a little good patience, and we really have to clip a lot probably to stop all the lymphoria which is going to come out.
Adds another half an hour to the surgery. That's fine. No.
So with these indications which we discussed, I think it is justified. Where it is not, then we don't do.
Obviously, you would not do with a gross nodal disease. Extensive nodal disease, there is no point in doing an extensive nodal dissection. You would need to give an, perhaps in the current scenario, he would go on a neoadjuvant therapy and then only come up for a surgery. Yeah, Jay.
For the small size tumors, I do agree. So only gross ones are there. I think any tumor which is say more than 5 centimeter, I think irrespective of whether imaging is showing nodes or not,
should do.
I believe we should complete the template because now with the immunotherapy coming and having role in decision making, if the nodes are positive or not, I think there is no excuse for not doing it.
There would be a revived interest in doing that. Okay. Let's close this session. Thank you.
Thank you, Dr.
everybody.
Kashyapi and all the panelists for that excellent discussion. We now have a panel discussion on CDK4/6 inhibitors in high-risk HR-positive, HER2-negative early breast cancer, patient selection, treatment benefit and management of side effects. To moderate this session, may I request Dr. Shailesh Bondarde, Consultant Medical Oncologist, Nashik, and our panelists, Dr. Nilesh Dhamne, Consultant Medical Oncologist, Kolhapur, and Dr. Ravi Vategaonkar, Consultant Medical Oncologist, Pune, to join us on the stage. This session is sponsored by Eli Lilly.
So, good afternoon. First of all, let me thank the organizers, Tushar and team, and also thank Eli Lilly for giving me this opportunity. So, we have seen a lot of changes happening in the recent past as far as the adjuvant space is concerned, and at least for last 2 decades, there was only aromatase inhibitors there, and nothing was really happening. And suddenly, we have now CDK4/6, now we have oral SERDs also coming up in an adjuvant. And to discuss this, I have my esteemed panelists, Dr. Nilesh Dhamne and Dr. Ravi Vategaonkar, and they will, we all will discuss and try to learn the newer aspects of treatment in adjuvant space. So, Dr. Nilesh, can you just take this, I mean, just to set the ball rolling, what according to you in an early breast cancer would be the high risk patients?
So generally the T3 disease, like having the tumor size more than 5 centimeter, the nodal disease, N1 disease, generally they are the high risk of recurrence. Okay. Or we may add grades, the poorly differentiated grade 3 ones, or we in the definition of Ki67 more than equal to 20%, they would be carrying the higher risk of recurrence.
Ravi, do you consider genomic testing for assessing the risk stratification? You know, these are mainly the clinical parameters and histopathological, but do you go at the molecular level to find out whether these patients are at a higher risk? Though, you know, for at least for the study which we'll be discussing, Monarch, they did not consider it. But in your practice, do you consider doing the genomic profile, doing MAMAprint or doing Oncotype DX and so on and so forth, just to find out whether there is a high chance of relapse in these patients, and whether would you like to add CDK4/6 to these patients or do some aggressive treatment for these patients?
Okay, so for node negative patient, I routinely advise them, and for node positive disease, probably node more than 4, I don't advise them, but for node 1, 2, 3, probably yes, I explain them about chemotherapy, but for all patients node 1, 2, 3 positive, I counsel them regarding Oncotype DX or MAMAprint.
Dr. Nilesh, in your practice, how large tumors do you see? I mean, depending on the size, you know, say T1, T2 or T3, what percentage of those size patients do you encounter in your practice? The more than 5 centimeter or more, or you know, you come across with smaller tumors as well?
No, most of the, like 50%, more than 50% will be T2 and above. So I would be seeing around 5 to 6 centimeter, quite common. We don't see the smaller size tumors. They may be the screen detected, but the most of the been referred for neoadjuvant are those, I would say, they are large size tumor, like more than 5 centimeter would have a N1 disease or fixed N2 disease.
And for all tumors, do you routinely do axillary screening with ultrasound or something to try to find out even the smallest possible lymph nodes which can be seen? Because if you're going for neoadjuvant, then your picture might change later.
Yes, so bilateral breast mammogram for staging to pick up any nodes, and if required, may take a sonomammogram to put the exact staging. Yes, so for all patients get a sonography guided staging.
Dr. Ravi, can you take this? Do all node positive patients with HR positive, HER2 negative early breast cancers have the same risk of recurrence? So you might be having a 1 node positive versus 4 node positive versus 12 node positive. So do they have the same risk, or you want to have additional tests in the form of stratification or clinical parameters, other parameters or histological parameters to say, that even if they are I mean, either less nodes positive, but they are high risk.
Okay, we all know as number of nodes increases, probably risk of relapse increases. But apart from nodal status, probably for node 1 to 3 node positive patients, I look for size of tumor, then grade of tumor, and Ki67. Because high Ki67 is again one of the important risk factor where chances of relapses increases. Again, tumor size more than 5 centimeters is also a risk factor for early breast cancer.
So all those which have high risk, even if the nodes are less in number, I mean, in this slide has shown that, it is as bad as the triple negative patients, which we all know that they are aggressive, triple negative, the chances of relapse and metastasis are high. So even if the lymph nodes are less, but if they have a high risk features, like you said, in the form of tumor size, grading, and even Ki67, so if these are high, having a poor risk factors or high risk factors, their prognosis is bad, and in many studies it's as high as 25 to 30% of the patients are going to have metastasis or relapse at the end of 5 years. So even if the nodes are less, but they have a high risk features, I mean, they are as bad as tumors having 4 node and above, which we know has a poor risk and poor prognosis. So even if less nodes are positive, but they have a high risk features, the chances of having metastasis and recurrence are high. Now, that's a $1 million question when we talk about the hormone receptor HER2 negative breast cancers, because now we have so many options, and even if they relapse, you still have so many other options which are available. Most of the options have a good PFS, so we expect a long time to really get a survival. Because even if this patient develop metastasis, then again it depends on whether they are endocrine sensitive or they are endocrine resistant. Your line of management might change. You have so many other hormone therapies at the end of treatment, followed by chemotherapy, and TDXD again coming into the picture in this scenario also. So we expect that these patients are going to have a long overall survival. So according to you, Nilesh, what is the importance of having OS? We talk about in metastatic also, when we talk about palbociclib and other drugs, abemaciclib, ribociclib, we say, PFS is good enough. In triple negative, we want to have an OS because the survival is less. But in HR positive, we are okay with PFS also. But when you talk about OS, I mean, how important it is to have an OS, and how difficult it is to get an OS in an HR positive, HER2 negative, early breast cancer, where we are thinking of the patient surviving 10 years, 15 years, 20 years, so on and so forth.
So as you correctly highlighted, they will have a longer course. They will have late recurrences, maybe after 5 years. So what we want to highlight that they should not recur after 5 years, or we could prolong that recurrence which is bound to come. So yes, OS is important. The delta which we will be looking maybe 2%, 3%, because in a patient who is hormonal positive early breast cancer, who has received chemotherapy, either neoadjuvant setting or adjuvant, who has done a good surgery with lymph node dissection, if required adjuvant radiation. After hormonal therapy in current era, let's say AI or maybe tamoxifen, adding any therapy, the delta which I will be aiming will be 2 to 3%. So it's difficult to get that OS, too difficult in predefined conditions in a trial setting. But yes, I still feel OS is important. And you say, what is the delta, Nilesh, you will be looking? Even a single digit 2 to 3 with the current scenario standard of care, I will be happy, I will take that.
Ravi, do you differ on that, or you have some additional comments?
No, I agree with Nilesh. My concern is safety of whatever treatment we are giving. and duration of treatment. I feel duration should be finite and toxicity should be acceptable. So I am okay with any delta, single digit delta, 2 to 3%, I am okay with it. And we all know early breast cancer is chronic disease and there are various factors they alter overall survival. So I am okay with delta of 2 to 3%.
So these are some of the historic landmark trials in the adjuvant treatment, where tamoxifen was used. I mean, that was the first drug which really came in an adjuvant setting. And we, at the end of 15 years, got a single digit. I mean, you can see that all are in single digits. But the duration of getting that data might be too long, really. I mean, you may not be able to really say it today. And the best, I think the sentence or the word the statistician use is the OS is still maturing, So I mean, they're still going to go on following. So that's what they routinely use the sentence, which I really like it. So these are and then the last one is obviously the soft and the text trial, where that more than 10 years follow-up gave us a very small digit of overall survival. So Nilesh, your take on the OS data of Monarch E, and if you can just summarize the study in short.
So as we see, hormonal positive early breast cancer bound to recur late. If anything, we can add to improve. So we had a molecule abemaciclib, which we had shown a consistent benefit in metastatic setting, advanced. If you could have tried in early breast cancer in an adjuvant setting, curative, will that really help? So the study was conducted. The patient continued the hormonal therapy of their choice, either tamoxifen or AI. AI may be letrozole, anastrozole, exemestane, steroidal or non-steroidal AI, with addition of CDK4 inhibitor abemaciclib for 2 years. The patient who required OFS, they will continue to have ovarian function suppression. So this was a study design. The initial primary and secondary endpoints were, first was, as sir said, DFS, disease control rate, disease-free interval, disease-free survival, and will that really turn out to be overall survival? That was the initial. The first, the patient in a study arm required to take abemaciclib Ramivan in the dose of 150 BD, and the first dose reduction was 100 BD, as diarrhea maybe was some initial concern. But at the end of 2 years and the further follow-up 5 years, continued to show DFS benefit study versus the control arm. So they initially showed a good DFS to the tune of single digit, and it maintained till first 5 years. Now we are coming across 7-year data. So the disease-free survival is maintained for the study arm. Now OS, as we already discussing, the data is still mature, 7 years. Are we really ready to comment, take that 2-3% delta? But I would say as of now, early breast cancer, curative setting, DFS is what we are, let's say, take on this, and DFS is still maintained for the, so what we got in first 2 years is maintained till next 7 years.
So Nilesh, you are not, you have summarized it so well that I don't have any further questions actually to discuss. so that's very well summarized by Nilesh. Ravi, Dr. Ravi, anything different in Natali as compared to Monarch E you would want to highlight?
Okay. So basically in Monarch E study, they enroll patient with more high risk factors like more than 4 node positive, or those with 1 to 3 node positivity with high risk features like tumor size more than 5 centimeter or grade 3. In Natali, they enroll node negative group also.
Correct.
Node negative with grade 3 patients or tumor size more than 2, and all node positive irrespective of risk factors. So probably in Monarch a subgroup where little bit they have more high risk as compared to Natali. So when looking at results, probably abemaciclib has abemaciclib showing improvement in IDPS, IDFS, and overall survival in high risk group as compared to. We can consider abemaciclib in very high risk group as compared to ribociclib.
So you have an option for N0 there. Also, the drug was given for 3 years. And
Yes.
number 3 is there was no tamoxifen. All patients had to undergo ovarian suppression in case they are premenopausal with AI, and no tamoxifen in that. It's all were supposed to take aromatase inhibitors in that. Nilesh, I think you already highlighted about the 7 years sustained IDFS, and what is important to see is the treatment is given for 2 years, but even once the treatment has stopped, the graph is still going apart till 7 years and looks like it is going apart henceforth as well. So that is something that the active drug has been stopped long back, but the efficacy of the drug is maintained. Dr. Nilesh, are you okay with disease relapse-free survival or IDFS?
As you correctly highlighted, sir, in this...
If the patient doesn't have disease, if the patient doesn't have relapse, fine, that's okay. At 7 years, everything is fine.
Quality of life maintained, he's psychologically, emotionally well, and at present OS may not be the end point, I agree. So we can take DFS as one of the marker that the experimental arm is working. So I agree, the DFS is a sufficient marker to take the treatment.
And you have less metastatic disease surviving on abemaciclib, you have more on the control arm, so obviously less and less patients are progressing. So overall this chart looks good. Dr. Ravi, can you take this as a, what are the guidelines recommendation for abemaciclib in an adjuvant?
So hormone positive, HER2 negative breast cancer, early breast cancer, more than 4 node positive, and those with 1 or 3 node positive, they have another high risk factors like grade 3 or a tumor more than 5 centimeters. These are recommendation for adjuvant abemaciclib.
So Monarchy had a second arm also, cohort 2. Yes. Cohort 2 was with Ki60. That's, I think, hardly 9% or 8% of the patients were on the second arm as well, cohort 2. So those are the recommendations as far as the ESCO guidelines, but most of the guidelines do recommend an adjuvant CDK4/6. This is our own ISMPO guidelines. Again, the guidelines are the same in line with the NCCN guidelines and ESCO guidelines. So dose reduction, what about the adverse events? Dr. Nilesh, are you comfortable with the managing the adverse events of abemaciclib? We were used to treating it in a metastatic setting. What about in an adjuvant, and for such a small, OS still not really significant, is it okay to use a drug which is toxic and causes adverse event, or the adverse events are manageable?
So whenever it came in Indian scenario, the first concern was the diarrhea, and most of the healthcare providers say it could be worrisome in Indian population. That was maybe assumption. My practice went and like 3 years using diarrhea. I feel is manageable. It's 20%. Most would have a grade 1, grade 2. Yes, I have few patients in adjuvant setting required first dose reduction 100 mg BD. Metastatic setting they manage well. So I see, and bone marrow suppression also not so toxic. I feel adverse event for this Ramivan in adjuvant setting are manageable. I feel yes, you may get dose reduction. However, we got a data with 100 mg BD also, the efficacy is quietly maintained. So it's a non-inferior with 100 mg BD also. So if we feel the diarrhea is troublesome or bone marrow suppression, because patient would already receive chemotherapy in adjuvant setting, so bone marrow suppression can be a concern. So you may get a dose reduction, but I think they're manageable. What I feel.
Okay. So I don't know how.
Regarding diarrhea, probably these diarrhea are for a few days only.
Correct. I was going to come to that. In my experience, we have seen that in 15-20 days, it's slowly the patient gets adapted to it, and then the frequency of stools reduces. But I don't know how many of us have really used niratinib. I had an opportunity to use in Nefertiti study, and the diarrhea in niratinib is too horrible. I mean, it's very difficult to manage. I mean, that's so compared to that, I think abemaciclib diarrhea is nothing. I have seen some of the people not starting with 150 but starting with 100 and then trying to escalate or down escalate. Your take on Dr. Ravi?
Sir, I feel abemaciclib is not that toxic, so I always start with 150 mg PD. And for severe diarrhea or probably severe neutropenia, I will reduce to 1 dose reduction or maximum 2 dose reduction. But again, this trial is showing with dose reduction, there is no compromise in efficacy. So I'm compatible with dose reduction also now.
So actually there is some data for number to treat the patient. I mean, there is some short form of that. I mean,
NNT.
And something like that.
Number
I mean, you can take that.
to come some statistical significance, NNT.
Yeah. So I mean, they have seen that 25% of the patients are likely to relapse in as per the Monarch E data. I mean, the patient number, the criteria for Monarch E patients they had taken. There is a 25% chance that those are the patients who are likely to get a disease back in 5 years. And of that, 1/3 of them get benefited if the patient is put on abemaciclib. So, 8 out of 24, 25, that's around 33% of the patients gets benefited as compared to Natalie, where the incidence is, the number is much less. I mean, so the benefit is up. But I understand in Natalie, you have N0 patients also. So, I mean, that could be one of the reason. Coming to the metastatic setting, before that, just an interesting question which came to mind because now Geredicetrant in LIDRA study is showing a promising results in the adjuvant setting. And there is a camizestrant which is coming up, Cambria 2 and Cambria 1, which is coming up in an adjuvant setting. So the Geredicetrant doesn't have a CDK4/6 arm. Camizestrant, that is Cambria 2, does have a CDK4/6 arm. So with this study coming, what would be your take on just an AI plus a CDK4/6? I mean, any guess? I mean, we don't know. There is no data. But just to make it a little interesting, because that is coming up. I mean, I know that, this is a positive study, and I'm a part of Cambria also, camizestrant, and so...
So as I'm also part of lead era and J2J, both Gridison as well Imrucent, I recruited 25 patients. The tolerance has been excellent. Gridison, I had 2 patients ongoing. This is the 4th year of study. So compared to tamoxifen and anastrozole, there is no any extra safety events. Now we got a lead era first interim assessment is there, investigated associate, and they show probably statistically significant. As we keep on asking about delta, is again 1.5 to 2% only, as it's an adjuvant setting, early breast cancer. So we may get FDA approval. Gridison is very well tolerated molecule. So keep it short, oral SCRM in adjuvant setting are very much possible on the cards. Now can we combine with that the other things like CDK4 bit? So we have to imagine a metastatic setting where with the patient on Ramivan plus fulvestrant we have for 4 years. They are doing so well and they tolerate so well. So we keep a finite duration in adjuvant setting, let's say 2 years Ramivan plus fulvestrant. I think tolerance should be fair. About the benefit ratio,
so at least with camizestrant, I know LIDRA didn't have any arm. I was a part of LIDRA as well. So there was no arm with CDK4/6.
So the comparison was Gridison with the current hormonal agent of choice.
Correct.
Correct. The investigator derived. So I feel pretty much we are forcing.
Anybody's guess. We don't know what is going to happen.
It may fail, but possible. I think they may derive benefit and may get FDA approval also for that.
At least this camizestrant, the CDK4/6 is abemaciclib only. So let's see what results we get in the future. Okay. So coming to the metastatic setting, this is a patient with endocrine sensitive 5 years after completion. Yeah. So this is a hormone endocrine sensitive patient which has developed a disease after completion of 5 years after completion of AI. So that's 10 years after the adjuvant treatment was started and developed liver mets. So what is your option of CDK4/6? We have 3 options.
So before,
yeah, Dr. Ravi.
So before giving the CDK4 inhibitors, I would like to check LFT If patient is in visceral crisis, then
I thought the first thing you will say is, I will do a rebiopsy.
Okay.
That's
So
the
as
first
I'm-
thing you will do, because after 10 years the
Yes,
patient has
yes,
relapsed.
yes.
The first thing you will do is
Definitely,
do a
sir.
rebiopsy.
Sir, rebiopsy and ERP or HER2
Correct.
Ki67 testing
That's right.
is important. And again, I will check for visceral crisis or not. If there is visceral crisis, I will go with chemotherapy. If there is no visceral crisis, then definitely liver mets is a very high risk factor for progression. So I will use best CDK4 inhibitor available. Probably Monarch 3 has very good data. There is difference of more than 30%. So I will choose. I will go with AI with abemaciclib.
Dr. Nilesh, quick, because I think time is pressing. So
Let's say
endocrine
really
resistant, your take?
Ideal scenario, no cost constraint, abema, given a choice, yes. Some issues, then we have to alternate CDK4 inhibitor. And as Dr. Ravi say, visceral, those things will say, though we have good data in visceral crisis, this high risk, 1/3 patient were in visceral crisis for this monarchy data. Though there was initial trend to use chemo, then shift, but now we are all comfortable in directly putting CDK4 plus hormonal even in visceral crisis.
And the partner will be SERDs?
SERD or even SERD prefer, or
AI also.
AI also fine.
The patient has already progressed on 1.5 years of AI.
There is disease free. AI free period is almost 5 years. No, sir.
No. This is on treatment, 1.5 years on adjuvant setting.
Okay.
This is a primary resistant.
Okay.
The patient was started on adjuvant AI, and within 1.5 years, the patient has progressed and developed metastasis. So you will probably put her on SERD.
Fulvestrant.
So that is the data of Monarch 2, where we have Abema plus fulvestrant versus placebo with fulvestrant. And we are recently having a new trial where patients progressed on CDK4/6 will be treated with a new molecule plus fulvestrant. So a lot of things going on in an adjuvant and metastatic setting as far as HR positive breast cancers are concerned. And we already have a good survival on these patients. We are trying to segregate more bad patients, treat them more aggressively, and get a better overall survival. So this is the results of ET resistance, and you can see whether it is a primary or a secondary resistance, whether it is a visceral disease, bone disease. But the graph is favoring abemaciclib plus fulvestrant as an option for even in endocrine resistance. So whether it is sensitive or resistance, you still have good options. If there is a liver mets also, then you can have. About visceral crisis, I think we were always skeptical to treat patients with visceral crisis. But with visceral disease without crisis, your take, Nilesh, Dr. Nilesh?
I think visceral disease without crisis, we are quite comfortable directly putting on CDK4 inhibitor plus either AI or SRM, ACRM, yes. Means using chemo.
Did you try it in visceral crisis by some time? The patient doesn't want chemotherapy. Dr. Ravi?
Yes, sir. I have tried in 2 to 3 patients because patients were not willing for chemotherapy, and even I tried palbociclib also, and actually these patients responded with CDK4 inhibitors. So abemaciclib is very potent CDK4 inhibitor, so I am comfortable when patient is not willing for chemotherapy.
Would you like to prefer this molecule even if there is a brain mets over other CDK4/6?
Probably for brain metastasis, probably best available CDK4 inhibitor I will prefer.
So that's the data where in a visceral disease, this molecule is supposed to be better than other CDK4/6 inhibitors. So with that, I thank my panelists for wonderful discussion. We learnt a lot, and thank Lily and the organizers for giving all of us this opportunity. Thank you so much.
Thank you, Dr. Shailesh and our panelists. We now move forward to our next panel discussion titled From Progression to Possibilities, Transforming Management of EGFR Mutated NSCLC, a topic that continues to redefine the landscape of thoracic oncology and shape real-world practice. Leading this session as moderator is Dr. Aditya Dhanavat, Consultant Medical Oncologist, Navi Mumbai, joined by a panel, Dr. Ashish Joshi, Consultant Medical Oncologist, Mumbai, Dr. Tushar Patil, Consultant Medical Oncologist, Pune, Dr. Reshma Puranik, Consultant Medical Oncologist, Pune. This session is sponsored by Johnson & Johnson.
Thank you, organizers, and good afternoon, everyone. I am Dr. Aditya, and I thank the panelists for joining me today. And we are going to discuss about, from progression to possibilities. The slides have been sponsored by the J&J. Without wasting time, so let's move on. We'll straight away jump into the case number 1. So it's a 58-year-old female who is never smoker, metastatic NSCLC with liver mets and exon 19 positive. Started on osimertinib, 15-month, and then progression. So I'll take this question with Dr. Reshma. What would be your next step in evaluating the mechanism of resistance? Would you want to do a tissue biopsy? Would you want to do a liquid biopsy, or would you want to do both?
So whenever a patient on any driver mutation progresses, they generally have a good PFS. So we would want to go for a rebiopsy, and a tissue is always preferred over a liquid biopsy. In case it is not available, then only the liquid. I don't think there's a need of both. Already there are quite financial constraints most of the cases. So would want to go ahead with a tissue biopsy. Look for many times EGFR positive may become negative or some other driver, or it may be a PD-L1 positive case. So would want to check everything, and then the second line treatment would be planned accordingly.
Absolutely. Tushar sir, would you like to add something to this?
Whenever feasible, at least a tissue biopsy. And if there are no constraints, then both.
Right. Ashish sir, you agree to this?
We'll try to do both if possible, because we want to capture the tumor heterogeneity. So
Yes.
if possible, both tissue as well as the liquid biopsy. Also tissue important because sometimes the non-small cell gets converted into a small cell, which is seen in 4 to 5% of patients. So I would definitely insist on tissue plus or minus liquid.
Rightly put. So we all agree that tissue biopsy we would do, liquid biopsy plus minus based on feasibility, based on other reasons. So now, given the lack of detectable actionable resistant mutations sometimes not picked up on liquid biopsy, would you want to do any other diagnostic workup? So we had a discussion on this, that we would want to do rebiopsy, and we would want to proceed with NGS directly. No EGFR, no PCR based this thing. Right. So we all agree with that. And what is your opinion on re-challenging chemotherapy for those who have received the FLAURA2 regimen? So PEM-carbo OSI progression after 15 months, would you want to re-challenge with PEM-carbo? Dr. Reshma. Yeah.
Re-challenging with the same regimen would not give us very good responses. Like I told you, the decision of second line would be based on what report we get on a rebiopsy specimen. And if it turns out to be all mutation negative, then maybe an amivantamab based regimen with chemo would be a better choice. Because the same, if you re-challenge with the same chemo or some other chemo, you may not get a very good PFS and you may not get very good results.
Okay. Ashish sir?
Also depends on how bad is the progression. Somebody who's just oligoprogressive and not very symptomatic, I wouldn't change the treatment.
Right.
I would just continue to keep the patient on the first line setting. But somebody like this, where there's a frank disease progression, obviously change of treatment would be wanted. I would not re-challenge. I would use change of regimen. I think amivantamab plus chemo would be my first option.
And if oligoprogression, you would give local therapy and continue osimertinib.
And then continue with the
osimertinib. Yeah. Tushar, you agree to that?
The same. Oligopd, it's local treatment, and we can still continue.
Sure.
I believe this patient has progressed.
Yes.
It is not an oligopd.
Not an oligoprogression. Yeah. So we'll come to the Mariposa 2, which is amivantamab plus chemotherapy plus or minus lazertinib versus chemotherapy in EGFR mutated, those who have progressed post osimertinib. And we discussed about the resistant mechanisms rightly put by the panelists, that in some percentages of cases you will find either small cell or squamous transformation. You would find EGFR mutation in about 6 to 10% patients, then some would be EGFR amplified. Again, MET amplification, important to note, is about 7 to 15%, and then you have other acquired mutations, and yeah, that's about it. And if you look at the resistant mechanisms to the second line osimertinib, that is again more diverse, Again, in 30 to 40%, it is still unknown. And we know that amivantamab works through 3 different mechanism of actions, one being the bispecific EGFR and MET blockade, 2 being the lysosome degradation, and 3rd being the antibody-mediated cytotoxicity, and that is the trogocytosis. So if we look at the study design, this was a 2:2:1 randomization, and amilas chemo versus chemo alone versus ami chemo. And they looked at the primary endpoint of PFS, blinded as well as the investigator initiated. And one thing to note was that brain imaging was, serial brain imaging was done for all patients. They did take patients who had brain mets, and they also took patients who had been treated with brain mets. The baseline characteristics well balanced between both the groups. Important to note again that roughly 44 to 46% of the patients had brain metastasis. Now if you look at the PFS, again there was a significant PFS advantage of AMI plus chemo versus chemo alone, with the median PFS being 6.3 versus 4 months. And if you look at the 1 year, it was 22% versus 13%. And this PFS benefit was across all the subgroups. And so let's move quickly to this. And among the Asian patients also, AMI plus chemo did better than chemo alone. And again, there was a PFS advantage of 46% reduction in progression. If you look at the objective response rate, again, significantly higher, that is 64% versus 36% was the response rate. And the OS data is not mature, but with the 18-month follow-up, there is a 2.5-month median survival benefit with AMI plus chemo. So this is again showing the PFS2, and in the PFS2 again you have AMI plus chemo doing better than chemo alone, 13.9 months versus 11 months. And this is the ESMO guideline which gives us option of AMI plus chemo as if there are no other resistant mechanisms seen. So, yes sir.
This trial when this
Mariposa 2
and lazertinib were used along with chemotherapy in the second line, the PFS achieved with the combination was 6.3, and in the PFS2, that is subsequent, was a higher PFS. So can we explain that?
So they've taken right from the first randomization till the second progression. That is why it is showing us.
So that duration.
Yeah,
it's a combination of the one achieved by the
followed by
combination and the second.
Followed by the second. Yeah. So we'll quickly move to the next case. This is a 70-year-old patient, again exon 19 deletion, progressed on osimertinib with brain mets, has developed multiple asymptomatic brain lesions, and patient does not want radiotherapy. So there's a smile among the panelists. So Ashish sir, so platinum-based chemo is the standard of care post osimertinib, but then intracranial efficacy is an issue for which we do offer radiation. What strategies would you consider for systemic and CNS progression in such patients?
Yeah, it's always a clinical conundrum, and we'll have to individualize the treatment options. But if you see the triple combination and the subsequent subgroup analysis of an Asian cohort and those with CNS disease, those who had triple combination in Mariposa 3 has a very good CNS response rates as well as CNS PFS.
Right.
So if given an option, I will use a triplet in this kind of patients with chemo, amivantamab plus lazertinib. But chemo plus amivantamab would be a reasonable option in this group of patients.
Okay. Dr. Reshma, you agree to this?
Yes, would agree to this. What I feel is many times in asymptomatic brain mets, we really don't need to treat them also with radiation. Anyways, patient is not ready for radiation, but triplet combination would have the best results. Even though amivantamab penetration in CNS is not very good, but the triplet combination still is better than the other options that we have.
Right.
Yes, just the pickup rate was high because they were mandating a MRI to be done. So
Yes.
many of these patients may not have been symptomatic.
Yes. And roughly 40% of those patients were treated brain mets. So, Tushar sir, how would you weigh the risk benefit of adding immunotherapy? So, ABCP regimen versus the AMI plus chemo regimen.
I think with the CNS response rate, especially that we have AMI plus chemo plus lazertinib combination would be a better one. Well tolerated also.
And if we remove the CNS from the discussion and put systemic progression, how do you?
Head on, so very difficult to compare.
Oh, I agree, I think. But prior to amivantamab, I used to use a lot of ABCP. And the only thing which used to probably, I mean, in my experience works post first line TKI is ABCP. Because they are really difficult drugs, biologically exposed in a resistant disease.
Yes.
But with amivantamab and also the triple combination Mariposa 2, I would put that first and I would put this as a third line and beyond.
So we can say that this has changed our practice in the way we used to use the ABCP, and now with the Mariposa 2, we are sure that we can give AMI plus chemo.
But ABCP was a good regimen.
It is a good regimen. It is a good regimen. So would we say that patients who are the fitter lot having liver mets, you'd want to prefer something like an ABCP?
Probably yes. If amivantamab we do not have an access, then I would still use ABCP. But with the current data, I think Mariposa 2 takes a precedence, clearly.
Sure.
Is there any rationale in adding to the AMI laser chemo combination immunotherapy?
I don't think anybody would have done that. And also it would significantly increase the cost of treatment. So in our patients, it would not be a possible alternative. Again, EGFR directed therapy plus immuno has not been compared. So again, we've taken the opinions on AMI plus chemo in this setting, so we'll move on. So the options, I think one of the option is if it is asymptomatic brain progression, you can offer radiation, but then the patient refused here. So offering radiation, local therapy, continuation of osimertinib. The second option we discussed, chemo plus amivantamab. And then third being again radiation followed by chemo plus amivantamab. Would you want to give radiation and then do the chemo plus amivantamab?
If it's multiple brain mets, yes.
Yes, we
now
would.
In the second line, we would like to treat them because they would be a problem later on somewhere.
So as rightly put by Dr. Reshma that it does not, it has poor brain penetration, but that intracranial PFS is more likely because of some micrometastatic disease and possibility of preventing the reseeding into the CNS. However, having said that, we would probably want to give, if it is multiple brain mets, and then start the AMI plus chemo. Agree?
Also, maybe Aditya, just a quick comment and a question as well. Somebody who is oligo-progressing or maybe frankly progressing and is unwilling for chemotherapy, there is, if you see the NCCN guidelines, it also mentions continue osimertinib and add amivantamab without chemotherapy. Though obviously there is no data to support this, but I have used it in a couple of my patients with a decent PFS benefit.
How was the toxicity like? How was the tolerance an issue?
The tolerance was not an issue.
Okay.
But there's if you see the guidelines in the NCCN
Yes,
second
yes.
page, it does
You
mention that
can add
somebody who has- you can
amivantamab.
probably add amivantamab, somebody who's not very keen on side effects.
So again, I would put here that somebody who is found to have MET amplification, we do add a MET inhibitor and continue the osimertinib along the same lines, probably add amivantamab. So again, management strategies for systemic and CNS progression. So platinum doublet chemo, but then limited CNS penetration. Add immunotherapy like the IMpower 150 ABCP regimen or AMI plus chemo as per the Mariposa 2. Although not CNS penetrant, but addition of amivantamab prevents the systemic reseeding into the CNS. So this is the intracranial PFS benefit, and the median intracranial PFS was 12 months versus 8 months, and the CNS protection was there. Then if you look at those patients who had history of brain mets and were not given radiotherapy, did well with amivantamab plus chemotherapy. So patients who have not been treated with radiation have also had a good intracranial PFS, which tells us that might as well avoid the radiation, start off with AMI plus chemo.
In the first line, were they treated with brain radiation? Because that would breach the barrier and probably make these drugs.
So these are those patients who have never been radiated. So these are those patients who have never been radiated, have brain mets. So we'll move to the third case, which is a 55-year-old patient on amivantamab plus chemotherapy and has developed grade 3 neutropenia on the first cycle. First question, how would you manage these adverse events while maintaining treatment efficacy, and what supportive care strategy or dose modification would be required? Dr. Reshma?
If it is, since it is a grade 3 event, one dose reduction may be possible, or we may continue one cycle maybe with the same dose, and then if it recurs, then maybe you can modify. So you'll have to take a decision case to case basis, and management like we manage the neutropenia.
Right. I believe others would agree to this. Yeah. So we'll quickly move. And if you look at the discontinuation rate due to any adverse event, so discontinuation of all agents was 11% in the amivantamab plus chemotherapy. And if we look at the safety profile, so most of the neutropenia, thrombocytopenia happens in the first cycle, and subsequent cycles patients are able to tolerate. The hematological toxicity is lesser in the subsequent cycles. And the rate of discontinuation because of thromboembolism was again low, it was 2%. And if you look at the severity of hematological toxicity, so it is more so in the first cycle, and then subsequently the risk of toxicity is similar to the chemotherapy only arm. So, the adverse effect profile was consistent with the both treatment regimen in terms of hematological toxicities. And yes, we should keep that in mind that in the first cycle, if we find a grade 3 neutropenia, not to change the dose, the rate of febrile neutropenia was only 2%. So that is again something reassuring. So this is case 4, 72-year-old, and again exon 19, progressed on osimertinib and planned for AMI plus chemo. And again they are concerned about the infusion related reaction and the dermatological reaction. So how will we approach? So let's go with dermatological reactions first.
Maybe the infusion reaction, the first dose we give it on a split dose. It's day 1, day 2.
Right.
It's important because
right.
if you do it that together, you're definitely going to have higher infusion reactions. As far as the dermatological reactions, if it's grade 1, grade 2, fine, but sometimes the skin toxicity can be quite a bit of a challenge. If it's grade 3 and beyond, interrupt, let it come to grade 1, grade 2, and then re-challenge.
Right. Dr. Reshma, would you like to add something?
Infusion reactions definitely a worry. Recently, when I have had one very severe grade 4 reaction to this molecule, but in the subsequent cycles, I could still re-challenge, and it didn't happen. I was also very apprehensive about re-challenging because it was a grade 4 in the first, when I gave it for the first time. But in the second, when they came for the second infusion, patient did not really have any issues. So I think the rate of reactions is high in the first cycle, but it doesn't really happen in second cycle onwards.
So I think 2-3 things that we can keep in mind is one, split dosing, day 1, day 2. Start the first infusion very slow. So we usually do 50 ml per hour, but you can go as slow as 25 ml per hour. And have the crash cart ready, and have the nurses informed about this. So if you look at the infusion reactions, it was 58% in the Mariposa 2, and majority, however, were grade 1 and grade 2, and they were mostly in the first infusion. Again, recommendation is to give antihistaminic. We usually use Avil PCM, and then we'll discuss about the dexamethasone. So this was the skipper study wherein they used the dexamethasone 8 mg prophylaxis. So day -2, 8 mg BD, day -1, 8 mg BD, and on the day of infusion again 8 mg followed by the infusion. And if you look at the infusion reactions, it reduced from 67% to 22%. So again, slow infusion is the key, and skipper did show that there was a 3-fold reduction in the rate of infusion reaction. So how would you implement in this practice? Any challenges that you would face with dexamethasone? So 8 mg BD, day -2, day -1, and then 8 mg on the day of infusion.
For a shorter infusion, only monitoring of the sugars would be required, nothing apart from that. So if that can be handled, it will be sure.
So if I put it this way, that patients who are diabetics, those who are elderly, you would have probably some challenge, maybe modify it a bit, put it only for day -1 and day 0, avoid the day -2 part. Also the thing being, some places have tried only day 0 dexamethasone, no day -1, and that also has worked.
Typically, I use only day 0 dexamethasone.
Yes. So this is the last case, Ms. Shetty, 37-year-old, again non-smoker, osimertinib 14 months and then CNS progression. Started on amivantamab, grade 2 acneiform eruptions on the face and along with pruritus. Dr. Reshma, how would you approach this patient? Dose modification, supportive care?
So no need of any dose modification for a grade 2. We can give symptomatic care. And we can give prophylaxis before the next cycle, some antibiotic prophylaxis, clindamycin, some skin ointments, and we'll be able to manage a grade 2.
I'll just take 2 more minutes, sorry. So dermatological manifestations, as we know that the initial first 3 to 4 months is where the acne form reactions and the pruritus is there. Subsequently, the dry skin effects start up. So there's dry skin, fissures, paronychia, which come later in the course. So first 3 months acne and then later on the paronychias. So again, we have data to suggest use of tetracyclines, either minocycline or doxycycline, and there are 12 studies which showed that it did help in reducing the rashes. So this is the cocoon regimen, and a cocoon regimen had minocycline or doxycycline. We used doxycycline 100 mg BD, and we started on day 0 at least for 3 months, and then clindamycin lotion for the scalp, moisturizer, ceramide based, and then chlorhexidine solution. We also advise for home based vinegar one patient can use for preventing paronychias. And if you look at the primary endpoint, again, with the cocoon regimen, the rate of reactions reduced from 76% to 38%. And this reduction was across all the subgroups, which is to say that, this is something that we have started using, and we have seen that the rates of dermatological reactions have reduced. And so prophylaxis we should give. Anything the panelists would like to add to the cocoon regimen? Any modifications that you've done in your practice?
It's something similar to what you see in cetuximab. We use a lot of doxycycline and patients respond really well. So never had to discontinue treatment for the same.
Agree.
Especially the acneiform eruptions.
And I think some prior experience of EGFR TKI in form of either afatinib or cetuximab has made us wiser in using tetracyclines. Yeah. Thank you. Thank all the delegates and thank the panelists. Thank you.
Thank you, Dr. Aditya and our panelists. As we continue our journey through the rapidly evolving landscape of cancer care, we now move into one of the most transformative areas in modern medicine, precision oncology. It gives me great pleasure to invite you all to the academic session 8, led by our session director, Dr. Jyoti Bajpai, consultant medical oncologist, Mumbai. Assisting her is our session coordinator, Dr. Reshma Puranik, consultant medical oncologist, Pune. We are privileged to have our esteemed chairpersons for this session, Dr. Prasanna Deshmukh, consultant medical oncologist, Nagpur, Dr. Shweta Gujar, assistant director, cancer research department, Pune, and Dr. Karan Chanchlani, consultant radiation oncologist, Pune. With that, we now open an important conversation, one that sits at the crossroads of science, innovation, feasibility, and the reality of clinical practice in our country. To steer the panel discussion on precision oncology, challenges and opportunities in India, we have with us our moderator, Dr. Preetam Karaskar, consultant medical oncologist, Mumbai. Joining him on the panel are Dr. Tushar Moye, consultant medical oncologist, Chhatrapati Sambhajinagar, Dr. Avinash CB, senior consultant medical oncologist, Mysore, Dr. Suneet Lokwani, consultant hematology and medical oncology, Indore, Dr. Nagesh Sirsat, consultant medical oncologist, Pune, Dr. Pavan Raghava Reddy, senior medical oncologist, Guntur, Dr. Boman Dabar, senior medical oncologist, Mumbai, Dr. Srinivas Kulkarni, consultant medical oncologist, Pune, Dr. Mihir Vaidya, consultant histopathologist, Pune, and Dr. Nitin Bias, medical oncologist, Mumbai. Over to you, Dr. Preetam.
So hi, good afternoon all. With the permission of the chairperson, I'd like to begin the presentation. I welcome all my panelists. So, the most exciting thing in oncology today is NGS, and whatever comes out of NGS, the directed therapies, that has changed the landscape of treatment that we are doing. So this presentation, this moderation is mainly based on what we are doing in our clinics. Can we, after this moderation, give some clarity to our august audience and people at large, what should be the way forward in terms of what testing we should be doing, what kind of panels. So these are the few problems we'll try to solve. Size of the panel, depth of the panel, choices, preferences, which, when, cost, other things, when to test, whom to test, solid versus liquid, how often to test in patient journey, role in preventive oncology, and role in MRD in solid cancer. So these are the few questions I'll be asking to my panelists, and I'm glad we have an extremely august panel here. So my first question, Dr. Nitin, if I ask you which panel, and specifically, is there a choice when somebody comes to you with a solid cancer, you send a panel, what do you think about it? Do you think of the platform? Do you think what kind of sequencing they are doing? You think about whether it is CAP accredited, and what is the depth you look at? So out of this, what is that you look at?
So first it will be a platform, and after that all these things will come, depth of sequencing and how much 50, 100 and all these things. So it also depends on for which type of cancer we are doing it.
Okay. So may I ask, yes, so you get a lung cancer patient and you have a biopsy report of adenocarcinoma, patient is in front of you, what test would you send? And when you are sending this test, whether you look at the platform and type of sequencing?
I have a lung cancer patients and biopsy is adenocarcinoma. In my practice, it is a resource constraint practice, so I would prefer to send a limited panel of around 12 to 16 genes because most of the patients have cost constraint.
Got it. So lung panel, a limited panel you have sent. I got the message. Dr. Lokwani,
Yeah.
if this was a breast cancer patient, a metastatic breast cancer patient upfront to you, what test would you send and which platform and the depth of sequencing?
So if, can I take the last question as well if you
Please,
permit
please,
me?
please.
So with lung when it comes, it is a crime not to send. That's what I personally believe, I beg to differ. And without that, in the modern day sequencing, if I don't have a hotspot panel for that matter, if I'm doing on an Illumina also, without that, giving treatment to a patient, I would not be doing, I believe, a justice to the patient. So I would definitely go for a lung panel which gives me a good TAT, and preferably an Illumina which gives me coverage of the wider genes where I have an actionable target, and I'll definitely go ahead with it. But when it comes to a breast, it's a metastatic disease. I'll try to not do complete NGS. I'd like to do other panels because we can definitely, in a metastatic setting in a breast also, we can get away with the IHC panels and we can do the job perfectly fine when it comes to an upfront meds. So I think if we are talking about per se disease, lung, yes. Breast, I think it can take some backseat. That's what I would personally do.
Got it. Bowman sir, if I can ask you, if there is a lung cancer patient, adenocarcinoma, and the patient wants to do a comprehensive test, right? We have a limited panel with us. So is a limited panel sufficient from therapy point of view? But if the patient wants to do a comprehensive, what is the advantage of it?
I think so. It's a good question. What I feel comprehensive will be much better than limited. It should cover RNA also, because many times in my practice also I have seen we have missed. If you have not done hybrid, means DNA and RNA both together, especially if you want to catch RET, NTRK, others which are so rare but are possible. They are mentioned in the literature, and I had a patient of RET whom we had missed by only doing DNA. So when we did DNA plus RNA, we caught the rat and the patient did quite well. So I think so if we can go for comprehensive, I agree. So we can catch those 1%, 0.5% of the patients also.
Perfect. I think so. The message is, if the patient is ready to afford for a comprehensive test, may it be lung cancer, please go for the comprehensive testing. And where there is a resource constraint, definitely a hotspot can be done. If it is an MBC, sir, what would be your choice? A metastatic breast cancer upfront?
You know, where treatment guidelines are very straightforward, as Dr. Alok said, I will not be jumping into that immediately. In a metastatic breast cancer, when we know that we are going to use AI and CDK4/6, irrespective of what we find, PIK3 or whatever we find, we are going to use this. So I may not jump right now into that. Of course, if the patients are very keen nowadays, we do that in JS also. But in JS also, what are required are only 3-4 things what we require. PIK3, ESR1. ESR1 we don't do immediately in a metastatic patient. Later on we will be doing. So what we want the information right now is just a PIK3 if at all. And that also may not change right now the treatment.
Got it.
If I may add, in this particular context, I think on a practical note, most of the patients, when they come to us first line, upfront, I think a 50 to 100 gene panel is most likely to be useful, to pick up the initial targets. And then sequentially, as we go on, if they progress, then like what sir was mentioning, the NTR case and all the fusions and those rarer mutations, usually most of them are approved in the second line. So I think it makes more sense going down the line. I think we can go for a higher panel. So on a practical note, that is also economically wise for the patient as well. So that's how I look at it. So practically at diagnosis, some 50 to 100 gene panel should be okay. And then going forward, maybe a 500 gene panel or maybe liquid biopsies as well. And my take on the 1000 gene panels, I think those are for the research setting. So that's how I would look at it.
You only presented your data of large gene panel in lung cancer, where you include more genes. Apart from actionable mutations, you are able to find out more resistance-causing mutations. So what is your opinion then? It should always be multi-gene panel or selected gene panel?
So as we concluded before on lung, if possible, I would send a comprehensive panel.
I think depth does matter when you are applying for solid versus liquid. Obviously, we need more depth in liquid biopsy than in solid. I think that the point should be taken.
So can our panelist, anybody can guide us, what is the depth with which you are satisfied?
So usually for solids, 500x, liquids,
500x.
1000x.
At least sometimes we expect 3000 to 5000 also in liquid biopsies, but I think 500 to 1000, yeah.
So the message is 500, sorry, please.
Yeah, so regarding depth or coverage, it entirely depends on a given clinical application. What are you looking for? If you are asking for germline or inherited panel, even 80x to 100x is more than sufficient actually. But if you are looking at especially somatic, I think 500 to 10,000, anything between that is basically ideal, but it should be more than 250. This is what is generally recommended.
Superb. I think if it is germline, then 80 to 100 is sufficient. If we are talking about solid panels, then 500 to 1000 is what somebody expects, or that is a standard.
And also one more addition to this. So in addition to the type of platform, the depth of sequencing, so the important thing that most of us miss is the quality of bioinformatics data, the scientist who analyzes that, because most of the time they give us a lot of data, so a high incidence of VUS as well. But then if the bioinformatics scientist is good over there, they'll not only give us what the mutation is and also the pathological relevance of the same. So it depends upon the quality of reporting as well.
Super. So I think for this slide, one thing which we didn't commented is the platform. Do you look for the lab, what platform they are using? Does that helps you in taking any decision? Whether it is Illumina, Ion Torrent, Pass Biofake, and Oxford Nanopore.
We are not experts on that subject, but still, I feel that Illumina is for a broad-based panel, and Ion Torrent, such as Thermo Fisher and all, for a focused panels. So that's how we usually look at it. But again, it all depends upon the depth, the quality of the reporting. So all these things matter, not only the platform.
Can I add something?
Yeah, please.
If you ask me, ideal lab would be doing both for me on a sample.
Sorry?
An ideal lab would be carrying out initially on an Illumina and checking it on an ion torrent. If both the things give me, because most of the times what happens is if you don't have enough DNA material at some place, ion torrent comes to your savior. But if you want a good TAT, or if you want it in an urgent manner that the patient should receive treatment early as possible, then Illumina is for your savior. So if there is a lab in an idealistic scenario, you carry out an Illumina, you give the report, and you parallelly carry out an ion torrent-based testing, Fisher-based testing, and conclude that yes, we have found this, we have confirmed it, and yes, you can go ahead with it. So that is in an idealistic scenario, I would suggest.
So any comments on this, that lab should be doing it on both platforms to reconfirm?
It has to be quite a generous lab to do on both platforms in same cost.
So out of the discussion, what I can conclude for the audience is, if we are looking for a comprehensive broad-based reporting, then Illumina is something that we are looking at, and for a small amount of DNA or a small SNVs or hotspots, Illumina is what we are looking at. We should be comfortable. Can we conclude on this? Anybody has any comment on it?
I thought Illumina is good for oncology. That is what my concept was. That one of the most accurate results in oncology is from Illumina.
Is Illumina. So probably none of us, we have a histopathologist here, but other than that, none of us is an expert in what platform. But yes, there is an agreement that Illumina is a better platform to use, and for hotspots, ion torrent. So I'll move to the next slide. So we were discussing about a lung panel, hotspot versus a PCR based technique. So these are the various pros and cons, and on the left hand side in blue is what should be an ideal lab we should look at. So as our panelists guided, a broad based panel should be more than 500 to 1000 genes. All the coding regions should be targeted, and the sensitivity should be intermittent to high. Depth, as everybody said, 500 to 1000 plus is good, and most importantly the reports many a time, if they are not with summaries, I am confused. So I like to ask my panelists, what do you look in the reports? If I don't find a molecular oncologist report with the NGS report, I am many a times clueless what to prescribe. So Dr. Tushar, your comments on it?
Yes, report, it should be precise, and it should give us information in the report that what hotspot mutation is there, and what are the possible treatment options, what are the trials which are going on for particular options, that all should be mentioned, so we'll be able to guide the patient.
Perfect. So recommendation plus what is backing that recommendation, a clinical trial, if that is mentioned, it will really help all our medical oncologist colleagues to just go through the data. Yes, sir.
Especially when there are 3-4 alterations together, it's really very confusing.
Absolutely.
As a clinician, so I also get lost when you see 4-5 things all in red.
And they all interact with each other, and we don't know what to give. Agree. So this was on the panel, the depth of panel, type of panel, the type of magnification or depth of mutation. We'll move to the next part. NGS, what are the different scenarios we test? We agree on metastatic. How many of us do it in non-metastatic? Any specific malignancy you prefer doing it in non-metastatic? Anybody can take that question.
So basically, probably nowadays we are doing NGS things for most of our metastatic patients, stage 4 disease, and probably there is little more time actually for that, checking these kind of NGS things and finding out ctDNAs, especially in non-metastatic settings. Robust evidence is needed because there are trials that are going on, especially I'll just give an example, especially in colorectal malignancies in the adjuvant setting. Now if the patient will be beneficial with adjuvant chemotherapy or no. Now they are doing some trials even in US. I think there was one dynamic trial actually. They are checking if there is ctDNA absence or presence. If it is absent, there is no benefit of any adjuvant chemotherapy.
But if there is presence, then the patient may get benefited with adjuvant chemotherapy. But I think that time will decide ki how much these things weigh, especially in non-metastatic. But invariably, we end up in doing all these NGS platforms in metastatic settings.
So, yeah, sir.
So what he said is right, dynamic and bespoke trial were there. But when I was going through just up to date for this, I saw there is one PIK3CA also we should be doing it, which I am also not doing it. And you know, there aspirin, there was an ECAS trial where they were shown just 160 milligram of aspirin has improved the PFS in stage 2 and 3.
Yeah, I agree.
So PIK3 is something which I never used to do, but I just have a thought. And I don't know in the panel also how many people are doing it and whether you have done or not. So PIK3 is one thing, and just an aspirin has improved the PFS. And there's one ECASIS trial which they have mentioned has improved even the survival if you use aspirin.
Absolutely.
Stage 2, 3.
So in a non-metastatic setting, colon cancer in adjuvant setting, PIK3 mutation is what on solid tumor we should do. I think the panel will agree on that.
Lung cancer also, since we have data for perioperative immune checkpoint inhibitors, adjuvant TKI,
Perfect. That's another cancer,
TKI.
yes.
So there also it's needed. Endometrial cancer for prognostication panel at least. So these are the needed indications.
So 3 malignancies, endometrium, lung and colon. Here we do solid NGS. ctDNA will come later, but solid NGS, these are the 3 malignancies. Any other comments from Dr. Lokwani, Dr. Tushar, Dr. Nitin?
No, I think, sir, I mean, CRC, endometrium and lung definitely rule the roost when it comes to non-metastatic setting, and we should go ahead with an NGS.
Yeah, perfect. So we'll move to the metastatic part. In metastatic setting, upfront, which malignancies you will not do NGS, right?
I think HCC is one wherein I think
HCC?
Yes,
Okay.
it's to be established.
Kidney, breast, when there is clear-cut HER2 positive or hormone positive, I think where we don't do upfront, obviously we try to do, but in lung, cholangio, I mean unknown origin, I think these are the areas where we have to do upfront.
Okay. So HCC is one which we don't do. Even I think in ovaries we don't do upfront NGS. So wherever we do upfront NGS, how many of us do the same test on progression, and do we keep a PFS like a year later or 6 months? What is the time duration we look at for progression? Anybody can take it.
Can I take an anecdotal answer to that? If you ask me per se, if I have a CRC case, metastatic CRC, coming up to me after a year of PFS, I would definitely like to repeat the NGS because the genomic landscape there can definitely take a transition. So if you ask me anecdotally, long time PFS, coming back again with a metastatic recurrence complete floret, I'd definitely try to repeat it. But in case of a CRC, I'd like to do that. Other, I think so the panel can guide better.
I think at progression, we are doing in lung cancer to look for the resistant mechanisms, ideally biopsy, if not liquid biopsy. The second indication, the hormone receptor positive breast cancer, which has progressed on AI-CDK4/6 inhibitors to look for the CSR1, PIK3, AKT mutations. And sometimes now when we are considering cetuximab re-challenge, when we want to confirm the RAS wild status by NGS, and we can re-challenge the patient with cetuximab. In such cases, we are considering for retesting in such scenarios.
So if I can reframe the question, what mutations do you expect to change over the course of time, and try to see them in an NGS report? Or you expect such mutations to develop, like ESR1 is something which develops over course, right? So any specific mutations which you expect can develop over the course of disease on progression?
Basically, we should look for dynamic markers who can change, like you said, but not for all. I mean, PIK3 usually it doesn't change. So ESR1 you will have to do. So while progression where you want to do NGS depends on the disease as well as, I think, markers where you want to do.
So on progression, I think lung we have a consensus, right? Colon, Dr. Lokwani suggested after a year he'll do it, right? So any other specific malignancy we prefer doing it, or it is just that the patient relapse, we do it. Because many times if it is more than 2 years or 1.5 years, I tend to do it. But many times I don't know the reason I am doing it. Just in the case, hope that there is a new nucleotide change and I'll find something new. But what is the guideline? Do you have a consensus on the guideline?
On progression, genomic landscape can definitely change. There is no defying it. So putting it in a narrower perspective is actually limiting oneself. That's what I personally believe. Most of the time we do go ahead with a blind NGS. That's something we might find. So taking that concept forward, definitely you should go ahead on progression.
Another reason is that if you're monitoring ctDNA levels, so it might reflect disease progression weeks to months earlier than radiographic progression. So
Yeah, we'll come to ctDNA.
Yeah.
I think
there is one question from the audience.
Yeah, there's a comment and a question. Especially for the colon, which Sumit was talking about, we know that RAS is a very truncal event in oncogenesis of colon, and I haven't seen RAS changing. So for those malignancies where we know the oncogenesis and the genotype, where there is not going to be a drift, then I tend to not repeat an NGS.
Sir,
but yes, you're right. You're right. No, I'm not kind of arguing. I'm just
no, the RAS basically changes. I've seen mutated turn to wild types. Not the one which we can target, but definitely there are cases where we can definitely have that they can change. That was the reason I took it and started an anecdotal thing.
Okay, sure.
Also might be, there is a situation where we have done a smaller panel initially. Then probably later on, I think if it is not fitting into an expected result or outcome, probably we might have to do a broader panel to look for various other resistance mechanism. I think that's also a situation where we'll have to repeat NGS in a broader panel when we have done a small panel initially.
So I'll just come back to it. When we do a border panel after 2 years, right? We always have a confusion that initially I had done a hotspot, I didn't know the complete sequence of the tumor. Now I'm doing a broader panel. So doesn't it make sense to do a broader panel upfront, right? Screen it completely and then follow up with it.
I think this you answered that you should do a CGP upfront only.
Absolutely. So any last question, any tumor where you will not start a therapy unless you have an NGS report. We do it for EGFR for sure. We get EGFR, right?
We won't start therapy.
Anywhere else, do you wait for the NGS report?
We won't wait, but for colon also we would like to know what has happened in the metastatic disease. For GI malignancies also, we may not wait, but upfront we'll do.
Upfront we'll do the test.
I think so. Early endometrial cases, I think also we can take it in this subset that adjuvant will.
Yeah, for the poly and P53, yes. I think that is where we will not start anything before an NGS. Rest all the places, I think it depends clinically. Most of the times we start. We don't wait for the NGS. Next part is the liquid versus solid. What is the take of my panelist on liquid biopsies per se? How do you find them in terms of reporting? What is the accuracy you feel? Are they equivalent to solid NGS? And what are the limitations to it? So anybody can take that question, and do you agree with this?
Yeah, absolutely. I think as rightly mentioned, solid biopsy is the gold standard, which we mandatorily do it upfront. So going forward, most of the times it may not be feasible to do a repeat solid biopsy at each progression. So then liquid biopsy is our go-to tool. So moreover, we have the benefits such as it is easier, it's usually cheaper, and we get the report earlier, and we can also have the tumor heterogeneity thing taken care of. So I think these are the things that liquid biopsy scores over. The cons being that it might miss a few cases. That's it, the sensitivity part.
I think they are complementary to each other. I think that's the best way to.
I think that is the best way to place it. There is, I think with this slide, there is an advantage of tumor heterogeneity which can be captured with liquid biopsy, which we can miss in solid. So I would prefer doing both together. If the panelists agree on it, I think that message can go to the audience that solid plus liquid both is a recommendation to be done upfront. Yeah, you wanted to say something.
So there are a couple of scenarios where as a clinician we always come across doing solid followed by liquid or getting both the things done simultaneously, because sir has rightly pointed out there are multiple tumors where do we come across tumor heterogeneity. and it may be, you know, missed on the somatic panel. So probably, I think now slowly we all are moving towards getting both the things done, because as you rightly pointed out, why not to do the broader panel in the beginning itself at the start of the, you know, decision making. So I think this is something which is coming up in a bigger way, to do both the things so that we should not miss out on anything. It will not only help us in deciding about the line of action, but also to make ourselves ready for plan B. So this is what I feel.
Perfect. So my panel on the last, sorry, I missed asking anything, please.
Sir, actually the liquid biopsy, that way it is great for SNV, single nucleotide variants, indels, and even for TMB, MSI assessment it is good. But sometimes because the concentration of the ctDNA and maybe because of the fragmented nature of it, some CNVs, copy number variations, like amplifications, or in certain fusions, some complex rearrangements like fusions, they might sometimes be missed on liquid biopsies. So for such alterations, solid and tissue biopsy is very useful.
Yes, Dr.
So
Lokwani.
there is one thing which is, apart from this, that as clinicians, we vouch for liquid nowadays also, but it's changing. But we vouch for liquid when gold is in short supply. When you don't go to the tissue, you go to the liquid part. So this thing is actually...
Agree. So
with us clinicians, so this I think should change in the near
so
future.
when biopsy is not possible, doing a liquid, we all agree on it. Many times patients are not ready or they are not fit for a biopsy. We agree for a liquid biopsy. Other than that, whenever possible, I think the answer is do both upfront and then follow up with it. I think that message is going to the audience. These are the few sites which I like to just skip. This is how liquid biopsy is done, from where the DNA and RNA is picked up. Yeah. This is also what we mentioned, we have discussed already this. So, very hot topic in terms of ctDNA, subclinical disease, early diagnosis and late stage disease. This is the three scenarios where we are doing, looking ctDNA as a newer thing coming up. So, my question to my panelist here is, how do you look at ctDNA as a screening tool? There are tests already available, though they have a breakthrough FDA approval. Have you suggested it to anybody? And actually, do you suggest it? And how do you follow up it? Anybody can take that question. ctDNA as a screening tool. Dr. Tushar, Dr. Nitin?
Not as a screening.
Not as a screening.
For follow-up, predictive, it can be used for who is already diagnosed.
Yeah, till now we are not using it as a screening tool, but maybe in future the liquid biopsies may put a role in screening some cancers.
So there were 6 questions asked. First is, I'll definitely offer it to somebody who's come out of a tumor but is remaining in the high risk pedestal of things. I'll definitely try to offer. So you see, ctDNA is coming big time as a pan-cancer marker kind of a thing. It's a biomarker in one way, if you see it on the other way around. And it should definitely be offered to patients who are actually very compliant.
No, sorry. I am talking about a screening tool. Screening tool for general population.
Predictive for recurrence, yes. For that I'm using.
For general population. Healthy individual.
No, sir.
As mother has breast cancer, is very concerned.
As of now, no. But in the future, it can.
It has come in the NCCN guidelines also, interestingly, the Garden Shield test. But they had mentioned the sensitivity for detection of advanced precancerous lesions is only 13%. So I don't think that is feasible. It will be very less useful in terms of colorectal cancer incidence reduction, mortality reduction.
So shall I conclude? I am running out of time. So shall I conclude that presently the panel believes it is not a screening tool. With more data coming in, it can be a screening tool in coming years, but not at present. Perfect. So there is an agreement on it. Lastly, there is an 80-year-old lady. She is having a PS3/PS4 general condition. She has a lung lesion and she is having ILD. We require a biopsy for diagnosis, but patient is not fit for biopsy. In such scenarios, would you use ctDNA for treatment?
I think definite no, as of now.
Definitely?
No.
No. But relatives are okay doing it, how do you justify, can we justify legally?
So basically you ask, do you advise ctDNA for treatment?
Yes.
Especially we don't even have a diagnosis to treat her. So basically we need to make them understand its implications. We don't even have a diagnosis. You are absolutely right, and probably we should look into the legalities as well. Say for example, now you have advised a ctDNA test and as a screening tool, and you come across some kind of abnormal genetic abnormality. You are in such an awkward situation, right? Just imagine a patient living with, he has some ctDNA and he's living. There is no symptom, no evidence of the disease. It becomes very difficult to manage. So in a given situation, 80 years old lady, lung mass, we definitely won't be advising any kind of ctDNA. Even if the relatives are ready, we should tell them.
So the
futility.
The consensus is we should not treat a patient on the basis of ctDNA at present. Medical legally, we will not be able to defend ourselves if there is something goes wrong, right? That is the message we want to give. Perfect. So I'll just mention whatever we have discussed, and anybody, if anybody is disagreeing with it, please interrupt me. So size of the panel, everybody agrees that a comprehensive panel is what we should do whenever it is possible. When to test upfront is what we are agreeing for most of the cases, apart from few of the malignancies where we can do it on follow-up. Solid versus liquid NGS, the consensus is upfront both is a recommendation. If possible, do both, solid versus liquid both. And how often testing? On progression, yes, we should test it. Some malignancies will show up some mutations, but yes, on progression, we should do an NGS. In preventive oncology, presently there is no recommendation of doing a ctDNA for general population. We don't have a consensus on it. We are awaiting for further randomized studies and further outcomes. Neither ctDNA can be used as a diagnostic tool. Perfect. Thank you. I thank my panelists to be here on a Saturday and guiding us all through this very, very important precision oncology discussion. Thank you all for being here, and thank you for the audience for being patient. Thank you very much.
Thank you, Dr. Preetham, and thank you to our panelists. We now move on to our next panel discussion on serplulimab, new standard of care in lung cancer. This session is sponsored by Intas. I invite our chairperson, Dr. Shona Nag, Senior Medical Oncologist, Pune. To moderate the session, may I invite Dr. Udip Maheshwari, Consultant Medical Oncologist and Hemato-Oncologist, Mumbai, with our panelists, Dr. Boman Dhabar, Senior Consultant Medical Oncologist, Mumbai, Dr. Ashwin Rajbhoj, Consultant Medical Oncologist, Pune, Dr. Ashish Joshi, Consultant Medical Oncologist, Mumbai, Dr. Vipul Doshi, Consultant Medical Oncologist, Solapur, and Dr. Avinash CB, Senior Consultant Medical Oncologist, Mysuru, to please join us on stage.
Good afternoon, everyone. So today we'll be discussing about serplulimab. It's Intas has handed me this slide. These are my disclosures. So we'll be discussing about the extensive stage SCLC first. So serplulimab in ES-SCLC, currently it's the it's approved indication of serplulimab in India. First line ES-SCLC with chemo. OS benefit seen in Astrum 005 global phase 3 trial and highest ESMO MCBS score of 4. So we'll discuss in detail about this with the panel as well. So looking at the charts, if you see 4-year OS of about 21.9% and proportion of patients alive at 4 years was 3 times more than versus chemo, and a median follow-up duration of about 42.2 months with a HR for OS was about 0.60. Now, looking at the cross-trial comparison for Atezo, Durva, and serplulimab, almost everything looks similar. 400 to 500 odd patients. The Asian patients were more in the serplulimab arm. Median age was about roughly 60. Males were more in serplulimab arm, and brain metastases were slightly more, that is 13%. So if you see the responses cross-trial comparison, OS of about 15.8 months versus 11 months in the serplulimab, 12.3 versus 10 in Atizo, 12.9 versus 10.5 in Durva, 15.5 versus 13.5 in Tislely, and 14.6 versus 13.3 in toripalimab. And OS rates were roughly similar. A 4-year OS of about 21.9% is a very good number, whereas in the others, if you see 2 years, OS maximum was for toripalimab, which is 25.9. Overall response rates were largely similar in both of them, and duration of response was also slightly better in serplulimab. So these form the cross-trial comparisons of these. Obviously, there are limitations to that, which we'll discuss in the panel. And again, highest ESMO magnitude of clinical benefit scale. I don't know if all of us are aware of the scale, MCBS scale. It's a scale where how much the drug has clinical benefit in practice is considered, and 1 being the lowest, 5 being the highest. Serplulimab was given 4. It looks at 3-4 things, that is the duration of response, the efficacy, OS benefit, DFS benefit, and based on that gives a rating of about this. So it helps us in our clinical practice. So now discussion for the panel, comments for the data. Sir, Daba sir, we'll start from you. Any comments on the data of serplulimab that we've shown in SCLC, sir?
Absolutely, because in small cell, till now, everywhere it has been less than 12 months. This was one of the first 2 trials showed that the 12 months mark was crossed by atezolizumab and by Durva.
Correct.
Both. These are the trials which have been breaking. It means very strong trials. And here we are seeing 15 months.
15.8 months.
Yeah, so this is really a great thing.
Yes.
So I would not hesitate to write if there is a patient when I see this data in a phase 3 randomized study.
And 4-year survival 22% is fantastic, unheard of, I think, in SCLC, right?
Statistically, it looks really great.
Yeah, absolutely. So, any Dr. Ashwin, I think next you can take any responses on cross-trial comparisons. Can we do? Is it fair to do a cross-trial comparison with this when we don't have enough data? But how do you look at the data? If I show you the results again.
So if you see the results again, I think as sir told, if you see OS more than 15 months, if you see delta also, it is more than 4 months as compared to others, maybe 2.8 months with Atizo and Durva, and 4 years data as well. So I think data is definitely strong enough to, with the options available, and we know about the cost. So I think in Indian scenario, it fits in a right choice.
Absolutely, perfect. So I think a point well taken that cross-trial comparison may be difficult, but still prima facie the data looks fantastic, and those are the drugs which will help prolong survival in ESCLC. Now, any Ashish sir, can you take on ESMO MCBS score? Any relevance that you find with that scoring?
Yeah, I think that score is very important because they're very conservative in giving approvals.
Correct.
Even this is a drug which is approved in China, in total 40 countries, of course, but
Correct.
UK, India being one of the 2. And
Yes.
they look at a lot of in terms of cost-benefit ratio. It's actually kudos to this drug that it is kind of approved, and this scoring system is very relevant.
Absolutely.
But coming back to Udip, your question about the cross-trial comparison, the data looks too good to me.
Correct.
To be very honest, why Empower and Durvas of the world haven't penetrated and catapulted the survival to 20%?
So higher Asian population is a very important point.
Very important factor, yeah. I mean, if this is the data, I would love to use it, as Bowman sir very rightly
Correct.
mentioned.
And there were good patients. Number of patients also, if you see, there are about 585 highest number of patients in the trial recruited, and they've had good hazards, good even the other arm was also well matched. Probably a very good data set.
Even
and
brain metastasis patients were also
even brain
good enough,
metastasis
more
patients
than
were
10%
13% highest. So I think all in all, the data looks very promising. So I think, sir, any more comments from you, sir, on this, so that we can move ahead?
The trial data is really good, the numbers,
the inclusion of Asian population, the inclusion of patients with brain metastasis, and end of the day, roughly there is a 15 to 16 months of overall survival, and there are roughly 22% are surviving beyond 4 years, and that was not seen in small cell lung cancer.
Correct, correct.
But as far as the experience is concerned, the incidence of small cell lung cancer is quite low. So like I personally don't have much of experience using immunotherapy in small cell lung cancer.
Correct. Perfect. So we'll move ahead since we have 8 minutes only, and there are a lot of other things to discuss. So upcoming studies in serplulimab, I'll move ahead with this. A head-to-head comparison with Atezo is going on, and that is the clinical trial design, which we'll be publishing soon. A global phase 3 trial for limited stage SCLC is also ongoing, where serplulimab is being given as concurrent CTRT. For definitive treatment, and then maintenance Atezo, which also is going to come through sooner. So in SCLC we'll have a comparison data, we'll have post CTRT in limited stage as well, and I think the horizons will expand for serplulimab there. Now beyond SCLC, if you look in China, indications are extensive stage SCLC, squamous NSCLC, non-squamous NSCLC, and the esophageal cancers with PD-L1 positive. And what we are looking at for squamous cell NSCLC is the study design, which is where serplulimab, nab-paclitaxel, carboplatin, and followed by serplulimab maintenance versus a placebo, nab-pacli, carboplatin, followed by placebo maintenance. So there, if we see the data, the graphs are dramatically separating, as we see in most immunotherapy trials with when they are compared with just chemotherapy. And if you see the Asian population here again, so there the main highlight point is that Asian populations are doing better. In fact, in the Keytruda study also, in the non-squamous Asians did very well. I'll show you that slide as well. Here again, in Asian patients, the PFS was about 9.9 months for an immunotherapy trial. It's a very good PFS versus 5.8 months. If you see the overall survival in all patients, it is again a significant improvement, 22.7 versus 18.2 months. And if you see specifically for Asian patients, it is 27.4 months versus 18.4 months. And if you see what the spectrum of drugs here, what are available as immunotherapy in all histologies of lung cancer, all of these have a hazards of about 0.6 to 0.7. Which is where this drug also, the Astrum 004, fits in, right? And if you see the cross-trial comparison again, in the Asian patients, 27.4 versus 10.8 is amongst the highest that is there for most of the other drugs like Keytruda, like the teslelizumab and torapelimab. So squamous NSCLC. For squamous, impressions on serplulimab, on Asian data, and OS benefit. So we'll need a quick comment, sir, from you.
First, let me answer that. When you ask for cross-trial comparison, I think Astride is the one in extensive stage small cell cancer which is going to answer that. So that's the first part. So you're comparing with Atezo.
Correct.
With respect to squamous cell, I think that's a fairly good data. You can compare with any other IO we are using.
Yeah, absolutely.
Definitely good PFS, OS, and good results. So we can definitely consider, and with the affordability, you can consider upfront compared to other IO.
Correct, absolutely. So I think fairly straightforward that immunotherapy plus chemotherapy does benefit. Yes, Ashish bhai.
So will there be any subgroup analysis with PD-L1?
So they have not mentioned in this that PD-L1 positivity, but yes, PD-L1 more than 50% does benefit better.
No, but is it for all comers or is it only
this
for?
for all comers?
It's for
Chemo
all
plus chemo.
But there is no subgroup analysis where, like the way we have it with the IOs.
There is, but we've not shown in the slides. There is a subgroup analysis that they have planned. So there is a subgroup analysis, yes. So this is for the squamous. Then if we go to the non-squamous NSCLC, again they have divided into Group A, Group B, Group C. Wherein Group A is serplulimab HLX-04 is a bevacizumab alternative, and carboplatin pemetrexed. The other arm where bevacizumab was not given, only serplulimab was given, and one arm where serplulimab, C arm where serplulimab was not given, only PEM carbo plus bev or the HLX-04 was given. So they have compared the 3 groups together. If you see the group A with all 4, 12 months, with no bevacizumab, it was 11 months, and with group C with no serplulimab, it was 7 months, 5 months, 5.7 months. So definite advantage of group A over group C. However, addition of bevacizumab, does it help so much with serplulimab is a question mark right now with their results. Right, so even here, if you see the OS, again similar results where there is definite distinction of the curves between group A and group C. However, the group B data is slightly off. It is slightly more. So again, impact of serplulimab on OS is definitely there if you see group A and group C for sure. But what about the data with bevacizumab? That will come later. Any impressions of serplulimab again here? Same to this after discussion of VEGF. So we'll discuss those points after discussion of VEGF so that we can save some time. IO and VEGF, they are now we are combining them in most of the trials. So is it better every time? So if we see ABCP trial, which was there, which did show some benefit, HR of 0.8, and the trial did show separation of curves. However, there were several other trials which showed that it may not benefit so much as well. So the rationale that they give is that, you know, there is tumor hypoxia is created, the drug delivery to that tumor post VEGF becomes difficult. So that is why the patients may not benefit that much here. And if you see in most LEAP 008, LEAP 007, Apple, all of these tried to do the same, and there was no significant benefit with adding any anti-VEGF therapy, like lenvatinib was used. Bispecifics did show benefit, that is ivonescimab, which hands down beat Keytruda in Harmony trial, and that is because of the structure, how it is placed. It is a bispecific antibody that leads to better drug delivery, short half-life, and can be a better alternative to adding this. So coming to the point that, no benefit for addition of bevacizumab, and is there a patient where you would add bevacizumab in such patients? So 3 points to discuss: serplulimab data in SCLC, very crisp answers, and addition of bevacizumab. Which patients would you select? Sir, Bowman sir, you can take it.
Upfront bevacizumab in non-squamous I hardly use upfront.
Okay.
Bevacizumab. So I don't think so.
No,
that
with immunotherapy, sir. ABCP kind of protocol.
ABCP, yeah, of course, but ABCP being not so popular upfront, we don't use bevacizumab so much upfront. Yeah, okay. Once there is a relapse, means I do use ABCP in EGFR positive patients, but.
Okay, sir. Your quick comment, sir, on this?
Yes, similar. Like we don't use much of a bevacizumab in lung cancer, especially along with the immunotherapy or chemotherapy.
Okay, perfect. So they've said that, tumor response they've done a trial with serplulimab and bevacizumab in brain metastasis, where they've seen intracranial ORRs of about 84.6% versus 64.1%, and extracranial ORRs of 64%, which are fantastic, with serplulimab and HLX-04, and that has shown very good response, and that is where I think we can add bevacizumab in patients with brain metastasis. So I think there's also, it is coming up in curative setting, and to conclude, I think most of the serplulimab is a good drug to stay, especially in our population where we are, and there are many more indications that may come up except ESCLC, where we can use it in lung cancer in most of the settings. So thank you, panel, for a healthy discussion. Thank you, the organizers, for giving me this opportunity.
So the one comment that in China, it is also approved for all MSI high solid tumors.
Yes.
So I think that's going to be one of the very important.
One of the very important, yes.
Immunotherapy has the maximum punch in MSI high patients.
Correct.
And in China there is an approval, but we do not have approval.
We do not have approval yet, yes.
But I think that would be also one of the worth indication trial.
Indication, yes, absolutely. Agree, completely agree.
Thank you. Thank you, Dr. Udip and our panelists. As we continue exploring the cutting edge of oncology, our next talk takes us straight into a space where innovation is rapidly reshaping possibilities, novel investigational agents in pancreatic ductal adenocarcinoma. To lead us through this exciting landscape, I am delighted to invite Dr. Daruka Mahadevan. He is the Director of Institute of Drug Development, Director of Research, Multi-Speciality Research Hospital, Associate Director for Clinical Research, Division of Hematology, Oncology, Department of Medicine, Mays Cancer Center, University of Texas, San Antonio, USA. We are honored to have him share his insights with us today. Dr. Mahadevan, can you hear us?
Are you able to hear me?
Yes, we are, sir.
Okay, good. Thank you. Good morning, good afternoon. Yes, thanks for the very kind introduction and the invitation to present today on novel investigational agents in pancreatic ductal adenocarcinoma. Next slide, please. Okay, so objectives are to quick introduction, everyone knows about the current treatment landscape. I won't spend too much time on that. And then more importantly, actually, we'll talk about KRAS targeted therapeutics. And unfortunately, there is the potential and there will be drug resistance and how to go after that. And then conclusions. Next slide. So we all know that this is a lethal tumor. In the United States in 2025, there were over 67,000 patients. And it's the fourth leading cause of mortality, around 52,000 patients in 2025. Unfortunately, the median age of diagnosis is 70 years, so it's an older age tumor. Most of them are ductal adenocarcinomas, and there's a smattering of other tumor types as you are listed. But there is also a genetic predisposition of about 10%. Most of the tumor arises in the head of the pancreas, but there's also a percentage in the body and the tail, as you can see. And unfortunately, patients present with advanced disease, more than 50%. And their 5-year overall survival is only 3.2%. So there's a lot of work to be done in this space, as we all know. Next slide. So the problem is this, not just the tumor, but also the tumor microenvironment. There's a whole host of cells, sometimes present in abundance, sometimes not so, causing this stromal reaction and preventing the immune system or drugs actually getting into the tumor. So 80% of the tumor volume actually is the desoplastic reaction. On top of that, added are the KRAS mutations. 90% or more of these patients have KRAS mutations, various changes in the amino acids, particularly G12X13, Q61, and so on. And unfortunately, also co-occurring tumor suppressors, particularly TP53 and CDKN2A and B, a part of the MTAP deletion program, and SMAD4 as well. So together with the pro-inflammatory cytokines and the desoplastic reaction and the profound immunosuppression, these tumors are really hard to treat. And so drug resistance is common, and so is tumor evasion. There are some pancreatic cancer that have an epigenetic reprogramming called the complex-like complex that are regulated by chromatin accessibility and gene expression that controls it through lysine demethylases and lysine methyltransferases. So the major operators in this very cold tumor are those cells that are listed, including the chemokines, the cytokines, and the epigenetic regulation. So these are the barriers to coming up with good drugs. Next slide. So just to highlight what we have already in the metastatic setting, we in front line, we have FOLFIRINOX. I wanted to just think about the numbers, PFS and overall survival with these chemotherapy drugs. We are talking FOLFIRINOX PFS of 6 months, overall survival just under 1 year. Same with gemabraxane, and then the other combinations, as you can see, we have NALIRIFOX now, and that's been compared to gemabraxane. Again, not very, it doesn't really give you extra PFS or overall survival, as you can see. One little advantage is that some of these tumors, 1% have mismatch repair deficiency and MSI high, they certainly respond very well to anti-PD-1 antibodies, as you can see. Next slide. So there has been a paradigm shift, everybody knows this now, and that paradigm shift is going after KRAS. So KRAS has been around a long time. It's a GDP exchange protein that activates downstream signaling pathways. Structurally, it's well characterized. We know exactly the structure of the molecule, how it interacts with its partners for GDP exchange and GTP hydrolysis, and also effector binding, particularly to RAF and PI3 kinase. We also know the different types of KRAS mutations, as are listed here. The most common is G12D, then G12V and G12R, and a smattering of others in the 1 to 2% range. The structure of KRAS didn't give us a good understanding of pockets, other pockets that would exist, and they are dynamic pockets, so you don't see it in the crystal structures. And also GTP binds KRAS in the picomolar range, unlike kinase inhibitors, which are in the nanomolar range. And so it has been a problem going after KRAS. It was considered undruggable until Shokat's lab showed that using a disulfide tethering fragment-based screen, they were able to identify a couple of molecules that bound a site called switch 2 pocket that you wouldn't see in the crystal structure. So it only opens up when the small molecule actually binds in that pocket. So now we have more than 30 KRAS inhibitors in clinical development going after this particular molecule. FDA has approved KRAS G12C, as everybody knows, in non-small cell lung cancer as single agent, as well as in combination in colorectal cancer with the anti-EGFR monoclonal antibodies. Next slide. So this all started in 2013 in the publication Nature that actually showed there's a pocket, switch 2 pocket that opens up. It's cryptic and binds this compound 6, and from then on it opened up the field to generate novel molecules. The question was, occupying this pocket, would it actually affect KRAS activity in the GDP off state? And clearly it showed that, because Amgen and Amgen's sotorasib and Mirati's adagrasib were potent molecules that were active in cell lines, animal models, and of course in patients. The question was then, this is just for one molecule with the KRAS G12C. The other mutations are not going to be targetable. That was actually not true, because we were able to actually come up with small molecule inhibitors that would occupy these pockets and inhibit other mutations in KRAS as well. And then there was another way of actually doing this, and Warp Drive Bio as well as Revolution Medicine came up with a different concept independent of targeting the switch 2 pocket. Next slide. Next slide. Okay, so just to give you a summary of the small molecule inhibitors that are in development, the first two, sotorasib and adagrasib, are off inhibitors, are approved. There are some other ones that have gone through clinical development. I'll mention that in the next slide. Divarasib and olomorasib, they are off inhibitors. And there's also glerisib and calderasib are off inhibitors. And RMC 6291, which is an on inhibitor from Revolution Medicine. And FMC 376 is actually both an on and off inhibitor. They all bind the switch 2 pocket in a covalent manner. And the newer molecule is gasorasib, also is an off inhibitor. Next slide. So just to give you a summary of these molecules in pancreatic cancer, sotorasib at 960 milligrams in 38 patients showed an overall response rate of 21% and an overall survival of 6.9%. So think about the numbers I showed you for chemotherapy at the beginning of this talk. In comparison to this slide, at a half-life of 5.5 hours all these molecules have toxicity, fatigue, rash, diarrhea, common. Adagrasib at 600 milligrams BID, overall response rate is 33%, so much higher. PFS is also a little bit higher. Overall survival is 14 months, but it has a much longer half-life of 23 to 24 hours. And there's fatigue, rash, and diarrhea, unfortunately, but manageable. Olomorasib is 200 milligrams POQD. You can see The overall survival with this molecule has not been reached yet. Half-life is 7 hours. Fatigue, diarrhea, nausea are common toxicities. Glycerin is 800 milligrams POQ day, overall response rates of 42%, and overall survival 10.7%. Good disease control rate, close to 94%, and a half-life of 7 hours. There's fatigue, anemia, increased LFTs, and hypertriglyceridemia are seen, but manageable. Next slide. So now there are many trials based on this. Just to say that of the 10 studies that have that have been administered with sotorasib and adagrasib, close to 1,000 patients have been treated with these molecules as a combo, and multiple tumor types. Pooled analysis shows that they're close to, and the SHP2 inhibitor, which is the upstream regulator of the tyrosine kinase pathway, and calderasib with pembrolizumab, sotorasib with the PRMT5 inhibitor, that's for the CDKN2A part of the pancreatic cancer, going after MTAP, which is present in about 20 to 40% of pancreatic cancers, as well as the RMC6291, which has only been tested in non-small cell lung cancer, but it's going to be tested in pancreatic cancer as a combination. And that molecule also showed very good activity in lung cancer. As you can see, overall response rate of 42% and overall survival at 1 year at 62%. Next slide. So how to go after the other mutations? One really good approach is this molecular glue approach, where cyclophilin A doesn't actually bind KRAS normally, but it does bind KRAS on state when there is a small molecule bound to it. So there is a chaperone that binds a small molecule, in this case daraxonrasib, and that forms the ternary complex, and that binds the on state of KRAS and inhibits its downstream function. It also binds the other types of RAS molecules as well, including NRAS and wild type RAS, as well as HRAS as well. So it's a versatile molecule. It binds all of the mutations, and so far we have not seen, I think in time when we look at these molecules, we'll see resistance developing, but it binds between the switch 1 and switch 2 pockets. So that's why it's able to inhibit the on state and downstream signaling pathways. So it is a unique molecule, and it's exciting. Next slide. So the first study that actually conducted with this 6236 molecule, the RNA inhibitor, there was dose escalation. They did achieve the maximum tolerated dose for pancreatic cancer between 160 and 300 milligrams, which is the dose that actually it's better. It's at a higher dose than the lower dose that is there on the figure that inhibits the preclinical models carrying these mutations. And so it targets all of the mutations, as you can see there, in pancreatic cancer, and there were 127 patients enrolled in this study. The next slide shows, go ahead, next slide. Shows the PK, the half-life is 18 to 24 hours, so it's a very long PK. Over 90% of the patients dosed at this 160 to 300 milligram dose showed steady state exposure greater than or equal to the exposure range in mouse models, which showed tumor regression. And there is also, coupled with that, as the dose goes up, there's also worsening toxicity, however manageable. Most common toxicities are rash, diarrhea, nausea, vomiting, stomatitis, and fatigue. But in grade 3 numbers are very small, as you can see in the right-hand column. So overall, well tolerated. Dose interruptions, reductions, and discontinuation actually was 0, but there were interruptions and reductions with this molecule. Next slide. Okay, so in second line by itself, these patients also have a really good response. 35% overall response rate with a disease control rate of 92% in the G12X, and the other mutants also very similar response rates and disease control rates. In the first line, also very active molecule, overall response rate is 47% in 38 patients with a disease control rate of 89%. Unheard of, actually, compared to the chemotherapy drugs we mentioned earlier on. It's a very, very promising molecule for pancreatic cancer. Next slide. So also we talk about ctDNA is an excellent way to actually study the tumor in addition to imaging. So to look at the liquid biopsy for KRAS variable allele fractions, in this case they were able to show that there was a decrease in the numbers by up to 93% if you're looking at more than 50% RAS VAF compared to 100%, which is about 50% in the different mutants. So a really interesting and promising way to also look at response rates. Next slide. So the studies are coming along now. These are the new studies that are planned or ongoing in second line daraxonrasib at 300 milligrams versus investigator's choice chemotherapy in the second line setting, and we will see how this pans out. I'm thinking the RAS inhibitor is going to win this. Primary endpoints are PFS and overall survival, and then the other endpoints are overall response rates and quality of life. Next slide. Then we have the RASolute 303. It's for first line. In this case, the dose of daraxonrasib is going to be 200 milligrams with the standard of care, 3 arms, daraxonrasib compared to Gemabraxane or the combination, followed by the RAS inhibitor. The primary endpoints are PFS and overall survival. And I think this will also be a positive study as we move forward. Next slide. So how about the other mutations? So there are also KRAS G12D covalent inhibitors that have been developed by Revolution Medicine and other companies, but this is the most advanced molecule, zoldonrasib. It's active. 1,200 milligrams is the daily dose that was recommended for patients with pancreatic cancer. As you can see there, the response rates are around 30%. There are toxicities associated with this, particularly nausea, diarrhea, vomiting, mostly low grade, but for grade 3, ALT elevation has been seen, but no grade 4 or 5 toxicities have been documented, no DLTs and MTDs, and the dose proportional for PKPD with a half-life of 18 to 21 hours, so long half-life. It's an oral covalent inhibitor from Revolution Medicine, really promising as well for these KRAS G12D mutations. Next slide. Is now we can also target KRAS G12D non-covalently with a targeted protein degrader, and you, I'm sure, have heard of this molecule ASP3082. Essentially, it's a PROTAC where this part of the molecule binds KRAS G12D non-covalently to the molecule in the off state. And then turns on the proteasome to degrade the molecule. There was a dose escalation study, and this drug is given IV once a week, so a little bit inconvenient for patients, unlike oral medications. And they saw some responses of 27 patients with pancreatic cancer, 6 patients had a partial response, and time to response was 2.6 months. MTD has not been reached, but there are toxicities associated with this molecule as well. Particularly infusion-related reactions are about 14%, pruritus, nausea, urticaria, some ALT, AST elevations, but mostly manageable. There is also G12V, we didn't mention V, but V, there is now siRNA targeted therapy and possibly a PROTAC coming along for V, which are the more commonest KRAS mutations. Next slide. So unfortunately, drug resistance will happen, and there's a nice paper for that is actually very useful describing these mutations when KRAS G12 inhibitors are given to patients. Up to 50% have clinical resistance due to mutations in the KRAS itself, either amplifications or mutations in the switch II pocket or other activating mutations or RAF MAP kinase mutations and NRAS HRAS mutations. 50% are other types of drug resistance, basically activating upstream receptor tyrosine kinases, all types, as you can see there, downstream signaling pathways, also epithelial to mesenchymal transition through PI3 kinase, lineage switching, immune evasion, and angiogenesis and coagulation. So these are all, unfortunately, need to be tackled as we go forward with these molecules. Next slide. Was a very interesting extension looking at Miapaka-2 cells that carry the KRAS G12C, introducing other mutations into this including KRAS mutations, lead to drug resistance. In all of the KRAS G12C drugs we know of, there are some mutations that are sensitive to the current drugs, and the other ones are very resistant. So the hypothesis is that can we actually combine these KRAS off drugs with on drugs combinations to prevent drug resistance? So better depth and degree of KRAS inhibition and mitigation of inevitable drug resistance. So this is actually nice preclinical modeling to justify combining these molecules in the clinical setting. Next slide. So there are clearly ongoing studies combining these molecules because of drug resistance, including with chemotherapy or with other KRAS inhibitors, whether it's PAN or G12D, with antibodies as well as chemotherapy. So these are studies that we will be reading out in the next few years. Next slide. So just to leave you with a summary of some of the KRAS-related toxicities, with the pan-KRAS inhibitors, unfortunately there is rash. 90% have a rash, grade 3 up to 8%, and they're pretty bad rashes when you get to grade 3. Very hard to take these molecules orally with this, and so managing that is a challenge for sure. Very interestingly, there is no ILD with these molecules, or very low or no ILD, which is a good thing. Cardiac toxicities are seen, but very rare for QTC, also for kidney. Lab abnormalities are certainly present, but in low numbers, less than 10% for most of these molecules. But the common GI toxicities are there and need to be managed, and are managed quite easily. Next slide. So in conclusion, I would like to say that the biggest problem was that very hard to there was a problem of finding a clear binding site, because it's very hard to target GTP and GDP, which bind in the picomolar range, undruggable. But when we did dynamics, they were able to pick up the opening of the pockets, switch 1 and switch 2 guided drug discovery. And that is the paradigm shift that has led to molecules being discovered and targeted, whether it's C, V, or D, or PAN, KRAS inhibitors. And as you can see, their response rates are higher than combination chemotherapy with probably less toxicity. And these drugs can be given for a longer time, unlike chemotherapy. So the idea is to combine them with standard of care. Obviously, that's a way to navigate these molecules, so FDA approval, through higher response rates, PFS, and overall survival. We do have to come up with strategies to disrupt adaptive resistance. Luckily for pancreatic cancer, rarely they go to the brain, but for lung cancer, obviously, there's 30% or more met to the brain, and these molecules do cross the blood-brain barrier. Adagrasib is better than sotorasib, and the other drugs mentioned are also brain penetrant. And then combining with the chemotherapy or immune checkpoint therapies and stroma modulation therapies are the next frontier to overcome, to actually treat this very lethal disease. And the figure on the side tells you that KRAS actually has a wide effect on the pathophysiology of pancreatic cancer. At every level, it's involved. And the idea is to go after all of these different pathways to cull this tumor and make patients live longer. Next slide. So I conclude my talk. I just want to say that this area is mushrooming out beyond KRAS G12C. The future has been mapped out a little bit here now and then for the next 2 years and beyond. There's a lot of activity in this area, and we hope to, we are sincerely hoping our patients will benefit from this and live longer with a better quality of life. Next slide. So thank you very much, and I'm happy to take questions.
Thank you, Dr. Mahadevan, for your insights, and we truly appreciate your expertise and time in sharing these insights. Thank you, Dr. Mahadevan, for joining us.
Any questions? I'm happy to take them.
No. I think we've really well.
Sir, the KRAS inhibitor, are we going to see much better options than what we have now with the combination or the protocols?
So could you hear the question?
Well, there are no questions. Well, I think it's lunchtime there, right?
No,
I think
Dr.
people are.
Mahadevan, we do have a
Yeah.
question. Could you hear us?
No, I couldn't hear you actually.
Okay, we'll
I
ask the
couldn't.
question again.
Could you put it in the chat? Maybe I can look into the chat.
Can you hear me, sir?
Yes, go ahead. I can hear you now.
So we always struggled with KRAS inhibitor. First of all, the cost part, accessibility part, but still patients who could actually take KRAS inhibitors, lot of side effects were there. So are we going to see better versions of KRAS inhibitor or combination therapies, and we can use them early?
You're breaking up. I really can't hear you clearly.
I'll type it up.
If you can put it in the chat, maybe I can answer that question for you.
Dr. Mahadevan, we are putting the question on the chat.
No, we're breaking up. I know you probably can hear me, but when you talk, it breaks up.
Can you hear us now?
Dr. Mahadevan, can you hear us?
Yes.
Hi, this is Dr. Maniyar. Good to speak to you again and see you again. Had one question.
Oh,
for you.
okay. So the question is, are we going to better KRAS inhibitors in terms of toxicity management and cost? It's a really good question, to which I don't think we can give a good answer right now. But I'm hoping that with the patients that we have studied, that have been taking these drugs, we are learning a lot how to manage the toxicity. The biggest one actually with the KRAS on inhibitors have been the rash. A bit like, when you inhibit the MAP kinase pathway, like a bit like in the EGF receptor inhibitors, rash is very common. And so we have to find ways to actually manage it. Luckily, we are grade 3 toxicities of rash have been less, but some patients have bleeding lesions. They get up in the morning and there's blood everywhere on the bed from their rash. And that's a real problem actually with these patients. So we may have to design dose reductions and dose adjustments and hold as well. And, the treatments have been the same, antibiotics, lotion, and so on. But luckily, it's only less than 10%. Most other patients are handling it okay. With the other types of KRAS inhibitors, we don't see much rash. Particularly the on-off inhibitors have very little rash actually, but they have other toxicities like you can have musculoskeletal toxicities, CPK going up, and so on. So if we can manage the toxicities better upfront, then the cost will be less. But I think this is also, you have to view this as, are we going to get these patients to a place that they've never been before in terms of overall survival, right? Most patients are dead at 1 year. If you can get them to 2, 3, 4, 5 years, I think we'll be able to manage their toxicities better by dose adjustments and dose reductions and navigating these drugs so that patients get optimal benefit. So that's how I kind of look at it. I don't think I gave you a complete answer, but that's the best answer I can give you right now.
Thank you so much for that answer. Can you hear us? Can we take one more question?
Sure.
in the absence of RAS inhibitors, there was a preclinical data of using anti-VEGF inhibitors or PD-L1 inhibitors in RAS mutated solid malignancies. What is your experience? Till we in India get access to RAS inhibitors or trials of RAS inhibitors, would you consider, should we add bevacizumab or immune checkpoint inhibitors in such patients? Do you have any such experience if they do better on these drugs?
That's a really good question. I think modeling animal model. So animal models are not completely optimal because we really don't have a good model for pancreatic cancer. But PDX modeling is a good way of doing this because it's not a home run. We're getting response rates 30-40% for pancreatic cancer, so we need to get to 80-90%. How do we do that? And I think for now, drug companies are going to get their drugs approved first, right? And the best way to do that is combining with chemotherapy and showing that it's better than chemotherapy and get it approved. But really, if you want to study biology, you've got to go back to PDX modeling. And one of the ways actually is immune checkpoint therapy combinations. That might be one way to do this. And that's an ongoing area of research. Combining with VEGF and other antigenic antibodies, I am not certain, but maybe a PD1 VEGF bispecific antibody with a KRAS inhibitor might be the way to test that out. So you're then testing not only the immune system, but also the vascular system as well as the tumor. All three together may be a good approach. Also, antibody drug conjugates combined with KRAS drugs would also be another useful way to actually move this field. So that's how I kind of think about this. Drug resistance is going to happen with KRAS. How do we avoid that? How do we think about targeting the desmoplastic reaction, both at the level of the immune system, because it's highly immunosuppressed, and the vascular system, so that we can bring in more drugs if you open up the blood vessels to the tumor. So this is how I'm thinking about it.
Thank you, Dr. Mahadevan.
Thank you very much.
Thank you.
Enjoy your lunch.
Thank you, Doctor.
Okay, bye-bye.
We now break for a session that requires no slides, no AV, and no question and answers. That's lunch. We would be back with another session that truly represents where the future of cancer care is headed, molecular oncology. Do enjoy your lunch and please return promptly. Thank you. Welcome back, everyone. I hope lunch was refreshing, conversations were energizing, and the post-meal slowdown is still at least an hour away. We now move into the academic session 9, Molecular Oncology, a theme that truly represents where the future of cancer care is headed. I invite our session director, Dr. M.V. Chandrakant, medical oncologist, Kolkata, and session coordinator, Dr. Nikhil Shirsi, consultant medical oncologist, Pune. With our chairpersons, Dr. Ashish Joshi, consultant medical oncologist, Mumbai, Dr. Sujit Joshi, consultant oncopathologist, Pune, and Dr. Raman Narang, consultant medical oncology, New Delhi. Our first talk sets the perfect tone for this session to take us through the role of artificial intelligence in molecular oncology, an area evolving almost as fast as AI itself. Please join me in welcoming Dr. Vinayak Makka, Senior Medical Oncologist, Bengaluru.
Thank you, and thanks to Tushar Patil and MOC team for inviting me. So if this topic was given 2 months back, I would have refused, but we had a very wonderful workshop happened in Guwahati. I learned a bit, but this is expanding branch. Whenever we disparaging for most of the people, but now we are using ChatGPT for the daily task. We have new models, and the models are telling that they are best thing happened to the AI. And there is some deep reservation from patients that whenever you use ChatGPT for their questions. But trust me, they are putting every report into ChatGPT and coming to you. So I have used overview. So role of AI in molecular oncology. Few evolutions talk which I will cover earlier. These are the models. So there are 3 terminologies which we use in AI. One is language model, large language model, neural network, and machine learning. So initially it was classical machine learning which was like used in diagnosis of histopathology slides, and then it evolved into the modeling. So I'm going to cover all the slides. The last and the latest is the AI agents. So this is the one which has been very much used in the practice. The AI agents as of now are used by specialists in these branches. For example, most usage for AI agents for me is in the field of PPT presentation, Gamma, Canvas, but there are in oncology they can be used better. I can show this one. These slides are from the ESMO 2025. First time they had a subject called ESMO AI and Digital Oncology. It was very much useful. So in AI we have 3 types of language models which are there for clinical practice. One is patient facing, which is used for symptoms query, early diagnosis, patient educations, lifestyle tracking, which needs AI for the complexity of the data which comes there. Second is for us to help in our day-to-day functioning of clinical work, where is clinical decision support, multilingual communications. Sometimes we need translations for a lot of international patients are there, and you have a country of different languages to communicate. For example, to create a consent form for at least 16 language is required for most of the multicentric studies. So there it can help you. Educational and training. And apart from this, we generate huge patient volume and data associated with that, and that data extraction and usefulness has been studied. So 3 words I said earlier: machine learning, deep learning, or neural networking. So with that, in precision medicine, which is a molecular insights which can personalize the treatment. So AI helps in it. So the need of AI is convergence of machine learning and deep learning technologies. It helps us to, because the biological systems are very complex, we need to have intellect to decipher the various interactions, and this will actually lead to individualization of treatment. So to put on headers, for data analysis and interpretation, it helps us to understand, see that there is not a single report. EGFR mutation was a positive, it is only PCR report. when you take a deep sequencing and a lot of data will come, through data you have to collect the relevant data for practice, so that we want to have a drug for that. So you have to identify the actionable gene mutations. So in genomics, if you take, it helps in identifying the somatic mutations, copy number variants, structural variants, and is this genetic alteration pathogenic or VS. Lot of AI technology is used for predicting the tumor mutational burden, which is a tumor agnostic marker as of now. So it helps in picking up that, and even for the personalizing the immunotherapy, where the patients will not respond, like ISTK inhibitors and other things, where the immunotherapy may not work. And lot of studies are happening in the NGS, where they're combining, integrating the multinomics like genomics, transcriptomics, epigenomics, metabolomics, so where they can get a comprehensive analysis of the tumor state. So once you have that report, we need to know whether we have a FDA approved drugs, either it is approved label or off label, and trials options. These are the one of the options in AI can be used to decipher. So predicting models, I think next speaker is covering, so I will not cover about that. So with clinical key review of the AI in genomics only is for variant detection, TMB estimation, multi-omics integrations, automated analysis, molecular prediction. So for example, in last the ESMO Asia AI meeting, the Manipal group has done a CT scan images. With the CT scan images, they are predicting whether EGFR mutant is there or not, or what allele is positive. And there are a lot of pitfalls for the analysis of the images, but with images, with CT scan images only, they can predict the mutation profile of the cancers. And liquid biopsy, biomarker identifications, the data is less and it requires more depth. We can use AI to predict much better. Drug discovery and precision medicines. So the challenges for that patients I told case where the Manipal did a study, they needed a machine, the images from only one machine type with the sequence fixed, and then they could analyze the data. Otherwise, data from lot of machines which are different companies, they found struggle to predict the mutations. So we need to have uniformity of the data. So data quality is must for a AI to interpret it. And there are, for clinicians to understand those the outlay or black box, what we call, of the information, same as matrix, you see the dots and screens, those are very difficult for us to understand. And there is always, algorithms are set by clinicians or human element, there will always be bias in the algorithmic things. Regulatory, as of now in India, the Data Protection Act is there, and we don't know how much we can share and how much we not share, and how will it will be commercialized. So in America, there were elements that NGS based discrimination shouldn't be there, we not reach there, and privacy concerns. So how many of us will upload just the image with patient identifier into the chat GPT or something is a risk, but that concern is always there. This is the first element, AI in genomics. Second element is the tumor boards. So it was felt neat, but now with explosion of the knowledge from genomics, proteomics, imaging, slides, variability of clinical presentation, and every 1 minute you have data coming, changing you things. So each conference is adding you burden of the data overload. So we can use AI also. So as you've seen, the various streams the information comes, can we integrate it? So we need a multimodal data integration before we actually use AI for the better things. It is this element of genomic, transcriptomics, histopatho, clinical data, which has to be combined to have integrated data. So from molecular tumor board, it will become integrative personalized tumor boards, which is the norm which is used now for in AI domain with a molecular tumor board. So till now we are doing that, and virtual tumor boards are happening. Almost we have close to 10 virtual tumor boards happening in the India. Various data is integrated. Once we have data and we have outcomes, we need to match the trials availability. So in India still I think lot of scope for match trials are there. But in the Western countries, there are various platforms. There are web-based platforms where they match clinical trials. If you see in your reports of NGS, there are a set of trials which is given accompanied to the report where the trials are there and what study is there. There are problems that genetic variants and lot of variants are there. But as of now, the second one, the SLIN is a better one as of now. But definitely we have pitfalls to use this one. So large language models are being used where they have we use the inclusion criteria, patients' reports, and integrate and give a matching which is more better than the web-based clinical trial matching. So just to give example, if they have a mutations with KRAS and you have a genetic mutation which is not G12C, it will pick up and respond that it doesn't fit the criteria, and lot of hard work is spared by entering data in a proper way. So this structural clinical matching using a large language model can refine and can give you the options better. So apart from this, every data can be fed into various platforms. You can use web-based, there are specific AI models for each options. Like example, you only want the information, you can use the Gemini, ChatGPT. There are some AI-based imaging. I'll just give one case presentation, I think, falling short of time. This is just a case pilot. So I use the word AI agent. So if you take an AI agent in this complex case, so 69-year-old male with metastatic colorectal adenocarcinoma, the molecular pathway showed KRAS G12C, apart from a lot of mutations, with relevant history of progression on FOLFIRINOX and bevacizumab. So if you feed this a raw image of pathology, so in this concept you need to have a digital images, okay? So it can analyze which block is more relevant. It can do the spatial genetic constitutions also. So you can give the type of structuring based on that. So you can use image AI to assess whether they can be evaluated, like target lesions. So you need to have target lesions to assess for the evaluation and trial eligibilities. You can use that, and you can get a good summary which can meet the clinical parameters, molecular parameters, and assessments. So apart from this, there are a lot of options, as I said, where you can search depending upon your needs, you can use the AI model. So this is the data, so you can feed multiple tumor boards before you get a concrete report. So, and most difficult part, which I think in practice, is explaining the molecular tumor board decisions to clinicians. So that also is, there are apps to make presentation easy to the end user, which is the patients. So summarizing, this is the last slide. So summarizing, AI integrates machine learning and deep learning to decode the complex cancer biology efficiently. This is a pattern, and analyze multiple omics and clinical data to usually personalize the cancer care. So it can help in various forms, but we are still here to learn. Thank you. I think slides over. Any questions? I'll take one or two questions.
Thank you, Dr. Vinayak.
Thank you.
Up next, we continue our AI journey, this time combining predictive analytics with oncogenomics to share insights on AI-driven predictive oncology tools integrated with oncogenomics for personalized cancer care. May I invite Dr. Chirantan Bose, Medical Director, Molecular Oncology, Mumbai.
Good afternoon. Thank you for inviting me. It was a very appropriate sort of stage set by Dr. Vinayak Maka's overview on molecular oncology related artificial intelligence tools. I'm going to talk about one specific tool that I am working on right now, which is called Onco360. But there is a lot of individualistic skepticism as well as thoughts that each one of us from the clinical fraternity have in artificial intelligence that may be slightly terrifying. We may question the genuinity of the data and information that we get from platforms like ChatGPT, Perplexity, etc. And clinicians do have this apprehension in certain fields, like from the pathology side as well as where interpretative opinion is sought, that AI might replace the clinician, and rightfully to certain extent, but of course I think that human interpretation and the human touch, human to human touch shall remain as core to medical practice in at least the near future. So I would like to specify and come into certain specific areas of what are our expectations through artificial intelligence use in day-to-day practice. We want to compare similar patients. When we have hundreds and thousands of patients, for example, of breast cancer, lung cancer, we need tools that we can put together this data and evaluate what kind of trajectories each type of patient has followed. We also want quantitative real-time analysis whether a certain treatment that the patient is getting will be efficacious or not. We want to find alternative treatment options. We want to identify clinical trials that these patients, especially in the metastatic refractory setting, could be enrolled. And definitely we want combination therapies in the adjuvant setting that can be incorporated. Now this overall, there is a term that we use that is called predictive oncology, where today before treating a patient, we want to use a tool that can give us robust and scientifically valid predictive outcome based on which clinical decisions can be taken. I think that is one of the core questions in AI in molecular oncology. That this is a busy slide which I have taken from Chaprano's paper recently, and I would like you to focus on the red box which has got the various inputs that we are getting into creating an AI platform. So there is genomic data, there is data on cellular pathways, there is of course indexed publications, there is genomic metadata which comes from individual organizations. For example, MOC being such a large and broad spread cancer organization can have its own genomic metadata. And then we use various pipelines to analyze these models and also put in the clinical information of drug response and drug-drug interactions. Say for example, a patient who has taken, let us say, a PIK3 inhibitor with another mTOR inhibitor or some other chemotherapy, what kind of drug-drug interaction was there? And finally, it extends into life sciences, clinical trials, etc. The upper part of the slide is what I will further go on and discuss. So this paper also highlighted this is the other paper from Nature Cancer which has just come in March this year, which highlights 10 areas that molecular oncology AI is kind of effectively working. The blue areas are in early cancer assessment, from cancer detection, screening to molecular profiling. The reddish blocks identify outcomes, patient outcomes and monitoring. Once you already have a cancer patient and you are assessing various different things like treatment planning, clinical trial design. And the yellow boxes, they are in the research area, identifying new drugs, combinations, designing new clinical trials. So this is where the maximum potential of AI is, that is in designing clinical trials. If an organization that is generating molecular oncology data has got its pipelines mapped, then one can support the design of clinical trials. And almost all clinical trials, what we are seeing in ASCO, ESMO or any of the leading world cancer congresses, are going to use a lot of this molecular pipeline data in randomizing the patients. For example, do you have EGFR positive lung cancer patients that have progressed on anti-EGFR therapy and have now developed downstream mutations like KRAS, PIK3CA, etc. These clinical trials will come and specifically ask you the data and access to these patients. So modulating and having this resource ready is very, very important for the organization. Similarly, the new cancer vulnerabilities in terms of identifying newer pathways which can be sort of druggable, that is the other area. Of course, in this entire process, there are multitude of, ecosystems which are involved. There are scientists, there are clinicians, there are patients, there is industry, the pharma industry, insurers, as well as regulators. Just focusing on clinicians and patients, of course, clinicians want to identify the unmet needs. They want to learn from AI models, and they help AI models to learn. And they can provide the effective feedback of what is working. And so today's clinicians will actually help in creating the AI models which will help patients tomorrow. And not contributing to that is possibly holding back oneself from science. For patients' perspective, of course, it helps in personalization of treatment, and it helps in predicting what is going to happen in times to come. So I'm just giving you few snapshots of this platform called Onco360, on which I am presently working on. This has been built on a real world data of over 6,000 cancer patients, and there is an algorithm which has been built to match the patient. So you can say this is cancer cousin or cancer sibling kind of a thing, where you can access this platform and find out with the data of a given patient today, whether in the data set there is another patient already existing who had similar molecular profile, and map the treatment trajectory. Recently, we have partnered with MSK Innovation Hub, and we have got access to 25,000 clinical and genomic data sets from MSK's CC, which is typed, and now comparing these data sets, I'll show you some examples, is what I'm doing with 4Base Care in developing further this Onco360 platform. And of course, it is accessible to any practicing oncologist, and to use and to see how this can help your practice. So as I mentioned, the data set basic data set consisted of about 6,000 plus patients with all their molecular parameters, clinical parameters, along with actionability and outcomes. The platform is based on graph neural network model, which is called GNN, which is a very commonly used term in AI. And there are various API interfaces which are built to get that data from EMR systems. And it gives a very easy user interface in summarizing how the digital records of the patients are translated into meaningful, actionable insights. So for example, here is one case which there is a biological trajectory of this case, and sorry, this is just the screenshot of that, so it's a bit small for you all to see, but there are certain mutation profiles in this patient. There is a BRAF V600E mutation, so you have the trajectory of this patient, and this is the current status of the patient. And then you see that this is the data which actually is input in real-time basis. What are the drugs? There is like the history of the patient. What are the drugs, for how much time this patient has taken, what has been the duration of response, etc. That you put into this. Then you ask the system to kind of give you parallel patients who have the similar drug history, similar tumor, and same kind of mutation profile. I've taken a very easy example, but this goes to very high levels of complexity in terms of SNVs, copy number alterations, amplifications, IHC markers, all of those things can be pulled in. So as you can see, this pulls out 3 patients, patient 1, 2, and 3, which are of a similar kind of profile. And then it brings out the match to the best match to the given case, what has been the treatment outcome, what has been the tests, what kind of molecular profiles were initially present, and what happened later on. So basically it gives you a match score of a given patient with a patient in the existing database. Now if I talk of the Onco360 platform as of now, it has got 25,000 plus 6,000, 25,000 of MSKCC and 6,000 of the pilot data set. So it has about 31,000 data sets already present. And almost for every patient we are able to find some match. It is not totally accurate that it can create a prescription out of that, but it definitely helps you in seeing what kind of, in matching what kind of best progression this patient can have, which you are kind of seeing. So these genomic scores, shared biomarker scores, you can see on top, there are some scores which are highlighted. The overall match score is 8.6. A 10 match would be a perfect match. But there is a significant match in the genome, 97%. There is a significant match in the shared biomarkers, 75%. I'm not going into each individual markers, but like in this case, there is BRAF V600E, PDL1, and some other mutations which are there. And it kind of writes down the story of what is the current impact of this in the given patient as compared to the patient which was already analyzed. This is a fairly exhaustive model. It requires some more time in explanation, so I am just browsing through in the interest of time so that there can be Q&A after this. And you can see that there is a current patient and there is a twin patient. Okay, this is system generated, so there are a lot of improvements, etc., that we are doing as of now also. For example, here there is a chemotherapy comparison to a target drug which is brought out, and there is an off-label drug also which is used. So that kind of data set comparison brings us, and finally there is a database of this Onco360, which is also incorporated, and it gives what is the most important potential driver. Now I would stop here. When you see a molecular report of a cancer patient, oftentimes when you have multiple mutations, the question is whether this is driver or not. Okay, and of multiple mutations, which is the most important driver? So this pipeline also helps in identifying. For example, in this case, it is a BRAF driven cancer, so obviously that target remains, and despite previous treatment. And this is the comparison of the treatment regime of this patient, what was treated to the current patient and what was the treatment of the previous patient. The previous patient had responses to, of course, BRAF inhibitors, and there was a prolonged survival, whereas the current patient has not received the BRAF inhibitor drug. And then finally, it gives actionable insights, which are again can be read in detail, what happens in a BRAF mutated lung cancer, etc., etc., and identifying what are the strengths and weaknesses in the given case and where you should look for more information. So just summarizing, this twin identification strategy, and this is not the only platform. There are many other platforms which are currently being used for identifying cancer twins, where the same cancer type with the same morphology and the molecular profile is being, the system can search. Now, this system can become only robust when more data sets are put in. So I think as people of the oncology fraternity, it is our responsibility that we put all the data in a searchable format into a system so that our own data sets can help us identify actionable insights further on. So I won't go into the treatment part. And this is backed by a very comprehensive molecular profiling of the patient. So oftentimes what we do is there is only somatic profiling, mutation profiling with either the tissue or the ctDNA, or sometimes some people do only germline testing. So actually the ideal way would be to do a somatic profiling from the tissue, a somatic profiling from the liquid biopsy, and germline together. This comprehensive molecular profiling basically helps to identify, one, what is true somatic and not kind of interfering mutations like CHIP, etc., which often come into picture of decision making. And then if there are any pertinent germline factors which also will sort of either promote or digress from the given treatment option. So back-end data, molecular data should generate from a very comprehensive profiling of the patient. That is what I am trying to identify here. And of course, its accuracy has been proven across thousands of samples, and that's, I'll finish there. Thank you.
Thank you, Dr. Bose.
There are no questions. Thank you. Thank you, Doctor.
Thank you. Our next speaker takes us into yet another fascinating frontier, the microbiome and its impact on cancer immunotherapy. May I invite Dr. Arun Lingutla, Consultant Medical Oncology, Hyderabad, to deliver this highly interesting talk.
Good afternoon. So the role of microbiome in immunotherapy. So majority of the time when we were residents, this concept of microbiome was not existing. And as the immunotherapy has come into existence, this has garnered more importance over a period of time. So this particular slide shows the scanned colored electron microscope of the bacteria present on our tongue. And that's my hospital. It's a 7-acre, 1,500 plus bedded hospital. So this is a disclaimer wherein it's for educational and information purpose only, and more research would help us to connect between these two gap, laboratory discoveries and clinical applications. It's preliminary and may not be validated, but eventually it might come into the practice in a decade or so. So these are the subheadings that I would be covering. So what exactly is the definition of the microbial? Communities have commonly been described as the collection of microorganisms living together. Some even have described human microbiome is now even considered to be our last organ. And of late, in the last 1 decade, close to $1.7 billion have been spent in the research of microbiome. And this is not just to the field of medicine, it's also being used in the field of agriculture, aquaculture, as well as horticulture. So there are the difference between microbiome and microbiota. So in a given particular habitat or a period, collective bacteria, archaea, protists, fungi and viruses form the microbiota, whereas this organism's genetic material in combination in a particular habitat or a period is called as microbiome. So how did we get this information? Way back in 2007 to 14, there was a project, Human Microbiome Project Part 1, which had emphasized the characterization of microbiome that is present, the microbiota that is present across the different systems of the body, including certain pathological entities as well. And the Part 2, which lasted between 2014 to 17, had associated this microbiome with physiology as well as the disease process extensively across all the diseases, infectious, chronic ailments and all. And for any researcher, this particular human microbiome project has data set which can be accessed. So what constitutes the microbiome? As I told earlier, bacteria, viruses, fungi, archaea, single-celled eukaryotes. And the human microbiome is a vast community of microorganisms, close to 100 trillion, and viruses outnumber almost 1:5 with the bacteria, whereas fungi are 1/10 of the bacterial. So when compared with human cells, it is almost 10 times, and they closely, because of the small cellular structure, they constitute only 1 to 3% of the entire body mass. Generally non-pathogenic, symbiotic with host, our habits, environment might turn it into a foe. So what are the factors influencing the gut microbiome development? If you see diet, even in the womb, mode of delivery, gestational age, genetics, environment, antibiotics, some researchers have seen that the difference of microbiota in a cesarean-born child versus a normal vaginal delivery born. And the microbiota changes right from the first day of the life. And some have extended this particular thing wherein they have smeared the vaginal, cesarean section delivered babies, smeared the vaginal secretions and applied over the breast so that they will get the first dose of vaccination and a healthy microbiota in those people. So this all will alter our microbiome, and in health, or disease, this would be dictating terms. So if you see the microbiota load and diversity ranging from the oral to the aboral end, as we go down, the diversity and the numbers keep increasing as we go to the large bowel. However, our focus of the modern medicine has been in the last 80 years to get rid of the bad microbes, and we never thought of this because we had no knowledge of helping the favorable bacteria that we do have. And this has led to two major problems. One is antibiotic resistance, and another is damage to our microbiome. And there are several cohort studies wherein simple toothpaste that we use day in and out, which do have certain chemicals which are used as a foaming agents like sodium lauryl sulfate, tend to damage our microbiome. And there are certain artificial salivary agents added to that and minimizing that particular damage to the oral microbiome. Including, there are certain cohort studies wherein usage of detergents to clean the floor, uses of detergents to clean the utensils have altered our microbiome. So there are certain trials wherein they have shown detrimental effect of an early exposure to antibiotics on the outcomes of immunotherapy in a multi-tumor cohort of patients. This was a recent publication wherein it has impacted the PFS as well as OS if an antibiotic was used at least 6 weeks prior to the immune checkpoint inhibitor. And majority of our patients are also immunocompromised. At one point of time before they come to us, they would have been exposed. Similarly, of course, steroid we do take care, but impact of PPIs are also there, and it has negatively impacted the PFS and OS in immune checkpoint inhibitors when PPI have been used. And we all know in India it is an over-the-counter medication. Many people do take this. So there are real challenges with immune checkpoint inhibitor responses. We know in the real world only 30 to 40% respond. There could be primary or acquired resistance. And even the adverse events related to the immune checkpoint inhibitors can also be affected with the microbiota. So we need a predictive biomarker and treatment optimization. Some of the key discoveries which drive immune checkpoint response is gut bacteria drive checkpoint inhibitor effective systemically, and even the tissue microbiome will also dictate the response. Responders versus non-responders had a different microbiota profile, and microbiota acts as a both biomarker and therapeutic agent. Clinical outcomes directly correlate with the bacterial composition. What exactly are the mechanisms in this enhancement of the immune checkpoint in some patients, whereas non-responders? Certain bacterial byproducts like inosine, butyrate, and had influence on the CD8 T cells, NK cells, and balanced T regular cells. This is a complex diagram, but I would try to ask you to see the center of the slide where certain, what I would say, insoluble fibers, when they are metabolized, they would lead to short chain fatty acid production. The acetate is the one, propionate and butyrate. These have not just effect on the intestines, but also across all the systems, lung, CNS, liver, pancreas, and bone marrow as well. So some responders tend to have certain microbiota more than the other. Some of are like Akkermansia, Faecalibacterium, Rhinococci, and Bifidobacterium. The higher the diversity, the better was the response to the immune checkpoint inhibitors. So microbiota as a predictive biomarker, some even started profiling pre-treatment, identified responders versus non-responders. And the methods they had used to identify this microbiota was 16S RNA, shotgun metagenomics, and quantitative PCR. apart from the complementary already existing tumor mutation burden PD-L1 MSI and all. These all were potential to guide early treatment selection and modification. So can we alter this immune checkpoint inhibitor with a diet and probiotics? Of course, high fiber Mediterranean diet promotes beneficial bacteria, not consuming ultra processed food. Prebiotics and symbiotics. Prebiotics are the food for the probiotics. Symbiotics are the combination of pre and probiotics. So these are much more important than the probiotics. Reason being, probiotics when given, they might be killed with the gastric acid and subsequently they might not be helpful. Are there any interventions? Fecal microbiota transplant, the only FDA approved therapy for C. difficile infections, but they are being researched. Can we take from the responders and use it in non-responders? There are certain engineered consortia which define bacterial combination personalized approaches, and these have already been used in other fields wherein to degrade certain plastics and all. This can be used for the immune checkpoint inhibitor responses as well. So clinical implementations and key consideration is antibiotic stewardship is very important, especially in the larger organizations where you can have this, whereas in the private practice or a lesser clinics, it's very difficult to maintain this stewardship. Pre-treatment assessment and even immune-related adverse events, the dysbiosis in this microbiota would have impact on the checkpoint inhibitors adverse events. But the challenges in studying all this is to have a standardization, inter-individual variability, and of course it has to be replicated in large randomized clinical trials. So in conclusion, the key takeaways and future direction is microbiota is a major driver of immune therapy success. Modifiable interventions offer immediate clinical opportunities. The future is real-time monitoring is important, and personalized consortia, especially combination of different microbiota and multi-omics integration would also help. This completes my slides, but I would like to put a photograph. This man was called as one of the dirtiest man in the world. And for some fear of that he would die if he has a bath, he didn't had a bath for decades together. He stayed in a small village in southeastern Iran. And people he didn't know his actual name. He was called as Amu Haji. And he didn't had a bath for several decades. And researchers tried to study him by doing scopy and skin examination. He was hale and healthy, no parasites, nothing. And somehow villagers convinced him to have a bath. And at the age of 94, he had a bath, and a few months later he died. And in Sanskrit, there is a saying, and, pind, and Brahmand. So that means to say what is there in cosmos is also there in our body. On the left-hand side of this slide is the microbiota which is there in our stool. Thank you.
Thank you, Dr. Arun. Dr. Ashish, if you would like to give a closing comment.
We thank all the speakers for their futuristic insights. And yes, AI has infiltrated every aspect of cancer care, be it starting from diagnostics till the treatment as well as response to treatment. So when we integrate everything with at the molecular level, at the pathological level, and even taking view of the clinician's thoughts, we actually give the patient a true personalized opinion and personalized care in cancer.
Yeah, I think wonderful talk by all the three speakers. I think the last microbiome lecture was very interesting. With use of immunotherapy, I'm sure there will be guidelines to guide us as to which antibiotics to give and pre and post immunotherapy. So I think with this, we will conclude the session, and I'll hand over the mic to the organizers. Thank you.
Thank you to our chairpersons. We now have a panel discussion on continuum of care in HER2-positive breast cancer. This session is sponsored by Roche. I invite our moderator, Dr. Ashish Joshi, Consultant Medical Oncologist, Mumbai, with our panelists, Dr. Shona Nag, Senior Medical Oncologist, Pune, Dr. Bowman Dabar, Senior Medical Oncologist, Mumbai, and Dr. Asma Pathan, Consultant Medical Oncologist, Pune.
So Dr. Bowman had some commitment, predefined commitment, because of the time change. He is not there. So I'll request Dr. Rahul Jaiswal and Dr. Vinayak Maka to join us on the stage, please. So good afternoon, everyone. Thank you so much, Roche, for giving us this opportunity. At the outset, let me thank my panelists. We have a very august panel here, Dr. Shona Nag, Senior Medical Oncologist and authority in the field of breast oncology. She is going to be with us. She was my teacher, by the way, when I was doing my MD in BC Medical College, and we used to have oncology OPD. So, been associated with her since then. Today, we're going to talk about continuum of care in HER2-positive breast cancer, and these are my disclaimers. We are not going to speak about HER2 low or ultra-low breast cancer. This is not a scope of today's presentation. And these are my disclosure. The scientific data has been partly supported by Roche. There are some real-world cases which have been presented in this presentation. And these cases do not intend to promote the use of FESCO outside of the prescribing information and are presented for the discussion purpose only. So the broader contours of what we wish to discuss today is we will probably have 20 minutes. We will divide it into two halves. The first half we will focus on the case-based discussion on the role of dual anti-HER2 blockade in the setting of ADC. As you know that probably we are bombarded with newer antibody drug conjugate in the HER2 new positing setup. And then the second half we will kind of dwell into the real world data of FESGO and treatment implications in the clinic. So if I can turn back to my panelist, this is just one concluding slide which I'm going to put upfront is how do you place dual anti-HER2 treatment in the various settings in the treatment of breast cancer, be it neoadjuvant, be it adjuvant without neoadjuvant anti-HER2, adjuvant with neoadjuvant anti-HER2, metastatic breast cancer first line, MBC second line, and CNS disease and beyond. So maybe we could start with Dr. Shona Nag, madam, your just quick take on this punchy slide which I have put up upfront.
I think it's an excellent slide, and I think by strong you mean level of evidence.
Level of evidence, yes.
Correct. And what we've been doing in practice for a long time. So one of the questions I've always had in neoadjuvant is that the limit for giving neoadjuvant has become smaller and smaller. Earlier we used to restrict it to node-positive disease, and today we are even giving it in tumors more than 2 centimeters, less than 3 centimeters. And there is data to show that you may not need dual anti-HER2 in these patients. So I just wanted my panelists to just comment that in a patient with a 2.5 centimeter tumor, the surgeon has sent you a ERPR negative HER2 positive tumor for neoadjuvant. Would you still use dual anti-HER2?
Sure. Dr. Asma, so Dr. Bowman sir also has joined us, so thank you sir for joining.
So use of dual HER2 anti-HER2 agent in early breast cancer cases with like 2 centimeters, that is doubtful, but even some clinical trials which have used the set of people, such set of candidates, even there is a response. So maybe to know the biology of the disease, and for the adjuvant setting, that may be required.
Dr. Boban sir, your take on this slide. This is the slide which kind of expounds upon the role of dual anti-HER2 treatment in the setting of ADC, and I've mentioned there the week. If you could see somebody who has received neoadjuvant anti-HER2 treatment, then probably you don't push for a dual anti-HER2 in the adjuvant setting. Either you go to the Catherine way if you have got a no PAT-CR, and if you actually have PAT-CR, you actually de-escalate to trastuzumab. So this is just the slide which kind of expounds upon this. So you just quick comment on before we move further.
Yeah, in an adjuvant setup, I do totally agree whether dual anti-HER2 is really required or not for a node-negative disease. But in the neoadjuvant setup, I do use a lot of dual anti, and especially tumor size more than 2 centimeters and all those NCCN guidelines. But ultimately, it's whether you can do a proper conservative mastectomy or not. That is the most important thing for the patient. If if the proportions are proper and the surgeon can do a proper job, then I don't think so. I'll be using double anti-HER2 also in that setting also. Like Shona said, 2.1 centimeter, 2.5, 3 millimeters over. But a surgeon says I can do a proper breast conservation, the lady is ready for that, then I don't think so we should jump into that.
Correct. So Rahul, you take on adjuvant without neoadjuvant anti-HER2, and that's where you have affinity data coming up. Jury is out that node positive DFS benefit, use it, node negative, don't use it.
Okay, I was also about to discuss this point only. So data part, if you see practical, so if you think of this, you are saying if we have given TCH in neoadjuvant and want to go with pertuzumab, addition of pertuzumab, if we have not achieved CR.
We are talking about a setting when the patient has been upfront operated, is a HER2 positive patient, and has turned out to be either node positive or node negative. The affinity 2025 hazard ratios are very clear that if you have got a node positive disease, there is a merit in using dual anti-HER2. For the benefits in a node negative disease, incremental benefits are very minuscule.
Yes. For node positive, I will go. For tumors more than 5 centimeter, I will go. And for the low size, if it is ER/PR negative, then I will lower my threshold to give even in 2 or 2.5 centimeter also.
Correct. Vinayak, your take on the last piece, which is metastatic breast cancer. You got first line data, very, very robust data across the setting. Second line, it starts getting little weaker there.
And the best option to start dual is first line. The data is good, and our experience says that it goes beyond what is given even in the trial. We have patients who are pulled on 4-5 years on only like the Fesco or whichever 2 drugs. Once they get used to even the side effect profile of pertuzumab, and they do well. So no doubt about the first line. Second line is description for ADC actually, but technically.
Yeah.
But challenge will be the data in the first line which is coming, which is also exciting. So it will be tough here to see weigh in, because I always feel the ILD, the element which are there, which are irreversible and very difficult to pick it early, this is going to here to stay for long.
Sure. So I think we'll move on to the case, and this is indeed a hypothetical case. There is an elderly female who has got a locally advanced breast cancer. She has a chronic obstructive pulmonary disease. She's hypertensive. She's diabetic. There is no other family history of breast cancer. She is ER/PR positive, Ki67 of 60%, and she's got HER2, which is amplified by FISH. So this is classic PET. It's not showing any distant disease. It's a local disease. So maybe we could go back to our panelist again. Shonanak madam, 3 options. You got Destiny Breast 011 as option 3. You got TCHP as the first option. And we often use for elderly patients like this with HP with weekly paclitaxel. Which one would you choose?
So I'm most comfortable with TCHP, and if you look at the NeoCarp and the Helen 6 data, you don't have to give the carboplatin, which adds to the toxicity.
Yeah.
So that's an excellent regimen that we have now. And I would do dual anti-HER2 with a taxane. I'd be most comfortable with that. Weekly Pacli in a 68-year-old may be a little difficult due to the neuropathy and the number of hospital visits. And I'm not too convinced with TDXD yet. I think we need to wait a little bit on this before jumping.
Sure.
I think a good old anthracycline is still the standard if required. I won't use it in this patient. And I think we are overusing TDXD in this setting.
Sure. Asma,
I agree with ma'am's opinion. Because a patient is diabetic, more of comorbidities are there. HP with weekly PACD also will go well. But patient is fit enough, then TCHP is the best regimen.
and you still use carboplatin, or because we see a lot of cytopenia, myelotoxicity with use of carboplatin, especially in TCHP regimen, and we often have to do dose reductions or even omit carboplatin as we flow. So what's that in your clinical practice?
Most of the patients, they tolerate well, but wherever we have difficulties, we try to omit it out.
Sure. Boman sir, your take, you have got patients who has locally advanced breast cancer, is absolutely no financial restraints. You got Destiny 11 data. What's your take? Would you use classic TCHP or you use TDXT followed by THP?
I will go ahead with TCHP because there is still more robust data, more long-standing data. So TCHP, although I know the problems that I face with TCHP, requires a lot of more counseling, talking to the patient, everything. But somehow or the other, it goes on with TCHP.
Correct. So Rahul, Destiny 1-1, 3 arms, and eventually the monotherapy arm was discontinued. And here if you see, they had used 4 TDXT followed by THP, and every time it was weekly Taxol in both the arms. And the second was classic dose-dense AC followed by THP. And as you could probably see here, that there is a big delta in the pathological complete response across the subgroup of patients. So would you be really attracted to use this regimen in your clinical practice on a Monday morning?
No, still.
No, but why no?
TCHP is not a bad thing. TCHP.
No, but if you have got almost 20% incremental benefits of PAT-CR, you got a drug which is there, patient doesn't have a financial constraint, what holds you from using it?
See, if finances apart, then also I have to see many things in the patient. Like finances is a real thing because the cost is too much. Then also, as Vinayak said, TDXD, you have a CLD issue, interstitial lung disease, and we are comparing with the TCHP, which is itself a very good thing. Suppose this data would have come with TCH only, and you ask me to add another ADC, then I would have been more happy to add. But already it is compared with TCHP, which is itself is a very good protocol, and still around 15 to 20% patients are only taking that. So I would not just write off TCHP,
sure,
even with this data.
Madam, have your comment? Yes.
So I'm not in a hurry to get rid of anthracyclines like the West is. I think they've gone a bit crazy trying to, replace anthracyclines with everything possible. You're giving only 4 cycles. That's the first point. The second point is that with TDXT, you're using everything up front. It's not true that patients who get a PCR in HER2 positive disease don't ever relapse. I have had patients relapse. I'm more comfortable with a triple negative getting a PAT-CR because that is less likely to come back. But a PCR in a HER2 positive does not guarantee the disease not coming back. And in that case, I really need something like TDXD as a backup.
Sure. I think very, very important comment. Vinayak, your take on Destiny 11 data, and then we will move on in the interest of time.
I agree with the previous speakers. The thing is, this didn't have a de-escalatory arms. I have a problem with, no one is trying to reduce it, either with Catherine or here, no one is trying to de-escalate also. So they need to de-escalate sometime, like either, if you're given pertuzumab with dual, you'll continue dual, or you'll escalate to the TDM1. Where is de-escalation? We are reaching there, we have to de-escalate.
Yeah, so I think in terms of de-escalation, currently obviously there is no...
no, in fact, if it is not compared, anthracycline, if so much is to get rid, why not other arms should be there with carboplatin also? Anyway,
so I agree with all the panelists. I think the message is loud and clear that don't jump the conventional regimen of TCHP or anthra subsequent to dual anti-HER2 blockade still continues to hold, because PAT-CR alone will not dictate your treatment decisions, and you have a lot more to achieve, especially in the relapse setting when the patient has got a relapse disease in an HER2 positive setting. So I think these were the few questions which I think most of our panelists have very well answered, and there's some interesting study which is going on, which is going to give us the results that whether in a patients who have not had PAT-CR, whether do you use TDM1 or TDXT. I think Destiny 005 breast would probably give us the answer. So the role of dual anti-HER2 treatment in the adjuvant setting without neoadjuvant anti-HER2 is very clear. Yes for node positive, no for node negative. In the setting where you've used neoadjuvant anti-HER2, obviously there is no much role of dual anti-HER2, because TDM1 is clearly superior in terms of patients which you do not achieve PAT-CR, and those who achieve one, then probably you de-escalate to trastuzumab alone, which is fairly good enough. In terms of metastatic disease, it's already been quite punchy here. We know that a dual anti-HER2 blockade has shown significant improvement in response rate, PFS, OS in the first-line MBC across the setting. It works with various combinations of chemotherapy, hormone therapy. It is an active component of a regimen involving ADC in the first-line setting with PFS benefit established, and it's the role in the era of ADC is very, very strong. And when we go to pertuzumab monotherapy, of course, it's not effective as we know, but in the second-line setting, I think TDM1, TDXT has got a very, very strong data as we speak. The patient ended up receiving neoadjuvant chemotherapy with FESGO, did not use TDXT. Of course, that was not there in 2024 when this case was studied. Eventually had a pathological complete response, and the patient was put on maintenance FESGO as adjuvant therapy for a year. Coming to the real world experience now, often there is a talk about subcutaneous administration, and you got intravenous dual anti-HER2 blockade in the clinic. So how do you make a clinical decision? Maybe I would start with Dr. Vinayak. Dr. Vinayak, your call.
So if the financial issues is not there, I prefer
no financial
subcutaneous
disclaimers.
Is much tolerable. Somehow interesting with our patients, I have not seen the diarrhea, which with generics I see more often with one company more than other company. But that is really troublesome actually. When you start with neoadjuvant, when you have docetaxel also with that arm, otherwise it doesn't much differ in a metastatic disease where you're giving just 1 or 2 paclitaxel along with dual thing. But definitely it is I would prefer this one in terms of patient comfort and quality of life, not on oncology or other outcomes.
So you think the toxicity is slightly better? Of course, apart from the quality of life issues, which are anyways an additional benefit.
They are happy with this subcutaneous thing. They're reluctant for that IV injection.
Lesser diarrhea, probably.
Sometimes the surgeons put a chemopotent side and I put on FESGO. That's what also happened actually.
Of course, that's a real world scenario. So Rahul, your experience with subcutaneous trastuzumab?
Yes, patients are happy, and this port is also very important. We are not required of port. Requirement of port goes off with subcutaneous FESGO. That is also a very good point, because every time to have injections and this chance of port infection is always there. And for the neoadjuvant it's okay, because you are anyway taking chemotherapy by IV, but for the adjuvant or even for metastatic, then taking only subcu injections without any IV break or without any central IV line is a great advantage.
Especially when you're not using anthracycline.
Sorry?
Especially when you're not using anthracycline.
Correct. Mohan sir, your experience subcutaneous FESGO versus intravenous Pertu Trastu. Now you got generic ones as well. How do you play in your clinic?
Initially I thought that, as they said, the port is there, and since IV is there, then why not IV? But I have seen most of the patients, even with the port, now prefer subcutaneous.
Subcutaneous.
The short term, means nobody likes to stay in the hospital for a long period, so fatafat ho jata hai, means everything. Sisters will, in fact, sisters tell us, sir, first go and see this patient, because it's subcutaneous. I said, those patients come before. No, sir, we'll finish off with that patient, so we have a bed. So I have to go and see them first, even if they are...
Typical daycare conversation. So Asma, any challenges you see, because it's typically given in the upper part of the thigh, sometimes you do see a lot of pain in the local area, but fairly manageable, I believe?
Yes, sir, fairly manageable, and because of the guidance to the nursing staff or doctors who are giving, the continuously support from the farmers to give it properly, so we are not facing such problems for the subcutaneous thing. So we use IV, but IV has more of like first week and fatigue, diarrhea is common, especially with the biosimilars.
So, madam, I think you must have first to use subcutaneous Vesco. I mean, I remember in my first daycare, all the Roche team had come when we had given the first Vesco subcutaneously.
Handhold us for the first few. And we have a small publication also with the Indian experience of about 30 patients.
Yeah, so
this
I think
has, obviously the numbers have gone up, but what was interesting was they were well divided between metastatic and neoadjuvant, and we had amazing PAT-CR rates of about 70 to 80%. And we also did a patient satisfaction survey with these patients. And they were really happy. And the other thing was some of this happened during COVID times. So we were able to send the nurse to the home to also give Vesco. So there was no interruption in the treatment.
No treatment interruptions.
So overall, it's been a great experience.
Yeah. I think these few slides expound data which even we did at MOC with the help of Roche's team. This was led by Dr. Udip and Dr. Disha. They were instrumental in getting this data collated. And again, echoing what Dr. Nag just mentioned, that there were 30 patients across the subtypes, neoadjuvant, adjuvant, metastatic, all the 3 subtypes. And very echoing similar to what we see in clinical practice, almost 75% PAT-CR rates. And then again, patient satisfaction also rates were very, very significantly high. And this is just a comparative various study. The first one is the MOC study, and then the one and the last is one which Dr. Nag did. It's also expounded here. A very impressive CR rate, very satisfactory patient's quality of life, and that has definitely impacted the patient's outcome. Again, so I'll end my slides with this take home. Again, neoadjuvant setting very strong. Adjuvant without neoadjuvant anti-HER2 very strong. When you are again going into the setting where something neoadjuvant has been used, then you do not have strong role for dual anti-HER2. Metastatic breast cancer first line, dual anti-HER2 has very strong role to play, and as we go beyond, probably you have got better agents to play with in this setting. With this, I conclude my panel discussion, and I thank all my panelists for their active participation, and thanks organizers for giving this time. Thank you so much.
Thank you, Dr. Ashish, and all our panelists. We now have Dr. Udip Maheshwari, Consultant Medical Oncologist and Hemato-Oncologist, Mumbai, to talk on liquid is solid in NSCLC. This academic session is sponsored by Zydus.
Wrong slides. Who's doing the slide work? Good evening, everyone. So this is a session sponsored by Guardant and Zydus, and they've given me the slides for this particular talk. So we'll be talking about liquid is solid, and particularly talking about the Guardant 360 NGS that is available to us, right? So specifically in lung cancer, we all know that 5.9% of all cancers and 8.1% of all cancer-related deaths in India is due to lung cancer. Incidence is rising from 7.9 in 2008 to 27.2 in 2018. 87% of male patients are smokers compared to 27% of female, and more than 90% are diagnosed at advanced disease. So if you see the 5-year survival rates over time have increased in USA, have increased in other countries like Japan. However, in India, the 5-year survival rates over 2004 to 2014 have gone down, rather. So it defines the unmet need here. And if you see for stage 4 NSCLC, we all know first line actionable mutations, and in patients who are not actionable, then we look at PDL1 for IO and chemo. So 45 to 70% of our lung cancer patients may benefit from targeted therapies. So looking at the Garden 360 data of the past NSCLC patients with a landscape profiling, we see that highest number of EGFR, as in, about 28.6% of EGFR mutations are seen. Surprising good 10% of ERBB2 is seen, which is a slightly higher side number. Is classically a lot of TP53 are seen in Indian patients, more than 50%. And that is median TAT is about less than 7 days, ctDNA detected in 93.4% of samples, and at least one clinically relevant gene which was seen in at least 51% of the samples. So 21% of these patients had targetable mutations beyond EGFR, ALK and ROS, and that is where it signifies that mutations beyond the common ones are better picked up on an NGS, right? So if we discuss it through a case, a 65-year-old never smoking woman from China, 2016 lung cancer resected, N1 adjuvant chemotherapy taken, 2018 recurrence in bone, mediastinum and lung. EGFR testing was negative by RT-PCR, platinum rechallenge was done, stable disease, moved to Canada, enrolled in a trial of nivolumab, continued until 2020. Should we rebiopsy? Is something that was a question, and ideally we in clinical practice do rebiopsy such patients who are recurrent, and in rebiopsy there was an EGFR mutation which was seen. Again, patient was started on therapy, did show a classical response to the anti-EGFRs. So NGS identifies twice as many EGFR exon 20 insertions as opposed to PCRs. We all know that PCR misses about 50% of exon 20 insertions because it only looks at 4 or 5 out of total 10 to 17 insertions that are variants that are being seen on NGS. So picking up of EGFR insertions, which is a very common thing nowadays, we are finding a lot of insertions, and a lot of newer therapies are available for these insertions, exon 20 insertions. We should be doing NGS in such patients so that we do not miss out on these. Right, so integrating liquid biopsy into routine diagnostics will help more advanced lung cancer patients access this optimal therapy. Absolutely yes, and that has been shown by the trials done here as well, that liquid biopsy will pick up more number of mutations, and that is where we see these chart where impact of upfront NGS testing. So patients whose NGS reports were available prior to first line treatment versus patients who've not had an NGS report prior to first line treatment, there is a stark difference in the graph. If you see median 24.6 months versus a median of 6.2 months. Again, a real world analysis reiterating the same thing, that patients who've had an NGS first line have had better overall survival as opposed to patients who have had in second or third line, right? So coming to the aspects of tissue and liquid, I think we've had a lot of discussion on tissue and liquid as well in the moderation by Dr. Preetham, where we discussed that the tissue liquid, which to do, when to do, what advantages, what disadvantages. So primarily what I see is the advantages of tissue would be, that it's one considered gold standard. Second, there could be some IHC testing for PDL1 that can be done on it, and also beyond DNA, if you want RNA and other analysis, that can be done better on a tissue. And the disadvantage could be that there is a higher turnaround time, limited tissue that may be available for testing, and then comes the liquid biopsy, where there is a higher turnaround time. It's faster, it's better. If you don't have tissue, you can do it upfront. It's easier to generalize, or anyone can take. Otherwise, for tissue, where the biopsy is done, how much is the biopsy processed, how is the processing of the fixing of the slides and blocks done. So all of that matters. For liquid, that process is reduced, right? So what do the guidelines say? Most of the guidelines have validated sensitive ctDNA assays can be used as genotype for advanced NSCLC. And in fact, initial genotyping with ctDNA has been recommended for treatment naive advanced NSCLC and as first line probably for TKI resistance, right? So there have been, all the guidelines have been in favor of these tests. So if you see as I was talking about the process that involves a tissue versus a liquid, obviously the process arm of the tissue is slightly longer as opposed to liquid. Also the testing if liquid is done with solid, together tissue and liquid is done, then you pick up more number of mutations. An additional 77 mutations were identified in cfDNA versus a 60 mutations identified in tissue, which was statistically significant difference, and doing both can identify obviously more number of patients. And cfDNA results are available earlier as compared to 9 versus 15 days, which is again a significant finding. So a Nile study again highlighted the significance of NGS testing, and most of them who were tested were treated and are continuing to be in response, and overall response rates of about 58 to 60%, which we see in most of the mutations positive. So complementary liquid and tissue profiling can be done. There are 3 ways to do it. You do a tissue followed by a liquid, you do a liquid followed by a tissue, or you do liquid and tissue both. There are pros and cons for both. However, we would err if cost is no barrier, liquid plus tissue doing together is obviously better, right? So going towards the next slide, for the liquid plus tissue, there is now things going on for liquid plus tissue testing, which increases the number of actionable alterations found. So insufficient tissue in 3 to 44%, incomplete testing, alterations in plasma only seen. So all of those seen, if we combine, if you see tissue plus liquid combined both, they'll pick up definitely more mutations, and you can see that across studies where blue is always the dominating color in all the studies. So tissue plus liquid definitely picks up more mutations, right? So liquid biopsy has faster turnaround time versus tissue genotyping, and leading to shorter treatment time to treatment. So 9 versus 15, as I discussed earlier, value trial again 7 versus 20.5 days, and then there's a real world analysis study 8 versus 22 days. So again it harps on the fact that we have liquid, which is a faster turnaround time, faster time to treatment, and we don't have to wait for giving the patient their desired treatment. Right, so advanced lung cancer and molecular testing in middle of coronavirus disease 2019, there was one paper which showed that 354 respondents, mostly from India, medical oncologists, 74% start treatment before molecular tests have arrived, and of these 56% would switch if actionable mutation comes, and while 12% would continue the initial treatment. So that is why turnaround time or TAT is important in such patients. At least 50% of advanced NSCLC do not receive second line treatment, and increased risk of severe immune related events once they have received immunotherapy, and post that if they have to use a TKI or a target therapy, the immune mediated side effects may be bothersome. So again, third thing that we are going to talk about is detecting resistance, clonal evolution in real time. So detecting resistance across use of TKI, there could be MET amplification, secondary EGFR, PIK3, cell cycle mutations, BRAF mutations, KRAS or HER2, and picking up these mutations on a liquid biopsy is recommended as an initial testing, but evidence based on first generation agents rather than current standard, right? So only 39% of patients with first line osimertinib resistance able to have successful repeat biopsy and NGS, need for better liquid biopsy detection of complex resistance mechanisms and histological transformation. So if you see from the dates, as we go every progression there is different mutation profiling that we can see, and definitely doing a blood or a liquid NGS will help in finding out the mutations. Here again, liquid biopsy guiding treatment and diagnosis of resistance. Patients with ALK positive lung cancer progressing on crizotinib with a Guardant360 test, they could pick up two ALK mutations which are sensitive to third generation ALK inhibitors, and giving them would definitely benefit these patients. So picking up these mutations as a resistance mechanism to first line therapy is very important. Similar tree for ROS1 rearranged lung cancer, wherein picking up resistant mutations in ROS can lead to better targeted and treatment therapy. So cancer tissue sample liquid biopsy, tissue quality is critical for analysis, standard pathological practice, complete histological information and relatively large amount of materials are the limitations with respect to tissue samples. Liquid biopsy is minimally invasive, multiple sampling is possible, potential for early screening and dynamic monitoring for disease control is the advantage. There could be no testing is perfect. There are definite pros and cons for liquid, which we've already discussed, and pros and cons for tissue. But should we do them together? A large study demonstrated that tissue genotyping alone may not deliver timely results before first-line treatment, again reiterating the same fact that we discussed before. And there is a prospective real-world study of clinical Guardant360 in a newly diagnosed metastatic NSCLC that shows that there are detected an additional 39 tier 1 patients with liquid. So from 85 patients with tissue alone to 124 patients with tissue and liquid, reiterating the fact that doing both of these together, the third arm would be an ideal way to save time as well as get more mutations and get more rare mutations, get those additional 10 to 15% of mutations, right? So initiating tissue and blood CGP at the same time will capture all 124 targetable actionable mutations 50% faster than others. And that is what, again, diagnostic algorithms again say the same thing, that do we do tissue together or plasma together or do both together. I feel that a complementary approach is the best way forward right now, which gives us the best possible results, right? So to take home, liquid biopsy is an important tool to ensure optimal treatment in patients with advanced lung cancer with potential to accelerate treatment and start and avoid repeat biopsies. Concurrent tissue and plasma genotyping is feasible and significantly increase the proportion of patients with successful guideline recommended testing overall and prior to initiation of first line therapy. Comprehensive complete genotyping results prior to the start of first line therapy is associated with significantly longer overall survival. These results support the incorporation of liquid biopsy in routine clinical practice alongside tissue testing, as well as in setting where tissue or time for molecular testing is limited. Also, I feel that tissue, the liquid testing is very important with respect to lung cancer, where tissue is always an issue. So liquid testing now, in first line mutation detection is also a very important way to move ahead. So thank you everyone for patient hearing. Any questions are welcome.
Thank you, Dr. Udit. Thank you. We now move on to a session that continues to shape treatment paradigms in breast oncology, redefining treatment outcomes with immunotherapy in early triple-negative breast cancer. I invite Dr. Minish Jain, Consultant Medical Oncologist, Pune, to deliver this talk. This academic session is sponsored by MSD.
I thank the organizers for inviting me for this talk. This is a sponsored talk from MSD, redefining treatments outcome with immunotherapy, early triple-negative breast cancer. Here, what we are going to look forward is the pembrolizumab in combination with chemotherapy is the first and only anti-PD-1 inhibitor which has shown a significant improvement in high-risk early-stage TNBC by improving the pathological CRs the event-free survival, and OS. And also we're going to understand Keytruda or pembrolizumab in treatment of TNBC, the dosaging, the administration, and the safety consideration. An overview of triple-negative breast cancer. We know that this is number one in terms of incidence and mortality. 175,000 cases annually, 90,000 deaths. So this is definitely one of the most important. In 2030, India would see more deaths with breast cancer than any other disease for females. TNBC, out of the breast cancer, we know that this is one of the most aggressive forms. Worldwide, it is 15 to 20%. In India, we do see a larger chunk, 27 to 35%. This is definitely higher prevalence. This is triple negative means ER, PR, and HER2 negative. Higher incidence of TNBC is seen in younger adults, adolescents, and these are larger tumors with higher grades, with more lymph node metastasis, with more likelihood of distant metastasis and death from the cancer. So it carries a very high risk. If you compare it with breast cancer, TNBC has a time to recurrence is half. It's almost 20 to 40 months compared to 35 to 67 months. And if it is a loco-regional recurrence, the 1 year survival is 80, and it keeps dropping. 2 years, 73, 3 years, 65. If there is distant metastasis, you see the numbers drop even further, 47, 28, 23. And if there is a combination of local recurrence and metastasis, it's worse, almost 30% at 2 years and 20% at 3 years. This is again showing the same thing. Localized disease, TNBC do well. Regional disease has a relatively poor prognosis, and distant mets have worse prognosis. Because TNBCs grow very quickly, they are likely to spread at the time of diagnosis, more likely to recur even after the treatment. And that's the reason why we need to be really good at treating these patients. We need to be as aggressive as possible upfront, and we need to attack the tumor even when it is our early breast cancer. Now there are different kinds of risk factors for TNBCs, modifiable and non-modifiable. The non-modifiable being age, genetic mutations, ethnicity, genetic history, density of breast, history of radiation and breast diseases. But certain things are modifiable, like drugs, calcium channel blockers, tricyclic antidepressants, estradiols, BMI. And what we have seen is even a BMI more than 25 in India, which is like overweight, is also a risk factor for most of the females. Physical activity, sedentary lifestyle is definitely a risk factor. Alcohol intake, which is increasing these days. Vitamin deficiencies, chemical exposures. Smoking is becoming important because there is an increase in smoking in females worldwide. Almost 1.6% increase, and the smoking in males are going down. Intake of processed food, we all know that has been the lifestyle for the young generation. This is classification of TNBC. TNBC has multiple subtypes. What we are interested in is the immunomodulatory subtype, which can be detected by gene signatures. Though we are not using it routinely, but that is like 10 to 20% of these patients are immunomodulatory. They are increased TILs, they have high CTLA, they have high PD-L1 expression, and they are immune hot. So they are the best ones to be attacked by immunotherapy. You have specialized IHCs also to detect this subtype. The current treatment, what we have is like, it's because we don't have a target for TNBCs, there is a limited molecular targeting, and chemotherapy is the only option available as of now. But in 2022, there was an update from ASCO. Patients with T1C N12 or T2 to T4 N0, that is stage 2 and 3, early breast cancers, TNBCs, where the panel recommended pembrolizumab along with combination of neoadjuvant chemotherapy and following pembrolizumab post-surgery. So this was definitely a breakthrough, because earlier we knew that only 30% of TNBCs were benefiting out of chemotherapy, and neoadjuvant chemotherapy was showing a benefit in these patients. For TNBC, we should have a multidisciplinary approach. The surgeons, medical oncologists should work together, and patients should be taken up for neoadjuvant chemotherapy whenever possible and not for surgery directly. So this is definitely improving and optimizing the treatment will improve the outcomes in this kind of patients. Conventionally, neoadjuvant chemotherapies had a pathological CRs of 35 to 45%, and Keynote showed a superior pathological CRs up to 64% in these patients. The benefits of preoperative systemic therapy: it facilitates breast conservation, it renders inoperable tumors to operable, allows time for genetic testing, allows planning of breast reconstruction, and it also helps us to treat TNBCs and HER2 positive, because you will know the prognostication of these tumors depending upon their response, and you can treat them based on the residual disease post-treatment. This is an NCCN guideline definitely allowing all patients who are in early breast cancer to be taken up for preoperative immunotherapy, pembrolizumab, along with chemotherapy. Neoadjuvant systemic therapy shift Keynote showed that there was an improvement in EFS, event-free survival, in pembrolizumab combination, and the hazard ratio was 0.63. In United Kingdom, what they found was a lot of patients, 30% of patients, were opting for mastectomy over the neoadjuvant systemic therapy, and they were missing the potential opportunity to do a surgical downstaging. Neoadjuvant systemic therapy improves surgical outcomes. It downstages the tumor, allows breast conservation. It also gives you an opportunity to look at the response and prediction of the outcome of a patient. It helps us based on the pathological response. We know that if there is a pathological response in a TNBC, the outcome is going to be superior. It helps us to reduce down the axillary clearance and the axillary morbidity. TNBC, as we know, is an immunogenic disease and has a higher expression of PD-L1 and more TILs. But while using pembrolizumab, you don't need to look at PD-L1 scores before starting it. You can start it irrespective of that. Blockade of PD-1, PD-L1 axis has emerged as an therapeutic target to enhance anti-tumor activity. And in Keynote 522, the addition of pembrolizumab to platinum-based neoadjuvant chemotherapy resulted in significant increase in percentage of patients who achieved pathological CRs. The addition of pembrolizumab was continued post-surgery, and it could be continued either with radiation or without radiation. So you can either complete radiation and then continue pembrolizumab, or you can continue it along with that. Pembrolizumab in combination with chemotherapy as a neoadjuvant treatment and then continued as a monotherapy in adjuvant setting is indicated in patients with locally advanced or early stage triple negative breast cancer at high risk of recurrence. So this is Keynote 522. This is the design. Basically Keytruda or placebo given 3 weekly along with carboplatin either 3 weekly or weekly, and along with paclitaxel weekly. Then there were 4 cycles of doxorubicin or epirubicin along with cyclophosphamide, and Keytruda was continued. The surgery was done at end of 6 months, and then Keytruda was continued or placebo was continued depending upon the scenario. So the enrollment was anybody who had a tumor more than 1 centimeter and less than 2 centimeter with nodal involvement, or more than 2 centimeter irrespective of nodal involvement. These were included irrespective of their PD-L1 expression. The patients were excluded if they had autoimmune diseases or they were on immunosuppression. They were stratified based on nodal status, positive versus negative, and tumor size T1, T2 versus T3, T4, and the choice of carboplatin weekly versus 3 weekly. And this was the schedule, what we had discussed already. What we see here is that almost half of the patients were node positive, half were negative, and significant 70% patients were T2. And you see the benefit is seen almost in all categories. And there is a correlation of pathological CR and OS. Again, that's very important. This was a study, there were 52 studies, 27,000 patients, 1999 to 2016. What they found was if there was a pathological CR, that led to a better OS, hazard ratio of 0.22. So this was definitely an important thing, and which we also saw in the study. In TNBC, if there was a pathological CR, the 5-year survival was 90% versus patients who had no pathological CR, the 5-year survival was 57%. So that was the Kaplan-Meier for pathological CR. And if you look at the event-free survival, patients who had achieved a pathological CR had a longer EFS and OS than patients who had residual disease. So in both situations, a pathological CR becomes an important thing. 13.6% patient had more pathological CR in Keytruda arm compared to only chemotherapy and placebo. So 64.8 versus 51.2. If you had node positive disease, they had a better delta, 20.6 versus node negative, 6.3, but both benefited out of this. And the forest plot shows that it was benefiting every patient. So early tumors, node negative, node positive, triple negative, consider immunotherapy. That is what was the meaning out of that. EFS at the first interim analysis, 18 months, 91.3% in pembrolizumab arm compared to 85.3. So with an intent to treat population EFS, again we see 16% of patient had an EFS compared to 24% in placebo. So there was almost a 37% reduction in the risk to event. Patients with pathological CRs, they predict definitely a better outcome with or without pembrolizumab. So in patients who had only chemotherapy and had a pathological response, they were doing good. But patients who received pembrolizumab, even with residual disease, their event-free survival was better. So that was seen in the lower part of the trial, lower part of the slide. Safety, there was definitely 5% plus side effects extra, what you can see from placebo, diarrhea, rash, pyrexia, decreased appetite, but they were all manageable. Grade 3, grade 4 were not so significantly higher. All grades, if you look at 34, 41, 24, 30, so a small percentage increase in immunotherapy subgroup. Keytruda and chemotherapy combination resulted in overall statistically significant benefit to placebo in all subgroups. And in summary, event-free survival, as I said, was better in Keytruda, 16 versus 24. The EFS was better, 87.8 versus 81 at 24 months. At 36 months, 84.5 versus 76.8. And the pathological CRs were superior, 64.8 versus 51.2. This is a case which we can go through. This is just a hypothetical case. BMI of 29, young patient, Mrs. Radhika, who had a 2.1 centimeter tumor, node negative. Biopsy was done, it was triple negative. PET scan was negative, ECOG performance 0, stage 2A. She was planned for Keytruda and neoadjuvant chemotherapy, 4 cycles of paclitaxel carboplatin 3 weekly, and 4 cycles of doxorubicin and Keytruda. So she had, after 12 weeks of treatment, she had abdominal pain and diarrhea, and she was diagnosed as immune-mediated colitis. She had to undergo steroids for a month, which subsided, and then subsequently, once the patient settled, she was resumed with immunotherapy, and she completed her treatment subsequently. The adjuvant part was completed. She had hypothyroidism immune-mediated, which was detected at a later date, and then she was started on hormone replacement for that also. So these are real life scenarios where you do get immune mediated complications, and you may have to handle them and keep going. But then the patient had achieved a pathological CR on her surgical specimen post surgery. So the recommendation today for early TNBC is neoadjuvant immunotherapy, chemotherapy, followed by surgery, followed by adjuvant immunotherapy. And you may consider these patients subsequently based on the residual disease. There are certain patients who can be considered for either addition of capecitabine or olaparib, though we do know that BRCA positive patients may not benefit out of immunotherapy that much, but these are individually you can plan your treatments. Thank you.
Thank you, Dr. Manish.
Any questions?
Thank you. Right, everyone. Caffeine levels are steady. Neuron. And it's the perfect moment to move into a topic that keeps all of us on our toes, early breast cancer. Welcome to Academic Session 10. This session comes together under the expert supervision of our session director, Dr. Shalaka Joshi, consultant surgical oncologist, Mumbai, and our session coordinator, Dr. Ritu Dave, consultant medical oncologist, Pune. I also invite our chairpersons, Dr. Bharat Parikh, consultant medical oncologist, Ahmedabad, Dr. Sanjay M.H., consultant radiation oncology, Pune, Dr. Nimesh Lodh, consultant surgical oncologist, Mumbai, and Dr. Almas Pathan, palliative consultant, Pune. To begin, we have a panel that brings forward the strength of multi-speciality collaboration, reflecting exactly how early breast cancer is managed in real life together. This session is supported by AstraZeneca. I invite our moderator, Dr. Chetan Deshmukh, consultant medical oncologist, Pune, and our panelists, Dr. Nilesh Mahale, consultant radiation oncology, Saroli, Dr. Prabhat Bhargav, consultant medical oncology, Mumbai, Dr. Rohan Kharde, consultant radiotherapy and oncology, Ahilyanagar, Dr. Swati Surarkar, consultant breast surgeon, Pune, Dr. Tabassum Varasadwala, consultant radiation oncologist, Mumbai, Dr. Amol Ubale, senior consultant radiation oncology, Chhatrapati Sambhaji Nagar, Dr. Jay Anam, consultant breast surgeon, Mumbai, Dr. Shuchi Sharma, dietitian, Pune, Dr. Vinita Pant, senior pathologist, Mumbai, Dr. Aparna Katdare, consultant radio diagnosis, Mumbai. Over to Dr. Chetan.
Thank you. Thank you, Dr. Tushar, Dr. Ravi, Dr. Mangesh, Dr. Ashwin, and team MOC in general. And I don't see my med-onc colleagues. Do you have any medical oncology guys? Nobody? I'll have to take the support of somebody from the audience, and I have quite a few medical oncologists in the audience. So let us begin. Dr. Manish thankfully has finished his talk a little ahead of time, so that gives me a couple of minutes extra. These are my disclosures. Early breast cancer, essentially up to stage 2A. The reason why I didn't include stage 2B is because there is a patient population with T3 which may be taken as 2B, but a lot of people consider it as LABC, so I'm not going to take 2B into it, just 2A. And there is a lot of discussion, lot of streamlining of therapy which has been done as far as the treatment of early breast cancer is concerned. There are ISMO guidelines, there are so many other guidelines, NCCN guidelines are always there. And we all go by one of these guidelines, whichever school of thought we follow. What I wanted to know from the panel is, since we are looking at early breast cancer, a lady has reported in time, we have to reward her with something. So do you believe that she should be subjected to de-escalated therapy, or we should be offering her full-fledged therapy, all guns blazing, young curable patient, we should go all out? So what is the mood of the panel? Do you feel that in today's world, do we look for de-escalation or escalation? You can, any one of you can pick up and start.
Yeah, of course, depending on the molecular subtype,
Okay.
it is definitely the era of de-escalation, loco-regional as well as systemic therapy.
Fine. Go ahead.
What we have achieved in terms of Hodgkin's lymphoma and NHL also, so same should be the goal for breast cancer.
So de-escalation.
Yeah, certainly.
So everybody is for de-escalation. So you based, Dr. Tabassum said that she's going to look at the molecular aspect. Anything else you would like to look at before you plan escalation or de-escalation?
Age of the patient.
I'm sorry, age, okay. I just listed a few things. Of course, disease biology is important, disease volume, how big is the disease, nodal status and all that, biomarkers of course, comorbidities, fair, and of course age remains an important aspect. So let's see how the panel de-escalates or escalates this therapy. She's a 58-year-old known diabetic school teacher. She's presented with a left breast lump since 3 months, clinically about 2 by 2 centimeter, no axillary nodes. A mammography was done, a solitary lesion 1.6 into 1.3 centimeter, no microcalcification, no axillary nodes. We have a radiologist on board, right, Dr. Kaddare. So in this era when we have fantastic PET scans, do we still need a mammography?
Absolutely.
So please let us know what all additional information and how important is that
What's written
information.
in the slide itself that we need for the microcalcifications, there is nothing other than a good mammography that will show that.
Correct. And for the benefit of the audience, what would the microcalcification tell you if it's pleomorphic or?
Okay, so a typical Birat's 5 lesion has pleomorphic microcalcifications. The other types of calcifications could be coarse heterogeneous, which also we classify to in
which
4
will be missed
or 5.
Which will be missed on a PET. Fair. So we need, for local therapy, mammography remains an important investigation and should be done today. Apart from the same breast, it also gives idea about the other breast, other non-palpable lumps in the other breast as well. So it's an important test. Nevertheless, this lady underwent a PET scan as well, which showed an FDG avid lesion in the left breast, about the same dimensions, no axillary distant mets. Biopsy was suggestive of an invasive breast carcinoma, grade 2. This lady on biomarker analysis turns out to be ER 90%, PR 60%, HER2 new 1+. Dr. Prabhat is here. Yeah, welcome Dr. Prabhat. But I'm going to focus most of my questions today on the radiation and surgical colleagues because in most of our panel discussions we don't get them. So I'm going to ask quite a few questions. So small tumor, less than 2 centimeter tumor, clinically node negative in the axilla, nothing on the PET. Upfront surgery or upfront chemotherapy? Any takers? Dr. Prabhat, any role of upfront chemotherapy?
No, sir.
No, fine. Surgeons, we have 2 surgeons, Dr. Swati and Dr. Jay. Yes.
Yes, surely we can go ahead with upfront surgery for the patient. We discussed the option of breast conservation for her. Also the need of radiation if breast conservation.
We'll come to radiation. We have 3 radiation oncologists. We'll come to that. Dr. Swati, any role of mastectomy in this lady? She's 58, fit.
Yeah. As she is 58 years old lady, she's a professional lady.
A school teacher.
Also, I would take into consideration breast to tumor ratio. The size of
It's favorable. The tumor is small, 2 centimeter. She has a fairly...
So, upfront breast conservation surgery I would recommend to her.
Imagine there were, on the mammography, Dr. Kaddare reported that there were 2 additional foci of 6 millimeters and 4 millimeter. Maybe one in the same quadrant, one in a different quadrant. Will that change your plan?
Yes, definitely. if those foci are with microcalcifications, or is there asymmetric?
They are positive on PET as well.
So with oncoplasty now, we can get those
Yes,
two also
no.
out.
So you'll still go in for.
Yeah. So
Fine.
and the field of radiation and all, we can decide.
We'll come to that. So I surgeons are great doers. We physicians love to talk, but surgeons do it. Today we are talking about de-escalation and all those things. When de-escalation was not even on the horizon, way back in 1980s, Umberto Veronese quietly did something which was revolutionary. He did a quadrantectomy in place of a regular Halstedian mastectomy and showed in more than 700 patients that the survival did not change, the progression-free overall survival did not change. So that was a unique thing which had to be done. Coming down to multifocal and multicentric tumor. So for these patients, even today, there may be a role of saving the breast. This was a large meta-analysis, close to 30,000 patients, and interestingly, the recent studies have shown that there is no difference in disease-free as well as overall survival. So probably as our techniques have improved, as our disease biology knowledge has improved, we are getting better and better. And Dr. Jay just mentioned that he would like to do oncoplastic surgery. So even if it's a multifocal, multicentric tumor, if the lady is desirous of saving her breast, yes, we can go ahead with breast conserving surgery.
All the traditional contraindications have become relative now because we are able to better map the disease and also take out all the foci and target radiation also appropriately with multidisciplinary coordination.
Excellent. Axillary surgery. So this lady, do you feel she needs a full axillary dissection, sentinel node sampling, or you can omit axillary dissection altogether? Dr. Jay and Dr. Swati, only you guys do it. So
definitely with the data now, she will require sentinel node biopsy.
Okay.
From my side, it's means axillary clearance is not required for her, as well as I cannot omit.
So fair enough. You are okay with sentinel node sampling. Dr. Swati?
Yes, sentinel node biopsy.
Suppose this lady had a bigger tumor to begin with, say 5 centimeter tumor, received neoadjuvant hormone therapy. Then what would be your plan? Same?
So now, for ladies who have had NACT or NAHT, we can still safely do sentinel node biopsy.
Fine.
Or a low axillary sampling also.
Absolutely, because axillary dissection has its own share of problems. This
But it's very important to also radiologically image the axilla and prove that it is radiologically also negative.
Fine. The point is, if we are cutting down on surgery, we also need to cut down on the axillary dissection because it has long-term problems. Almost 20% of women will develop arm lymphedema, which is not a very comfortable thing to happen. So yes, ASCO guidelines do tell us that sentinel lymph node biopsy is a good thing. This lady decided for primary surgery. She was planned for sentinel node sampling. At surgery, there was one sentinel node positive for metastasis. Do you still, Dr. Swati, do you still go ahead and complete axillary dissection, or you leave it at that?
I will go ahead with axillary dissection.
Full axillary dissection for this lady, level 1, 2, 3?
Level 2 up to level 2.
Up to level 2. Dr. Jay, any different thoughts? One sentinel lymph node positive, ER 90%, PR 60%, HER2 negative.
She fits into the criteria of Z11 trial also. So actually, if breast conservation is done, I would like to know that how many nodes were excised for her.
4 sentinel nodes removed, 1 is positive.
So so she fits into Z11 criteria. So by de-escalating her axillary surgery, I need to radiate the axilla now. So
Fair. Are you going to go ahead with axillary dissection? Yes or no?
No, sir.
No. Fine. This lady underwent breast conserving surgery. Again, sentinel node sampling. The final histopathology report was again IDC grade 2, T1C 1.7, 1.3, 0.9, 1 out of 5 sentinel nodes positive. We did not proceed with full axillary dissection. This was the biomarker status. Now this lady, somebody has told her that she's node positive, she's going to need chemotherapy. She's already Googled chemotherapy, and these are the standard side effects of the 4 classes of drug which we use commonly. Alkylators, anthracyclines, taxanes.
Can you qualify the node as micro or macromet?
It was a macromet, clear, straightforward. about 0.7 centimeter met. Let's make it clear cut. So, this lady has already Googled these side effects. Dr. Prabhat, you are the sole medical oncologist. Are you going to offer cytotoxic chemotherapy to her? Yes, no?
Considering postmenopausal grade 2 tumor.
58-year-old postmenopausal PT1C N1 disease. ERPR positive, HER2 negative.
I would like to offer Oncotype DX, but if
okay.
not feasible.
So you are going to discuss molecular testing. Okay, we have a pathologist on board. I'm going to come back to you for KI-based decision. Okay. Any takers for just mutual discussion and, you know, आप क्या चाहते हैं, बहन जी आप क्या, that types, anybody, any takers for that? No. So you want Oncotype DX. Fine. You have four different tests today, Oncotype DX, ProSigna, whatnot, and our own homegrown can assist. How do you decide?
Sir, robust evidence is for Oncotype DX.
Best evidence is for Oncotype DX. Fair enough. Suppose this lady was not keen on Oncotype DX or she simply cannot afford it, which 95% of our patients are fit that bill. She cannot afford it. What would have been your plan?
Then it would be my decision based on other soft markers.
Other soft markers. Which soft markers?
I don't do remaining 3 of them, what you have shown on screen. So other soft markers was, that is why I was saying age.
She's 58.
A grade 2
fit.
tumor, very small, 0.7 centimeter one node. But against this, that it is not strongly hormone positive.
Oh, she's 90-60.
60%. PR determines more prognosis compared to what ER determines prognosis wise.
I think the cutoff is 20, right? So 60% is good.
60% is good, but I am not happy if I have to take decision.
Okay, fair enough. So no takers for anything else except Oncotype DX. Am I right?
I thought mammoprint is also.
Well, TMH says Oncotype, so Oncotype. Now, Dr. Vinita, you know, ISMO guidelines say more than 15%, 14, 15, I don't know. International Breast Cancer Study Group says KI of more than 19 is important. Monarchy study, we did the trial, the cutoff was 20% for high risk. There's an Italian study by a tongue twister name, he or she has said that it's 32%. And none of the gene-based analysis even look at Ki67. So how do we go about this business? You do Ki67 from 3 labs, you get 3 different results, 10, 20, 50.
Yes, because there are multiple variables starting from pre-analytics, analytics. I'll not go into the pre-analytics. We are presuming that the lab has got its SOPs in place. Now, in analytics, according to the Ki67 working group for analysis of Ki67, they have given that the cutoff of less than 5% and more than 30% is reliable. Okay. So, interpathology discrepancy in these two ends, 5% and 30%, is very low, inter-observer. What happens is, now how is the pathologist looking at it? Is he looking at the whole tumor and giving an average Ki67? Is he or she looking at the hotspots and giving you the Ki67? Before that, is she looking at the biopsy? Are we looking at the excision, heterogeneity? So there are multiple factors in, this is not a one value, it's a continuum.
So to cut a long story short, do you feel that we should be using Ki67 as one of the soft markers in early breast cancer decision making?
As a soft marker, yes.
Yes.
It gives you some idea.
Some idea. Fair enough.
So long as more
I have some more questions for you because
I describe it.
Okay.
So if I see that it's a tumor which is showing hotspots, some activity in hotspots, not in the overall. So I say it has a heterogeneous distribution, and in this area I see this much.
Okay. Another thing is about this Maggie scoring. There's a lot of work going on. People have shown, the Western world has shown that there is some concordance between Maggie score and the Oncotype DX. There's a small Indian paper also where they found reasonable concordance between the low risk score and the Oncotype DX, but as the score changes to high and moderate risk, of course the concordance drops to 50%. So we have specialists from multiple institutions. Do your pathologists give you this Maggie score? And what is stopping us from doing this Maggie equation? Dr. Vinita, if you... Yeah, please. Yeah, go ahead, Dr. Tabassum, go ahead. You said something.
I mean, we don't, it's not reported at our place.
You do?
It's not reported.
It's not reported, I know, but what is stopping our pathologists? It doesn't sound very complicated. So why can't we do it? It will give us an idea. Ultimately, telling someone to spend $40 to $100, it's a lot of money, right? So why can't we do it? Or should we be pushing for it? Is it technically challenging?
I have no experience with this.
Okay, fair enough. Dr. Prabhat, coming back to you. This lady you wanted Oncotype DX, you got Oncotype DX. Oncotype DX score is 32. So what is your plan of action now?
So she's low risk. High risk. So
yeah.
She needs chemotherapy.
How much? Suppose this lady wouldn't have done chemotherapy and you would have gone with your soft markers. How many courses of chemotherapy would you give? T1N1, T1C N1?
Considering T1N1, even taxanes are indicated.
I'm sorry?
Even taxanes are indicated after 4 days.
So how many courses so you would have given 8 courses even otherwise. So now this lady is 32. Will you go ahead with
yes,
the full course again? Okay. Just based on her high risk, genomic high risk score, do you think this lady will require CDK4/6 adjuvant? She's node positive, 1 node positive, 0.7 centimeter. Do you feel that she may be considered for adjuvant CDK4/6 inhibitor?
Considering a risk score of 9 years, 20%, I think we should offer her CDK4/6 inhibitor.
You will offer her, that's interesting. So 5-year risk score is high. So you want to add some CDK4/6 inhibitor, one of the two, whichever is feasible, right? What about genetic counseling? She's 58, ERPR positive, HER2 negative. Does she go in for genetic counseling? Do you test routinely? Anyone from the pathology or anyone from the panel? Do you test these patients routinely?
Not everyone for 58 years of age.
But the cutoff says 65, below 65 everybody.
You used word routinely twice, so I thought let's say no.
Okay. Now, radiation therapy. What are the options of radiation therapy? So, she has heard and she's Googled something called APBI, Accelerated Partial Breast Irradiation. It finishes off in time, so she doesn't have to skip her school for a long time. Radiation otherwise will be about 15-20 days, every day, going to the unit, coming back, Saturday, Sunday. She has holiday to school, but radiation is also not working on Saturday, Sunday. So what do you do?
So I differing this from her, I mean whatever is her Google knowledge. So even whole breast radiation can be completed in 1 week.
Okay.
And we can also offer patients a weekly treatment on a Saturday, and she exactly fits into the criteria of offering ultra hypofractionation.
So these are the criteria for APBI.
Yeah, so she even
agreed.
Criteria for APBI, she can be offered APBI with external radiation.
Okay.
Also,
Okay.
it is also possible to do brachytherapy. So both the options are possible, and we will ensure that she completes her radiation in 1 week.
Okay, so you are okay with the abbreviated.
But would you do APBI for node positive also? Node.
Yeah, so node positive patients are generally not considered for APBI. That's why, I mean, whole breast radiotherapy can be, for this particular case, it is whole breast radiotherapy with addressing the axilla also, because the axilla has not been addressed.
Fine. Dr. Sanjay, you wanted to make a point.
Major advantage that APBI had was short duration of treatment.
Of course.
But now whole breast can also be done in 5 settings.
In 5 settings.
APBI loses the advantage, that particular advantage.
Okay.
Anyway, she was node positive. Node was 1 node out of 5.
Fair. But can we omit radiation therapy? She says, well, low risk.
Not in this case.
Not in this case. Why?
Maybe probably pointed to new data.
Yeah, because there were a couple of studies where they showed that
But in that study, around 2/3 patients were very early, ER positive, postmenopausal.
Okay. So suppose this lady would have been node negative, would she be a candidate for omitting radiation therapy? Assuming she's node negative. T1C, N0.
Low grade, then,
grade 2.
Yeah, grade 2.
you would still consider for RT. Fair enough. Now imagine an alternate scenario. She's triple negative, same size, everything same, 58-year-old. Does the same plan apply?
No, sir. More than 5 millimeters in size can give an advantage. I don't want to operate the patient and then have a positive node. So
I'm so happy. So, you know, I just wanted to ask the surgeons in the field, in the hall, keep your hands on your heart and tell me how many triple negative, more than 1 centimeter tumors are referred for chemotherapy upfront. Because that is not what we usually see. You know, the cutoff is actually quite variable. Yes, guidelines say 1 centimeter, but 2, 2.5, sometimes even 3, breast tumor ratio favorable. Very often, Dr. Swati is already nodding. So what is your experience, Dr. Swati, if you have a 2.2 centimeter tumor triple negative?
Definitely, I will give her an option of first neoadjuvant chemotherapy. But again, it's in our Indian scenario, what is seen, people are more afraid of chemotherapy rather than surgery.
Absolutely.
So,
fair enough.
So you have to take chemotherapy after the surgery.
Yeah.
So why not give it first and finish?
That is true. That I am so happy that you are speaking on my behalf. That is great. But still, now assuming that the tumor was small, 1.7 centimeter max dimension, do you put a clip at diagnosis, or do you let in some courses of chemotherapy and then go ahead with the clipping? After 1 or 2 courses of chemotherapy. Fine. Now, let us assume that the patient turned out to be the same T1C, N1. What is your plan of adjuvant chemotherapy? Of course, here there is no need of any testing. Dr. Prabhat, standard protocol for T1, N1, triple negative.
AC, taxanes and even carboplatin.
AC and taxane. Let's take it one. AC is fine. Taxane weekly, bi-weekly, dose dense, or 3-weekly docetaxel?
Because I would like to add carboplatin, I will give 3 weekly.
So you want 3-weekly paclicarbo for 4 courses. Okay. And what about any addition?
She's 50.
She's 58, diabetic.
No carboplatin, only dose dense.
No carbo. But then the carboplatin data, Dr. Gupta sir's study was for NACT. Here you are not giving NACT. It's been already operated.
Agreed. But that does not, till now we know that NACT and adjuvant are one and the same. In reference to Gupta sir's studies, we know NACT and adjuvant does not impact OS. You can give either of them.
Yes.
So I would extrapolate Gupta sir's study in adjuvant also.
Okay.
And another reason we have multiple trials that even adjuvant carboplatin does help.
Fair enough. So adjuvant paclicarbo, you will finish it off in 3 weekly, or if you feel that she is a diabetic 58-year-old, you don't want to use carboplatin. Both are. Any additional workup now that she is triple negative? Would you do a BRCA for her? She's triple negative now.
Yes, definitely.
Yeah, okay, because she's node positive, will you consider her for any additional therapy?
She's even node positive. No, I don't practice maintenance 1-year capecitabine presently. Otherwise,
no, but this is post-surgery. There was upfront surgery.
Even adjuvant 1 year of capecitabine can be given.
I was asking about olaparib.
But olaparib, she's 1 node positive, and if she is BRCA positive, yes.
Fair enough. Now, I was told that there's a dietitian on board, but the dietitian is not here, so I'll skip the dietary questions. There's an interesting survey actually which we did. There are a lot of restrictions on diet which patients self-impose, and WhatsApp University also imposes on them. So multiple restrictions, and unfortunately there is no good scientific evidence to back any of these. In fact, there is a trial to the contrary that there was a randomized trial in pediatric patients who underwent chemotherapy. They were subjected to these so-called neutropenic diets, and that did not make any impact on the infection. In fact, going for this diet required more effort than regular hygienic food. So let's not go by. Let us quickly finish the second case. She is a 43-year-old lady, young, no comorbidities, banker, presents with a right breast lump since 2 months, clinically 3/2 centimeter with a suspicious axillary node, mammography, more or less the same dimensions, PET scan, nothing else in the system. essentially a localized or a loco-regional disease. Biopsy is ERPR negative, HER2.
That it is really positive. And
FNAC is positive.
Then with paclitaxel, trastuzumab, pertuzumab, and followed by AC.
So dual HER2, so pacli, trastu, pertu, followed by AC.
For 4
So then you are going to interrupt your HER2 directed therapy during AC regime.
Yes.
Okay, because most of the standard protocols today are comfortable with TCHP or
no.
So why do you want to?
Even Destiny Breast 11 compared it with AC only. Still standard worldwide.
No, I'm okay. I'm a fan of doxorubicin. It was the otherwise young willing to come.
Even I got excited and I've tried in 3-4 patients, but it has severe neuropathy. The dose of
neuropathy
is too
troublesome.
stiff.
Fair enough.
Finish all 6 cycles.
Fair enough. Now this lady somehow was started on dosi, carbo, trastu. How frequently do you assess these patients on therapy? Every 2 cycles, every 3 cycles? Ultrasound, PET? No, this comes from TMH, so this is going to be practiced from Monday.
I am smiling because residency in between, so sometimes it becomes a challenge. But yes, for PTs, if paclitaxel trastu is given, then after 4 cycles we do a formal evaluation with the surgeon also.
Okay.
Whether they are happy with the response or it is not, or they are not. And if everybody is happy, then we continue with neoadjuvant chemotherapy.
After 3 courses, she did an ultrasound and it shows a complete response. Can we avoid surgery for her? The surgeons?
No, sir, we cannot avoid this.
Okay. No, there was some, I was just reading, there were some studies where we can omit surgery after NACT. Some interesting studies, not a small number, quite a few studies have. So if you can do repeated vacuum assisted biopsies and document a PAT CR, can we avoid surgery?
No, sir, we cannot avoid this.
No, okay. Fair enough, ERPR negative, HER2 positive, it's an aggressive disease. So you wouldn't want to push for such adventurous therapy. But I believe that if we have better targeted therapy, maybe some more ADCs and MAPs coming in, that day is not far where we can do away with surgery. We'll probably
that day is very far.
I understand. But yes, that day at least is on horizon today. You know, earlier we were thinking of doing a complete mastectomy, now we are looking at only minimalistic surgery. So probably that will also happen. So I think that's my last slide. Just to summarize, early breast cancer, we are seeing more and more patients with early breast cancer. Our screening uptake is improving. We have more aware patients, so we'll have more and more early breast cancer patients. And of course, we'll have to plan some strategy where this patient receives standard therapy which will not affect her chances of cure, at the same time giving her the least amount of morbidity. Using biologics is going to be used more and more often, and of course with radiation techniques improving, as Dr. Tabassum said, even regular radiation therapy we can finish off in 5 days, and that's a great benefit to all of us. Thank you very much.
Thank you.
Thank you, Dr. Chetan, and thank you to all our panelists. Up next, we have a recorded talk by one of the most recognized voices in breast oncology worldwide. We are honored to have Dr. Shahina Dawood. She currently serves as an adjunct clinical professor, Mohammed bin Rashid, University of Medicine and Health Sciences, consultant medical oncologist, Dubai. It is truly a privilege to have her share insights on TNBC in 2025. Can we have her video, please?
Good afternoon, everyone. Thank you for the invitation. I wish I could have been there in person, but I'm sure the interaction will be great. I was actually asked to be across different targets such as the incorporation of immunotherapy, PARP inhibitors for those patients with BRCA mutations, the use of antibody drug conjugates, the use of AKT inhibitors, and of course anti-androgens. Now in the last decade, the use of immunotherapy has been extensively explored in the first-line setting of patients with metastatic triple-negative breast cancer in combination with chemotherapy. We saw the results of the passion-1 trial that looked at atezolizumab plus nab-paclitaxel that improved progression-free survival and overall survival in those patients with PD-L1 positive disease. The passion-1 was a negative study that looked at the combination of atezo plus paclitaxel, and of course our standard of care pembrolizumab plus chemotherapy, the Chemo 355 study that did significantly improve both the progression-free survival and overall survival of patients who had tumors that had PD-L1 CPS score more than or equal to 10. Question is, can we improve better the prognostic outcome with the incorporation of antibody drug conjugates? And we have seen multiple trials that looked at a heavily pretreated group of patients looking at antibody drug conjugates, such as DATU-DXd, negative breast cancer. We have seen improvement in prognostic outcome with the incorporation of ADCs. We saw the results of the ASCENT trial that randomized patients to sacituzumab govitecan versus physician choice of chemotherapy, where it improved median progression-free survival as well as overall survival. And the OptiTrop Breast 01 study that looked at sacituzumab tramotecan versus physician choice of chemotherapy, again a significant improvement in progression-free survival and overall survival with the use of ADC. We've seen the results of the Tropion Pan-Tumor 01 trial that looked at Dato-DXd in this realm. And you can see it was associated with an overall response rate of 32% and a median progression-free survival of about 4.7 months. So the question that we ask ourselves in 2025, if we take ADCs into the first-line setting, will it improve prognostic outcome? And we did see two very important studies at ESMO this year that looked at patients in the first-line setting, metastatic triple-negative breast cancer, who were not candidates for PD-L1 inhibitors. We saw the results of the ASCENT-03, Tropion Breast 02 trials, very similarly designed trials randomizing patients in the ASCENT-03 to sacituzumab govitecan versus physician choice of chemotherapy. Here, crossover was allowed to sacituzumab govitecan in the control arm, and doublet chemotherapy was allowed in the physician choice of chemotherapy arm. Tropion Breast 02 randomized patients to Dato-DXd versus physician choice of chemotherapy. Crossover was not allowed, and doublet chemotherapy was not allowed. Some other differences between the two studies: ASCENT-03 only allowed patients who had recurrent disease to have a DFI of at least more than or equal to 6 months, and the primary endpoint here was progression-free survival. In the Tropion Breast 02 trial, any disease-free interval was allowed in those patients who had recurrent disease, but it had to be less than 12 months with a cap of 20%. And here the primary endpoint was co-primary endpoint of progression-free survival and overall survival. When you looked at the patient population, you can see that only about 5% of patients had actually received neoadjuvant or adjuvant immunotherapy. And again, this is not reflective of the patient cohorts that we're going to see in 2025. Nonetheless, when we're looking at the progression-free survival, both trials met its primary endpoint of improving progression-free survival. You can see in the ASCENT-03, the absolute improvement was 2.8 months. In the Tropion Breast 02, the absolute improvement was 5.3 months. You can see that in the ASCENT-03, the control arm of physician choice of chemotherapy, actually these patients did better than in those enrolled in the Breast 02 arm, really calling into question, is this due to the doublet chemotherapy that was was allowed in ASCENT 03. When you're looking at that top part of the Kaplan-Meier curves, you see a very early separation of Kaplan-Meier curves telling us that the use of ADC is showing an impact very early on. When you're looking at the response rate in ASCENT 03, sacituzumab govitecan was associated with an overall response rate of 48% in TROPION-Breast02 study. Dato-DXd was associated with an overall response rate of 63%. Overall survival was significantly improved in the TROPION-Breast02 study. You can see it improved the overall survival from 18.7 months to 23.7 months, favoring the group of patients who are getting Dato-DXd. As of now, in the ASCENT 03, there is a descriptive analysis suggesting an overall that a benefit with the use of sacituzumab govitecan in terms of overall survival. But however, remember that crossover was not allowed in Breast 02, but it was allowed in the ASCENT 03 trial. We have a number of other trials that are going to be looking at other ADCs in that first line setting. TroFuse 11 is one of those trials. They're looking at a purely PD-L1 negative group of patients randomized to sacituzumab trimotecan or sacituzumab trimotecan plus pembrolizumab versus physician choice of chemotherapy. Now, why are we considering other combination strategies? And I'm going to take you back to the Keynote 522 trial in the recurrent setting, and just looking at those patients with residual disease post getting pembrolizumab and chemotherapy in the neoadjuvant setting, and you can see that they do very, very badly, telling us that we need to have better strategies for when they relapse, because they have a high risk of relapse. But more importantly, it also tells us in those residual patients, in those patients with residual disease post-op, even though they do badly, when you're giving them immunotherapy, they're still doing better than if you don't give them immunotherapy. Begging the question, can we potentially combine ADCs with immunotherapy in those relapsed patients? We've had a number of phase 2 studies, phase 1, phase 2 studies have actually looked at this question. The Begonia trial combined Dato-DXd plus durvalumab in that first line setting in metastatic triple negative breast cancer patients, and you can see in the arm 7 study, in the arm 7 of this study that enroll patients irrespective of their PD-L1 status, you can see an overall response rate of 79% and a median progression-free survival of 13.8 months. In the Morpheus Pan breast cancer study, the combination of sacituzumab govitecan plus atezolizumab in those patients with PD-L1 positive metastatic triple negative breast cancer, first line again, 30 patients, the overall response rate was 77% with a median progression-free survival of 12.2 months. In Begonia, when you looked at arm 8 of the study that focused on those patients with PD-L1 high tumors, you can see an overall response rate of 81.8% when you combine durvalumab with Dato-DXd. A number of ongoing phase 3 trials is taking what we saw in the phase 2 trials to the phase 3 trials. We've got the TROPION-Breast05 that's looking at Dato-DXd plus durvalumab versus physician choice of chemotherapy plus pembrolizumab in those PD-L1 positive patients. The ASCENT-04, which is already read out at ASCO this year, that looked at sacituzumab govitecan in combination with pembro versus physician choice plus pembrolizumab in the first line setting in those patients with PD-L1 positive disease, and you can see that we have seen a significant improvement in the progression-free survival going from 7.8 months to 11.2 months, favoring the group of patients who are getting sacituzumab govitecan plus pembrolizumab compared to physician choice of chemotherapy plus pembrolizumab. Now, is there a rationale to do something even more novel, like taking immune checkpoint inhibitors, combining it with an anti-VEGF plus chemotherapy? There's a strong rationale for giving this triplet combination, where you can see there's a lot of synergy that can actually be had by combining the 3 agents together. And we've seen a number of phase 2 trials that has explored that. We've seen a phase 2 trial that's looked at invonicimab, which is a bispecific antibody of anti-PD-1 VEGF, and then BNT327, which is another bispecific antibody, and then the combination of AK105 which is an immune checkpoint inhibitor in combination with anolitinib, which is a tyrosine kinase multi-targeting anti-angiogenic inhibitor, and they've all been explored in phase 1, phase 2 studies in combination with a taxane in patients with PD-L1 positive as well as PD-L1 negative disease, and you can see some very decent overall response rate, about 80% across the group, and then you can see a progression-free survival of about 9 months with invonicimab, 13.5 months with BNT325, and about 10 months with AK105 and the TKI. Now, if you look at invonicimab or BNT325, you can see that the benefit in terms of overall response rate and PFS is irrespective of the PD-L1 status, really telling us a significant anti-tumor activity, low primary resistance, and the overall response rate and PFS seem to be independent of the PD-L1 expression. Now, when you're looking at these triplet combinations and really looking at the overall response rate and the PFS and sort of comparing it to Ascento-3, Tropion-Breast02, and Ascento-4, I think it's very decent. And I'm looking forward to those phase 3 trials that are actually going to explore looking at bispecific plus chemotherapy in that first line setting, and whether it can break the 10 to 11 month PFS benefit that we're seeing with ADCs in that first line setting will be very exciting. What other novel strategies are we considering? Well, HER3 is a potential therapeutic target. We know that 30% of patients with metastatic breast cancer will overexpress HER3, and it is associated with a poor prognostic outcome. We've seen some early preclinical as well as clinical activity of patritumumab deruxtecan in the heavily pretreated group of patients that's targeting HER3. You can see in the metastatic triple negative breast cancer cohort overall response rate of 16% and a median progression-free survival 5.5 months. Can we target deficiencies in the DNA repair pathway? Simple answer is yes. We've used PARP inhibitors in those patients with germline BRCA mutations. You can see from Olympia D and Embraca that using either olaparib or talazoparib is better than physician choice of chemotherapy. Question is, can we use better PARP inhibitors? And that takes us to the next generation of PARP1 selective inhibitors with AZD5305, PARP inhibitor, which is highly selective, more than 500-fold for PARP1 versus PARP2. We know that PARP2 is essential for erythropoiesis, and only PARP1 inhibition is really required for synthetic lethality in that HRR deficient setting. So it's hypothesized that if you use an inhibitor that's more selective for PARP1, it will have a favorable tolerability profile, it will enable higher drug exposure over target, it will achieve greater and more durable target inhibition and achieve greater anti-tumor efficacy, allowing broader combination options. So we have seen from the Petra trial that looked at AZD5305 study in patients with BRCA1, BRCA2, PALB2 and RAD51C mutations across multiple tumor subtypes, including breast cancer, and we saw some very, very impressive results. So again, I'm looking forward to this in the phase 3 study. Now, again, we should not forget there's so many other targets that we need to be looking at in the metastatic triple-negative breast cancer, not only directed at DNA repair pathways and immunotherapy in those inflamed phenotypes, but also looking at alterations in AKT pathway, androgen receptor pathway, and of course those agnostic markers such as HER2 mutations, NTRK fusions, and RET alterations. Now, what are the challenges we are going to face in the clinic as we start to incorporate antibody-drug conjugate? We're going to start to have to think about mechanisms of resistance to antibody-drug conjugates, both at an antigen expression level, ADC cellular processing level, and of course at the payload level. And as we start to have multiple ADCs in the clinic, we're going to have to think about how to optimally sequence patients with those ADCs. The use and sequence of two ADCs sharing the same target but different payload may not produce significant cross-resistance, and maybe that's the way to go, unless data exists on the use of ADC sequencing of two ADCs with different targets but with similar mechanism of action of the payload. So we may need to start to think about this. Now, we do have a number of retrospective data, more so in the hormone receptor positive HER2 negative realm. They've looked at ADC followed by ADC with sacituzumab govitecan and trastuzumab deruxtecan. And when you sequence these two ADCs, you can see that the second ADC doesn't have as good a progression-free survival compared to if you take one ADC sequencing it with chemotherapy. So again, a lot of work needed in this realm, and there are a number of clinical trials that are actually looking at sequencing ADC with ADC. One of them is the TRADE-DXd study, very interesting study that's looking at HER2 low patients, sequencing T-DXd followed by Dato-DXd or Dato-DXd followed by T-DXd in both the hormone receptor positive, hormone receptor negative cohort of patients. Now finally, where are we with the management in the early stage setting? We know that in the early stage setting, Keynote 522 is the standard of care in the early stage setting, where we're giving neoadjuvant chemotherapy plus pembrolizumab. And we know that when patients undergo surgery, if they achieve a PCR, they do fantastic. If they have residual disease, they don't do as well. So our efforts have really been to improve regimens, or to get regimens that will improve pathological complete response. And to this end, we are taking ADCs into the neoadjuvant setting. One of these studies is the Herthena Breast 03 trial that's specifically looking at that. And in the post-op setting, we're focusing our efforts on directed therapy based on residual disease, and we're taking ADCs into this study, and there are a number of clinical trials that are actually looking at this. We've got the Trofuse 012 study that's looking at sacituzumab tramotecan in combination with immunotherapy. We've got the Optus and the SASIA trial that's looking at sacituzumab govitecan in that residual disease setting. So in my final slide, I want to show you the current NCCN guidelines that's telling us in the first line setting, you use a combination of pembro plus chemotherapy in patients with a PD-L1 CPS score of more than or equal to 10. If they've got a PD-L1 CPS score of less than 10, you use systemic chemotherapy with a PARP inhibitor being an option if they've also got a BRCA1 or BRCA2 mutation. This is now going to change with all the data I've shown you. We know the Ascent 04 is going to replace Keynote 355 with sacituzumab govitecan and pembrolizumab being now used in combination in those patients with PD-L1 CPS score of more than or equal to 10. We now know that in those patients PD-L1 negative tropium breast 02 and sacituzumab tropium breast 02, which used Dato-DXd, and Ascent 03 that looked at sacituzumab govitecan can be used in those patients with a CPS score of less than 10. And I'm looking forward to the Tropium Breast 05 study that's going to take what we saw in Begonia and tell us that Dato-DXd in combination with durvalumab can be used irrespective of the PD-L1 status, but that is the future. As of now, we're going to see a change in the NCCN guidelines with the incorporation of ADCs, and that will be very exciting, but perhaps cost is going to be the biggest barrier. So thank you very much.
Shifting gears, it's time to spotlight a domain where every case feels like a new chapter: rare tumors. These are the conditions that challenge protocols, sharpen judgment, and remind us why multidisciplinary collaboration matters. To lead this session, I request our session director, Dr. Vijay Patil, consultant medical oncologist, Mumbai, and our session coordinator, Dr. Nilesh Dhamne, consultant medical oncologist, Kolhapur. I would also invite our chairpersons for this segment, Dr. Chandrasekhar Pethe, consultant medical oncologist, Nashik, Dr. Rakesh Neve, consultant surgical oncologist, Pune, Dr. Sonali Pingle, consultant radiation oncologist, Pune, and Dr. Vaishali Shinde, consultant radiation oncology, Pune. We have a richly informative case-based panel discussion featuring 3 challenging scenarios, the kind of cases that make us pause and then dig deeper. Guiding this discussion is our moderator, Dr. Vijay Patil, joined by a panel of experts, Dr. Shiv Kumar Thiagarajan, consultant head and neck oncosurgery, Mumbai, Dr. Smith Seth, consultant medical oncologist, Mumbai, Dr. Rahul Pathare, consultant medical oncologist, Pune, Dr. Gaurav Ningde, Consultant Medical Oncologist, Kolhapur. Dr. Nikhil Himthani, Consultant Medical Oncologist, New Delhi. Dr. Sagar Gaikwad, Senior Consultant Radiation Oncology, Mumbai. Dr. Bhushan Bhalgat, Consultant Oncosurgeon, Pune. And Dr. Amit Jain, Consultant Pediatric Hematology and Oncology in BMT, Mumbai.
Yeah. Thank you. And we have 3 cases today. The first we will focus on mucosal melanoma. The second will focus then on anaplastic thyroid cancer. And third, I will hand over to my colleague to focus on medulloblastoma. So we'll keep 15 minutes for each. And let me go with the first case. So this is a case which actually came last week. 41-year-old female, no comorbidities, no major surgical or any history in the past. She had pain over the right submandibular region for 3 months. She noticed a tiny swelling for which she was given antibiotics. And it was not getting resolved. So they did an FNAC that got reported as metastatic melanoma. A PET scan was done which showed that there was a lesion in the scalp which was around 1.8 centimeter, likely source of primary. And there was a left supraclavicular neck node which was by that time 4.3 into 2.2 into 5.2 centimeters. On examination, there was when I had seen her, she had a lesion in the scalp which was clinically 5 by 3 centimeters and a large node in the submandibular region which was again of the around 5 by 4 centimeters. So here, let me come to Shiva. Shiva, cutaneous melanoma of the head and neck region. How would you approach this case?
Yeah, I mean, this lesion appears to be pretty advanced in the sense that not just the submandibular gland, but also the supraclavicular node. Though I don't see any distant metastasis, but it gives me a hint that it's an melanoma as such being aggressive, this being, not the straightforward one. So I wouldn't go, and operate, do surgery upfront. Maybe I'll consider, depending on the affordability of the patient and various other aspects. Going with immunotherapy and then maybe surgery later.
Let me put this case in a different manner. 1 centimeter lesion in the scalp and a 1 centimeter single node. And completely mobile, no issues. Would you then operate this patient? Or
maybe I would consider upfront
maybe you
surgery.
could consider operation. Let me take opinion from Dr. Bhushan also. Oh, Dr. Bhushan is not here. Oh, so Shiva, we have only one surgical oncologist. Okay, so let me come to the medical oncologist on the panel. And let me start with Rahul. Rahul, if such case comes, what would you plan for this patient? And why?
This case.
This case.
So, I will offer the option of an immunotherapy to the patient.
Okay.
I will explain the option of an nivolumab plus ipilimumab if patient is afforded.
Okay, great. So you want to plan Nivo-EP for this patient. Dr. Nikhil, what would you plan? Nivo-EP or Pemro? Or you want to do a BRAF in this patient and then check for it?
So irrespective of BRAF, I think in first line, I would consider for Nivo-EP in this patient.
Okay, Nivo-EP. Let me go to Dr. Goel. Okay, Dr. Goel is not here. Okay. Dr. Gaurav, what would you plan?
Yeah, definitely, sir. So, doublet immunotherapy will be the...
So, what you are seeing is there is a very consensus that if this, and this is ESMO guidelines, if this is stage 3 disease, which is node positive disease, then you have 2 options here. The ESMO allows either an upfront surgery to be done, as Shiva rightly pointed out, you could do a surgery and then give adjuvant PDL1 to the patient. And the other option is either to give a dual immunotherapy of neoadjuvant Neo-EP, and then operate the patient and then give further based on pathological response. Or you also have the option of giving neoadjuvant pembrolizumab to the patient and then give adjuvant pembro to the patient. Now, let me come on this to the medical oncologist. If you are given a choice of what to use, then what would be the thing which you would want to do? Neoadjuvant or adjuvant? Let's say that you are sitting on a tumor board and can someone help me to move the slides? You are sitting on the tumor board and the surgeon is saying that it's a small lesion, I want to operate. Do you want him to get operated or you say no, I want to give neoadjuvant? And I would want an opinion from all 3 medical oncologists. Rahul, you can start. Oh, Gaurav has the mic, you can start from there. Resectable case, Shiva says, I want to operate. Are you going to say in MDD, go ahead and operate, or you're going to say, no, I want to give neoadjuvant immunotherapy? Basically, the question is what immunotherapy has to be given in a node positive. What is the advantage of neoadjuvant immunotherapy over adjuvant immunotherapy?
So as such, we don't have much data on neoadjuvant immunotherapy. So I think if it is operable, then we should operate it first. And
Okay. Any other difference of opinion?
So ideally, theoretically speaking, neoadjuvant immunotherapy is supposed to work better because of the tumor bulk and release of tumor neoantigens. Again, there is lack of data, so I think either of the approach is acceptable.
Okay, so in melanoma, cutaneous melanoma, we have two randomized trials in which neoadjuvant and adjuvant has got compared, and both the trials with pembrolizumab or with neo-EP, both are New England Journal articles, and both show that giving neoadjuvant gives a distinct EFS advantage to the patient. There is definitely no overall survival advantage. And if you see the EFS advantage, it's not small. It's in the range of around 25 to 30% at the end of nearly 1 year itself. Second, now there is a new classification which called International Neoadjuvant Melanoma Consortium classification, which allows you to get the pathological response after surgery. And if you have a pathological response of PCR or MPR, which is less than 10% viable tumor or no viable tumor, you can actually safely exclude the adjuvant immunotherapy after that. And this data comes from a recent trial called PRADO. So if you use, so at present guidelines allow you to use both adjuvant and neoadjuvant, but if you use neoadjuvant, in 60% of the patients you are likely to get a major pathological response. In them you can do away with the adjuvant immunotherapy itself. Now let me come to Shiva. Mucosal melanoma versus cutaneous melanoma differences. How do they differ?
So I think basically, I mean this is from the the site of origin itself, and the prognosis per se for mucosal melanoma is poor. And though we can extrapolate what applies to cutaneous to mucosal to some extent, but more, largely they are two different entities.
Correct. Correct. Though both are melanoma, they are completely two different entities. And what this graph shows you, that BRAF in cutaneous is around 50%, but if you look at mucosal, it's around 3 to 15% according to different series. Even the response rates to immunotherapy of a cutaneous melanoma versus a mucosal melanoma are grossly different. So you need to be very careful with respect to mucosal melanoma. Now let me come to my radiation colleague, Sagar. If there is a mucosal melanoma and Shiva has operated it and it comes to you, there is node negative. Let's take two situations, A, node negative, B, node positive. In which situation you are likely to give radiation to the patient and why?
Two things, sir. First of all, so I can count how many melanomas have been referred to me for adjuvant radiotherapy. So there is not a very strong data to go either way. Second thing, it's a very unique disease. It just basically radiotherapy is a regional treatment. So many times the planning becomes complicated. For example, this patient had 2 scalp lesion, 1 over node. So we need to be sure what we are targeting and is it really practical to do that.
Correct.
And the third thing, what I try to do or what is practically followed, we follow the same principles like any head neck malignancy. If it's a locally advanced disease, if the margin was a challenge, if there were multiple nodes and local control could be a problem, in such cases we do offer, but in limited cases, sir. Yeah.
Shiva?
Yeah, so I just want to add that mucosal melanoma compared to cutaneous melanoma, it's very difficult to get a negative margin in mucosal melanoma compared to cutaneous. So that's a major challenge.
Correct. Correct. And that is where probably you could throw the adjuvant radiation toward the patient, and there's good, now I won't say good data, there is reasonably amount of data on 300 plus patients that it does add to local regional control. We'll come to the second case, Shiva. This was a lady, which is 68-year female. She presented with a small lump over the left lacrimal duct, and it was there for long standing. Each March, she saw an ophthalmologist who advised a DCR for presumed nasolacrimal obstruction. The patient kept avoiding it, took homeopathy treatment, and the lump continued to increase. In July, they tried to attempt a DCR, but the surgeon found that lacrimal sac had a mass which was abnormally hard, and hence the DCR was withheld and a biopsy was taken. And that biopsy initially was reported as PCOMA, which then we sent it to Tata, and that got reported as malignant melanoma. And then the workup started, which did show that she had a high-grade metabolically enhancing soft tissue in the left sacral region with erosion of the adjacent left nasal bone and soft tissue extension in the left nasal cavity. And tiny nodules in the lung which were considered as indeterminate. Because it was very close to the orbit, we got an MRI orbit done, which showed that it was an epicentered around the left lacrimal gland, going up to the medial canthus, extending into the nasolacrimal duct and into the left inferior meatus also. It was found to be very close to the medial rectus, and this is the case. What would you do if this case would have come to you?
So I think this would entail surgery which will also include an orbital exenteration.
Correct.
And maybe a superficial paratectomy on the ipsilateral side for the nodal disease and level 2 sampling. So if the level 2 is negative, I would stop there. She will probably require a free flap to reconstruct the defect, and then I'll send for the adjuvant. That will be
correct. So actually she was offered the exact same thing, that she will require this surgery. The lady was not ready for orbital exenteration. And with that we come, what are the treatment options if such mucosal melanoma is not ready? Then what, and let me start from Rahul, what are the treatment options which you could give in such patients, for mucosal melanoma patients?
In such cases, we can go ahead with the nivolumab plus ipilimumab.
Correct.
If BRAF positive, then we may offer dabrafenib plus tamitinib combination.
Okay.
Or else we can give pembrolizumab.
Okay. So we don't have very big data. One of the biggest data comes from toripalimab and axitinib, and what you could see that response rate is around 33% only. It's not very great, and pathological complete response is seen in around 16% of the patients, and major pathological response in another 16% of patients. We have data for neoadjuvant lenvatinib with pembrolizumab also, and that gives a pathological response rate of around 13.3% of the patients. And as rightly pointed out, there is data for Nevo and EP also to be given into that. And this was an interesting study, not very large, but one of the rare studies which I saw in head and neck, in which what that done is was mucosal melanoma patients, they actually did a propensity match scoring, in which who underwent upfront surgery versus who were given neoadjuvant immunotherapy and then underwent surgery. They did propensity matching, but the matching could not be done because neoadjuvant immunotherapy was given specifically in those patients who could not be resected upfront. What it showed is after receiving neoadjuvant immunotherapy, their outcomes were very similar to what those patients who did not needed the neoadjuvant immunotherapy were given. So this lady, we actually gave 3 cycles of toripalimab and axitinib. The mass actually well shrunken, and Dr. Pai actually operated her, and we did not have to do orbital exenteration. She had actually had a pathological CR. With that, let me come, we have 3 minutes left for mucosal melanoma to another case. 76-year-old male, nasal blockade and fatigue. CT scan shows something in the right nasal cavity. He is operated by Vikas in Delhi on 31st of October. And at time they were not clear whether this is melanoma or not. There are certain pigment-laden cells which was seen. This gets reviewed later on in Mumbai, and it comes out to be mucosal melanoma. Surprisingly, this comes out to be IHC BRAF V600E positive also. And there was a suspicious lymph node which was seen, which undergoes a FNAC, and that shows that this was negative. So, question to my medical oncology colleagues, and let me start from Gaurav this time. Gaurav, do you want to give chemo in this patient? 76-year-old male, or immunotherapy in this patient? Mucosal melanoma, operated?
So as we know that mucosal melanomas are poor, like they have very bad
Correct.
prognosis, and we don't know. And per se, immunotherapy, if patient is not contraindicated, is safe. It's not like chemotherapy that age criteria
Correct.
should be. So I think I might give a chance.
Correct. Nikhil, what would you do?
Mucosal melanoma, as we have read that they are very poorly responsive to immuno. So maybe I would give a trial for Dabra and Tremitinib in this
Correct.
patient.
You want to give an adjuvant Dabra and Tremitinib,
Yes.
fair enough. What do you want to do?
Same, sir.
Same. You want to give a trial for Dabra, and we have certain amount of data for adjuvant Dabra and Tremitinib also. Now, one of the reasons why they talked about Neo-EP, because this classic study of adjuvant Neo-EP had 15% patients of mucosal melanoma. And the reason why the option of Dabra and Tremi was given, because again in cutaneous melanoma, they had 10 to 15% patients of mucosal melanoma, which did show that adjuvant Dabra and Tremitinib work. Now, interestingly, from China, we have 2 randomized studies which were done for mucosal melanoma, and the number of patients are very healthy, 189. The first study actually compared interferon, it's an old study, came first time in 2013. They compared interferon with temozolomide plus cisplatin. And what they did show that temozolomide plus cisplatin had a RFS and an OS advantage in this situation over interferon. And obviously, this then was again, they, after a phase 2, they managed to do a large phase 3 also of around 300 patients and presented in ASCO. And that was clearly surprising with the number of mucosal melanomas they could accumulate in that short period of time. But again, the results reciprocated the results what we saw with the previous study, where cisplatin temozolomide was better than interferon. After 5 years, the same group actually came up with another study, in which this time they compared temozolomide cisplatin versus toripalimab alone. So toripalimab being a Chinese and they don't have access to Neo EP, they actually compared this. Guess what would the results be, Shiva? No, actually teripalimab did not work. This was actually a propensity match scoring, so it was not a head-to-head randomized study. But if you see at the overall survival and the DMF, it was much better with the cisplatin temozolomide arm than with the PDL1 arm. So just a food for thought, maybe mucosal melanoma, we may require more studies in this manner. And with this, I won't go into palliative, because if we can switch on to the slide deck of anaplastic thyroid, yeah, please. So up till now, if you want to use some chemotherapy, use cisplatin temozolomide. There is a good body of evidence for 4 cycles of cisplatin and temozolomide in this situation. So let me just run with the case quickly. This is anaplastic cancer, and I am happy that Aditya is there, and Aditya did this data collection for Tata Memorial Hospital, and this was the results of Tata Memorial Hospital, that whether they were radically treated or whether they were palliative treated. The survival of most of the patient was less than 150 days, which is less than 5 months. And I am going to go with this case. She is a 36-year-old female, metastatic poorly defined thyroid cancer, gets complaint of pain in neck, gets an ultrasound done, gets a CT scan done. She undergoes surgery on 7th of September 2022. Post-surgery, the biopsy has been done, which was poorly differentiated carcinoma. Because she was poorly differentiated, she was given post-operative radioiodine treatment. And after the radioiodine treatment, I saw her in December of 2022. She came with severe pain in the neck and was rushed to the emergency. And at that time, another lymph node had come, which was encasing the carotid artery. And that was ruled out by the surgeon because the node encased the carotid artery, that anything could not be done. Because the radioactive treatment was given a few months back only, the nuclear medicine doctor said that no, we cannot give any further radioactive treatment for these patients, and that at this point of time she only has this lymph nodes, and she comes to you in the OPD. And let me start here with Gaurav. Gaurav, what would be your treatment option for this patient?
I think this unresectable patient, we might give a chance of neoadjuvant therapy with this is poorly differentiated this thing.
So you want to use a immunotherapy-based regimen. Perfectly fine. Nikhil, what would you do?
Sir, is this papillary or anaplastic? Because
see, this is poorly differentiated, so you put it more closer to anaplastic rather than papillary. It is behaving like an anaplastic.
So, sir, I would like to do an NGS to look for some driver mutations.
Correct. I'll come to that in a
maybe cisplatin adriamycin based chemo.
Okay. You wanted to use cisplatin adriamycin.
I would offer a pembrolizumab plus lenvatinib.
Okay. Lead data. Okay. Perfect. In fact, I did offer her pembrolizumab plus lenvatinib. The swelling did decrease, but on 15th to 12th of Jan, she came to the casualty with severe breathlessness. We actually thought that she may have developed lung metastasis, but surprisingly, we observed that both vocal cords had developed palsies, and she underwent emergency tracheostomy. And then she received a cycle 2 of immunotherapy on 11th Jan 2023. And at that time, we noticed that she has a high blood pressure and a high heart rate. So lenvatinib is not given with, lenvatinib is not given, and pembro is continued. After this, she goes to Calcutta, and her pulse continuously is in the range of around 130, 140. And there is no apparent fever, no pain this patient has, no cause for the pulse to be in the range of 130, 140. Gaurav, so our patient on immunotherapy, lenvatinib isn't stopped, pulse is continuously remaining high. There is no anemia, there is no apparent cause which you are seeing for it. What are the things which you would suspect?
So as we know, like Lenva was not given at all because Lenva might cause sometimes hypertension.
Correct.
And those kinds. So first we'll have to see whether it was given earlier and then stopped because of the high blood pressure or this thing. Other possibility.
She actually developed myocarditis, immune myocarditis. We got a normal 2D echo done, did not show anything. Plus, but be aware that in a normal 2D echo, we may not be. You require a GLS 2D echo to identify early myocarditis features.
But sir, usually it takes like 2 myocarditis to happen with
Correct.
the immunotherapy.
Correct.
The duration
What
is
you're saying is correct.
Yeah.
We actually got a biopsy also done after that to prove that this is myocarditis in this patient. So after that, she gets shifted to weekly Pecli carbo, and this patient, in spite of giving weekly Pecli carbo, just keeps on progressing. This is a very affording family, so we got a PDL1 done from Foundation, from Guardant, and even from Indian labs. They didn't want to take any chances, so PDL1 was 5%. Even with others, we did not see any actionable mutation to which Dr. Nikhil was pointing out to be that if there's an anaplastic thyroid cancer, can we have any actionable mutations? We got Guardant tissue and liquid done, no mutation detected. And this patient actually, we tried to look at multiple gene-based pathway analysis, and we couldn't see anything major. And that is the unfortunate story of anaplastic thyroid cancers, that many times we don't get any treatment options in this patient. But not to forget, around 40% of your anaplastic thyroid cancers would have some or the other amount of mutations which Dr. Nikhil was pointing to. With that, let me come to this important discussion of, and let me go to Shiva. Mark Zaffaro's paper, Shiva, on thyroid cancer, which says that if you have a BRAF mutated ATC, you treat with neoadjuvant pembrolizumab in combination with dabrafenib, trametinib. Your comments on this trial?
Yeah. So the data coming from MD Anderson is very encouraging. You know, for anaplastic thyroid carcinoma, where the median survival is 6 months or 9 months, with the use of neoadjuvant, dabrafenib, trametinib, and now with addition of PDL1, pembrolizumab, things are getting better. So I think yes, it could be considered, because the number of patients whom we see who are upfront resectable in anaplastic are very few.
Correct.
Actually, most of them come in very advanced stage. So this definitely offers some hope to these patients.
One of the things which we need to understand when you're dealing with anaplastic thyroid cancer, we need that BRAF report quite early. So it might be useful that you can send a sample for NGS, but you could request your pathologist to give an IHC report early, which can come in around 36 to 48 hours itself. What interesting and why I wanted to show this is, one cycle of pembro with a 21 days run-in of dabra plus trametinib, then surgery and then adjuvant. And the reason why it started with showing the TMH results, where you could see that radically treated patient had lifespans below 150, and I won't waste time here. This was a single-arm study which was looking at gross surgical resections, and they had classified the surgical resections with different types. And I'll ask Shiva, most of us are medical oncologists, we don't understand this. So can you just explain what does this mean and how important this is with respect to anaplastic thyroid cancer situation?
So basically, anaplastic thyroid carcinoma are locally very infiltrative, involving the trachea, esophagus, and the recurrent laryngeal nerve. So if the surgery is going to be morbid, then the patient's post-operative quality of life is going to be dismal. So that's how they're grading it, depending on how gross extrathyroidal extension is, whether the vessels are involved, the nerve is involved, or the viscera is involved. And based on that, the grading they've given. So higher the grade, worse is the involvement of the locoregional tissue. So I think grade 1, 2 and 3, grade 1 and 2 is definitely resectable, 3 is doubtful, 4 is unresectable.
Correct. And what was interesting is they took 70 patients, eligible patients for trial were 42. In 2, they couldn't get BRAF mutation, so final analysis had 40 patients. And when you look at the response rates, partial response was seen in nearly 72% of the patient with a 21 days run-in and a single dose of pembrolizumab. And when we look at resection rates, which traditionally the resection rates were largely R1 and R2 in MD Anderson, I'm not talking about good surgeons like Tata Memorial Hospital has, but here what you are seeing that R0, R1 resections were 74%, and the reason why they put a p-value is because this is in with respect to the historical control data which they had. And what you also see here is the unresectable, very severe, severe, moderate and mild, and you could see that at initially hardly any patient was in mild, moderate were 5%, all others were between severe, very severe and unresectable. How could downstaging happened with the use of pembrolizumab and dabrafenib trametinib in these patients? And what we see here also is, for one of the first time, we saw that 3-year survival in anaplastic thyroid cancer is in the range of 44%. Those of you who treat anaplastic thyroid cancer would know that getting a 1-year survival, even with radical intent therapy, is very difficult. So get a 3-year survival of around 44% was nothing short of a remarkable achievement in this situation. And if you look at PFS also, the 3-year survival is largely driven by a very good progression-free survival, which is at the end of 3 years nearly of 33%. What does Mark Zaffaro's paper opens up is that this opens up the possibility in BRAF mutation positive anaplastic thyroid cancers of a new way of treating these patients with neoadjuvant pembrolizumab, giving dabrafenib trametinib. And this was the icing on the cake, that if the patient had a complete response versus there was a residual, and you could see that if the patient develops a complete response, and that number is not small, if you see that number is 20, and if you remember we had started with 40 patients, that is nearly 50% of your patients who would develop complete response, and their 2 years to 3 years survival is in the range of around 69 to 70%, and we are talking about anaplastic thyroid cancer, 50% of the patients in whom we could get around 3 year survivals of 70%, as opposed to that patient who had ATC residual disease, the 2 year survival was only around 30%, which is still better than what are the historical controls. Any comments, anything you want to say, Shiva or the 3 medical oncologists?
Just one comment is that in MD Anderson they have a hotline. When a diagnosis of anaplastic thyroid carcinoma is done, the first thing that they do is BRAF and they do a immunohistochemistry, and that's how the follow-up goes on. So I think, and what they recommend is they should have an anaplastic thyroid carcinoma clinic and do this in a systematic way so that everything is fast-tracked.
Correct. Gaurav, any comment from your side?
No, nothing.
Yeah.
I think the results are pretty encouraging.
Yeah, these results are pretty encouraging. Yeah. In fact, in a situation of anaplastic thyroid cancer, you may not get better results from this. With that, what I'll touch base upon, whether the 3 minutes left, is a neoadjuvant treatment in papillary thyroid cancer or differentiated thyroid cancer. Shiva, in last 2 years, how many patients have you sent to a medical oncologist that, okay, boss, this is papillary thyroid cancer or follicular thyroid cancer, but this is not operable, do neoadjuvant therapy and then let me operate it?
We are sending more and more cases than what we used to in the past, but those are not huge numbers. But nowadays we are tending to do, when especially the surgery is very morbid, is going to be morbid for the patient, or considering various other factors. So we do send for a neoadjuvant.
Correct. Let me ask my all 3 medical oncologists. Have you got a good surgeon like Shiva who sends you patients of papillary thyroid cancers if he can't operate for neoadjuvant therapy?
No, sir.
So one of the things which we need to understand is that in differentiated thyroid cancer, if you cannot operate it completely, today giving lenvatinib gives you a very good response rate, which is around 70%. Though when I say response at 70%, which means that the target reduction of more than 30% is seen in more than 70%, but any size reduction is seen in nearly 95% of patients who receive lenvatinib. Now, and this is where it makes the surgery very easy. After lenvatinib, you have to hold the lenvatinib for 14 days before you hand it over to the surgeon. 4 weeks to 6 weeks runs of lenvatinib enables you to achieve those response rates, and then it makes the job of the surgeon easy, and it makes the job of nuclear medicine person also easy, because once the thyroid is completely removed, the doses of radioiodine also are stepped down. Yes, Shiva?
So the cases, I just want to give an example as to what are the cases that we send across or we consider to be, borderline resectable. Like for example, if it is going into the thoracic inlet, going to, close to the subclavian vessels or the innominate artery, or you need a sternotomy and or there is, invading the esophagus. So once there was a patient who had symptomatic lung metastasis, though the disease was resectable. So we referred for TKIs, the lung metastasis responded, patient felt better,
Correct.
then we took up for
Correct.
surgery. So
Correct.
there are various situations that you need to consider. It's not like a uniform blanket.
Correct.
You need to really discuss in a multidisciplinary tumor board.
One of the things which I want to just put it also that normally we get patients once they are radioiodine refractory for differentiated thyroid cancers. Once you have a good run of lenvatinib, there is no harm in looking at the radioiodine uptake again. There are 10-15% of the patients who also start having radioiodine uptake after that. I don't think we need to talk about sulpectinib in erect activated thyroid cancer. Everyone knows that giving sulpectinib in these patients gives a miraculous kind of response rates. I'll stop here and I'll let Amit start with his case of medulloblastoma. Thank you.
So, good evening everyone. So without wasting the time, I'll start my case. So he was a 12-year-old boy without significant family history. He was diagnosed as localized medulloblastoma in November 23. Molecularly, he was SHH activated with MEK and amplified. He received gross total resection followed by CSI and radiation to the tumor bed, followed by neoadjuvant chemotherapy, and completed treatment in November 24. Within 3 months, he developed recurrence which was localized, and tumor was involving cerebellopontine angle. So now what? How would you manage? Would you operate? Would you re-radiate or palliate? First, we'll start with surgery colleague.
Actually, I don't, I'm a surgical oncologist, I'm not a neurosurgeon, okay. So I wouldn't be the right person to comment on this.
Okay. Radiation.
Okay, so he is a 12-year-old boy and CSI I think has concluded just a year back.
Yes.
Am I right? And is patient symptomatic for that? Because it's supposed
to
be
he was symptomatic. He had gait disturbances, headache.
Yeah. So in order to give a better symptomatic relief, I would always request my surgical colleague to have a look, because there is some pressure changes which I think will be better addressed with surgery.
Okay. So since it was a very early relapse within 3 months, site of tumor is difficult to navigate. Along with that, the poor biology of the disease. Probably surgery would not help here because of these changes. So we started him on vismodegib because he was SHH mediated tumor. So unfortunately, he progressed on vismodegib. He was ineligible for resurgery re-radiation, and so I think slide has changed. It was different. It's okay. So any suggestions from medical oncologist? Would you offer some kind of chemotherapy or palliation here, or some other treatment options?
So second line chemotherapy basically with palliative intent, irinotecan temozolomide combination plus minus Bev.
Okay. Any other suggestions from anyone?
Sometimes platins also can be used.
Sorry?
Platins can be also.
So with palliative intent only. So actually parents were not keen for palliation and they want some form of curative treatment options only. So we have planned for a salvage chemotherapy followed by autologous transplant, although the data is not very promising for these kind of patients, but especially from the European settings and Koreans, they have started doing transplant in these in patients who have received radiation and surgery within a less span of time and who has relapsed very early with poor biology. So we planned based on that, and we did harvest before the transplant. So I think, sir, would you comment on pre-salvage harvest or?
So this was a bad biology disease, and this is a gray zone area. We had a discussion for sending the patient on palliative care itself, but the family was very adamant that it's a young boy to do something. In fact, he was sent to Dr. Jalali sir also to take an opinion on proton if it was possible, but because the radiation had just finished a few days back, it was told that radiation is not an option. He was seen by B.K. Mishra sir in Hinduja, and he said that because it is a large tumor, he does not want to operate, and it has come back very early. And at that time, we told them that whatever chemotherapy we give, it is going to come back in a few days. And we had quite a bit of discussion with the family, and then we gave them an option of doing an autologous stem cell transplant if he responds. Now the problem here was the kind of medicines he had received prior to this in his adjuvant. We had to use ifosfamide and etoposide based and a platinum based regimen. Now once you use ifosfamide based regimens, then the chances of getting CD34, if you use 3 cycles or 4 cycles, in subsequently actually go down a lot. You do not get a good yield. And if in a medulloblastoma you want to do a autologous stem cell transplant, at least a dose of 4 to the power of 10 raised to 6 is required. This is different from the multiple myeloma transplants, where even a dose of 2.5 into the power 10 raised to 6 per kg you could give, because the kind of conditioning which we give won't get the bone marrow recovery won't be good if the dose was not done. And that's the reason why we opted for a pre-salvage harvest here, and we got a good harvest of around 4.4 into 10 raised to 6. And then the patient was started on the ICE therapy.
So there was an article from ASTCT in which they have clearly quoted that dose more than 3.6 into 10 raised to the power 6 has significant OS and EFS advantage. So that was adequate enough dose. After 3 cycles, there was significant response to the tumor, and around 85 to 90% of tumor has been regressed. This was the scan. So we have planned for then autologous hematopoietic stem cell transplant. So patient has already received carboplatin etoposide, which was the common conditioning regimen used in medulloblastoma transplant, and we cannot use more doses of carboplatin and etoposide. So we have to opt for some conditioning regimen which has better CNS penetration. So one option was busulfan, then other option was thiotepa. So since levels of busulfan was not available in Mumbai, and since it is a kid, the metabolism was cannot be clearly mediated. So we went ahead and did novel conditioning regimen, thiotepa and melphalan, probably first in India. It is a very huge dose of thiotepa, around 800 mg per meter square, divided into 4 doses, and 210 mg per meter square of melphalan over 12 days. So child has significant complications. He infused the CD34. Viability at the time of infusion was 99%. We infused the full dose. So this was the article in which the EBMT article, which showed that the dose of thiotepa and melphalan, especially in the brain tumor patients. So they have amongst them around 25 patients were of brain tumor, out of which 12 were of medulloblastoma. All these patients, nearly all patients have grade 3 and grade 4 side effects, which we anticipated in this patient. And surprisingly, at the end of 3 months, around day 100, all the patients are surviving and tolerating this chemotherapy well. So post-transplant, he developed significant complications in form of grade 3 CINV, grade 4 mucositis, grade 4 neutropenia, thrombocytopenia, over which he developed MDR sepsis, which was OXA48 and CTXM resistance, requiring high-end antibiotics, triple inotropic support with strong blood bank support in form of granulocyte and buffycoat infusion. And child recovered after 4 to 5 days of these support. After that, he developed bloody diarrhea, which was probably secondary to the rotavirus infection. He engrafted neutrophils on day 11 and platelets on day 30, although he required TPO analog support for platelet recovery, and patient was discharged on day 20. So this was the scan. Just a minute. This was the pre-salvage scan, and this was the scan after the transplant, which showed near resolution of the tumor and probably some treatment related changes. Currently child is 12 weeks post transplant, doing well, going to attending schools, and is currently no issue. He had no issues. So any role of post transplant maintenance in such cases? If yes, what are the options from the medical oncology colleagues, if anyone has any suggestion?
So again, this is a gray zone area. This patient had already progressed on vismodegib, so another option to give is sonidegib in this patient as a maintenance period. But another thing which has very limited some cell line data of mebendazole is there in medulloblastoma. So in this situation, I actually had opted the patient to be put on mebendazole because that wouldn't hamper with any of the post-transplant, won't cause any neutropenia or till he recovers for another 1 or 2 months. After that, the trial could be put on an SHH inhibitor.
Yeah, as correctly said by Dr. Patil, we have started him on high dose mebendazole and awaiting scans, 4.5 months scan at 12. After that, we'll decide whether the patient will require and one more thing, which is the latest advance in that SMO inhibitors, they usually do not respond when patient has MECAN amplification. So probably this was the reason patient has not responded to vismodegib. Yeah. Thank you, everyone.
Ichpal sir is there. Yeah. Sir, medulloblastoma, a quick recap in 2-3 minutes for benefits of all here. How would you treat these patients? Yeah.
So, sorry Vijay, I was not there when the presentation started. I believe this was a relapsed SSH pathway medulloblastoma.
Yes.
And I mean, like you said, the radiation had just finished. To be very honest, post-relapse after CSI has been done, if you have a relapse in medulloblastoma, it is not curable. And that is something that we have to understand and accept. I I mean, the parents wanted to do some curative form of treatment, but you cannot cure. I mean, of course you can prolong survival, but the child has gone through a lot of toxicity. Good that he has survived all of that. But I think maintenance, mebendazole, I mean, there is some cell line data. You're giving 800 milligram 5 times?
Yes, sir.
So we would actually, certainly we would not have recommended very intensive, aggressive salvage therapy, but these are situations that are sort of based on a case-to-case decision, and if the parents are very keen, there is some role of doing high-dose chemotherapy and stem cell rescue. It's just that the duration, like, so you have to have at least a year or 2 years of disease-free interval. If you have less than 6 months of disease-free interval, that's really bad biology disease, and that's not a very good thing to do. This child was, how old was this child?
12-year-old boy.
12-year-old, yeah. So, infant SHH medulloblastoma who are treated with radiation sparing approaches up front, as and when they relapse, they can be salvaged and they can be cured. I mean,
That is what I want to ask you. Sir, is there any role of upfront transplant in these patients, reducing the dose of CSI and radiation and doing high dose?
So, infant SHH, I mean, now the definition of infant goes up to 5 years also in certain cooperative groups in certain countries. I think the data will be published very soon. If you do high dose chemotherapy, you need not give radiation. If you do intraventricular methotrexate based chemotherapy, you need not give radiation. And if you do CSI, if the child is more than 3 years of age, the survival in all of these three is exactly the same. So based on your local circumstances, you can decide. So if IV methotrexate may be a problem if because you need a Omaya and that has a learning curve. So if that is not feasible, high dose chemotherapy can be given. Conventional chemotherapy, standard dose chemotherapy, the outcomes are much inferior. The 3-year or 5-year PFS is less than 50%. So it's not a good thing to do just standard chemotherapy in infant medulloblastoma. Many times many people do standard chemotherapy and then even focal RT, that doesn't help. So high dose chemotherapy with or without the stem cell rescue, intraventricular methotrexate based chemotherapy, or if the child is more than 3 years, you can do CSI and you will achieve very similar outcomes in all.
Okay.
So, quick, can you just for the benefit of everyone can tell me how should you treat the newly diagnosed standard risk, high risk medulloblastoma?
So that, risk categorization has changed in the molecular era, so it's no longer only standard and average. Now, low risk, which is the Wnt pathway medulloblastoma, the standard risk, high risk and very high risk. The very high risk is like SHH, TP53 mutant and group 3 MYC amplified with metastatic. All of that falls in the very high risk. So, but I think still most people go by the standard risk and the high risk. So newly diagnosed medulloblastoma, if it is a standard risk disease, you can do 23.4 gray craniospinal irradiation plus 30.6 gray boost, followed by 6 to 9 cycles of any chemotherapy regimen. Whether it is what we use at Tata, we call it the CET protocol, or in COG and ACNS they use regimen A or regimen B. Actually, a randomized trial showed there was no difference between regimen A or regimen B. Till such time that you use good chemotherapy, platinum and cyclophosphamide based, it is fine. For the high risk disease, most of the time it needs more aggressive therapy, so we would need to give a higher dose. So typically full dose CSI, it's 36 in 20, plus the boost would be 18 gray in 24. So that primary site dose still remains 54 gray in 30 fractions in 6 weeks. And then you have to add the chemotherapy as well. We also boost the metastatic nodules as far as possible. If there are macroscopic nodules, you should boost. Occasionally, when there is very plaque-like enhancement all along the neuraxis, then we can sometimes give extended dose CSI, which is like giving 39.6 gray in 22 or 40 gray in 24 fraction. Then you don't need to focally boost all the lesions. So this is how the newly diagnosed medulloblastoma should be treated.
If there are any questions regarding any of the 3 cases for the anaplastic thyroid cancer, for the mucosal melanoma, or for the medulloblastoma, then we'll take or we'll call off the session. If there are none, I thank the panelists. I thank Amit.
Yeah, thank you
organizers for the opportunity.
Thank you everyone for navigating us through these rare yet impactful cases. We now move to another set of our industry sponsored sessions. We have a session sponsored by Astellas on enfortumab vedotin in relapsed and refractory bladder cancer, followed by a focused panel discussion. Leading this session is Dr. Vijay Patil, consultant medical oncologist Mumbai, who will serve both as a speaker and moderator. He is joined by our expert panelists, Dr. Tushar Patil, medical oncologist Pune, Dr. Aditya Dhanawat, consultant medical oncologist Navi Mumbai, and Dr. Rahul Kulkarni, consultant medical oncologist Pune.
Okay, so Tushar sir is not here, I think, and so we'll start. So what we are going to discuss over the next 30 minutes is the role of enfortumab vedotin, and what I would request is we would discuss this beyond relapse and refractory. I would request the panelists to educate us with the new data which has come up in the ESMO conference also. So one of the disclaimers is the slide are provided by Astellas, and I couldn't modify the slides. So what is enfortumab? And let me start with Aditya. Aditya, what exactly it is?
So it is an antibody drug conjugate wherein we have conjugated the antibody with a chemotherapy drug. The antibody is against the Nectin-4 and the drug is vedotin, which is a microtubule inhibitor.
Correct. Which type of monoclonal antibodies? IgG, IgA, IgD?
This is IgG.
Yes, it is IgG kappa type of monoclonal antibody against Nectin-4. And can you just explain how exactly is the mechanism of action? How does it attach? How the linker is destroyed? How the payload is released?
So there are 2-3 things in this. One is the antibody-mediated cellular cytotoxicity, and then is the because of the vedotin, the chemotherapy-related cytotoxicity.
Correct. So there is one is antibody mediated, second is gets attached to nectin, gets engulfed in the linker gets dissociated, and the payload, that is MME, it's a microtubule inhibitor which then inhibits the mitotic spindle formation and arrests the cells in the M1 phase. So let me come to Rahul. Rahul, today where do you use N4 to make vedotoxin? In which situations?
So the data is very well established both even in the front line as well as in the second line. The availability was an issue, the second issue was the cost. So given a choice, we have a strong data to use it upfront as well along with immunotherapy. But if you are not able to use it, then at least after the first initial chemotherapy and immunotherapy, we can use it in the second line.
Okay, so that's perfectly correct. You can use in, well, let's talk about metastatic setting. We are talking about palliative setting at present. You can use it in the first line setting also, and you can use it after the failure of the platinum and the immunotherapy. Tushar sir, which patient would you select it for the first line setting?
I think it's a category 1 indication for all patients.
Correct. Correct.
All patients. So there should be no distinction.
Correct. So today in category 1, any patient who can afford this is eligible and is fit for it, is eligible for it. So let's look at few of the trials which were designed. And let me come to Aditya. Aditya, can you just give a brief about what is EV301 and what did it look at?
So EV301 was in the second line and beyond setting wherein they wanted to use EV post IO progression, and that was compared with the chemotherapy, physician choice chemotherapy. And they looked at the PFS.
Correct. So looking at this design of EV301, you would see this adult patient which are performance status 0 to 1. This is patient who had progressed on PD1 or PD-L1 inhibitors, and that received prior platinum also. So both platinum and PD-1 exposure was there. Around good number of patients, around 600 patients, half were given EV and half were given investigator chosen chemotherapy, which could be any one of the taxanes or of vinfluin. The primary endpoint was the gold standard endpoint of overall survival. The secondary endpoints were PFS or response rate, DCR, which are pretty standard. And when we look at this, Rahul, when you look at this demographic, do you think this is the demographic of the patient which we see in our real world practice, or the trial supra-selected patient, as we commonly see in multiple myeloma trials?
No, I feel these are the type of patients we generally see. Generally, we get elderly patients. Maybe the performance status also is borderline, but we do get patients who are having a good performance status as well. In Indian settings, I feel that in our patients the performance status is slightly
on the
1 or 2, but we still get those patients.
Correct. So if you see that the median age is around 68, which is nearly 50% or above the patient was very elderly. More than 75 age was nearly 20%. Good amount of them were tobacco users, and interestingly, I will come to this point in later with detail, that history of diabetes or hyperglycemia was there in nearly 20% of the patients. If you could look at whether it was only bladder, no, it was bladder also, and it was upper urinary tract also. It was both urinary or transitional cell, but they also took mixed type histologies will also be taken, and in the mixed type they did included adenocarcinoma, squamous cell carcinoma, or pseudo-sarcomatic differentiation also, which tells us the data is applicable not only for urothelial types, but if urothelial is the predominant with another mixed histology, also with that type, and 10% of the patients were of others also. So even if the other histology was predominant, still this could be used. If you look at the metastatic sites, Visceral disease, and this is important, was seen in nearly more than 75% of the patients. And if you look at prior lines of therapy, as it mandated that pembro and platinum was exposed, obviously everyone was post first line of therapy, but there were good number of patients, around more than 10%, who were post 3 lines of therapy also. If you look at responders, you could see that majority of the patients which were taken were non-responders to the most prior line of therapy, which was nearly 70%. So we are talking about elderly patients, we are talking about patients who had a mix of both urothelial type cancers, we are talking about mixed of histopathologies, we are talking about who have been exposed to quite a bit of therapies, and we are talking about patients who had no response to this. And let me come to Tushar sir. Tushar sir, when you look at this curve of EV, what are your comments?
I think as we can see, there is a significant reduction in the risk of death, and these curves have started separating from 3 months onwards only.
Correct.
Very early.
Correct.
And the separation is still continued.
Correct. So there is a significant separation. Don't look at that curve at 20 months. The number of risk at that point of time after 18 months are very few, so you are not supposed to look at that point of the Kaplan-Meier curve. And as sir rightly pointed out, from the first assessment itself, which was around 3 months, there was a separation which was seen, and this led to a hazard ratio was 0.7 for this, and a significant improvement in overall survival was seen. Let me come to Rahul. Rahul, do you think that there was some group which benefited more, or the benefit was seen across all groups?
Looking at the graph, we can say that the benefit is seen in most of the subgroups. Only I think in the female subgroup, it's showing that it's not giving that much benefit, but we can generalize it and use it across.
You could see that the major hazard ratio is on this side. Even the confidence interval for few of them is though crossing. It is largely because the number at risk of patients were very small in this, and even in those which are like more than 75 years, upper unit tract primary, which we would say are bad, those with liver metastasis, though we did not have any previous response, these patients also benefit. The point to be noted here is it's not that the benefit is driven by patients who had good prognostic factor clumped with poor. This here, the benefit is both in the good and in the poor prognostic groups. And if you look at the progression-free survival curve, Aditya, can you comment on this PFS curve?
So while numerically it may look that it is a 2-month benefit, but it is statistically significant, and we can see that there is a clear separation right from 2 to 3 months time.
Correct. What you see here is, remember we are talking about patients who are, majority of them are post 2 lines of therapy. We do not expect survivals in them to be beyond 12 months. We are talking about PFS, which in around 15% of patients is continuing till 18 months, and quite good data for that. Now, Aditya, you can take this question. Was the benefit of PFS also seen in all hard to treat populations also?
So here again, because of the small sample size, like if we look at more than 75 years, the number is small. So that is why it was had a large confidence interval. But apart from that, across subgroups, it has shown that there is a clear benefit of EV.
Yeah. Tushar sir, it's important for response. We always say that OS is important, but as medical oncologists, we know that when the tumor shrinks, the quality of life of the patient and the doctor both increases significantly. And even just looking at the shrinkage also, and not only that, many times the symptoms of the patients do get responded with a good shrinkage. How do you compare the shrinkage with EV versus that of chemotherapy?
We can clearly see that the objective response rate, which is CR plus PR, is quite high. That is 40.6 as compared to 18%, and in which there is a 5% CR rate, and we are talking about a second line treatment with both poor and good risk factors. And the disease control rate, which is combination of CR, PR and stable disease, again stands high with the EV, 71.9% as compared to 53.4%. And the achievement to this response is close to just 2 months, 1.2, 1.8.
And even the duration of response sustained is more than 6 months, it's around 8 months in this situation. And if you look at the response rates, again, across all subgroup, you could see that this is again in favor of EV, and we won't go into details of this. And let's look at this quality of life. And Aditya, take this with respect to quality of life. Can you explain for the benefit of many how how this graph is read and what is significant?
So when we go from 0 and downwards, that is worsening of the function. This is the C30, and the scoring would tell us that the lower the score would be worse for the patient. And we can see that the yellow line is for the chemotherapy, which is performing worse than the EV.
Correct. So any line going down, that means the scores are getting worse. Anything only which is sustained, which means that the quality of life is sustained for this patient. So again, showing that EV maintains the quality of life of this patients also. Now, if we look at this graph, and Rahul, would you want to take this graph where you are comparing the longitudinal comparison over 2 weeks? We are looking at physical functioning, role functioning, emotional functioning, cognitive and social. How do you think these things, EV versus chemotherapy, how do you look at this table?
So basically, both the physical functioning, as we can see, it is better seen with EV as compared to chemo. When we are talking about emotional as well as cognitive, I think even though it is not better than chemo, but it's almost the same. It's not worsening it.
Correct.
So I think we can take it in a
Correct.
positive.
And the point is that the intervention you are making is going to impact the physical functioning. It is not going to impact the emotional, cognitive or social functioning. We are not doing those interventions. It was a trial. So obviously PALCare was given on both sides. So do not expect that emotional, so cognitive or social functioning to differ. We did the intervention at the physical and role functioning level, and that is what we could see, that the symptoms have improved with this. Now, I'll come to Tushar sir. Tushar sir, EV301, we are talking about patients post PDL1, post platinum. What are the key takeaways for the audience?
So there is definitely a clear cut what we say as trend towards decrease in the risk of progression as well as death and maintenance of quality of life.
Correct.
We are talking of a second line setting and without any chemotherapy backbone.
Correct.
Yeah.
Correct. So that's important. Without any chemotherapy backbone, OS improved, PFS improved, and quality of life also improved. And let's discuss this now in a case how we look at. And this is the data. And Aditya, if you can take this. This is the data from key phase 3 studies. And could you put numbers on this OS, PFS, and response what you've seen? This is first line setting. We are not talking about third line setting what we saw with EV.
So in metastatic urothelial also first line cisplatin is better than carboplatin. However, majority of our patients are cisplatin ineligible even in the first line. And that is why we resort.
Can you, for the benefits of the audience, put the criteria where would you see, because they are slightly differ in head and neck versus what we use in urothelial cancers. What are the criteria for saying that the patient is platinum ineligible in urothelial setting?
So in urothelial, we would put platinum ineligibility as less than 40 to 45.
Correct.
Whereas in head and neck, it would be on a higher side.
So what you would see is, even in the first line setting, the PFS are in the range of, if you use cisplat as the base, 8 to 10 months, carboplatin as the base for about 4 to 6 months. And what we saw with EV was we could recapitulate those results in the third line and beyond setting. Now, with respect to PDL1, and because many times patient is ineligible for cisplatin, we could use PDL1. Rahul, how do you look at these results of PDL1 monotherapy?
So obviously till EV was available, the only other option was immunotherapy.
Correct.
And with the use of immunotherapy, especially pembrolizumab, we were able to achieve a PFS about 3 to 4 months, or maybe a survival of about more than 6 months, but not beyond that. And also the responses to the tune of 20-30%. And that was the best thing which we could have done.
So if you look at the numbers which were shown previously versus, I think I'm going in the opposite direction.
What was striking here was in the second line also,
Correct.
EV had an overall
Correct.
objective response rate of 49%.
Correct.
49%.
This is exactly what I was trying to show, that if you look at immunotherapy numbers, they are not very great even for the first line and for the second line monotherapy numbers.
Correct.
Where you could see the PFS also is not great, and around 20% is the response rate, and EV response rate in third line setting is much better than this. So let's go with the case now rather than. So we are talking about a lady, Lata. She is a 78-year-old female, PS1. She has an unresectable malignancy. She has received cisplatin plus gemcitabine plus ipilimumab switch maintenance, which we used to use, and the disease has spread to the abdominal wall. She has type 2 diabetes mellitus, she has fatty liver, and her renal clearance is only 34 ml per minute, and she is on metformin. Rahul, you have the mic. In this patient, what are your choices? And this is the choices which you could enlist from in the NCCN guideline, and why?
So in the current situation and availability, I think we can go for EV and for Vedotin, because looking at the age criteria and the other borderline situation status, she has already progressed on platinum and immunotherapy. Apart from other chemotherapy agents, there is no other active molecule which we have. So given a choice, we can give a try.
Correct. So this, any other panelists differ in his opinion, and because if this patient is affordable, we would take the patient for EV. And now, as we had discussed that we could use EV
Then
in...
I just wanted to ask a question. Is if this patient on ipilimumab maintenance responded for close to 1.5 to 2 years and then she failed, would you offer her EV plus Pembro because she benefited, or continuation of ipilimumab and addition of EV?
Sir, I would have offered EV plus Pembro. I would have counseled the patient and I would have offered EV plus Pembro, but this is a grey zone area. And let me ask from any of the medical oncologists in the Vipul, what would you have done? You heard the question. The question was Gemcis, then you give Pembro, avelumab. Patient did well on avelumab for 1.5 years, and now the patient has failed. Patient is ready for EV. Would you add a Pembro with it, or you just want to give EV? And so there is the reason why I told you, because the cell line data also, that when they combined it, they saw that there was an additive effect of adding Pembro with EV, and that's the reason why they then took it in the first line setting subsequently. So as we had seen that if you have a platinum received and a PDL1 received, you can use EV. And let me come to Aditya. Aditya, before starting EV, for the benefit, can you just enlist the 4-5 important side effects of EV which are manageable, but you need to take care of them?
So one of them is worsening of diabetes.
Correct.
So hyperglycemia, peripheral neuropathy, skin reactions, ocular side effect, keratitis. So these are some of
correct. The mnemonic I remember is hippos. Hyperglycemia, you can get infusion issues, you can get pneumonitis, you can get peripheral neuropathy, you can get ocular issues, and you can get Steven Johnson or any skin. Out of them, though others get highlighted, actually skin is the one common problem which nearly 50 to 60% of your patients. Yes, sir.
We lost one patient to Steven Johnson.
Yeah, because I also have seen that the skin is a problem which and the thing with hyperglycemia is, even if the patient is not diabetic, you need to check. And one thing which I just want to, any time before you give EV, please check the random blood sugar. If it is more than 250, please hold that EV, or you would put the patient at risk of going into diabetic ketoacidosis. Continue. So, what are the precautions would you tell the patients?
So in terms of diabetes, again, put them on if they like optimize
good sugar optimization for sugar. If they any rash, you report fast. Do not wait till it comes back. Any cough which can be a precursor of pneumonitis, you report very fast.
For neuropathy.
Correct. Watch for neuropathy, and any dry eye. If the patient says there is draining of eye, to report fast, because then you need to look at get an ocular examination done to look at this for the patient. Now, let's look at these. What are the other factors you need to consider, Rahul, before starting the patient on EV?
So obviously, whatever other factors we look at is the performance status, age,
correct,
and other organ functions.
Correct.
But fortunately, EV has a good data and safety profile when it comes to the other organ dysfunctions.
Correct.
So we just have to keep a watch and to be careful while giving it, and may require modification as well.
Basically, though this get highlighted, you are supposed to do this for every drug. You look at the renal clearance, hepatic clearance, and whenever we look at any ADC or any antibody, basically the clearance are not of that ADC or any antibody. The clearance are of two parts. The one clearance is of the monoclonal antibody, which is the IgG, so the clearance follows that part, and the other clearance of the partner, which like we were here it is MME, in sacituzumab is another drug, so the clearance of that partner. Those two factors are to be taken into account for any drug. Important. Like we see Rahul PDL1 before any marker for EV. Do you do the nectin antibody or irrespective of the nectin antibody you can give? No, we don't. We don't do. We give it irrespective of that. Yeah. Now, so there is, as I told, there was no concerns. So, Tushar sir, what are the precautions you take? We talked about diabetes. What are the precautions you take when you give the infusion of EV? So, in the terms like we look infusion reactions, or with this that is no extravasation. How do you monitor for those things?
So probably as a rule, we've made mandatory that all ADCs will give first dose will be a little slower. Okay. Though they recommend 30-minute infusion, but we make it as a
correct. So that's important. That it's though they mention 30 minutes, it's better to give the first dose slower.
First dose slower.
Second, my request to you, even if the patient has port, better that first dose is given with periphery, because with the port, the majority drug goes in the central circulation very fast. It's difficult to manage the reactions if they happen immediately. Second is, this is one drug we should be careful, like adriamycin, that if it gets extravasated, it can create a problem. So please instruct your nurse to see that there is a proper flow before you start on this on the drug. So this patient received EV, and after 5th cycle, she developed sensory neuropathy. Aditya, how do you assess sensory neuropathy, and how do you classify it?
So the sensory neuropathy grade 1 would be asymptomatic. It's the grade 2 which would start having symptoms.
Correct.
And we should assess them every cycle and ask them leading questions related to neuropathy. For a grade 1, in this case, I would want to give duloxetine and manage the neuropathy.
Correct.
Probably continue at the same dose.
Correct. What he said was perfectly correct. If the patient complaint is not grade 1, it has moved to grade 2, and grade 1 is very difficult to catch. Probably someone was looking at the ankle reflex of this patient.
Pre-existing comorbidities like diabetes or exposure to previous drugs like cisplatin will always increase the possibility of having a peripheral.
Correct. So, as was rightly pointed out, we could give duloxetine to the patient. And let's look at this next question. Rahul, you can take this. Lata experienced a hyperglycemic episode, and at what blood glucose, which is non-fasting, would you interrupt the treatment with EV?
So, as so you have also mentioned that as per guidelines, sugars going beyond 250, we should be alarmed, and we should not give the drug, and we should be managing the sugars first and then going ahead.
Correct. And if it's any dryness of the eye, if the patient calls upon you, please get a ophthal examination done, and also tall artificial tears. One of the reasons why you also get ophthal examination done is that sometimes we say that this is because of EV. The patient is an elderly patient. You have given steroid in previous year. They can very well have cataract or other things also in this patients. So the point is, this would require some amount of multidisciplinary care till we get over the learning curve of this drug. As was with pembrolizumab, when it came, we used to thought that we may need to know more amount of immunology, more about pneumonitis, more about endocrine deficiencies. I think with more and more patients we treat, we would get expert in how to manage this drug.
I wanted to ask you, what are the timelines of these side effects? Like hyperglycemia, usually what is the cycle that they develop, or peripheral neuropathy, what is the timeline? Usually.
So we have a slide of that. Peripheral neuropathy actually comes after 4 months. Most of them actually come before 3 months, but we have slides for that. So these are the side effects which we are talking on. And let's move on to this. We have already covered the side effects, and we'll come to this important, that how the impact of EV comes into play. Aditya, do you want to take this slide?
So this slide is regarding the dose intensity and showing better response.
Correct.
And they have looked at the 4 quartiles of the dose intensity and said that the responses are better if there is higher dose.
Yeah. So what is essentially shown is sometimes we get an habit that we are using something in beyond second line in a setting. He's an elderly patient, let's give a lesser dose and see. But this shows that there is a dose response curve, and so unless the patient is okay, unless the patient has you have a dire need for do the dose reduction, it might be fruitful to dose the patient appropriately. This graph also shows you the same thing, that when you dose it at 1.25 milligram per patient, obviously dose reductions will be required if the patient has side effects, and they need to be done. An appropriate dose reduction done for management of toxicity does not hamper the outcomes of these patients. Now with that, if you have to do dose reductions, Aditya, you have the mic. What are the dose reductions? How are the dose levels stepped up?
So I would do dose reduction in grade 3 neuropathy. I would do it for grade 3 skin reaction, and
so I'll just correct you there. If the patient develops grade 3 skin reaction, it would be worthwhile to stop the drug, because it flares up very fast. But for rest, you can, and grade 3 pneumonitis also you need to stop the drug. So pneumonitis and skin reaction, you will have to stop the drug. For rest all, you can do a dose reduction, which can go from 1.25 to 1 to 0.75 to 50. And the maximum doses also are written so that you never exceed those maximum doses. Now, so the key takeaways, sir.
Dose is different as a single agent and as
Correct,
with combination.
Sir, no. With even with Pembro, the dose is same. No, dose is same, sir. That is for Brentuximab, sir. I also got confused when I was reading the literature. So, key takeaways, sir. Tushal sir, you can take this.
I think in the second line it has shown very promising results. The objective response rates of 49%, a good meaningful progression-free survival, 30% reduction of death and progression, and a manageable side effect profile.
Correct.
Majority of the side effects can be actually pre-identified, worked up with, patient can be counseled and maybe managed.
Now we have 3 minutes left. As Dr. Tushar had pointed out, you can today use this as the first line for metastatic setting. You can use in second line and third line also. ESMO had a very good presentation, Aditya. And can you just brief what were the findings? Because STLS couldn't allow me to this, but that's very important to discuss the finding of in neoadjuvant setting what came for EV with Pembro.
Yes, sir. So that was EV303.
Correct.
And they did EV plus Pembro neoadjuvant followed by surgery and had a better response than chemotherapy arm.
Yeah, one of the major challenges we get when we look at bladder cancer is A, they are elderly. Second, their creat clearance are on the lower side. And cisplatin ineligibility is a major problem, and in cisplatin ineligibility we always had been doing divide the dose of cisplatin, and with this combination of EV plus Pembro, which got presented as in the presidential symposium in ESMO, which showed remarkable good response rates, major pathological response, and even PAT-CRs. Very soon we might have an approval for those indications also in India to use it even in the neoadjuvant setting. Any questions from the audience? If no, I'll leave final comments with Aditya. You only give. Let Rahul give.
No, I think it's a good drug. Only because of the availability we were not able to use it, but now with availability, maybe cost we still need to come down, but with experience I think it should be coming in the earlier settings as well, and I think it's a promising drug.
I'll just make one correction. When sir asked me the dose and the schedule for single agent is day 1, day 8, day 15, 28 days. With Pembro it goes day 1, day 8. Dose remains the same, but the schedule is day 1, day 8. That's correct. Yeah. Thank you.
Thank you to Dr. Patil and our panelists. We now move on to our next sponsored session on selecting appropriate frontline immunotherapy-based treatment in metastatic RCC. This session is sponsored by Bristol Myers Squibb. I would request our video team to kindly pause the recording for this session. Moderating this discussion is Dr. Aditya Dhanwat, Consultant Medical Oncologist, Navi Mumbai, joined by a distinguished panel, Dr. Reshma Puranik, Consultant Medical Oncologist, Pune, Dr. Vipul Doshi, Consultant Medical Oncologist, Solapur, Dr. Ashish Joshi, Consultant Medical Oncologist, Mumbai, and Dr. Satyajit Pawar, Consultant Medical Oncologist, Pune.
Hello, good evening. I thank the organizers and welcome the panelists. So we have Vipul sir, Ashish sir and Satyajit sir with us. Dr. Reshma is probably not here, okay. So we'll quickly do this. So this is the panel discussion on frontline immunotherapy in metastatic RCC. The slides are from the BMS. And this is the disclaimer. So this is the Globocan 22 data with new cases of RCC of 17,000 in 1 year from India. And this was in the TKI era, wherein the 1 year survival was 36% and 2 year survival was 22%. And approximately 40% of RCC patients die from metastasis. But having said that, this is from the US. Our Indian data is much worse than this. So there is some unmet need in terms of efficacy in RCC treatment. If you look at the median PFS and median OS, and there is a wide variability because of the TKI, the IO TKI, and this is what we are going to discuss today. So my first question is to Dr. Vipul. Would you please take this? So what is the goal of therapy in first line treatment as per you? Would you look at the OS? Would you want durability of response?
As a doctor, as a patient, like all should be our goal of like this overall survival, progression-free survival, quality of life, response rates, especially those who have a heavy burden of disease, who are symptomatic for it. The complete response is always better, even the durability of response. So like all these parameters matters as a patient point of view.
Completely agree. Other panelists would agree to this, that all the points matter?
Yes, definitely. For a heavy burden disease, we would definitely look at a quick response and to improve. And especially if you are able to give, if you are looking at a longer duration of treatment, then quality of life will also matter.
Right. Ashish sir, would you like to take that? How important is durability of response as a goal of therapy?
Yeah, I think I agree with my co-panelist. It's a chronic disease that we're looking at. So durability of response, helps me to manage the toxicity of the treatment better. Because you are with a stable drug for a long period of time. Patient is less symptomatic because of the disease. And then obviously since you have a long PFS, you obviously get a better chance of giving a better treatment in the second line, third line and fourth line setting, which I'm sure all of these patients end up receiving. So yes, durability is also equally important, but all of them are very, very important.
Couldn't agree more. So we'll move to the next thing. So this is the short term wherein we look at the objective response rate and the PFS, and the long term the OS. But in all, the durability of response, as all panelists agree, and the quality of life is equally important. So this is the Checkmate 214, the 90-month analysis, wherein the median follow-up was 99 months. And if you look at the median survival benefit, it is roughly 26 months to 46 months, so roughly 20-21 month benefit over TKI alone with IO plus IO, that is Nivo EP. What is your take on this, Dr. Satyajit?
So I think the data is very impressive. You have a long-term data of Nivo EP combination over sunitinib, and we know that almost 30% of patients are progression-free. One third of the patients are progression-free at the end of more than 5 years now.
So roughly we can see that in the 8 years, roughly 10% are more patients are living as compared to sunitinib alone. Now this is the PFS curve of the Checkmate 214, that is IO plus IO. Now again, when we look at there is an early separation, so that there is a considerable number of patients who are going to progress, which we call the bad biology. But then there is a certain amount of patients which you see that in the 6 months time point, the curves have started separating, and there is a durability of that response, and which translates that even at 8 years, the PFS is 25% versus 8% with sunitinib. Now let's talk about complete response. And I'm sure we all have used Nivo EP in our daily practice, and we have seen patients who have attained CR. So what's your take on this? Ask Dr. Vipul. So Nivo EP complete response at 8 years, 12%.
Yeah, that's a very impressive thing. Even in the case of intermediate and poor risk patients in the palliative setting, if we see 12% of patients at 8 years almost disease free, and that's a big number. And like most of them are in CR for longer period of time. So that's a wonderful thing.
So while the left side is important, even the right side, that of all the patients who attain CR, 84% are still maintaining CR at 8 years of time point. And this is the quality of life which does favor Nivo EP over sunitinib. And this is the duration of response. Again, highlighting that there is a higher duration of response with Nivo plus EP as compared to sunitinib. Now, this is an interesting slide wherein you see that there are these patients which are still on treatment. Then there are some patients who are off treatment and never receive subsequent systemic therapy. So again, this is a question that often patients ask, that those who are on CR, when do you stop the nivolumab?
Typically, you give it for a period of 2 years. And post that, if the patient continues to having a response, then I think continue immuno beyond 2 years. I'm not sure whether you add any meaningful clinical benefit. So 2 years.
Other panelists agree to this?
Yes, yes. So 2 years is an ideal time point where we can think about stopping nivolumab.
Yeah, so completely agree that our standard practice is patients who attain CR, we continue for 2 years, and then post 2 years of that, we can stop the nivolumab, keep under observation, and there is good enough data that on disease progression, you can again restart the nivolumab and patients respond to that. So now this is the most pertinent question. How do you choose Nivo EP versus all the IO-TKI options that you have? Dr. Vipul.
Nivo EP and IO-TKI combinations, like what all things we can consider? Yes, disease-related symptoms, like the disease burden is more, patient is symptomatic. Then we can choose a IO-IO combination, Nivo EP, where we can get faster responses, better responses, and like early symptom relief. So that's one point. Then there are some patients who we can see TKIs are difficult to manage because of TKI-related specific toxicities. Even in that scenario, a combination of IO-IO will be preferred one.
Okay. Dr. Satyajit, would you like to add?
Two specific areas were variant histologies like sarcomatoid and a CNS metastasis. I would prefer using Nivo EP. But otherwise, if you want a rapid response, the data for IO-TKI is better. So if you want a higher disease burden, then I would go ahead with the IO-TKI combination. Again, patients, so one problem with IO-TKI is you have to give TKI for longer term, and the toxicity of TKI keep on adding. And at some point, you need to stop that, basically. So I think Nivo EP will overscore over TKI in such cases.
So if I were to put one based on the IMDC risk, that favorable, I would want to give IO-TKI, whereas intermediate to poor, I would want to give IO-IO. So Dr. Reshma, would you like to take this? So we are discussing on IO plus IO, that is Nivo EP versus IO plus TKI. When would you prefer IO plus IO, and when would you take IO plus TKI?
Sir, IO plus IO is basically a good combination for the non-clear cell, especially sarcomatoid varieties and the other non-clear cell. And IO-IO overall works very well. The only set of patients where I don't want to use it is, like for example, if there's a bony met, an impending compression. So in such patients, sometimes the flare which occurs, that can be problematic. So in only such situations, otherwise, overall, even for a clear cell, non-clear cell, especially for a non-clear cell, the IO-IO combination is what I would want to prefer.
Okay, so I put it this way, that in favorable risk, I want to use IO plus TKI. If I want early response, I would want to use IO plus TKI, and if I have a large burden of disease, I would want to use IO plus TKI. Whereas for intermediate to poor risk, sarcomatoid, rhabdoid variants, I would want to use IO plus IO, right? So this is the rationale for immunotherapy, and we all are aware about this, that it's a highly immunogenic, RCC is highly immunogenic, there is upregulation of all the immune cells, and the tumor microenvironment does express high PD-L1, and more than 50% of RCC tumor infiltrating lymphocytes express the PD-L1. And then the Nivo is an anti-PD-1 which inhibits the interaction between the tumor cell and the T cell, and EP is an anti-CTLA4 which inhibits the interaction between the dendritic cell and the again the T cell, thereby reducing the deactivation of the T cell. So again, as a combination, both have shown efficacy, and I'll quickly skip through those slides. So this is the IMDC risk stratification. So for the benefit of our audience, Dr. Reshma, would you like to take it? Do you follow IMDC in your day-to-day routine practice?
Yes, because I think it is very easy to classify. They are very common parameters which are, whenever the patient comes to us in the OPD, they generally come with the platelet, the CBC and the other parameters mentioned. So it is very easy to calculate this score. So I use this commonly, and it also helps in decision making.
So one of them that most often gets missed is the calcium levels. So it is important to do calcium at the baseline. And this was based on the TKI era, wherein the favorable, intermediate and poor risk showed 44, 22 and 8 months of survival. So now the next question would be, which approach is more reasonable while you select the first line treatment? Either you want to start IO based combination in the first line, or you want to initiate a TKI based monotherapy. So we want to discuss, now that we have discussed that in favorable risk, we prefer IO plus TKI. So IO plus TKI versus TKI alone. What's your take? Dr. Ashish?
I think there is enough data, 3 large RCTs which have included even the favorable risk, and it does show PFS OS benefits of combination. So given a option, if the tolerability toxicity profile is fine, I would still tend to use IO plus TKI. There are those rare patients who have got a oligometastatic disease, long PFS after nephrectomy done, a very low volume, a couple of med, and you've done some local therapy for oligometastatic. These are the patients probably you could still have a TKI alone as an option.
Right. All panelists agree to this. Dr. Vipul, Dr. Satyajit, yeah. So let's say a patient, again 70 years old, had nephrectomy done in 2018, 25, has come with 2 metastatic lesions. Maybe you might consider TKI alone if it fits into the favorable risk, right? So again, we discussed this regarding the median OS and the survival benefit of Nivo EP. Again, the responses to Nivo EP are fast and durable, wherein they looked at, as compared to sunitinib, it was, the median time to response was 2.8 months versus 3.6 months. And now the next question is, how important is durability of response? And we had a discussion regarding this, that yes, durability of response does matter. Having a good complete response, and then 84% of those complete responses continuing till 8 years is what Nivo EP does offer. I'll skip this, and then we also discussed about this. Now the next question would be, how do you choose appropriate patients who will derive Nivo EP in the frontline setting? So we again discussed on this: intermediate, poor risk, sarcomatoid, rhabdoid variants, and those in which you would want complete responses. Now, when a patient progresses on Nivo EP, what would be your subsequent therapy? So Dr. Reshma, could you take this?
Sir, if the patient progresses on a IO-IO combination, then the TKI becomes a good choice in the later line.
Would you give TKI alone, or what would be your options in this situation?
So we can use a TKI alone. If it is a pazopanib, sunitinib combination, we can use it. Or maybe we can try a TKI-IO combination also.
Okay. Dr. Satyajit?
Also use lenvatinib plus everolimus. I think it's a great combination. Used it in second line, and in fact, when nothing works, sometimes lenva, everolimus, because you're completely biologically approaching the tumor very differently, so it works.
Completely agree. And what would be the median PFS that you would expect in this situation with lenva evero in the second line?
Expect 12, 13, 14 months plus as well, and even more sometimes,
right,
if patients respond.
Dr. Satyajit?
We have data now of belzutifan plus everolimus also in post-progression on IO, so that is one option which can be considered.
So the problem with belzutifan is A, not available, 2, import costs about 20 lakh per vial. Again, I don't think anybody would be feasible for that.
What we use is cabozantinib or lenvatinib.
Would anybody prefer Nivo plus Cabo in this setting?
If there is a on-treatment frank disease progression on dual immuno, then I would prefer not to continue with it.
Right. So we all agree that if there is frank progression, we are going to stop the immuno, switch over to Lenva-Evero. And post Lenva-Evero, what would be the third line choice? Dr. Reshma, would you take it, or Ashish sir, would you take it?
Yeah, Amish, yes.
Sorry. So the second line, if you see all the TKI and if you compare, tivozanib scores better than Lenva Pembro. If you see now 2025 they have come out, in where there are 20-25% patients crossing 2 years of PFS. So tivozanib, although it's not available, but it's not more expensive than Nivo EP. It is expensive. So if you see everolimus plus lenvatinib versus tivozanib, tivozanib scores over in the second line.
Agree, sir. Agree. And what would be the third line choice? Would you want to re-challenge with the immuno? Give another TKI?
Very individualized treatment approach in this setting. What patient has received in the part, what are the toxicity, how much PFS we have achieved in the first line treatment. Yes, if there is a fair gap between the last immuno, there is always an option of re-challenge with immuno plus TKI. But typically, we tend to use the next TKI.
Right. So if we put it this way, that let's say the Lenva-Evero took at least 1 year of PFS, then you might think about giving an immuno again? Probably.
A fair chance.
So this is the NCCN guideline wherein Nivo EP was the category 1 for intermediate and poor risk. And so next question is, how do we choose the IO plus TKI combination? Would you choose Pembro-Lenva? Would you choose Pembro plus Axi? Would you choose Nivo plus Cabo? Dr. Vipul or Dr. Satyajit?
So IO-TKI combination is like what we use, like which TKI is better tolerated, and that we see lenvatinib and axitinib are the better tolerated ones as compared to cabozantinib. So that determines like which TKI we choose first.
Okay. Dr. Satyajit?
Preferred TKI I would say would be lenvatinib, because the data is also better for using lenvatinib, and also it is better tolerated as compared to cabozantinib.
Okay. Agree or any opposing views?
Patients with the sarcomatoid histology, I will use cabozantinib because the data is there
good
for
with
cabozantinib. For a chromophobe, I would not use either because.
No, we are restricting to clear cell.
Okay, fine. So for a sarcomatoid variant of clear cell, I
Yes.
would tend to use caboza. Otherwise, for other patients, it's either going to be lenva or axitinib.
Sure. So again, this is the checkmate 9ER, which shows Nivo plus cabozantinib versus the sunitinib, wherein the median PFS was 16 months versus 8 months, and the median OS was 46 months versus 36 months. And there was clinically meaningful primary and secondary outcomes with 3 times more CR rates with Nivo plus Cabo as compared to sunitinib alone. And yes, PFS, OS and objective response rate all were better with Nivo plus Cabo. Again here we see that Nivo plus Cabo has a median time to response of 2.8 months and a median duration of response of 22 months. Now here, Dr. Satyajit, would you like to take this and 50% patients alive at 4 years, exciting?
So yeah, definitely, as I said previously also, almost more than 1/3 of patients we now see are living without disease progression.
And this tallies with our day-to-day clinical practice. This is what we see in our clinical practice as well. Dr. Reshma, how frequently would you consider dose reduction for cabozantinib? What is your approach? Would you like to start at 40, go down, or would you like to start at 20, go up? How? What is your practice?
So cabozantinib, I feel 40 mg is a dose which is well tolerated as per the weight of our patients also. 60 I find it very difficult, very rare.
So we are talking about the combination IO plus cabozantinib, so it's 40 mg.
Yes, as a single, as a combination. So 40, and if not tolerated, then only step down. But otherwise, I feel 40 is being tolerated by most of them.
Okay, Ashish sir, you would agree to that?
Yeah, I do, but then somehow I think sometimes there is almost, at least in my practice, almost 50% patient would require a dose reduction.
Yes,
It's not that easy drug to handle.
So we analyzed our data of about 400 patients, which we presented at the SOGOCon, and so it was a 400 patient data on cabozantinib use, and roughly 45 to 50% patients required dose reduction, either to a 40-20 alternate or to go to 20 mg OD. In fact, there were some patients who were on
20 mg alternate.
And there were some patients on 20 mg alternate as well. So the next question is, does it impact outcomes? Dr. Vipul, would the cabozantinib dose impact the outcome?
Not really.
Because,
Can reduce the dose as per the tolerance.
because we feel that Nivo is what is driving the response. So again, we'll quickly talk about the toxicities of Nivo plus Cabo. So most common being HFS, hypertension, mucositis, and proteinuria, which most of them, they require dose reduction because of HFS or mucositis. So again, we discussed this checkmate 214. So I'll just quickly tell about this. This was a 1:1 randomization. The Nivo EP had 4 cycles of 3 mg per kg of Nivo and 1 mg per kg of EP, 3 weekly given for 4 cycles, and then Nivo monotherapy was continued as 3 mg per kg 2 weekly, and that was compared with sunitinib. So this was the dosing. And if we talk about safety, so Dr. Vipul, Nivo EP in your practice, common toxicities that you would have seen?
Some autoimmune related toxicities we can see, common of which is some autoimmune endocrinopathies like hypothyroidism. In some cases, rare cases, autoimmune pneumonitis, but like fairly well tolerated regimen.
Right. This is basically the treatment-related adverse events that was reported with Nivo EP compared to sunitinib. And in this, if you look at the grade 3 toxicities with the time interval, so as the time goes by, the toxicities to Nivo EP reduces. We know that the toxicities are going to be in the first 6 months to 12 months, and after that the toxicities go. And this is the pattern of toxicities. If we look at the sunitinib, the toxicities continue over a period of time, whereas in Nivo EP, the toxicities settle. The other interesting thing is, this is the overall survival in patients who discontinued because of treatment-related adverse events versus the intention to treat. So those who discontinued because of treatment-related adverse event had a survival benefit again over the intention to treat population. So even if we are having a drug discontinuation because of toxicity, the survival benefit is being maintained. Again, majority of immunotherapy related adverse events happening in the first 4 doses, and that's how it is. And this is the acronym to remember this: colitis, hepatitis, adrenal insufficiency, myocarditis, pneumonitis, infusion reaction, ophthalmologic, and nephritis. So it is a safe drug, roughly 20 to 30% requiring having immune related adverse events, and those who are discontinuing are still having survival benefit. This is the NCCN guidelines. For favorable risk it is IO plus TKI, and for intermediate to poor it is IO plus TKI or a IO-IO combination. Now last part, sarcomatoid RCC, we discussed well. That again, Nivo EP scores over sunitinib big time, the median OS being 48 months versus 14 months, and hazard ratio of 0.46. Again, the objective response rate being 60% versus 23%, and this is the 30-month overall survival probability based on the risk factors. So because of this, the 0 risk factor, that is the favorable risk, did not show benefit over sunitinib. That is why we are not preferring Nivo EP in favorable risk. And this is again the toxicities that we've discussed. Right. So thank you. Any last comments that any of the panelists would like to add?
See, if our patient is doing well on IO-TKI combination, for example, if it crosses 2 years, do you all continue? Like, I do not stop.
Regarding
So whether we discontinue the IO beyond 2 years, what are we all following?
So in some of our patients, we have discontinued the IO. We have continued the TKI only and only if he has tolerated well. So most of the times, because they have taken it for a long period of time, we know that this is the dose that he is stable dose has been reached. So we try to continue the TKI, we withhold the IO, and there is good enough data that when the disease would progress again, you can re-challenge the IO, right? Thank you panelists, thank you audience.
Thank you, doctors. Now we move to the remarkably common but no less complex, the world of head and neck cancers. It's time to begin academic session 12. I invite our session director, Dr. Arvind Krishnamurthy, consultant surgical oncologist, Chennai, and session coordinator, Dr. Siddhesh Trayambake, consultant medical and hemato-oncologist, Pune, along with our chairpersons, Dr. Abhishek Shankar, consultant radiation oncology, Delhi, Dr. Kirutiga KG, consultant histopathologist, Pune, Dr. Tejpal Gupta, consultant radiation oncology, Navi Mumbai, Dr. Vidita Paule, senior consultant head and neck surgeon, Pune. To start this session, we look towards a rapidly shifting frontier, perioperative immunotherapy in resectable HNSCC. Is it practice changing in 2025? To answer these questions, please join me in welcoming Dr. Minish Jain, consultant medical oncology, Pune.
Good evening, everybody. We'll be discussing this topic, which is perioperative immunotherapy in resectable head and neck squamous cell carcinoma. Is it practice changing in 2025? Yes, the shift in practice is primarily driven by positive results of two landmark phase 3 clinical trials, Keynote 689 and NIVO post-op. The Keynote 689 presented at the AACR, American Association, and ASCO 2025 annual meetings demonstrated that adding perioperative pembrolizumab to existing standard of care significantly improves the outcome in locally advanced head and neck squamous cell carcinoma. June 25, FDA approved this perioperative pembrolizumab in resectable locally advanced head and neck squamous cell expressing PDL expression more than 1. The PDL expression, that is PDL CPS1, should be more than 1 in this particular indication. And this marks the first major treatment advance over 2 decades. Similarly, NIVO post-op is again a landmark study which is changing the adjuvant nivolumab was given to the standard of care. The results of this are awaited and this is waiting regulatory approval. So this is again a very significant trial which happened in 2025. So what was the rationale? If you look at, let's go with the 2 studies one by one. Keynote 689, which is perioperative. The rationale is treating an intact tumor may prime a stronger immune response by exposing abundant tumor antigen in situ. Now this will do an activated and expanded tumor specific T cell pool, which will further lead to tumor cell kill, which will release more antigen. So there is going to be a better loco-regional response, and there is going to be also a control of distant metastasis. The study was basically 1:1 randomization. The neoadjuvant arm had 2 leading trial, 2 cycles of pembrolizumab as a lead, and then surgery, and then 3 cycles of pembrolizumab along with radiotherapy plus minus cisplatin, and post surgery the other arm was radiotherapy and cisplatin, standard of care. These were all patients with stage 3 and 4A. So patients with oropharyngeal had either P16 negative or positive, and larynx, hypopharynx, oral cavity were included. ECOG performance 0 to 1 and PDL testing was necessary. The patients, the primary endpoint was EFS, the secondary endpoints being major pathological response, and the other secondary endpoint was safety. The trial showed that significant and clinical meaningful improvement was seen in median EFS from 30.4 months with standard of care to 51.8 months in addition of pembrolizumab, a 27% reduction in risk of EFS event. And the benefit was driven by improved distant metastasis-free survival. See, this is the study which shows that benefit was in preventing distant metastasis. But when we go to the second study, we will see a different thing, and I will point out that to you later. The keynote 689 showed that EFS in CPS more than 10 population was significantly more pronounced, but the benefit was seen in all patients including CPS more than 1. So the hazard ratio was favoring pembrolizumab. And the hazard ratio for this was 0.66. The only thing what you see on this forest plot is that hypopharynx showed a poor response of like 2.55 hazard ratio. So there was no benefit, but these numbers were 8% of patients were included in this study, and this was not powered to say why this happened. And the other benefit was not seen in female patients where the hazard ratio was 1. This were 13% of patients, but overall there was a benefit seen, and a bigger number requires to look at these particular events. The pathological response were significantly higher, both in primary tumor and lymph nodes, and which are serving as a strong prognostic indicator. The safety and tolerability of this study was comparable with standard of care, and there was no significant delay in surgery for the pembrolizumab arm. So if you look at the summary of keynote 689, perioperative pembrolizumab significantly improves EFS in resectable locally advanced head and neck squamous cell carcinoma. Successful implementation requires a multidisciplinary care. There are newer studies where NeoIP or chemoimmunotherapy to increase efficacy is going on. Now let's look at the second study, Nivo post-op adjuvant nivolumab. This was presented at ASCO 2025, and it showed a significant improvement in disease-free survival, and adjuvant nivolumab was added to standard post-operative chemoradiotherapy. The addition of nivolumab to post-operative chemoradiation significantly improves disease-free survival in patients with high-risk resected head and neck squamous cell. And this outcome is driven by improved loco-regional control. So if you add immunotherapy post-op, it's a loco-regional control. If you give it pre-op, it's a distant control. And so you need to choose right patients for either of these things. Nivo post-op is going to become a standard of care probably in 2026. The Nivo post-op was adults less than 75, ECOG 0 to 1, oral cavity, oropharynx, larynx, hypopharynx, completely resected stage 3 and 4, and high-risk pathological features like margins positive, closed margins, more than 4 nodes, extracapsular extension. So all these patients were given a lead cycle of Nivo 240, and then Nivo 360 was given 3 weekly along with cisplatin 100 per meter square, and subsequently 6 cycles of 480 monthly. So the meaningful improvement in DFS was seen 63.1 versus 52.5, and 24% reduction in risk of recurrence or death. So as we see that this benefit was due to loco-regional control. The safety, this was generally well tolerated, but there were more grade 4 adverse events in the nivolumab arm, 13.1% versus 5.6%. Both the studies, Keynote 689 and Nivo post-op trials, demonstrated that adding immunotherapy to standard perioperative treatment for locally advanced head and neck cancer significantly improves survival outcomes, a major advance in over 2 decades of stagnant therapy. And the key difference lies in the treatment strategies, patient population, and the distinct pattern of disease control. So this is a comparative review. In Keynote, you required a PDL1 more than 1, PDL1 CPS more than 1. For Nivo post-op, there was no requirement. There was a distant control in the Keynote, and there was a loco-regional control improved in Nivo post-op. Impact of perioperative immunotherapy, this is a new standard of care. Both the trials validate the integration of immune checkpoint inhibitors into curative intent perioperative management of resectable locally advanced head and neck squamous cell carcinoma, establishing it as a new treatment paradigm after decades without any significant progress. This is a tailored approach. The distinct benefit of distant control with keynote and loco-regional control with neo post-op suggests that treatment selection should be done and tailored according to patient-specific recurrence profile, clinical feature, advanced head and neck malignancies. Thank you. See, that is what is the thing, that they don't know whether it is the same kind of tumor and the benefit is going to be with immunotherapy or not. So that is why chemotherapy was showing a better benefit in that, and the percentage of patients of hypopharynx were 8%, 8.2 or 8 and odd. For the females also it was 13.5, but both were not powered to see why this has happened. So what the paper quotes is that larger studies required to be done in this particular subset to understand it. As of now, with this particular thing, I would say that you should be offering it more to males and not to hypopharynx.
Are you convinced with single agent pembro as part of neoadjuvant or preoperative approach, or you want to combine it with chemotherapy as of now?
See, basically, we must understand that as I showed you that future trials are going to be chemoimmunotherapy or immunotherapy. But this is a beginning, and the beginning is not bad. So you may add if you want, but the trial doesn't say that. It says that you just add. The reason is that you don't want to delay the surgery also. These are resectable malignancies. Now, if you add chemoimmunotherapy, the whole idea of doing surgery in time will be lost.
So in IO, typically we see hyperprogressors. So in this trial or in this, we can say protocol, how will you identify the hyperprogressors? So that their surgery won't be delayed and patient will be catched up.
Hyperprogression means progression of disease or pseudoprogression?
Progression of disease.
See, that part is going to be clinical. You cannot be judging it based on how would you identify. There are no tumor markers or there are no guidelines to see who is going to respond or who is not going to respond. So there would be some patients who would be progressing despite immunotherapy, and they may become from operable to inoperable. So we don't know how many patients, but there was, the paper did mention that there was no delay in surgery in patients, and there was no difference in the outcomes of the patients if they received these 2 cycles.
Sir, apologies. Sir, can...
This session of the same paper, and the presenter there mentioned that every surgeon was examining the patient, whether the patient is making progress clinically or not. And on the day 1 of patient recruitment in the immunotherapy, the date of surgery was decided. Whether the patient is going to benefit or not, their surgery, date of surgery was booked. And every week the patient was examined clinically, and if the patient progresses in between second or third week, at the planned date of surgery, the surgery was performed. So that stringent protocol was followed in the original trial. Whether we will be able to follow it in our center, that is the biggest question.
See, it is always more difficult to follow.
Dr. Jain, if we can wrap up the session, we can take the questions during the panel. Our next talk explores one of the most dynamic and globally evolving areas in head and neck, HPV positive oropharyngeal cancer. To take us through the cutting edge updates, please welcome Dr. Shwetab Sinha, Consultant Radiation Oncology, Navi Mumbai.
Thank you. So good evening to everyone. I'll be talking on HPV positive oropharyngeal squamous cell carcinoma de-escalation strategies. So ever since the publication of the seminal paper by Kianang, we know that HPV positive oropharyngeal cancers are associated with a better prognosis than their HPV negative counterparts. They are diagnosed at a slightly younger age. But what was also intriguing was that not all HPV oropharyngeal cancers have better prognosis, and even within them, the prognosis is impacted by smoking status, T stage, N stage. So efforts were ongoing to identify the best candidate for de-intensification strategies. This is a paper from 2015 which told us that the best candidate for de-intensification are the T1 to T3 tumors, N0 to N2C, and non-smokers. Now mind you, this was 2015 or so. So AJCC 7th edition was there, so HPV positive oropharyngeal cancers did not have a separate staging. So ultimately we did come up with a separate staging for HPV positive oropharyngeal cancers in the 8th edition, and what was intriguing was that ECE or the extracapsular extension in node was not given separate importance, and it was not upstaging the tumor to N3B status as was in the HPV negative counterpart. However, a couple of months ago, the 9th edition of HPV positive oropharyngeal cancers has been updated and published, and at least in the post-operative setting, it is recognized that besides the number of nodes, it is the ENE status also that impacts the prognosis in HPV positive oropharyngeal cancers. And these are perhaps not the best candidate for de-escalation. They have now been given stage 3 as compared to the N2, which are now stage 2 in the AJCC 9th edition. So what are the strategies? We have two broad strategies for the management of HPV positive oropharyngeal cancer, the definitive RT approach and the adjuvant RT approach. And de-intensification strategies have been tested in both. In the definitive, we have the replacement of cisplatin by cetuximab, the reduction of doses of RT as tried in the NRG HN002 and 005 trials, and we have reduction in volume as well, which is in the Optima trial. And in the adjuvant setting, that is post-TORS, we have risk-adapted dose reduction. We have a dose reduction as well as systemic therapy treatment change, and we have again a reduction in volume and the very radical omission of RT after response to neoadjuvant chemotherapy as seen in the Nectar's approach. So I'll go through briefly each one of them. So this is by and large a well-settled debate. I think most of us will agree that cetuximab cannot replace cisplatin for HPV positive oropharyngeal cancers in patients who warrant concurrent systemic therapy. At least 5 randomized trials are there, although with separate, slightly different inclusion criteria, but inferior progression-free survival as well as overall survival was there in most of the trial. The toxicity profile was also similar with cetuximab as compared to cisplatin. So when, as far as RT dose de-escalation goes, the NRG HN002, which was a phase 2 randomized trial, showed promising results of giving 60 gray instead of 70 gray with IMRT, along with 2 cycles of 3 weekly cisplatin, and the 2-year progression-free survival was 96.7% in T1, T2, N1, M0 or T3, N0, N1 cohort as per the AJCC 8th edition. However, when this was tested in the phase 3 trial, which is the NRG HN005, to the standard of care, which is the 70 gray IMRT, this is slightly accelerated IMRT, this is given over 6 weeks, that is 6 days of a week. And there was a third arm, which was 60 gray IMRT with nivolumab. Both the experimental arms, that is 60 gray IMRT with cisplatin and 60 gray with nivolumab, fell short, well short of the standard arm. 98.1% was the 2-year progression-free survival estimate, and actually this gives us a kind of new benchmark against which all the de-escalation trials in future will be tested. I mean, it is difficult to trump 98.1%, and all the de-escalation trials have their jobs cut out, in my opinion, to trump this result. So what are the further promising approaches? The 30 ROC trial as promoted by the Memorial Sloan Group, they are using F-MISO as a marker for hypoxia, and those patients which are not hypoxic, they are radically de-escalating the dose to 30 gray instead of 70 gray. The phase 3 randomized trial is already ongoing for it. We also have the Optima trial where responders to NAB, paclitaxel and carboplatin HPV positive oropharyngeal cancers are stratified at low risk and high risk. And there is a volume de-escalation where only the first echelon nodes are treated, and dose de-escalation also is there, although there are hyperfractionated RT is also utilized in a couple of phase 3 trials. So these are the approaches in the definitive setting, and we look forward to these results. As far as the adjuvant results go, the ECOG 3311 is sort of the prototype for all de-intensification trials in the adjuvant setting, and in the intermediate risk as defined by the ECOG 3311, which includes clear margins, less than 1 centimeter of extracapsular spread, 2 to 4 metastatic lymph nodes, PNI and LVI present, it seems that 50 gray de-escalation by 10 gray. So from the standard of 60 gray to 50 gray, the adjuvant doses seems feasible. The long-term results of this trial are now also available, the 5-year update, and the results show encouraging results with 50 gray de-escalation. However, we know that in the adjuvant setting, one of the major problems is the definition of margin. Each of the similar trials, Pathos, Orator, ECOG 3311, all have different definition of margin. So we may really find it difficult to implement this in our setting. We also had the recent results from the Mayo Clinic trial. So Mayo Clinic actually practices a very interesting strategy of after doing TORS, they radically de-escalate the treatment by giving hyperfractionated RT 1.5 gray BD along with 2 cycles of concurrent docetaxel. So the total RT in low risk patients is 30 gray and in high risk patients is 36 gray, and this is given with concurrent 15 milligram per meter square docetaxel on day 1 and day 8. Again, in phase 2, this showed very good results, but in phase 3, actually the results were disheartening, and they have cautioned de-escalation in ECE positive and margin positive patients. So we have a couple of other approaches where we are combining RT and surgery. So we are doing surgery only for the primary and RT for the neck, and the primary aim is to reduce feeding tube dependence. Again, this is being tested in phase 3 trials, and as I mentioned, the Nectar's approach, which is the radical approach of giving only neoadjuvant chemotherapy and surgery, and irrespective of the pathology results, patients are not receiving adjuvant radiotherapy. So again, this is being tested in a phase 3 trial, and the interesting thing is that the distant metastasis rate seems to be quite low with this approach. So coming to the last part of my talk, this is the ctDNA monitoring in oropharyngeal cancers, HPV positive oropharyngeal cancers. So ctDNA is not new. We are using it as a prognostic marker, as a predictive marker in certain other cancers. In the HPV positive setting, it has largely been used in the post-treatment surveillance and detection of recurrence, and there are multiple trials, both retrospective as well as prospective. There are a couple of systematic review and meta-analysis also, and all of them are saying that it has really a high negative predictive value, which essentially means that patients who have a negative post-operative ctDNA are actually at a very low risk of recurrence, although the vice versa may not be true. If we look at the pre-treatment level correlation, there is only modest correlation. Some trials say that it can detect the T stage and N stage, but other trials fail to do so. And there are ongoing studies that are evaluating the efficacy of ctDNA based de-escalation, particularly in the post-TORS settings. One thing to note here is that there are variation in the probes utilized all across various studies, DNA based versus RNA based. So this is one of the studies published from US, and what it says is that we can actually, in addition to increasing the negative predictive value, we can actually improve the positive predictive value also of circulating tumor DNA detection or ctDNA post definitive CTRT, and if we do 2 consecutive tests, the positive predictive value is 94%, and there is a lead time gain of roughly around 4 months between ctDNA positivity and detection of a biopsy proven recurrence. In the post-TORS setting, as I was already mentioning, this is one of the trials from Japan, and in this stage 1 and stage 2 HPV positive oropharyngeal cancers, we can really see very high negative predictive value. And out of the 30 patients who had a negative ctDNA post-TORS, they were treated with various strategies as per the institutional protocol, observation, radiotherapy, chemoradiotherapy. None of them actually developed a recurrence. So this really sets the ball rolling as a prognostic marker. But however, when we have tried de-escalation strategies based on HPV DNA, the results have not been so promising. This is only one of the trials that has reported. I think another 4 or 5 trials are ongoing. So this is reported from the Memorial Sloan Group around 2 months ago. And it's only a small trial, 12 patients, intermediate risk group have been chosen, so kind of similar to the intermediate risk of ECOG 3311. And what they have done is that patients who are negative with ctDNA as well as no radiographic disease, they are not giving RT and they are choosing only active surveillance, and patients who develop ctDNA positivity throughout the course of surveillance are offered delayed RT. But the results are not so encouraging. The authors have said that deferring adjuvant radiotherapy based on HPV ctDNA using the probe for DNA testing resulted in high rates of disease recurrence. So to conclude, yes, we are doing good in terms of some as better than let's say what we were 5 years ago in terms of choosing de-escalation strategies. However, we have to note that there is variation in inclusion criteria across trials and strategies. There has still been modest success, both primary TORS based and primary RT based strategies. And as I showed that actually for any de-escalation strategies, we should be doing large scale multi-centric phase 3 trials rather than relying only on phase 2 trial results from single institute. And better identification for de-escalation candidates are required. We can use biomarkers, liquid biopsies and radiomics, and all trials for all these are ongoing. Thank you.
We'll take the questions later. So we can take them during the panel when we do. Since Dr. Adam is already with us online, so before we proceed to our head and neck panel, we have a talk that bridges cutting-edge science and real-world change in breast oncology, a subject that's truly reshaping care standards across subtypes. It gives me great pleasure to introduce Dr. Adam Brewski. He is the co-director, Cancer Therapeutics Program, UPMC Hillman Cancer Center, Professor of Medicine, University of Pittsburgh School of Medicine, USA. Dr. Adam will be talking on something all oncologists secretly love, therapies that are smarter than the cancer itself. Yes, the revolutionary rise of antibody drug conjugates. Dr. Adam, if you may start your presentation.
Thank you very much. And again, I appreciate the organizers for inviting me, and I appreciate the flexibility of the organizers allowing me to give this talk during the head and neck session as opposed to the breast session. So I'm going to talk about antibody drug conjugates for the next 15 minutes. And I think these really are revolutionizing the treatment of most cancers, actually. But I think we have a lot of data in breast cancer. The data has been, in the last several years, really accelerating. So what are ADCs? I think most people here know what ADCs are, but they really have three major components. Number one, they have an antibody, usually a monoclonal antibody, targeting a specific antigen. They have a linker, and the linker can actually be cleaved by multiple mechanisms, by proteases on the cell, by low pH, by various other cellular processes. And then finally, they have the payload itself, and that's the drug, and what the mode of administration and action are of the drug is really important. I think we have microtubule disruptors such as DM1 and MMAE. We have DNA damage agents such as derivatives of deruxtecan, SN38, irinotecan derivatives. But the idea is shown here that basically an ADC circulates in the plasma, binds to an antigen, is internalized by the cell, and in the lysosomes, what happens is that the payload is released and then actually does its thing, either disrupting microtubulars or damaging DNA. And actually, you can get cleavage in the extracellular space as well, allowing bystander killing of cells that potentially don't express the antigen. So I'm going to give you two major examples in breast cancer of what's happened so far. The first, HER2 antibody drug conjugates in metastatic HER2-positive breast cancer. I think we have two really at this point in time. The old one is trastuzumab emtansine, shown on the left. It has a drug-to-antibody ratio of 3.1 to 5. Did not have a tumor-cleavable linker, and there's no bystander effect. The more modern antibody is trastuzumab deruxtecan, which has a topoisomerase 1 payload, deruxtecan, a drug-to-antibody ratio of 8 to 1, a cleavable linker allowing a bystander effect. So the first trial of this was Destiny Breast 03. This is from several years ago. 529 patients with unresectable or metastatic HER2-positive breast cancer that had one prior therapy with a taxane were randomized to TDM1 or TDXD. And as you can see here, this is dramatic data. the median progression-free survival was 28 months with TDXD versus about 6.8 months with TDM1, a hazard ratio of 0.28. And I think this really, you don't see separation of curves like this very often. So we actually, in very recent data, presented at this year's ASCO meeting in Chicago, actually then tried to test the antibody in earlier settings. This is a first-line trial now of HER2-positive advanced breast cancer. Destiny Breast 09 took patients who had had no more than one line of endocrine therapy, but no other prior systemic therapy for HER2-positive metastatic breast cancer. About 1,000 patients were randomized to TDXD and placebo, TDXD and pertuzumab, or the typical THP, taxane, trastuzumab, pertuzumab. And in this particular trial, you can see here clearly a 40-month progression-free survival in the first line, which is almost unheard of. This is over 3 years. At 2 years, 70% of the patients had not progressed to first-line TDXD. THP itself had a progression-free survival of about 27 months, but again, a hazard ratio of 0.56, very statistically significant. This actually led to the beginnings of an overall survival benefit. However, patients do so well that only 16% of the patients had died, and so we're awaiting survival follow-up. But I think that trastuzumab deruxtecan plus pertuzumab is clearly better than THP alone. The issue is how much trastuzumab deruxtecan we're going to give. This is because there are side effects. These are the special interest side effects. The most particular one is interstitial lung disease or pneumonitis. About a 12% any grade pneumonitis. About 2 patients died at 0.5%. There's also left ventricular dysfunction from the TDXD that we have to be careful, as we have with all anti-HER2 agents. So that's kind of where we are with first-line therapy and second-line therapy for HER2-positive disease. What about brain metastases? So looking over all of the trials that have ever been done with trastuzumab deruxtecan in breast cancer, it turns out the intracranial response rate, specifically that of active brain mets, was very high. 60%, 70%, 40% in these trials. And so for that reason, about a year ago, data was presented at ESMO in Barcelona of a trial called Destiny Breast 12. And Destiny Breast 12, these were patients who had brain metastases and less than 2 prior lines in the metastatic setting. They could not have had HER2 tyrosine kinases. And they basically, half of the patients had baseline brain metastases, either stable or active, untreated brain metastases. And these patients were given trastuzumab deruxtecan at the typical dose every 3 weeks. And as you can see here, this is the CNS overall response rate in all patients. Actually, the response rate was 71%. And in patients who had active brain mets without any treatment with radiation at all, it was 63%. And if they had no prior treatment of any kind, the CNS response rate was 83%. So clearly these drugs, even though they're large, do cross the blood-brain barrier and have the potential to ameliorate brain metastasis. And I think in the US right now we are using these drugs, particularly for leptomeningeal disease, but other diseases, obviously, other breast cancer subtypes, we're using it as well. So we've now extended this because we've had such success with HER2 ADCs in late stage HER2-positive breast cancer. We've expanded this now to early-stage HER2-positive breast cancer. So at this year's ESMO, 2 months ago, or about a month and a half ago, Destiny Breast 11 was presented. This is actually a randomized global open-label phase 3 study of patients who had early-stage breast cancer, but fairly advanced. They had to have at least T3 lesions or N1 to 3 disease. And they were randomized 1:1:1 to either TDXD by itself for 8 cycles, TDXD for 4 cycles followed by THP, or dose-dense ACT followed by THP, which was the control arm. The primary endpoint was pathologic complete response rate. And what you can see here is that the strategy of TDXD followed by THP had a pathologic complete response rate of 68% versus 53% with a control arm. And specifically in hormone receptor negative HER2-positive disease, that difference was about 16.1%, 83% versus 61%, 62%. So clearly this is clinically meaningful and is likely to result in an improved event-free survival, which we have here. Most women actually do very well but clearly there is the beginnings of an event-free survival benefit. At 24 months, fully 97% of the patients had not recurred who received 4 cycles of TDXD followed by 4 cycles of THP. And I think that, again, we await further follow-up, and we'll see that probably at this year's ASCO meeting. The adverse events of this trial, obviously, with trastuzumab deruxtecan, clearly there was a little bit more nausea, diarrhea, neutropenia, and leukopenia from the combination, but because he only received 4 cycles of TDXD, fatigue was really not a problem with this, or alopecia. I mean, there was some mild alopecia, but not terrible. So again, only 4 cycles of TDXD is actually fairly well tolerated in this setting. The interesting thing, though, is that TDXD by itself did not appear to work. It actually had less of a PCR rate, 43% versus 56%, and basically the hazard ratio was 0.82. There was essentially no difference in event-free survival between TDXD by itself and dose-dense AC followed by THP. So it's interesting that you need to, that 4 cycles appears to work better than 8 in this setting, and I think we're trying to figure this out. We don't really understand it that well. So what about HER2 low breast cancer? I mean, now we've really had lots of successes in HER2 positive breast cancer. Well, in HER2 low breast cancer, obviously, part of it is defining it. And we initially defined HER2 low as having immunohistochemistry of 2+ with FISH negative or IHC 1+. We now go to ultra low, which is any staining whatsoever. And again, it's very hard to get the pathologist to agree on what HER2 low is, and so we have a lot of other methodologies we're using besides immunohistochemistry. They're still in clinical evaluation, but still most of us still do IHC to determine HER2 low or not. So the first trial of this was Destiny Breast 04, and these were women predominantly hormone receptor positive, HER2 low, 494, or there were 63 patients who were hormone receptor negative, HER2 low, and they were randomized. These were actually had been through multiple chemotherapies, at least 1 to 2 prior lines of chemotherapy in the metastatic setting, and they had to be endocrine refractory if they had endocrine therapy. They are randomized to TDXD or physician's choice of chemotherapy. You see capecitabine, eribulin, gemcitabine, paclitaxel, or nab-paclitaxel. And again, the median prior chemotherapies was 1, prior endocrine therapies 2. 70% had prior CDK4/6. And again, in this trial, there were substantial differences, a hazard ratio of 0.51, 10-month PFS in TDXD versus 5.4 months with physician's choice of chemotherapy. And again, this is actually all patients, including the ER-negative patients. You can see here also in the triple-negative disease that was HER2 low, the same thing, a hazard ratio of 0.5. So this is clearly dramatically different, and it resulted in overall survival improvement, hazard ratio of 0.64, 24 months versus 17 months with physician's choice of chemotherapy. So we went even further and now did Destiny Breast 06, and this is actually now patients who are chemo naive in the metastatic breast cancer setting, and included about 150 patients who were ultra low, again randomized to TDXD or physician's choice of chemotherapy. 20% of the patients were ultra low, the median number of prior endocrine therapies was 2, and almost all of the patients that had a prior CDK4/6 inhibitor, and again the primary endpoint was progression-free survival. And in this ultra low, you can see here the median progression-free survival was 13.2 months versus 8.1 months with the physician's choice of chemotherapy, a hazard ratio of 0.62, and I think this now is a standard of care. You can see here, again, these are, this is just the physician breast blinded independent review, again showing 13.2 versus 8.1 months. And so clearly this is now a standard of care, specifically in patients with very rapidly progressing disease on CDK4/6 inhibitors or with bulk disease after CDK4/6 inhibitors. So now let's just briefly, before I end, and talk about TROP2 ADCs, and in terms of at least initially the data in metastatic triple-negative breast cancer. I didn't have time in this particular presentation to talk about early first-line data presented at ESMO, but at least I'll talk a little bit about some of the second-line and beyond data. So again, I think that TROP2 is present on about 96% of triple-negative breast cancer. An ADC, sacituzumab govitecan is an ADC with SN38, an irinotecan derivative, bound to a cleavable linker. This linker is cleaved at low pH, either in the endosomes or in the extracellular space of rapidly proliferating tumors. The ASCENT trial, which was presented and published actually now 5 years ago, took women with metastatic breast cancer and 2 or more prior chemotherapies for metastatic disease, randomized them to sacituzumab govitecan or physician's choice of chemotherapy, with the primary endpoint being progression-free survival. Most patients with physician's choice had eribulin. And what you can see here, this is data published in the New England Journal of Medicine about 3 or 4 years ago, that sacituzumab govitecan not only had a substantial improvement for disease progression, hazard ratio of 0.41, but actually doubled the overall survival of these patients from about 6 months to about 12 months. So this really now became an international standard of care in women with metastatic breast cancer in the 2nd or 3rd line. Now we do have data now from the 1st line, and this was presented at ESMO this year. ASCENT-03 took patients in the 1st line who had PD-1/L1 negative tumors or PD-1/L1 positive tumors that were previously treated with a PD-1/L1 inhibitor in a curative setting. And they were randomized to sacituzumab govitecan as 1st line or physician's choice of chemotherapy, paclitaxel, nab-paclitaxel, or gemcitabine carboplatin. And in this particular trial, you can see here progression-free survival was improved by about 3 months with a hazard ratio of 0.64, a 6-month PFS rate of 65 months versus 53 months, and you can see these curves separate and continue to separate. And actually 2 years later, fully 20 to 30% of the patients are still alive without progression on this 1st-line antibody-drug conjugate. The major problems with sacituzumab include diarrhea, which is grade 3 in about 10% of patients, and this is controlled with dose reduction and loperamide, as well as neutropenia. 43% of the patients did develop grade 3 or worse neutropenia, and basically we control this with growth factors, usually long-acting G-CSF on day 9 of the day 1, day 8 cycle. Now there is another antibody-drug conjugate. This is datopotamab deruxtecan. This is actually deruxtecan bound to a TROP2 ADC with a drug-antibody ratio of 2 to 1. And in this trial, TROPION-Breast02, these were women who actually, again, had triple-negative breast cancer with no prior chemotherapy. They were randomized to Dato-DXd or physician's choice of chemotherapy, which included paclitaxel, nab-paclitaxel, capecitabine, eribulin, or carboplatin. And in this particular trial, you can see here progression-free survival in the 1st line with the datopotamab deruxtecan was almost doubled from about 5.6 months in the control chemotherapy choice arm to 10.8 months with a hazard ratio of 0.57, which is dramatic and actually improves survival as well. So there was an overall survival benefit, again, of about 2 years with 1st-line antibody-drug conjugate in this setting, 24 months versus 18 months, hazard ratio of 0.8 roughly. So again, I think I appreciate allowing me to give this talk, kind of intruding a little bit on your head and neck session, but I really think that at least in breast cancer and other cancers I'm sure you've heard about during this multi-tumor conference, at least in breast cancer where I think we've had the most data, HER2 ADCs are really now the standard of care. For neoadjuvant therapy, I believe, for high-risk HER2-positive early-stage breast cancer. It's now really, I think, the standard of care as well for HER2-positive metastatic breast cancer as 1st line. Clearly, it has an overall survival benefit in the 2nd and 3rd line in HER2-positive breast cancer, as well as substantial activity in brain mets. So the question now is really when to use it. Do we use it as 1st line for some period, stop it and give maintenance therapy, and then give it as 2nd or 3rd line therapy, or do we all give it in the 1st line? TROP2 ADCs have overall survival benefit in 1st line metastatic breast cancer with or without immunotherapy. I didn't really talk about the ASCENT-04. Again, TROP2 ADCs also have overall survival benefit in the 2nd and 3rd line. So when is the best time to use it? So I think really where we're going, what about TROP2 ADCs after neoadjuvant chemotherapy in early stage triple-negative breast cancer? Those trials are ongoing. What about other antibody-drug conjugates? What about bispecifics? What about antibody-drug conjugates that have more than one payload? What about sacituzumab TMT, which appears to be a very active TROP2 ADC? I think the future ahead is very bright in this field, and I think that really it's changing the treatment of metastatic and early stage breast cancer in multiple intrinsic subtypes. So with that, thank you very much for allowing me to kind of get into the middle of this session, and thank you again.
Thank you, Dr. Adam, for joining us and delivering such an exceptional and insightful lecture. We now move to our panel discussion from the head and neck section. What will you do differently in 2026? Moderating this session is Dr. Vijay Patil, Consultant Medical Oncologist, Mumbai. Dr. Vijay, may I invite you to the stage? We also invite our panelists, Dr. Ravi Kumar Vategaonkar, Consultant Medical Oncologist, Pune, Dr. Nilesh Tiwari, Consultant Head and Neck Surgical Oncology, Bhopal, Dr. Prashant Chandra, Consultant Surgical Oncology, Pune, Dr. Mahesh Pawar, Consultant Surgical Oncologist, Pune, Dr. Aditi Saha, Consultant Head and Neck Surgical Oncology, Kolhapur, Dr. Bhushan Zade, Consultant Radiation Oncologist, Pune, Dr. Sarbani Ghosh Laskar, Consultant Radiation Oncologist, Mumbai, Dr. S. Nirni, Consultant Medical Oncologist, Hyderabad, Dr. Chirag Berud, Consultant Surgical Oncologist, Pune, Dr. Vidula Mistry, Consultant Head and Neck Surgical Oncology, Kolhapur, and Dr. Gaurav Jaiswal, Consultant Radiation Oncologist, Pune.
So very rarely in panel discussion you don't have a loss to follow up, and that's what happens. I anticipated that there will be 20-30% loss to follow up and the panelists will be less. But without wasting any time, there's a full-fledged panel, and let's start with pre-malignant lesions, and let me start from Vidula. Vidula, pre-malignant lesions in head and neck cancers, and let's put it in two ways. One, that patient has not developed head and neck cancer, okay, and he has developed pre-malignant. How much of an issue is this? And second, B, patient is a known case of, let's say, oral cavity who has got operated and keeps coming back with leukoplakias or erythroplakias. How much of a problem is that?
For pre-malignant lesion, first of all, we need to do a clinical examination, SOS biopsy, and re-stratification of the lesion. And based on the re-stratification and whatever histopathology diagnosis which we get, we need to consider the risk of malignant transformation in that region. And based on that, we need to see whether we need to, how do we need to treat it, whether we need to go aggressive on it or we can observe it. So if it is a high-risk lesion like proliferative verrucous leukoplakia or erythroleukoplakia, so we cannot observe it because there is a very high risk of malignant transformation, so we need to do a surgical excision for those regions.
Fantastic. Dr. Chirag, now how often do you come to a situation where you have repeatedly done either a surgical excision or the laser excision for this pre-malignant lesions and you say, no, I can't go beyond this, or a situation where there is the whole mouth has multiple pre-malignant lesions and you say that this is not a case for surgical intervention?
Yeah, we usually face such patients who are chronic tobacco chewers and smoking. They have multiple leukoplakic patch all over your oral cavity, and in these cases it becomes a problem because they have an increased risk of malignancy in the oral cavity.
Mahesh, how easy or difficult it is to do a good clinical examination and surgical excision of these patients, considering many of them have used tobacco and there's a good amount of submucosal fibrosis there?
Yeah, so SMF itself is one of the pre-malignant conditions, and most of them will have some kind of trismus. So it is really difficult to do surgeries in most of them. A good clinical examination is must for assessing the risk of it being malignant actually.
Correct.
So first we have to do a clinical assessment, and depending on whether it is a high risk or low risk lesion, we can decide to go ahead or not to go ahead with biopsy.
For the benefit of the audience, can you analyze what is the 2-3-4 rule in leukoplakia, which we would say is the high risk, these are the high risk leukoplekic lesions.
So a thicker looking, limited to, basically when we see a patient with a thick leukoplekic patch,
correct,
with slight change of say erythroleukoplakia, and on the high risk sites like lateral border of tongue or buccal mucosa, we generally say that it is a high risk lesion and high risk of harboring a malignancy.
Correct.
So a biopsy or a excision is to be done in those patients.
Correct. So any high risk lesion which you have, surgical excision remains the predominant treatment. Any kind of systemic intervention will come only when the repeated surgical interventions have failed, or it is unlikely to be excised surgically. What this paper from Dr. Hanan shows is the 2, 3, 4 rules. Well, there is a pre-cancer varicose leukoplakia which is multifocal, more than 2 sites, contiguous 3 cm or greater, or a single lesion which is 4 cm or greater with epithelial dysplasia, or a PBL with a 4-quadrant oral cavity involvement with at least one localized leukoplakia with moderate dysplasia, or a erythroleukoplakia for which surgery was indicated but either it is not feasible or not refused by the patients. Interestingly, for these patients, they were given nivolumab, 4 doses of nivolumab, 480 mg, given once in a month. And this is the kind of responses which we saw. And let me ask Ravi. Ravi, can you just have a look at the responses and tell me how good is the responses when the 4 doses of nivolumab were given in these patients?
So more than 50% patient they responded to nivolumab. That is actually very good response.
Correct. Correct. So if you see here, the major responses were seen nearly 9% of the patient. Partial responses were seen in nearly 27% of the patients. And majority of the patients, 88%, completed the treatment. Interestingly, the cancer-free survival at around 2 years was nearly 72.8%. 27% patients did develop cancers. And if you look at the images, see where you could see there was a nice reduction in leukoplakia which was seen. I found it's interesting, very limited time we talk about pre-malignant lesions in head and neck cancers, and it is not an uncommon problem. We see it quite often. And so I thought that we'll have the discussion for this. We'll start with this. Well, yes, Nilesh.
This is definitely intriguing,
Yeah.
using nivolumab without cancer. But for any systemic therapy in pre-malignant lesions, we need to look at long-term malignant transformation
Correct.
rates. So
Correct.
that
What
is
you're,
going
what
to be
you're,
the main.
what you're saying is correct, and that's
Basics
why,
of field cancerization,
correct,
they also.
correct, and that's the reason why this data, when it came in JAMA, it came with a 3-year CFS data. And if you could see in the table, they had a 3-year data. This is one of the most systematically kept data of systemic therapy, where we had data till 3 years that 66.2% was the cancer-free. Unfortunately, we don't have a parallel study which is so well documented for patients who did not undergo an intervention. What was the? Yeah. So let me come to the other medical, Dr. S.S. Nilni. How is he here? Okay, there is one loss to follow. Sorry. Oh. So 480 mg nivolumab, how easy it is to give?
Yeah, we have used nivolumab since almost 3 to 4, more than 4 years. It's a safe drug.
Correct.
Once in a, usually RCC we use once in a 2 weeks, or and it's basically safe drug.
Correct. So, we have used nivolumab in right, left and center. Even 480 mg dose 4 weekly is a very safe dose. Don't expect major complications in this patients. Now let me come to Sarbani ma'am. Sarbani ma'am, what would you say if you have to use this kind of intervention for the patient, whom, when, where and how? Would you say that when you are sitting in MDT, you would say, okay, this might be the patient you would want the poor medical oncologist to have. उन्होंने कभी pre-malignant देखे नहीं रहते, उनके पास भेज दो करके.
So the thing is, you're talking about a 480 milligram of
Correct,
nivolumab.
correct.
So that brings into a point the cost issue.
Correct.
That's one thing. And
Correct.
of course, you are going to give it only to those people who are not amenable to
Correct.
resection or
Correct.
who are not wanting any kind of
Correct.
resection. So it's essentially the dose, the frequency, and the cost because
Correct.
of the dose.
Correct. So perfectly said by ma'am that it will be the dose, the frequency and the cost which will be the matter. And here enters another study which came from MD Anderson, which actually gave intralesional nivolumab. And the dose they tested were 20 mg and 40 mg. So with a dose of 20 mg and 40 mg itself, they got responses in 50% of the patients. This data, as was rightly pointed out by my colleague Nilesh, that does not have long-term follow-up of 3 years. And what this has done is, this has actually entered a phase 2 with a plan to enter in a phase 3, even in the phase 2 also, it shows to be successful. With that, we'll stop here on pre-malignant lesions. Anyone has any questions on pre-malignant lesions? If no, we'll go to resectable head and neck cancers. And let me come to Dr. Prashant Chandra. Are you really satisfied with the kind of outcomes with the current treatment in locally advanced head and neck cancers? Whether it is surgery followed by radiation, surgery followed by CTRT or radical CTRT itself, are you really satisfied with the 5 years and 10 years outcomes which we are getting?
So at present, what we are doing is surgery followed by radiation, yes, but no, it's not satisfactory. I mean,
Correct.
India is sitting as the global king. We are the global king in oral cancers, and we don't have a good treatment for it. So I would like my medical oncology colleagues to come up with something new which can give us better survival, better recurrence rates, and I'll be glad if it comes in the coming future.
Okay. Yes, sir.
Because of the adjuvant pembrolizumab and nivolumab giving very good results, I think we can.
Correct. Correct.
We can.
I'll come to Bhushan. Bhushan is sitting quiet for a while. Bhushan, CTRT in adjuvant setting, we had dose escalations, we had fractionations, we had multiple agents we tried. In fact, this ESMO, I did not include that slide because it won't change treatment. We had a data of adjuvant presented by Dr. Iyer of nimotuzumab, cisplatin RT, which also failed to show improvement in outcomes in adjuvant setting. Why are we failing? Means we tried neoadjuvant, we tried CTRT, we tried adjuvant, but why are we failing in head and neck cancers?
See, over the years or over the decades, we have definitely improved, but the improvement is not that dramatic.
Correct.
Only disease-free survival, oral survival, we have improved on toxicity profile also with the newer drugs or newer radiation techniques or newer surgical techniques. But definitely there is a room for more, and probably we are looking at some molecules which are going to be there to address that. But definitely. It's an aggressive disease. The biology is probably different than the other systemic diseases.
And nothing but this RTOG 9401 highlights that. If you look at the 10-year overall survival, it's 27-29%. Even with RT or CTRT, if you look at the 10-year DFS is 19 and 20%, which means out of the 100 patients we treat, 80% of the disease is coming back in 10 years, and out of them, 70% are not even alive at 10 years. With this data, and let me come to Ravi again. Ravi, how do you see this data of Keynote? Sir also pointed out data of Keynote 689 coming, where Dr. Manish also described it in great detail, where addition of pembrolizumab neoadjuvant adjuvant setting led to a nearly 15% increment in EFS.
So actually this is very promising data. Only thing is, as Dr. Mangesh rightly pointed out, there is chances of pseudo-progression as well as proper progression of disease. So that has to be taken care.
What you are saying is correct, but let me point out in this Keynote 689, out of the 234 patients, there was not a single progression which was noted with pembrolizumab, at least in the study. Obviously in the real world setting, we would have different data coming up, but at least in the study, there was no progression which was noted.
Okay. So this is very promising data. Yeah. So probably from next.
Salvani ma'am, how do you look at this data?
I think it has a lot of promise, but we have to identify the right patient to give this, because it has different connotations for us. One thing is, what actually strikes me in this particular 689 is the fact that the compliance to standard of care is relatively lower than what we see even in routine practice. So that's something that is really that is really a little confusing as well as puts you on your toes. The other thing is, of course, the cost. You need to give everybody the neoadjuvant, the adjuvant, and then continue with the maintenance. So that's the other thing that's going to add to the cost. And the other thing is, though Nivo post-op has shown a gain in the loco-regional control, this trial is predominantly for overall survival, because the distant metastasis rates are much lower in 689. So we have to look at it a little closely before we just give it to everybody.
Agreed. This is... Yes, sir, please.
Another thing is this study, like most of our patients, they have a lot of lymph node involvement. So in this, whether the recurrence is less with the high nodal involvement, that detail is not there in this study.
Correct. So what?
Or if there is high nodal involvement, can we add like adjuvant chemotherapy plus pembro? Because in our hospital, if the nodes are positive, we are giving adjuvant TPF, even though it is not recommended, but
So
routinely we are
adjuvant
giving.
TPF trials were done and they have failed.
Yeah.
I think why we are excited with this is because this is probably the first time we are seeing 15% EFS advantage, though I had recent OS. But if you look at the OS, this was an interim analysis for OS. The OS was below 0.05, but the threshold which they wanted for OS to be set to be positive was 0.025, for which adequate number of events were not there. We will definitely get an OS data which may or may not be positive, but the way it seems right now, in next 3 years we might get an OS data positive for the trial also.
The other thing is, though Nivo post-op is positive for improved loco-regional control, if you look at the recent ESMO presentation of Keynote 717, which has added the Pembro to the concurrent chemoradiotherapy in the high risk and the intermediate risk, actually then you really don't know.
Correct. What you're saying is correct. Unfortunately, Pembro addition to CTRT, Pembro addition in the recent ESMO paper did not. Again telling us that probably each of them behave differently. Like for example, NEO and EP was tried in metastatic head and neck cancer in the first line setting, but they did not work. Pembro worked. So it may be not that they are not a replaceable drug. Coming to the very important point which Madam raised for compliance, in both those studies, the compliance with surgery, underwent surgery was 88 and 87.7%, and this I thought it would come up with a striking that nearly 13% of the patients never underwent surgery. But if you look at any clinical trial which was done in head and neck cancer, and what I put up is one of the famous trial by Dr. N. Gopal Iyer, which was the only trial which randomized operable patients to surgery versus CTRT and proved beyond doubt that in oral cancers and maxillary sinus surgery is the way to go. Even if you look at that chart, 10% patients did not underwent surgery. Now, there are multiple reasons when a clinical trial a patient may not opt for surgery, and as I pointed out, progression disease was not the aim. Now, let me come to Bhushan. Bhushan, with respect to Nivo post-op, how comfortable you are with inclusion of nivolumab with cisplatin and IMRT? Both. It had actually one dose before the CTRT started, few doses during the CTRT, and then a maintenance after that.
Standard design. See, in my practice, I haven't tried it yet, but as the data of a Nivo post-op shows, toxicity profile was higher, but for a select group of patient probably in our clinical practice, say higher nodal burden or the progression of or the history of the disease was like rapid. So in that case, probably in our practice we can think of adding this as well.
Yeah. Okay. So there is only a second left, and this was pointed out by Dr. Minit also, that for reasons which we are not understood well, Neo post-op has a loco-regional importance. Keynote has 6 and a distant. If I can request the organizers to give me 5 minutes more, this is only a 15-minute session, does not justify 12 panelists. My question here is, and let me run through how this would run. Let's take a case and just discuss it. Let's say this is a 54-year-old man, and he has a left oral tongue, T3N0M0, stage 3, and healthy, very good surgical candidate. Dr. Aditi, we had not asked a single question to you. What are you going to do this for this patient? See, ASCO assumes that if there is no tumor board, this will go for surgery. We say that there is a tumor board. What would you do for this patient with T3N0M0, C oral tongue?
Yeah, for this case, actually, I would rather take it upfront for surgery, because since it's T3 N0, and I would assume that if pathologically also it is N0, now we are keeping the chemotherapy as such for reserve, and adjoint only RT can be given. So I would still rather go for surgery first rather than directly considering him for perioperative immuno.
Any of the medical oncologists in the panel differ with her? Or you agree that this patient should undergo surgery T3 N0?
This patient is a fit patient and 55 year. I think better to go for surgery than followed by adjuvant treatment.
Fair enough. Tejpal sir, would you agree that this patient would go for surgery? correct. This patient should undergo surgery because you see, if it turns out to be actually T3N0, it allows you to keep the patient only on observation. If it goes on this arm, and if you are following keynote 689, this patient would require radiation and pembrolizumab also. Let's take another case. He's a 70-year-old male. Again, a right oral tongue, 2 centimeter, T3N0. This also will go for surgery. So let's take this case. And let me start with this time with Salmani ma'am. 42 male, CA buccal mucosa ma'am, CT4A, CN2, but operable. Would you send it for a pembro, or you would say no, this goes for surgery?
I would, if it's resectable with negative margins, I would still send it for surgery.
Okay. Aditi, what would you do?
So likewise, same. I would still go for upfront surgery.
Okay. Ravi?
With keynote data, probably patient is affording then.
You would probably go for it. Bhushan, what would you do?
Definitely surgery.
Okay, so there is a good divide with surgery or not surgery. Dr. Chirag Desai sir is saying this. Sir, what would you do for this patient which is CT4A, CN2, CA buccal mucosa?
As of now, till the last year, I would say I would have sent the patient for surgery. But this year, looking at the keynote data, I think I will be offering pembro to this patient.
Okay. So, CA larynx, yes, CA larynx, and let me start with Vidula here. CA larynx, CT4A, CN1. What would you do?
Sir, T4A, I want to see whether T4A is because of just exolaryngeal spread or cartilage involvement.
Take cartilage erosion.
Cartilage involvement, upfront surgeries.
Upfront surgery. You don't want to give this patient pembrolizumab?
Sir, we can.
PDL1, 95%.
So we can think
affording
of it.
Family niece staying in MSKCC doing medical oncology.
Sir, maybe I would prefer it in the adjuvant setting.
Okay. So, Nilesh, what would you do in your practice? CT4A, CN1 because of cartilage erosion.
So we can offer based on CPS, if it is 95%, we can offer because of promising results.
So let me come to one, and this was brought by Dr. Tejpal also, that CA hypopharynx, we always say that there is a more risk of getting distant metastasis. And this is one where neoadjuvant chemo, then decision making on response assessment is quite acceptable. If it's a CA hypopharynx with T3N3 or T3N1, how many of you, and let's have a raise of hands, would send the patient for pembrolizumab? CA hypopharynx, CT3N3. Okay, pretty good.
But on 689, you can't send it for pembro. But you can send it for systemic therapy, which is not pembro.
Okay, you want to send it for systemic therapy, but not pembro. We will combine pembro with chemo, ma'am. And with that, I will come to, we have these discussions which are going on where we are seeing responses. But there are a lot of phase 2s which have come, which have started combining immunotherapy with chemotherapy. And they are showing quite dramatic response. And I'm showing one of such good papers which came in Nature, which did show that every patient responded. And even the pathological response rates, major pathological response rate, if you could see that H curve is around 76.4%. And if you see the survival of these patients or anything, you could see this is unlike head and neck cancers, where most of the curve dip by 2 years or by 3 years. The curves are maintaining till 36 months. Why is this important? Because borderline and resectable head and neck cancers are very common in India. We may not get a randomized trial where we might see addition of immunotherapy to chemotherapy. It may take time for us to do that, and this is one situation where you actually throw the sink at the patient to get it operated. We had a question of, there's only 20 seconds left, so I won't go to the panelists. We had a question of cost. This is good data which came from CMC Vellore, which show that addition of low dose nivolumab in induction chemotherapy also does a good job in borderline resectable head and neck cancers. I think I have already overshooted the time. So unless there are any burning questions from the audience, we will take those. Sir, आप कुछ पूछ रहे थे? Sir, I can answer that with respect to the pembrolizumab study. I think that was a bad design. if we go back and look at the paper of pembrolizumab plus CTRT followed by adjuvant, that trial, I don't know why they wanted the P to be 0.025. That was the P which they decided. The P actually came 0.04. And that's the reason why the trial has been deemed as negative. Sir, I agree. Avelumab failed, durvalumab failed. Sir, but avelumab, durvalumab, even in metastatic setting, have not shown any. See, sir, I think we need to come out of this that every immunotherapy is the same.
No, but we also need to understand the molecular basis because of the induction of the TILs. So now with proton therapy and in the adjuvant setting, perhaps addition of concurrent chemoradiotherapy, because we also need to understand that in the melanoma setting, concurrent chemoradiotherapy works and chemoimmunotherapy with radiotherapy works. So there has to be some molecular basis to understand this.
I completely agree, ma'am. Immunotherapy and targeted therapy are two settings where the clinical results have come much faster, and like the molecular results have been coming delayed. But I think this is something very fantastic. For resectable head and neck cancers, we did not have something coming up. We need to go back to 2005 where cisplatin got added to radiation, getting a 15% EFS benefit, a trend toward overall survival benefit. In 20 years, for the first time, we have got something in head and neck cancer to cheer upon. With that, I'll stop here.
Vijay,
yeah.
here, Amish, here. What is the final panelist conclusion? I would like to know versus neoadjuvant pembro versus post-op nivo. What do the panel think? What are we ready for today?
Okay,
I would like to know the conclusion.
We'll start from that, sir. There will be no conclusion. Let me tell you that.
Sarbani will have conclusion, I'm sure.
We'll start from this side. So Sarbani ma'am ends it. We'll start from here. What would you send the patient for neo post-op or would you send the patient for pembrolizumab?
I would send for the pembrolizumab.
Pembrolizumab, good.
So neo post-op.
Neo post-op.
See, there are cost implications, so we have to be selective about this, and probably yes, new post-op seems.
Sir, both, because in neo post-op most of the patients were high risk. But I would like to add either low dose or standard dose immunotherapy to patient. Those surgeon refer us for neoadjuvant chemotherapy.
Okay.
So I'll decide based on subsite, especially bad disease like tongue, T3, T4. They are known to recur early. We'll definitely consider a new pembro.
Mahesh?
Locally advanced and organ preserving strategies, if we are planning, then pre-operative I will definitely go for.
Sir, exactly this is what I wanted to say. Locally advanced, high-risk features, organ preservation in my mind, neoadjuvant is preferable.
Yeah, pembrolizumab based chemotherapy.
I'll agree with Dr. Mahesh, I think. Locally advanced only.
Yeah. Aditi?
So the same, very selective patients for pembro pre-op, otherwise nivo post-op.
Ma'am?
I'd give my patient both options if he were to come to me pre-op, and that would be either doing it pre-operatively when he showed the examples, so then those patients have an option of going the pembro way. But if they came to me after surgery when I have the pathology in hand, I would give him or her the option of nivo post-op.
So Dr. Sarbani, if a patient accepts neoadjuvant pembro without chemotherapy, just last 10 seconds, sorry. You are okay giving IO alone and not IO plus chemo in a neoadjuvant setting? Because we can discuss about that a lot, but I just would like to know your conclusion, and then after that I'll close.
So IO, I would actually ask my medical oncology colleague to tell me the answer, because at least from the recurrent metastatic setting, we know that if you have 1% only, then you would have to give IO plus systemic therapy. But if you had a high CPS score, then you would give IO alone.
I think with that,
We can take that over dinner probably.
Thank you.
Thank you to our moderator and all our panelists. Up next, we have our Pfizer-sponsored session on recent advances in the management of relapsed and refractory multiple myeloma. Delivering this talk is Dr. Sandeep Shah, Senior Consultant Medical Oncologist and Hematologist, Ahmedabad. We look forward to his insights on evolving treatment strategies. Dr. Sandeep, before you proceed, may we request Dr. Arvind Krishnamurthy to kindly give us a single line concise take-home message from the panel, please. Thank you, Dr. Arvind. Dr. Sandeep, we request you to please start your talk.
Yeah, good evening, everybody. And we, first of all, thanks Pfizer and Dr. Tushar Patil for giving this opportunity. And we can see that immunotherapy, both in solid tumor and as well as in hematology, had made the subject again very interesting and exciting. And for people like us who are practicing for, I think, probably the last 5 years of our practice, again, there is a huge excitement because of immunotherapy in the field of hematology also. And today I will be discussing new bispecific in management of relapsed and refractory multiple myeloma, again a immunotherapy. This is the disclaimer. And I think this audience knows what is multiple myeloma. So it's a plasma cell disorder, and proliferation of plasma cell disorder, they get converted to malignant plasma cells and cause organ damage in the form of bone marrow, which is causing anemia, lytic lesion in the bone, and the deposition of M protein in the kidney, so causing renal dysfunction, and lytic bone lesion causing hypercalcemia. So this is the second most common hematological cancer in USA, and 1.8% of all cancer and 19% of hematological malignancies. And almost 36,000 new cases were found in 2024 of multiple myeloma. Globally also the annual incidence is 1.78 per 1 lakh people, and the annual mortality in 2020 was 1.14 per lakh people. And we also have Indian data also. The overall incidences in India is roughly 1 to 1.27 per 1 lakh population, and proportion of cancer, if we see, almost 1 to 1.2% of all cancers are myeloma and 17% of all the blood cancers. Males are more common, and the age incidence again in India also, the 75% of the patients are in the more than 55 years of age. And the incidence is highest in southern and northern zones, and surprisingly it is lowest in northeast India. And stable rates from 1990 to 2006, but the incidence is rising in some areas after 2006. So what is the etiology? We don't know the etiology exactly, but the old age, some racial variation, radiation exposure to pesticides, and some genetic variations. So we don't know the exact etiology, but these are the proposed cause for the myeloma. And if you see myeloma genesis, the plasma cells are converted to clonal plasma cells, and then we have MGUS followed by smoldering myeloma, and then the plasma cells are actually, the clonal cells are converted to malignant plasma cells, and we get multiple myeloma, and then ultimately end organ damage, and finally they can cause extramedullary disease or plasma cell leukemia. So we already discussed this, that proliferation of plasma cell causes the CRAF features by doing end organ damage. And coming to the biomarkers, biomarkers are important for diagnosis, risk stratification, individualizing the treatment, and for doing MRD. So we had initially cytogenetics followed by FISH when we could do the translocation, then we have gene expression profiling, and now we have NGS. So new generation flow and NGS are important for doing the MRD, and that is very important for deciding the endpoint of so many clinical trials also. So treatment of myeloma started, you all know the single agent melphalan plus prednisolone was the standard of care for so many years, followed by VAD therapy or CVAMP. We have given 4 days of CVAMP or VAD therapy for so many patients, and we had taken them for autologous stem cell transplantation. And then we had proteasome inhibitors in the form of bortezomib and then thalidomide and lenalidomide. That changed the treatment landscape of myeloma. Then we had monoclonal antibodies like daratumumab, and now when all these lines fails, we have bispecific antibodies in form of immunotherapy. So the treatment is decided by patient-related factors and disease-related factors for the first line of therapy. So patient with myeloma should receive individualized treatment options based on patient and disease-related factors, and those factors are whether patient is fit or fragile and patient is for transplant eligible or not eligible. So disease-related factor, whether patient is having a high-risk cytogenetics or what is the tumor burden, whether patient is having plasma cell leukemia, and when patient relapses, then the treatment history is very important. What previous therapy patient has used it and what group of drugs he has received previously. On that basis, the further line of treatment is decided. So myeloma treatment paradigm is, first of all, we decide whether patient is transplant eligible or ineligible, and then we give induction therapy, then consolidation therapy, followed by maintenance therapy. So if patient is transplant eligible, then 3 to 6 cycles of either triplet or quadruplet is given, followed by stem cell collection and stem cell transplantation, and we give maintenance therapy till progression, and mainly lenalidomide is used. If patient is not transplant eligible, then 3 to 6 cycles of induction therapy, and followed by same therapy, patient has responded well for almost 1 year, and then the same drug is given as a maintenance therapy. So for the frontline multiple myeloma today, we are not going to discuss the frontline therapy. There are multiple options which are shown here. Usually triplet of lenalidomide bortezomib and dexamethasone, which is the standard most. But now if patient can afford and patient is high risk, then quadruplet by adding daratumumab is the standard of care for the first line therapy. And if patient fails on first line therapy after transplantation, then the second line therapy is decided whether patient is lenalidomide sensitive or lenalidomide refractory, whether patient is bortezomib sensitive or bortezomib refractory. And finally, if patient progresses on this therapy, then the bispecific antibodies or CAR-T therapy are used for the therapy. So today we will discuss B-cell maturing agent, that is BCMA and elranatamab. I had practiced so hard for pronouncing this elranatamab. So BCMA is all know that it is present on the myeloma cell, and it is the best target if you want to kill the plasma cells, malignant plasma cells. And today we are having three class of these drugs, anti-BCMA drugs: antibody drug conjugate, that is ADC, which is belantamab mafodotin, which is marketed by GSK. Then cellular therapies, that is CAR-T therapy. There are two CAR-T which are approved for multiple myeloma, which we'll see later. And bispecific antibody constructs, that is this elranatamab, teclistamab, and talquetamab. So these are three bispecific antibodies which are approved for multiple myeloma after failure of 3 lines of therapy. So elranatamab is a BCMA CD3 bispecific antibody, and that induces myeloma cell death. It has two arms, one is BCMA and one is CD3. And it's a immunized bispecific BCMA CD3 antibody which bridges T cells and BCMA expressing myeloma cells, enabling T cell mediated lysis of engaged multiple myeloma cells. BCMA expressing myeloma cells, they in a directed release of perforin and granzyme B and subsequent MHC independent cytolysis of multiple myeloma cells. Elranatamab mediated activation of T cells has been shown to result in the release of cytokines including interferon gamma, IL-2, IL-6, IL-10, and that is why we get CRS or cytokine release syndrome. So this is the structure of elranatamab, and you can see it has two arms, and it has a more affinity for BCMA than CD3. So it favors BCMA over the CD3. So elranatamab may have less likely to activate T cell in the absence of myeloma cells, and that's why decrease in the likelihood of T cell exhaustion and off-target effects. So because of this bias affinity for BCMA over CD3 and its modified Fc region, it may decrease the likelihood of immunogenicity and immune-related toxicity. That way it is slightly different than teclistamab. So this was the trial Magnetis MM3 on which this drug got approval in August 2025 for the multiple myeloma relapse refractory patients after 3 lines of therapy. So the key inclusion criteria were refractory to more than one of the following: PI, IMID, and anti-CD338 antibody. Performance status less than 2, clear and clear. All others are standard factors. And there were 2 cohorts. One is no prior BCMA directed treatment, and second was prior BCMA directed ADC or CAR T cell therapy. And the drug was given as 76 milligram sub-Q weekly on a 28-day cycle. And the primary endpoint was overall response rate by BICR. So this was a phase 2 Magnetis MM3 trial, and we will see the results. So patients were heavily pretreated with a median of 5 prior lines of therapy. 96.7% had triple class refractory disease and 42.3% had penta-drug refractory disease. So here the patients were highly refractory, and almost 76% were 5-drug refractory patients. And high proportion of patients had more than one poor prognostic features at baseline, including ISS stage 3 disease, high-risk cytogenetics, or extramedullary disease. So even all the high-risk patients were also included in this trial. And you can see the duration of treatment, but the median duration of treatment was 5.6 months, and the median duration of treatment for more than 6 months was in 48% of patients, and in more than 12 months of duration of treatment, it was in 34.8% of patients. So the primary endpoint was overall response rate, and it was 61%. More than CR was achieved in 35% of patients, and VGPR was achieved in 56.1% of patients, and 7.3% responders remained on treatment and had not achieved complete negative. Even MRD negative was achieved in almost 90% of patients, those who achieved more than complete remission. So same thing is shown here, and here it is shown that in high-risk patients, that is with extramedullary disease, RISS stage 3 and 4, and patient with penta-refractory disease, the response was low compared to the generalized response rate in other patients. So in high-risk patient, the response rate was almost 50%, so around 30 to 40% of patients had overall response rate. So same thing is shown here, that those patients who had a complete response rate, the duration of response was longer compared to the overall response patients. You can see the two graphs, and the patient who had achieved CR had a longer duration of response. So same thing again shown is here, that in high-risk patients, so the response rate was inferior compared to the patients, those who are not having the high-risk features. So this is the summary of this magnetis multiple myeloma 3 patient, that overall response rate is 61%, MRD negativity was in 90% of patients, those who achieved CR. Median progression-free survival was 17.2 months, which is very high compared to teclistamab, which we will see later on. And median duration of response is again around 24 months. And median overall survival at 24 for 6 months was also high. So the safety profile, the commonest side effect were infections. Patient had CRS and ICANS, but no patient had grade 3 or 4 CRS or ICANS, while infections, almost 6.5% had died because of the infection, and almost 40% patient had grade 3 or 4 rate of infection. So infection is the major complication of all the bispecific antibodies. So magnetis MM3 is a phase 2 registration trial of elranatamab monotherapy, enrolled heavily pretreated patients with relapsed refractory multiple myeloma, and monotherapy, with response to this monotherapy were rapid, deep and durable among a diverse population reflective of real world patients with relapsed refractory myeloma with a median, and then there is a flat dose of 76 milligram sub-Q every weekly, and after 24 weeks if patient is responding, then the drug is given every 2 weekly. And every 4 weekly is still investigational, not used in practice. So same thing is shown here. So these are the two trials for teclistamab is Majestic 1 and magnetis MM3 for elranatamab, and the difference is the median progression-free survival, which is 17.6 months compared to 11 months for in Majestic 1 for teclistamab. And there were more high-risk patients and more penta-refractory patients in magnetis MM trial. So median progression-free survival is 11.3 months in teclistamab, and in this elranatamab it is 17.2 months, and overall survival is 22 months, while elranatamab it is 24.6 months. So in this MAC also, it was shown that there is a slight superiority because of the long duration of progression-free survival. And today we are having this four options, teclistamab, elranatamab, and there are 2 CAR-T therapy which are approved for multiple myeloma therapy, ID cell and CETA cell. And you can see the CETA cell, the overall response rate is 97% and median duration of response is 22 months and median progression-free survival is 27 months. So out of 4, this is the best therapy. So the problem is how to sequence this.
Dr. Sandeep, apologies, but we would have to
Yeah,
wrap
so
up the session.
last minute. So those patients who are stable, we can directly go for CAR-T therapy, and then when they relapse on CAR-T therapy, we should switch to bispecific antibody. Those patients we are not stable, which are not stable, we should start with bispecific antibody because they will respond far. It on the shelf available immediately. No time is required to develop CAR-T cells. So bispecific antibodies should be used in those patients who are unstable, and once they respond, you can change over to CAR-T cell therapy. So that's how the sequencing should be done. Those patients who are stable, start with CAR-T therapy, and if they are not stable, with bispecific antibody. And if bispecific antibody to BSMA fail, then we can use talquetamab. Thank you for the patient hearing.
Thank you, Dr. Sandeep. We now move on to a sponsored session by AstraZeneca titled Paradigm Shift in the Management of Non-Muscle Invasive Bladder Cancer. I would request our speaker, Dr. Ashwin Tamankar, Consultant Urologic Oncology and Robotic Surgeon, Pune, to walk us through the latest developments in transforming care in non-muscle invasive bladder cancer. Over to you, sir.
Good evening all. Probably only surgeon left in the crowd amongst the medical oncologists. So that topic is non-muscle invasive bladder cancer. But I'm sure everyone is now pushing their boundaries and getting into the phase of non-muscle invasive disease as well. So I'll probably go through about 20-30 slides and give us some information about NMIBC and the role of durvalumab, which is coming up in a big way now. And all of us know the premise of this is also that Niagara trial gave us positive results in terms of utilization of durvalumab along with gemcitabine cisplatin in a neoadjuvant setting for muscle invasive disease, and now we are extrapolating and getting some good outcomes in non-muscle invasive diseases as well. So the premise, I'm going to skip through these slides because these are universal slides. 5-year survival is, bladder is a very aggressive disease in urological oncology and 13th most cause of cancer death. So what we know in NMIBC is about 75% are primary NMIBCs, and out of those 45% are high-risk diseases. The definitions of high-risk diseases are, all of us know, essentially either a T1 disease or a high-grade disease or a carcinoma in situ or a recurrent disease and a largish more than 3 centimeter. A little bit of variation in EAU and AUA definition, but more or less T1 high-grade CIS are combinations. And these are potentially treatable and curable diseases because we don't talk about survival at this point of time. They are non-metastatic, so they are we don't talk about survival as an overall survival to a large extent. What we talk about disease-free survival. So we are trying to minimize the disease progression and outcomes of these patients to go to muscle invasive diseases, and there we start talking about survival of the patient. So 50 to 70% chances of recurrences and significant chances of progression, 20 to 30%. That's how the overall algorithm is, TRBT, and then we do another TRBT for these patients because we tend to miss out nearly 20% muscle invasive diseases, and then the subsequent therapy starts. So the whole gamut of immunotherapy, actually the credit of immunotherapy actually goes to BCG, because all of us know, if you have heard talk from Dr. Ashish Kamath, he keeps saying this originally that only immunotherapy tested in bladder so far is BCG, and that's the gold standard. Of course, that's something which is age old. We're using it. A lot of good outcomes for these patients and variable debates about dose, toxicities going on and off, but that stands as the benchmark for non-muscle invasive diseases for post-operative care to minimize this, to minimize the chances of both recurrence as well as the progression. And we are concerned about the progression to the most adequate or to the maximal extent. Now, in spite of these, still patients will recur. I'm going to go to the important bits. Concerns with BCG, of course, little bit of cystitis. Every patient will eventually has to discontinue BCG for some or the other reasons. A lot of local toxicity described. The dose have been also modified these days. And some patients will end up into systemic complications also. So these up to 40% patients of NMIBC will fail the intravesical BCG and there will be recurrence. And these recurrence essentially will be MIBC, and rarely we get metastatic diseases as well, very rare occurrence, but that happens. And then we have descriptions of 3 kinds of BCG related problems in terms of cancer related outcomes. One is BCG refractory disease, second is BCG relapse, and third is BCG unresponsive. So essentially the definitions are a little bit different with respect to the timelines, but let's understand any high risk disease coming back within 3 to 6 months is going to be refractory disease. Either it is a T1 disease or a carcinoma in situ. There is a concept of BCG reinduction if you have early disease at 3 months, but again that will also have been classified into, as when the disease comes back again after that, we call it progression. Age-old concept of non-muscle invasive disease with BCG failure is of course cystectomy. Still there was a little bit of role of, so now the bracket of BCG naive diseases and post-BCG recurrence diseases were explored, and that window was explored with some immunotherapy agents. So all of us know that pembrolizumab came up in a way where I'm going to come to that slide first and then come to the discussion on BCG naive setting. So BCG unresponsive diseases, we had about 2-3 trials, out of which pembrolizumab gave us good response, and it was approved in FDA in June 22. So, and the outcomes were quite optimal. So, but the inclusion criteria were those patients who were not keen or willing or unfit for cystectomy. There you have a good chance of disease-free survival, and the therapy was continued for about 2 years, 24 months. Now that window has been explored with BCG naive setting, and that's the spectrum which we are discussing today. So we have about 2-3 trials which are exploring this. One is durvalumab, which is published recently. It's a 2025 publication. Durvalumab with BCG. Some trial or the concept of BCG and atezolizumab is also tried. And sasanlimab with BCG is also been considered in the trial called CREST. So out of which we'll discuss 1 or 2 trials in details. This was about the pembrolizumab thing. I'm going to skip this for the want of time. We know that this was a positive outcome in terms of disease-free survival, and the inference was utilize pembrolizumab for patients who are unresponsive. They are not BCG naive, they are unresponsive to BCG, and then continue that for about 2 years. You will have a fair response on disease-free survivals. Good amount of patients tolerating the therapy, about 40%, and median duration of complete response was about 16 months as well. So fairly good response, and hence the FDA approved that trial based on the 2-year data on the study. Now coming to the core discussion about the ProtoMax study. So it was a randomized open label phase 3 study wherein inclusion criteria was BCG naive patients, NMIBCs, and high risk tumors defined with either T1 or G3 or carcinoma in situ and multiple and recurrent diseases. Those were randomized into 3 arms. One was durvalumab plus BCG, induction plus maintenance. Induction will be 6 doses and maintenance will be based on the schedule. 3 doses at 3 months, 6 months, 12, 18 and 24 months. So up to 2 years of BCG maintenance. That was compared with durvalumab with BCG induction only. Probably hypothesis behind this was if we add something to intensify the treatment, we can potentially try and see whether we can minimize the subsequent BCG, thereby minimizing the toxicity. That might be the hypothesis. That's the second arm. And the third arm was standard of care, which was BCG induction plus maintenance, going up to 2 years with 6 doses of induction and 3 doses based on the schedule up to 24 months. Primary endpoints, disease-free survival between the first and the third arm, and secondary endpoints were comparisons between only induction and standard of care and disease-free survival at 24 months. They extrapolated secondary outcomes of survival at 5 years, but as I said, this is a non-muscle invasive disease. So we are more keen on knowing disease-free survival rather than the overall survival outcomes at this point of time. So the nearly 330 patients, 339, 340 patients randomized on all 3 arms, totally about 1350 patients, out of which they randomized nearly more 1000 patients, and nearly 270, 260 patients are ongoing with the inclusion and exclusion criteria. That's the case mix. Important is to know all 3 arms were quite balanced. Age was about 68, predominantly male gender because that's a more commoner gender for having a bladder cancer. Western Europe and the rest of the world were about 40-50%. good performance status patients. Current or former smokers were significant in number, about 60-70%. And T1 was about 60%, and carcinoma in situ primarily only was about 37. That is an important thing to know, because we tend to underestimate carcinoma in situ in Indian settings. In fact, unfortunately, even the pathologists do not pick up those carcinoma in situs that commonly, but if you go to TMH data, the good pathologists will always say that carcinoma in situ is unfortunately not been picked up so well, but that's something which is also included in this trial, because we know that it's a bad disease to have. And high-risk papillary diseases were about 50%. So high-risk diseases basically. They also checked in the background about PD-L1 expression, whether it was high or low, and high was about 1/4 of the patient, 24-27% patients. Now the actual treatment, the BCG treatment compliance was fairly good. So nearly in induction, all patients majoritarily received 6 cycles. In the maintenance, an average of about 14 cycles were received. That goes up to 82 weeks of treatment with BCG. So fair number of patients going beyond the 1 year of therapy on the BCG without much of toxicity, and nearly 14 maintenance cycles received on both sides in the maintenance, first and the third arm. Now the comparison between two, the disease-free survival was showing good separation of curves initially as a rapid response within even 4 to 5 months, and that separation stayed constant for a longer follow-up up to 68-69 months, so approximately 5-year follow-up. And then the hazard ratio, of course, stood at 0.68, which told us that disease-free survival endpoint as the primary product is giving us benefit by adding durvalumab to induction and maintenance schedule of BCG against to only BCG, which was the standard of care comparison. This actually translated into 32% reduction in the disease-free survival rates in favor of durvalumab arm. Now a subgroup analysis based on various parameters. If you see, forest plot is majoritarily in favor of parameters towards the durvalumab side, including the older age or the younger age, male gender. Surprisingly, female gender didn't show a lot of results, but probably the numbers were lesser, 20% females only. Probably that might be a biasing factor. Then the performance status. So in smoking, current active smoking was far superior in benefit of durvalumab. So probably if you want to choose a candidate, we can take some points out of this who can afford that treatment. BCG strain, it was up to the discretion of the local. There were about 18 to 20 centers which were accruing the patient. So up to the availability of BCG strain, there was a lot of debate on BCG availability in the COVID times. Luckily in India, we are blessed to have adequacy of BCG, but in the West, BCG availability is a huge concern, especially in US as well. So there is a role of addition of these, and then the predominant strain which was used was BCG TICE, with about 20-25%. Remaining 75% had mixed match of various strains based on the availability. Even the carcinoma in situ was in favor, and high PD-L1 exposure was in favor. So predominant parameters were in favor. If I can summarize, high PD-L1 was better, carcinoma in situ was better, high risk category was better, active smoker was better. So these were the predominant important parameters. Now the overall survival, almost comparable, but of course definitely it was not inferior. So basically what they said was at up to 5 years survival stood at the similar points without much of a difference. The adding of the next question which comes into mind is, are we killing into quality of life domain by adding these two therapies together? So not really, because there was no major impact on the patient related quality of life parameters. The disease free survival, the difference, now the second comparison between the second arm and the third arm, basically only induction with durvalumab, induction BCG with durvalumab versus BCG induction plus maintenance. So that difference did not stood significance for disease-free survival. Essentially, it means BCG has to be the baseline benchmark for this treatment, and addition of durvalumab over and above that gives disease-free survival. So BCG maintenance preferably should be given along with this as well. So it's a combination of therapy, sort of intensivization of treatment, what we do for now every cancer at this point of time. This is the summary of tolerability and the toxicity. No major, as in if you see serious adverse events which they have reported, which might be possibly related to any treatment, was about 13%, the 11% and 4% in 3 arms. out of which some will be of course because of BCG, but of course we will be able to make it out. BCG is predominantly going to throw local symptoms and rarely systemic symptoms, and durvalumab will essentially have all those side effects related to the standard immunotherapy, but luckily no major untoward consequences, no leading cause of death because of any therapy. That's something which is fairly acceptable. These were the side effects which were matched on both sides between the durvalumab arm, durvalumab BCG arm, and only the BCG arm. And if you see the typical side effects of hypothyroidism, fatigue, diarrhea, rash, these were predominantly more commoner on the durvalumab side. Of course, that's natural because BCG won't give those side effects, but more or less side effect profile was balanced, and it wasn't very much to consider durvalumab as a negative threat for this. Now, CREST study, there are another 2 studies which are currently giving some positive vibe on this. So, sasalimumab, which is another PD-1 receptor inhibitor, which is added with BCG again. Similar composition, BCG induction and maintenance, one arm, second arm is induction, and third arm is BCG induction and maintenance. And some good amount of data coming through. I think the data will mature further, but at this point of time we have about good improvement in the disease-free survival with a hazard ratio of about 0.68 and 0.53. The difference between two, that's the hazard ratio. Somehow the hazard ratio is quite significant. The only difference lies is sasalimumab went on up to 25 cycles, so roughly about 2 years, against to the durvalumab, which was only for a year, 13 cycles. So probably a shorter therapy giving almost optimal results. So that's a difference. But of course, the data for both trials should mature more for us to have differentiation. And another study called ALBAN, which use atezolizumab, and that somehow at this point of time has not shown a lot of significant results. But again, these data are relatively yet to mature to a very large extent, though the first the trial, durvalumab trial, has given us 5 years of data at this point of time. So conclusions, durvalumab in combination with BCG resulted in statistically significant and clinically meaningful improvement in disease-free survival for BCG versus BCG induction and maintenance arm for BCG naive high-risk patients at median of 5 years. Significant 32% reduction in the disease-free survival events, and early, which happens as early as 4 months, and sustained DFS benefit up to 5 years of horizon. And after a median follow-up of more than 5 years, OS stood nearly similar, so there was no diminishment by any means on the OS front. And durvalumab has fair tolerability and manageable safety profile, and was consistent with the known safety profiles of the individual agent. So this trial particularly supports 1 year of durvalumab in combination with BCG and induction and maintenance as a potential new treatment for patients with BCG naive high risk NMIBC. And I would conclude here. Happy for any questions, or if I think one quick thing, a lot of medical oncologists around, just sort of trivia sort of thing. We all of us know these durvalumab trials have typically different kind of name. So I was just trying to Google through why these names are typically given. So Niagara, Potomac. So for the benefit of everyone, Potomac is again a river which runs through close to Washington DC. Niagara is a water body. Danube is a trial, all of us, it's in bladder. So we have 3 trials in bladder cancer where they have non-resectable bladder cancers. They have combined durvalumab with something, I think tremelimumab for the results. And I think there are 2 trials in lung cancer, I think Caspian Adriatic. I'm not a lung cancer person, of course, but Caspian and Adriatic, I guess. So all 5 are water bodies, and that's something which I think durvalumab people want to the best capacity for naming their trials. So with this I will conclude. Thank you so much for the opportunity.
Thank you, Dr. Ashwin. We now move to the academic session 13 on lung cancer. I invite our session director, Dr. Chirag Desai, session coordinator, Dr. Mangesh Mekha, senior consultant medical oncologist, Pune, and our chairpersons, Dr. Smita Gupte, consultant medical oncology, Nagpur, Dr. Brij Mohan Zanwar, senior surgical oncologist, Latur, and Dr. Chandrasekhar Tamane, senior radiation oncologist, Chhatrapati Sambhaji Nagar. Our first talk sets the foundation for the entire session to help us navigate the state of art in both limited stage and extensive stage SCLC. May I invite Dr. Preetam Karaskar, medical oncologist, Mumbai.
Hi, good evening all. I have been asked to speak on the past and the present state of limited stage and extensive stage small cell lung cancer. And happy to present something generated by an AI just in few seconds. So, small cell challenges, as we all know, these are the most difficult cancers any oncologist would like to treat. Very good responses, but they all are short-lived. You name it a limited stage and extensive stage. Very, very limited period of responses. The presentation which we all of us see, I think 80 to 90% of the patients which we see are extensive stage. Numbers say 70, but in our practices, I would say most of us see 90% of the patients are extensive. And without treatment, the extensive stage hardly survive beyond 4 months. On the past, not much data, the survival was very poor, then came the era of cyclophosphamide, then radiation, and then came EP. That was a breakthrough and it actually gave a median OS of around 12 to 14 months. This has been the evolution of limited stage from sequential radiations to concurrent, and presently we are trying to add immunotherapy to the concurrent RT. Since 2000 to 2015, not much things moved. All of us were treating with concurrent CT-RT, and for extensive stage it was always and always EP. Then came the era of immunotherapy, IMpower 132, CAPSIAN study, the Adriatic study for limited stage small cell lung cancer. So from past to present, this has been the change in the median OS, the 5-year OS in limited stage and the extensive stages. This is something which is changing and will probably shape how we treat extensive stage small cell lung cancer. 3 important studies, IMpower, CASPIAN and the Astrium 005, serpilumab, durvalumab and atezolizumab. Cross trial comparisons, a median OS of around 15.8 months, 13 months approx in both atezo and durvalumab, and PFS of around 5.5 months each. Overall responses 68 to 60%, which we usually see on even with EP, but the median OS is something which we miss only on immunotherapy. So yes, there is approximately 5-month plus addition of OS to these regimes. So if I conclude, presently the standard of care in 2025 as we stand is concurrent. We give cisplatin etoposide plus immunotherapy durvalumab as a good data, followed by PCI. In extensive stage again, etoposide, platinum plus immunotherapy. We have 3 to 4 immunotherapy drugs in this line, and the expected median OS is around 13 to 14 months. Thank you. Thank you all for your patient listening.
Thank you, Dr. Preetham. Up next, we have a recorded session from Dr. Kripashankar, which we would be playing up later. We move on to the panel discussion. This session is supported by AstraZeneca. I request our moderator, Dr. Amish Vora, Consultant Medical Oncologist, New Delhi, to please conduct the panel. I also invite our panelists, Dr. Sonal Dande, Consultant Medical Oncologist and Hemato-Oncologist, Nashik, Dr. Aditya Dhanwad, Consultant Medical Oncologist, Navi Mumbai, Dr. Anil Tibdewal, Consultant Radiation Oncologist, Mumbai, Dr. Swapnil Kulkarni, Consultant Pulmonologist, Pune, Dr. Rahul Dhake, Senior Consultant Histopathology, Pune, Dr. Sanket Bankar, Consultant Surgical Oncologist, Pune, Dr. Arvind Krishnamurthy, Consultant Surgical Oncologist, Chennai, Dr. Shailendra Savle, Consultant Radiologist, Pune, Dr. Amol Dongre, Consultant Medical Oncology, Nagpur, and Dr. Jay Mehta, Consultant Oncopathologist, Mumbai.
1, 2, 3, 4, 5, 6, 7, 8. We have 8 people and there are 10 names. Who are missing? Dr. Sonal? अमोल वो रहा यार भावेश भाई आउ कराओ छो anyway I think अच्छा the radiation oncologist is not there okay and one more person Dr. Sonal is there, Dr. Aditya is there, Dr. Swapnil is there, Dr. Rahul is there, Dr. Sanket, surgical oncologist is not there. Okay, perfect. I congratulate MOC for achieving a lot of things, including this conference. So we have 10 panelists and I see I have 19 minutes. So we'll start with surgical oncologist, Dr. Arvind. Dr. Arvind, limited stage small cell. Pathologic lymph node staging is must, compulsory. I know we all see very small amount of T1, T2, N0 where the surgeon role is required. But do you see and do you do the pathologic staging compulsory and what are the methods which you use?
Yeah, I think even the guidelines also, present day guidelines also say surgery is there in the stages 1 and 2, especially in the N0, your survival rates are good. And of course, as in any cancer, even in the non-small cells, so mediastinal staging is important from every perspective, from the treatment perspective also and the prognostic perspective as well. So initially, of course, we start with the EBUS.
You start with EBUS first.
Yeah,
okay.
The EBUS. Of course, after assuming that you've done the PET CT scan for staging and the MRI brain. So I'm just assuming that because that's almost
assuming
standard.
That is done, and then EBUS followed by
EBUS and subsequently, if it's EBUS negative, supposing you're taking up the patient for surgery. In that case, like you will do a mediastinal. Of course, there is a subset of patients who have a peripheral lesion less than 3 centimeters and all, in which you may not do EBUS. A PET alone would suffice. But as you already said, those numbers are very, very limited.
Yes.
For the vast majority of the patient, mediastinal staging in the form of EBUS. The guidelines say that if EBUS is negative and if you are taking up for surgical approach, pre-surgical, do a mediastinoscopy.
Right.
But then I guess nowadays people are getting better with EBUS. So the false negative rates and all those things are
right.
Are
so Dr. Swapnil is a pulmonologist here. Yeah. Dr. Swapnil, Dr. Arvind is praising pulmonologists a lot that EBUS yield nodes very well. Right. What percentage of patients where you feel that this EBUS is not sufficient?
Not sufficient.
Yes, yield is not. What percentage?
So it all depends on the size of the lymph node. I feel if the size is more than 1 centimeter, the yield is good.
Then yield is good. Yes. Okay, excellent. We have radiologist Dr. Shailendra. Dr. Shailendra, all the principles of imaging and everything is written, but PET CT sort of thing is nowadays everybody does. And there was a lot of hue about AI started reporting. So what would you say? What is the role of AI, especially in small cell lung cancer?
Basically, everybody says AI will replace radiology or.
No, I have not said that.
I'm saying, but basically, I think it will complement the radiology.
It will complement.
It will reduce the workload.
Have you started using AI in any form?
Definitely. We are actually having our team of engineers. We are developing many protocols.
Okay.
And we are trying to incorporate in our studies also. For example, segmentation of the organs, stomach, liver. It will just workflow will be very easy. The minor things which are tedious, like measuring the SUVs, measuring the sizes. Definitely
right. And between PET CT or MR versus PET MRI, we are talking of small cell today. Which one you feel is the best amongst the three imaging?
So basically 90% majority part is PET CT is enough.
Contrast PET CT is enough.
PET CT is enough. But when we are looking for the vascular invasions and those things, sometimes MRI is helpful. But what we do in our setup, we do PET CT. In questionable cases, we'll do the MRI. And PET MR combination machine is costly, but if you do the retrospective fusion, what we do regularly, it will give a better idea and you get a precise staging.
So, if I understand correctly, PET CT is good enough unless until you have any issue about the image. Perfect, fair. First is Dr. Jay Mehta and then Amol. How many oncologists send you NGS for small cell?
Not many, very seldom.
Zero?
No, sometimes you do get it because they feel perceive there's a second component in it, and sometimes you
No,
end up.
I'm not talking of adeno going into small cell. I'm talking
that's
of
at
de novo
relapse,
small cell.
Yeah, no, I mean, very rarely, yeah.
Very rare. When did you last get NGS in small cell? Amol, how many times do you send?
Well, sir, not a single time. Maybe, we'll send for IHC, get it reconfirmed that this is small cell, and that's it. I mean, I'm sure lot many oncologists sitting here, and none of them are sending at least for the limited stage and as well as for the extended stage NGS.
Okay, Dr. Aditya and Dr. Sonal. Dr. Aditya, assuming very small piece, and our radiologist says that Dr. Shailendra says, I'm not very convinced it can be, sort of large lesion but small biopsy. Would you like to send NGS not to miss any molecular alterations?
Sir, if my IHC is confirmatory, I would not like to
Then
send.
you would not send. Okay. So I think fair enough, none of us send NGS in upfront. De novo small cell. Perfect. Right. So, we don't have radiation oncologists, but I would ask Dr. Sonal. Dr. Sonal, Dr. Krishnamurthy said that I can't operate. Node is positive. Now it is for limited stage small cell lung cancer. Concurrent immuno with CTRT, or would you give immuno after CTRT?
After CTRT.
After CTRT. Why? Why would you do that? You are right. But we have LU005 study, which is just reported in 2025. They had used immuno along with CTRT. In head and neck, we have immuno along with CTRT. In bladder, we have immuno along with CTRT. In cervix, we have immuno along with CTRT.
In a limited stage, I will still use CTRT followed by as a maintenance.
Followed by this thing. Okay. Any of the, Dr. Aditya, Dr. Amol, any other difference of opinion? Or you would follow the same what Dr. Sonal has said?
So, LU005 was negative, sir. And I would...
Absolutely. So that is what I wanted to say, that since we are talking of what has changed, the timing of immunotherapy is very important, and this particular trial had said that you should give immunotherapy minimum 6 weeks after completion of CTRT. And the Adriatic study was the one which showed the benefit of that. And LU005, as you rightly said, Dr. Aditya, it was a negative study, and that's why you should not start. It is that, and that is what we saw here, that durvalumab to be started only after CTRT is there. Okay. Role of PCI, anyone? Amol, do you send regularly? Patient has done very well prophylactic cranial irradiation in limited stage?
Yes, sir. For sure, sir.
You send. And for sure, when you said, do you have category 1 recommendation, 2A, 2B, 3?
Traditionally, we have been known that PCI is indicating only 2 indications. One is ALL and other is SCLC. So irrespective of brain metastasis, we do PCI.
Right. Okay. Aditya, it is a personal choice. I don't think we have a category 1 recommendation. Aditya, what do you do?
So MRI surveillance is an option.
MRI surveillance is an.
But having said that, the patient profile that we cater to, whether his ability to come every 3 months for follow-up, do an MRI every time, that is a challenge.
Absolutely.
So
Okay.
in a day-to-day
So you also follow what Amol follows. Dr. Sonal also follows the same. Perfect. I think both options are there. MRI surveillance is as good as you give PCI. Some centers follow PCI, some centers don't follow PCI. Okay. Now let me start with Aditya. Aditya, you have incorporated, you start with immunotherapy plus chemotherapy, patient responds well, followed by immunotherapy maintenance is your standard in extended stage in metastatic small cell.
Yes, sir. And along with that, if the disease has responded well, I would want to consider with consolidation with RT.
You would like to give consolidation with RT, fair enough. Dr. Sonal?
Yes, sir. Same.
You would do that, okay. Amol? You do agree, okay. Since we are talking of consolidation RT, Dr. Krishnamurthy, do we have any role of surgery in ES, SCLC? Any role where you have operated upon?
No, haven't operated on any of these
I'm
things, but I
asking.
think I'm not really sure whether there is any role at all. Maybe if there is only some, say, impending pathological fracture or any other onco emergencies warranting, wherein you feel that other modalities of treatment may not sort of give the desired effect, then maybe you can consider surgery. But I guess role of surgery seems to be limited to very small, limited stage.
Dr. Sonal, lurbinectedin is incorporated in this particular NCCN which I downloaded today morning. Are you aware that this has become a new category 1 in small cell? Because one of the topic is what has changed and what is going to change. So if you see, October 2, 2025, FDA has got approval of lurbinectedin with immunotherapy in small cell ES. Are you aware of this?
Yes, sir, but maybe whether we'll be able to use it, so that would related to the cost, basically.
Related to the cost. Did you feel the same when IO was introduced in the market? I felt the same. Without PAP, first 20 patients of mine ran away saying that, sir, 50 lakh rupees, 60 lakh rupees per year. I think only MOC doctors must be getting patients who can afford that.
So at least nowadays, because immunotherapy has made such an impact in terms of the small cell lung cancer, we are seeing a very good survival. Sometimes these patients, even in the metastatic phase, are with a maintenance therapy have a better survival. So till the date, maybe immunotherapy is, we are pushing our patients with have newer options of immunotherapy even in small cell with a lesser cost. But as you said, this is a newer first line.
Newer first line. So we will come to that. Dr. Sonal, Dr. Krishnamurthy, you just mentioned some of the patients do very well. He says, where do you cure extended stage? Have you ever had any patients who were so-called cured in extensive stage small cell? Or all of them have died, whom you have seen?
Metastatic.
Metastatic small cell.
So usually they have a
Any
very
7-year, 8-year, 9-year survivor? We can tell the surgeons and radiation oncologists we also do a good job.
7 years.
No, okay. It's very rare. Okay, Amol, cisplatin or carboplatin?
Well, sir, I mean, we are talking about metastatic extensive stage, so definitely depending on patient's PS and the creat clearance. Otherwise, I am comfortable.
Patient is eligible for both.
Then cisplatin.
Then cisplatin. Aditya?
So I agree to this, sir. There is a caveat. If I am giving durvalumab, then cis or carbo both are there. In atezo, only carbo.
Okay. And in limited stage?
Limited stage, cisplatin.
Cisplatin. Dr. Sonal? Okay. So there is a slight change here. Adriatic study, if you see the forest plot subpopulation, the carboplatin was slightly better than cisplatin. So this is the first time where in small cell lung cancer, the carboplatin was proven to be, although see it's a forest plot, subgroup analysis, it was proven to be better than cisplatin.
So both of them crossed unity.
Correct, I agree, both of them crossed unity, but at least you have non-inferior, because we always believed cisplatin should be used as much as possible. My point is that we have now data where cisplatin and carboplatin, either of them can be used. Okay, Aditya, quickly, patient can afford both. Would you give Durva or Atizo? By the way, this is sponsored session of AZ, right? No? It was written. So I am supposed to speak about Durva. Aditya,
So
patient can afford both.
So that is the million-dollar question. But I would prefer Durva. Reason being toxicity described and
So between Durva and Atizo, you feel Durva is less toxic?
Yes.
Okay. The textbook says something else, although Dr. Sonal.
Atezo.
Atizo. Okay. Dr. Amol? Durva. Okay, fine. So this is a real world, first time real world comparison in 2024, last year December. They found Durva to be slight better than atezolizumab. But they found that the side effect by Atizo is better than durvalumab. So that was there. I think both of that are okay. Aditya, tislelizumabs of the world?
Currently, I would use serplulimab.
5 minutes? Okay.
Currently, I would use serplulimab.
Currently, you will use serplulimab. Okay. Dr. Sonal.
Yes, sir. Same.
Same. Patient can afford everything. And you have a choice. Would you give serplulimab? 46,000 versus 2.57 lakhs.
So if the patient can afford, then I will maybe use the whatever you have downloaded today morning. So I will try to use the
Durvalumab.
therapy plus no
Okay.
combination.
Amol, patient can afford everything. I'll tell you why I'm asking that question. If you see serplulimab, tislelizumab, their median OS has reached 15 months as compared to 12 months with Durvas and Atezos of the world. And if you see 4-year follow-up in this tislelizumab, it's 20% OS at 4 years. And just recently, 2 months back, if you see 5-year OS with tislelizumab is touching 12%, which is exactly same with durvalumab. Amol, why spend patients' money when we can do it at a cheaper cost?
Well, sir, we have data of tislelizumab, in second line. I mean, the best data for tislelizumab is in this thing only, small cell and squamous.
I'm showing the data, yeah. So my question is, what would you do? Yes, Aditya.
Tislelizumab.
Tislelizumab. He will use serplulimab. You will do tislelizumab. Sonal will use durvalumab.
If feasible, then durvalumab. The reason being that we say that the median OS for serplu is better, but then more sick patients were there in the durvalumab as compared to serplu.
Okay, so this is what I was saying, and it was lurbinectedin is an alkylating agent. It was first in second line, now it is in the first line, and this was the data, very nice data, which is there, and we should look at that. I would not go, we have 3 minutes, I would come to tarlatamab. Yes, Dr. Aditya.
Per vial is 30 lakhs.
Per vial is 30 lakhs. We have Dr. Jay Mehta and Dr. Rahul. Dr. Rahul, are you getting DLL3 by IHC? Any request from anybody?
No request.
No. Dr. Jay Mehta? You get in CAR T cell, you told me, not in small cell.
No, not for small cell.
So, in small cell, it is not basically required to use tarlatamab. One of the fundamental thing which I love about this molecule is the sustained long-lasting responses in the second line, what we are getting. Cytokine release storm is an issue. I would skip. So, this is something I again would like to ask first Dr. Rahul. Dr. Rahul, assuming non-small cell lung patient progressing and the repeat biopsy says, high, poorly differentiated, would you use NGS there to show that this has progressed into small cell?
Yes, definitely, but along with IHC.
Along with IHC.
First I will do IHC and then we'll go for NGS.
Dr. Jai, assuming that patient of NSCLC, you have done NGS, no altercations, but RB1 loss is there and TP53 loss is there, both tumor suppressor loss. By textbook, it should be put it as a small cell variant also.
Yeah, I wouldn't do the NGS then. I mean, morphology and IHC is good enough to diagnose that.
Assuming NGS shows RB1 loss and TP53, would you revisit your IHC?
I think they would be concordant. It's easier, it's easier to do P53 and RB1 loss on IHC also. It's much faster and economical to do that.
Have I not asked any question to any of the panelists? Okay, done. Fine. So I think we have just 54 seconds left. This is the study which is probably going to change because it is showing based on biomarker they are going to do the study. My conclusion would be tarlatamab in the second line is category 1, sustained response is seen, cytokine syndrome is seen in 50%. If not used earlier, lurbinectedin used, it is better than topotecan. IO re-challenge, no. NGS today is not helpful. Thank you so much. We have 27 seconds left. Yes, Dr. Jai.
I was reading about this role of NGS in SCLC, and apparently a big study from, data from Guardant said that on relapse of small cell lung cancers, about 14 to 15% of them show androgen receptor mutations.
Which mutation?
Androgen receptor.
Androgen AR receptor mutation.
And that's kind of, therapeutically something that you can
So
exploit.
there's a
I didn't know
target,
that.
there's
I
a
thought I'll share
target,
it
but
with
we
all of
don't
you.
have data where if you have used anti-androgen and there is a response.
Yeah, that's what
So
I said.
it
I'll
is
share
just,
it with
yes,
you.
but it is a good
because
point,
it's
yes.
kind of, actionable, I think.
Right, absolutely. Thank you so much all the panelists, and thank you organizer for giving this opportunity.
Thank you, Dr.
Yeah,
Ramesh, and to all our panelists. And now we move into a moment that is very close to our hearts. Medicine is a profession built on science, but sustained by compassion, resilience, and an unwavering commitment to patients. Tonight we honor those who have lived these values every single day of their careers. They are the torchbearers, the mentors, the giants on whose shoulders we all stand. And tonight we honor them. It is my absolute privilege to invite you all to stay with us as we begin the Lifetime Achievement Awards, a celebration of legacies of lives spent in service and of contributions that have shaped the very fabric of cancer care in our country. To honor the legacy of our first awardee, we have an AV that highlights the milestones that shaped the incredible journey. Can we have the AV, please?
Modernities. A mentor, a professor, a visionary who led Tata Memorial's oncology department and went on to guide India's finest cancer institutions. Recipient of the Padma Shri, the Padma Bhushan, the Harvard Lifetime Achievement Award, and honors from across the world. For 51 years, he pioneered advanced cancer therapies, inspired new generations, and brought compassion to every patient he touched. A man whose work is not just medicine, it is a national legacy. Tonight, we go to the extraordinary journey of Dr. Suresh Advani. We salute to your extraordinary contribution to oncology and honor you with the Lifetime Achievement Award.
We are very privileged to have with us Padma Bhushan Dr. S.H. Advani, sir, to whom we
for both of us. Yeah, I would really like to thank the MOC for giving us this real honor, and I feel humbled by the fact that this is not the award for me, but it's for all the people with whom we have collaborated, worked throughout our last 50 years of mine. And Pankaj Shah and myself, we have really done a sort of joint work and managed to keep the medical oncology going. And now, of course, we are in a position to say that we have thousands of medical oncologists doing a human service to the society, where people in the very distant places also are able to receive the best of the treatment near the home. So I think that is where particularly the MOC has worked in the small places also, having the centers along with the trained personnel, so that they have been doing a good work. And I really wish them all the best. And again, I must thank them for considering me for this honor. Thank you very much.
We thank you, sir, for joining us. And we are really privileged to present you with the Lifetime Achievement Award. Can we move ahead to the next one? To honor the legacy of our...
For 47 years, he has served as physician, teacher, researcher, and institution builder. Former President of India's top oncology societies, Director of GCRI, Vice President of the Gujarat Cancer Society, and mentor to countless young oncologists. He founded Gujarat's leading oncology program, shaping the future of cancer education in the country. Honored with the prestigious BC Royal
Hello, MOC, Pankaj here from Ahmedabad.
Science with deep compassion and community service. A leader, a teacher.
Can you see my video?
Tonight, we celebrate the remarkable legacy of Dr. Pankaj Shah. We salute to your extraordinary contribution to oncology
Hello.
We have Dr. Pankaj live with us.
Hello.
Sir, we can hear you.
Are you in? Thank you very much, MOC. Because of the half an hour I have visited all your Facebook entry and lots of educational material on your website. And I am very happy and proud to see that somebody has asked that sugar is not curing cancer. You can eat sugar. And this is a nice way of educating people. So first of all, let me congratulate MOC. MOC is the product of Ahmedabad, I can say. It has started the boys, the medical oncologists who have been trained in Ahmedabad, has started this in Mumbai. And as Dr. Advani has already conveyed, that we both are very proud to see the progress of oncology in the country and around the world. We have an opportunity of observing oncology for more than 50 years, 52 years by now. The growth is phenomenal and the science is blooming. Only thing which I am worried about is that new diagnostic methodology. Even though the government is helping a lot to the people, it is very difficult to get a proper molecular diagnosis in each and every case. And for that, all the regional cancer center, there should be a basic facility available to properly diagnose and establish the exact diagnosis so that the best treatment we can offer. Thank you very much, MOC, for considering me for this particular award. Thank you again. Thank you, Advani, for using a good word for me also. Thank you very much.
Thank you, Dr. Shah. We are really privileged that you're here with us live. To honor our next awardee, we have another special AV. Can we have the AV, please?
A true luminary of medical oncology, Dr. Ramesh Nimagada. For more than 45 years, he has shaped cancer care across continents, from Asia to Canada. As Director of Medical Oncology at Apollo Chennai, for over 2 decades, he built one of the India's leading cancer centers and continues to guide and inspire as senior consultant today. His global impact began in Canada, where he led the new Brunswick Provincial Cancer Registry and contributed to national clinical trial bodies and the Royal College of Physicians, recipient of the ISMPO Lifetime Achievement Award, and leader whose compassion has touched thousands. Tonight, we honor a monumental career and an extraordinary legacy. Thank you, Dr. Ramesh Nimagada.
May I invite Dr. Chirag Desai to present the Lifetime Achievement Award to Dr. Ramesh Nimagada. Thank you, Dr. Nimagada, and thank you, Dr. Chirag. We will now play an AV showcasing the outstanding achievements of our next Lifetime Achievement Award recipient. Can we have the AV, please?
A relentless force in the world of oncology, Dr. Purish Parekh, former professor and head at EMH, editor-in-chief, and a leader who helped shape academic oncology across Asia. Founder of powerful oncology societies, advisor to national bodies, and a voice that fought the distorted Novartis delivery case, bringing affordable treatment to thousands. He exposed unethical drug trials, championed integrity in research, and through the ICS Cancer Cure Fund, delivered over 170 crore worth of free cancer medicines to patients in need. A pioneer of ethics, access, and excellence.
May I invite Dr. Bhavin Shah to present the Lifetime Achievement Award to Dr. Purvish Parekh. May I request Dr. Ramesh Nimagada to kindly share a few words with us.
I want to thank MOC and Chirag. I'm sure he's been there. And Chirag and I have been associated for a long time, tried several things, but didn't work some of them. And I hope at some point it still works. But I must say that from coming from Canada and to Chennai, I must thank all the oncologists. At that time, there are 4 others in the city and probably in the state when I joined Apollo in 1985. And they have been taken me immediately as one of them, and we used to conduct my monthly oncology club. But I must thank Parvish and others in TMH, which have accepted me as part of any conference, anything they have done all these years. And so academically it has been a very good experience, which is very, very important in oncology. Unfortunately, many places it doesn't have, and they are isolated, and it's very, very difficult. That I think is one thing, and I feel very at home in any conference, even today, but searching for people I know, because of late we have not been meeting, so thank you very much.
Thank you, sir. I now request Dr. Purvish Parekh to kindly share a few words.